Hello, my name is William Middleton. I'm a professor of radiology at the Mallinckrodt Institute of Radiology at the Washington University in St. Louis. Today I'm going to present a lecture entitled Basic Aspects of Renal and Adrenal Ultrasound. Okay, so let's start with the normal characteristics of the kidney. Normal renal size centers at about 11 centimeters, plus or minus 2 centimeters, so the range is from about 9 to 13 centimeters. The echogenicity is compared to the liver on the right and the spleen on the left, and the right kidney should be equal or slightly less echogenic than the liver. The left kidney should be significantly less echogenic than the spleen. The renal parenchyma can be divided into the renal cortex and the pyramids are slightly less echogenic than the cortex, although you don't always see the pyramids. Notice on the image in the upper right-hand corner, that's a high-resolution view of a renal transplant, and you can see the location of the hypoechoic pyramids with respect to the slightly urine-distended calyces. The renal sinus is composed of fat and fibrous tissue, as well as the vessels and lymphatics, and it is hyperechoic and is centered in the center portion of the kidney. And then the outer margin of the kidney should be smooth. Now, the most common indication for renal sonography is in patients with acute renal failure to exclude hydronephrosis. Now, in the general population, the yield of finding hydronephrosis in this clinical situation is only about 1%. And unfortunately, false positives are relatively frequent. So even when patients don't have renal obstruction, mild hydronephrosis is seen. Now, the yield of sonography increases significantly if you only look at high-risk patients. And those are patients that are postoperative from abdominal surgery, have a history or physical examination findings consistent with a pelvic mass, have a history of kidney stones, etc. The diagnosis of hydronephrosis is made when there is anechoic fluid separating the renal sinus. In almost all situations, the renal collecting system will be displayed as several dilated infundibuli that are connecting to the renal pelvis centrally and connecting to renal calyces within the periphery of the kidney. And this should be seen on both transverse and on longitudinal planes. If you only see it on the longitudinal plane, but not on the transverse plane, it's probably not real. Hydronephrosis can be graded in several categories. Grade 0 is considered normal. Grade 1 is where the collecting system is just barely distended and barely abnormal, but the kidney is otherwise within normal limits. Grade 2 is a collecting system that's clearly abnormal, but the surrounding renal cortex is well preserved. Grade 3 is when the collecting system is clearly abnormal and dilated and the cortex is thinned. Now, hydronephrosis most of the time is due to obstruction, but that's not always the case. You can have a patient that has hydronephrosis, but the kidney is not obstructed. And unfortunately, the corollary is also true. You can have obstruction without having hydronephrosis. And there's a couple of ways to sort this out, or at least to help to sort this out. One is to check arterial blood flow by measuring resistive indices in the intrarenal arteries. If the resistive index is unilaterally elevated on the side of suspicion, then obstruction is likely. And the cutoff value for an elevated resistive index is 0.7, or asymmetry between the two sides of greater than 0.1. If the resistive indices are elevated bilaterally, that doesn't help you in looking at the suspected side of obstruction. And if the resistive indices are normal, that also doesn't help you in either excluding or making the diagnosis of obstruction. This is an example here that's being displayed where the grayscale image shows clear-cut hydronephrosis and dilatation of the proximal ureter. When you look at the resistive index of the questionable kidney, it's 0.76, and when compared to the contralateral kidney, which was 0.60. So clearly there's asymmetry in the resistive indices, and the resistive index on the right side is abnormal, and this was a kidney that was obstructed by a ureteral stone. Now, another way to get indirect evidence about the presence or absence of obstruction is to look at the flow of urine out of the ureters and into the bladder. If the ureteral jets are absent on one side, that means that side is likely obstructed. If there is a low-level continuous flow of urine out of the one side, then that also likely indicates obstruction. Now, the advantage that ureteral jets have over resistive index measurements is that they're affected immediately when obstruction occurs, and they resolve immediately when obstruction is relieved. The disadvantage is that you have to scan through the bladder for 5 minutes in order to make sure that the ureteral jets are clearly absent. And you also have to have a difference in the density of the urine that's exiting the ureter and the urine that's residing within the urinary bladder. So here's another example where you can see mild separation, very mild hydronephrosis in that longitudinal view of the kidney. When you look at the resistive indices, the right kidney had a resistive index of 0.71, the left had a RI of 0.57. So that would indicate that that kidney, although only showing mild hydronephrosis, probably is obstruction. When we looked at the urinary bladder, we saw that there was a detectable ureteral jet coming from the left ureteral orifice. Over a span of 5 minutes, we never saw a jet from the left, and that also suspects or makes you suspicious of obstruction. And very close analysis of that distal ureteral orifice showed a stone in that distal ureter. Now let's move on from obstruction and talk about kidney masses. The most common kidney mass is a simple cyst, the frequency of which increases with age, and by the time you reach 50 years, you have about a 50% chance of having a kidney cyst. Ultrasound is clearly the most accurate way of evaluating cystic lesions in the kidney, and it's especially useful when an indeterminate mass is seen on a CT or MR or a urogram where a cyst is highly suspected. The ultrasound criteria for diagnosing a simple cyst is the lumen should be anechoic, the back wall should be well defined, there should be posterior acoustic enhancement, and there should be no measurable wall, all of which are satisfied on the image displayed. Now, what can look like a cyst but not actually be a cyst? There's a number of things. Lymphoma is a solid tumor, but unfortunately it can look like a cyst because it's very homogeneous and generates few reflections. Fortunately, this doesn't happen very often, but this is an example of anechoic lymphoma. Calyceal diverticuli can mimic cysts, arteriovenous fistulas can mimic cysts, and aneurysms and pseudoaneurysms can mimic cysts. This is a pseudoaneurysm that looks very much like a simple cyst, but on Doppler analysis, you can see that it has readily detectable internal blood flow. Now, what about cysts that aren't simple, in particular cysts that are hemorrhagic? Well, initially, when a cyst undergoes hemorrhage, it will have a solid appearance as shown here. Often will be heterogeneous, but will appear solid. Now, over time, that cyst and the clot within the cyst starts to lyse, and the cyst becomes more complex, evolving into a lesion that may be cystic with solid elements or cystic with thick septations. Now, eventually, the cyst will, a hemorrhagic cyst will completely liquefy and may have diffuse low-level echoes, as shown in this image, or may have a fluid cellular layer, as shown in this image. But if you wait long enough, and this may take a matter of several weeks or months, cysts will usually convert back to a simple appearance. Now, in general, we think about cysts as occurring in the cortex, but there is a subpopulation of cysts that occur in the peripelvic region. These are felt to be lymphatic in origin. They're usually solitary, but it's not uncommon for them to be multiple, as in this example. And they can be bilateral. When they become quite numerous, they can simulate hydro, as we see in these two examples. The difference between multiple peripelvic cysts and hydronephrosis is that with hydronephrosis, you can almost always see a distended pelvis extending continuously into an upper and lower pole infundibulum and many times into a mid-pole infundibulum. And with peripelvic cysts, you see separate cystic structures that do not communicate. Polycystic disease is a disease that affects the kidneys more than any other organ, although the liver is often affected. The pancreas is very rarely, but occasionally affected. And you can get cystic lesions in the vasculature of the CNS, in particular cerebral aneurysms. Up to 10% of patients that have end-stage renal disease in North America and Europe have this because of polycystic disease. Survival is approximately 10 years on average if it's untreated. By the time patients reach the age of 60, they will usually have renal failure. It's an autosomal dominant disease, but up to 50% of patients will not have affected family members, either because of variable expression of the gene or due to spontaneous mutation. So don't be surprised if you see this on a sonogram and there's no history of family disease. Type 1 polycystic disease is the most common, and it presents earlier and is more severe than type 2 and is easier to diagnose. The signs and symptoms of polycystic disease are listed there on the left. When you're trying to make the diagnosis in a patient at risk, i.e. a patient who has an affected family member, the criteria are below the age of 30, you have to see 2 cysts in one kidney or 1 cyst in each kidney. Between the age of 30 and 60 years, you have to see at least 2 cysts in each kidney. And over the age of 60, you need to see at least 4 cysts in each kidney. Now realize these criteria will only be applicable to patients who are at risk, patients who have affected family members. If you applied these criteria to the general population, you'd be diagnosing polycystic disease much too frequently. And these are some various examples of polycystic disease and various stages of severity. Because there are so many cysts in patients with polycystic disease, it is not uncommon to get crystalline deposits within the cysts. And when that happens, you'll see ring down artifacts such as this. It's also not uncommon to have cysts that have hemorrhaged. So you'll see cysts that look solid and will ultimately go through the evolution that I described earlier. But polycystic disease does not have an increased risk of cancer, so these solid appearing lesions are almost always hemorrhagic cysts and not tumors. Now, polycystic disease is different from acquired cystic disease. Acquired cystic disease occurs in dialysis patients and generally occurs in a high percentage that have been dialyzed for over 3 years. The cysts are variably sized and they almost always occur in small echogenic kidneys. This upper right-hand image shows multiple cysts in a kidney that measures only 7.6 centimeters in size. Now, if the cysts become very numerous, then the kidney may actually become enlarged, as we see in this lower left-hand image. And in those situations, it can be difficult to distinguish this condition from polycystic kidneys. Now, unlike polycystic kidneys, acquired cystic disease does have an increased risk of tumors, and if you see a solid appearing mass like this, you have to be very concerned about a renal cell carcinoma, as was the case in this particular patient. Another complication that these patients get is retroperitoneal hemorrhage. Von Hippel-Lindau disease is another abnormality that presents with abnormalities in multiple different organ systems, but in the kidneys, it produces multiple bilateral cysts and multiple bilateral tumors. The tumors may be solid, as is seen in this example. They may be complex, as is seen here, or they can be predominantly cystic with little solid nodules, as is seen in this intraoperative scan. Now, we've kind of alluded to renal cell cancer that occurs in particular conditions. Let's just talk about renal cell cancer by itself. It's the most common solid renal mass, accounts for 90% of all renal malignancies. Risk factors include advanced age, smoking, and as we mentioned, von Hippel-Lindau disease and dialysis. It's most often detected incidentally nowadays, and traditionally it has been treated with radical nephrectomy, although nowadays there's a big increase in the number of laparoscopic procedures that are being done and the number of partial nephrectomies and ablative therapies that are being performed for renal cell cancer. Sonographically, 50% of renal cell cancers are hyperechoic to the cortex. About 10% are similar to renal sinus fat. In other words, they're markedly hyperechoic to the cortex, and this is particularly common in small renal cell cancers. 30% are isoechoic, 10% are hypoechoic, 5% are predominantly cystic, although many renal cell cancers have some cystic components, and then 10% contain calcification. And here's a collage of various renal cell cancers. A hyperechoic cancer here that looks very similar to an angiomyolipoma, and we'll discuss that in a minute. A hyperechoic lesion that's just slightly more echogenic than the renal cortex. An isoechoic lesion, a hypoechoic lesion, a complex cystic lesion, and then a lesion that contains some stippled internal calcification. Now, one unique thing that renal cell carcinoma does is it will invade the renal vein, as we see here. Now, renal vein tumor thrombus differs from bland thrombus in that it has tumor vascularity to it. And many times, although not always, you'll be able to detect that internal vascularity on color Doppler or power Doppler techniques, as we see here. Now, eventually, that renal vein thrombus may extend into the inferior vena cava, as we see in this transverse view, and it may extend well into the cava and sometimes even above the diaphragm and into the heart, as we see here. Transitional cell carcinoma is much less common than renal cell carcinoma, but it is the most common urothelial cancer. The rest of urothelial-based cancers are squamous cells. 10% of transitional cell cancers are metachronous or synchronous, and it occurs much more frequently in the bladder than the renal pelvis, and more often in the renal pelvis than in the ureter. Now, ultrasound is not sensitive in detecting transitional cell carcinoma in the kidney, ureter, or renal pelvis, better in the bladder. When it is seen, it's often seen as a solid mass centered in the renal sinus, or as shown in this image, focal eccentric urothelial thickening seen here in the upper pole of this kidney, or thickening of the renal pelvis as seen in this transverse view. Now, metastases also occur in the kidneys, and in fact, in autopsy series, they're seen in up to 20% of patients dying from cancer. But most of the time, they're small and they're not imageable. When they can be seen, they're often infiltrative, and they're frequently and almost always solid. They can be single, multiple, unilateral, or bilateral. So the appearance, unfortunately, overlaps with that of primary renal cell cancer. So in a patient that has an extrarenal cancer, when you see a renal mass, you have to consider metastases. And since metastases will not require nephrectomy, and renal cell cancer will require nephrectomy, biopsies are appropriate in this situation. These are examples of renal cell metastases: a small lesion with a hyperechoic halo on the left, and an isoechoic lesion that was seen really only on Doppler techniques as an area of decreased vascularity in the kidney. Lymphoma also affects the kidney, usually in the setting of widespread disease elsewhere in the body. Non-Hodgkin's disease is much more common in the kidney than Hodgkin's disease. It's very rarely symptomatic. On sonography, it typically appears as a solid, hypoechoic, multifocal bilateral process. Less often, it's unifocal and unilateral, or diffuse and infiltrative. As we mentioned earlier, it rarely is anechoic and can simulate a cyst. And one unique thing about lymphoma is that it can infiltrate the perinephric region, and in those situations, it also looks very hypoechoic and can simulate perinephric fluid. Again, since lymphoma does not require a nephrectomy, and it overlaps in its appearance with renal cell cancer, if you are faced with that differential diagnosis, it is appropriate to do a biopsy to distinguish those two. These are different examples of lymphoma. This is an enlarged kidney that is just slightly lumpy, bumpy, although it's hard to discern discrete lesions. This is a lesion with multiple hypoechoic masses. This is a lesion with a solitary unilateral isoechoic mass. And then here's another patient that has several lesions that are anechoic and look at least somewhat like renal cysts. And these are 4 different examples of perinephric infiltration of lymphoma that look very similar to perinephric fluid collections. So just keep that in mind when you're faced with that appearance. Angiomyolipoma is a benign renal tumor that's composed of vessels, muscle, and fat. It's the most common benign tumor. It tends to occur in middle-aged women and in patients with tuberous sclerosis. It has no malignant potential, so if the diagnosis can be made reliably, the patient does not have to have surgery unless the tumor gets to be big. And beyond 4 centimeters in diameter, these tumors tend to bleed, and sometimes they'll be removed just prophylactically to avoid bleeding complications. 80% of angiomyolipomas are homogeneous and very echogenic. 20 to 30% will attenuate the sound beam, and that's another thing that's unique to, or almost unique to, angiomyolipomas. Our approach to suspected angiomyolipomas is to do periodic ultrasound follow-up if they're less than 1 centimeter, and to do CT or MRI if they're larger. CT and MRI are pretty reliable in confirming the presence of fat in small or in larger angiomyolipomas. It's more difficult with the smaller lesions. And here's a typical angiomyolipoma. You can see a very echogenic solid mass in the cortex of the kidney. Now on this conventional view, we don't see any sound attenuation from that lesion, but when you look with a high resolution linear array, as shown on the right, you can see some attenuation of the sound deep to that lesion. Oncocytomas are another benign renal neoplasm that account for about 5% of all renal tumors. The appearance overlaps that with renal cell carcinoma, and as you can see in the two images on the right, those are very nonspecific solid renal masses that look for all the world like renal cell carcinomas, but when these were resected, they were found to be oncocytomas. Now occasionally you'll see a central scar on a contrast-enhanced CT or MRI, or if you do contrast ultrasound, you can see it on a contrast ultrasound as well. But in general, these lesions can't be distinguished from renal cell carcinoma, so they're treated surgically just like renal cells are. The last tumor that I'll discuss is a multilocular cystic nephroma. This also is a benign tumor that tends to occur in young boys and older women. They appear as masses with multiple variable-sized, non-communicating cystic elements, as shown on the two examples on the right. Unfortunately, the appearance of multilocular cystic nephroma overlaps with the appearance of cystic renal cell carcinoma and Wilms tumors. So these lesions are also treated surgically, just like renal cells, because we can't tell the difference. Now, there are a few things that are non-neoplastic that can appear mass-like on sonography, and one is pyelonephritis. Pyelonephritis typically, if it doesn't have a normal ultrasound appearance, will appear as renal enlargement with focal cortical changes. Now, these are often wedge-shaped, not always. They can be either hyperechoic or hypoechoic, and unlike other organs where inflammatory lesions are hypervascular, in the kidney, infection causes decreased vascularity. Urothelial thickening can also be a sign of pyelonephritis, but occasionally you'll get focal masses, as we see in the two images on the right, that will look for all the world like a renal neoplasm, but will turn out to be inflammatory in nature. And those often have to be correlated clinically and sometimes need to be biopsied to prove that they truly are inflammatory. Renal abscesses are another inflammatory condition that can simulate the appearance of a cystic renal cell carcinoma. They, like renal cell carcinoma, can appear as complex cystic masses, and to make the diagnosis, you really need to correlate with the clinical history and, again, aspirate the lesion and see what you get for further evaluation. So just in summary, renal masses often have characteristic ultrasound features, but like all modalities, there's a fair amount of overlap in the ultrasound appearance of both benign and malignant and non-neoplastic renal masses. So ultrasound should be viewed as complementary to CT and MR when evaluating renal masses, and it's especially valuable in evaluating cystic lesions. Now, I also need to discuss renal stones. We no longer do ultrasound as often for evaluating patients with suspected stones, but you can see stones with sonography, and you should become familiar with the appearance. They really appear similar regardless of the type of stone. Whether or not you see them depends on how large they are. And stones that are 5 millimeters or smaller get progressively harder to see. On the other hand, stones that are 5 millimeters or larger are seen fairly reliably. And they all appear as hyperechoic lesions, most of the time with an associated shadow, and oftentimes with a twinkle artifact. So this is your hyperechoic lesion with a shadow. This is a large staghorn calculus that appears hyperechoic with shadowing. And here's a twinkle artifact on color Doppler seen from a very small stone that was difficult to detect with grayscale. Now, realize that renal stones are more difficult to detect than gallstones. Gallstones, ultrasound is fantastic. Renal stones, ultrasound is much more limited. And that's the reason that we do non-contrast CT to identify renal stones nowadays. Now, another type of calcification in the kidney is medullary nephrocalcinosis. This occurs most frequently in patients with hyperparathyroidism, renal tubular acidosis, and medullary sponge disease. This causes increased echogenicity to the renal pyramids, as you see in the first two images below. And it tends to start in the periphery of the pyramids and then progress into the central aspects of the pyramids. As the calcification becomes more progressive, you'll start to see shadowing associated with these hyperechoic pyramids, as you see on the third image. Now, ultrasound is very sensitive in detecting medullary nephrocalcinosis, which is a little strange given that it's got limitations in detecting renal stones. But medullary nephrocalcinosis is seen very easily with sonography, probably as well or perhaps even a little bit better than seen on CT. Okay, now I want to shift gears a little bit and talk about renal Doppler, and first talk about renal arterial Doppler, specifically renal arterial Doppler for the detection of renal artery stenosis. There's a variety of criteria that have been established. These are the ones that I rely on most heavily. One is on color Doppler imaging, detection of focal flow abnormalities that include focal aliasing of the Doppler signal and focal vibration of the perivascular tissues around the stenotic site. Measurement of the waveform velocities is also very helpful, and the cutoff value for renal artery stenosis is a peak systolic velocity in the main renal artery greater than 200 centimeters per second, or an elevation of the ratio between the renal artery and the aorta, the renal to aortic ratio, or RAR, greater than 3.5. And here's some examples. In the upper left is an example of focal aliasing, where you see this abrupt color conversion in the proximal left renal artery. Upper right, you see this focal tissue vibration manifests as extravascular colored dots, equally distributed between red and blue in the areas around the right renal artery. The lower left is a patient with elevated peak systolic velocity of 327 centimeters per second, secondary to stenosis. And in the lower right is a patient that has a borderline elevated peak systolic velocity in the proximal right renal artery of 213 centimeters per second. But when you compare that to the velocity in the aorta, you see that the renal to aortic ratio is slightly greater than 5, meaning that this is very likely to be a significant renal artery stenosis. Now, there are limitations in renal arterial Doppler, and these include poor visibility of the artery secondary to a variety of causes, but most frequently obesity, bowel gas, and shortness of breath. Sometimes the Doppler angle is very limited, and you can't measure velocities at a Doppler angle greater than 60 degrees. Extensive arterial calcification can cause enough shadowing that you just can't evaluate certain segments of the renal artery. Cardiac arrhythmias can affect your Doppler waveform. Fibromuscular dysplasia and distal atherosclerotic lesions are more difficult to detect because they're not in the proximal renal artery. Accessory renal arteries are common and difficult to detect with sonography. Even in the best patients, examination times are relatively lengthy, and it's important to remember that even at the best that we can do, we don't detect stenoses less than 60% diameter narrowing. We don't even try to. We're really focusing on detecting stenoses that are significant, and those are the ones that are greater than 60 to 70% narrowing. So how do we get around some of these limitations in looking at the main renal arteries? Well, one is to look at the intrarenal arteries. Significant stenosis in the proximal main renal artery will cause parvus tardus effects in the distal renal arteries, in the arteries within the kidney themselves. And parvus tardus refers to decreased systolic amplitude and slowed systolic acceleration. And there's a variety of ways that we can identify parvus tardus effects. The schematic that's showing in the upper right-hand corner shows a normal renal arterial Doppler with a very rapid systolic upstroke and a sharp early systolic peak. With proximal stenosis, the distal waveforms start to look like this. You lose that early systolic peak, and the early systolic acceleration starts to decrease. And then with progressive stenosis, the systolic peak gets progressively blunted, the acceleration diminishes, and that early systolic peak gets very rounded. So what do we use to quantify this? Well, in addition to looking for loss of that early sharp systolic peak, we can quantify it by measuring the early systolic acceleration. And that's done by looking at the upslope of early systole. Now, in the image in the upper right-hand corner from the left kidney, you can see that the slope, which is the early systolic acceleration, is 92 centimeters per second squared. That's extremely low compared to the right kidney, where it's 1,806 centimeters per second squared, which is much faster. Now, you don't really need to measure the slope in this case, because you can just look at the waveforms and see how different the systolic acceleration is in the left kidney compared to the right kidney. But in borderline cases, measurement of that early systolic acceleration can be handy. Now, what are the limitations of intrarenal arterial analysis? Well, many people, including myself, feel that it's less sensitive to borderline stenosis than main renal artery analysis. It does not distinguish occlusion with collaterals from a high-grade stenosis. It doesn't localize the stenosis to proximal, mid, or distal renal artery. And in fact, you can get changes if the stenosis is in the aorta or in the aortic valve. Sometimes the cursor location for measuring the early systolic acceleration is questionable, and all of it is dependent on having compliant vessels, which is not always the case, especially in elderly patients with significant intrarenal atherosclerosis. Okay, now let's change gears and talk about renal vein thrombosis. This is something else that we sometimes try to detect with renal Doppler. Realize that this requires a combination of both grayscale findings and Doppler findings. You can miss it on grayscale if you just rely on that. You can miss it on color Doppler if you just rely on that. Now, in the right renal vein, we have a fairly high sensitivity because it's a short vessel and you've got that nice big liver to scan through. The left renal vein sensitivity is lower because the vein is longer, there's more of it to evaluate, and you don't have as good an acoustic window. It's important to realize that with even total renal vein thrombosis, it still is not uncommon to have venous flow in the hilum of the kidney, so you can't just take views of the kidney, see venous flow in the kidney, and exclude the diagnosis. You really need to see the entire renal vein to get a full examination. And also realize that arterial flow into the kidney is usually not affected or only minimally affected in native kidneys that have renal vein thrombosis. Now, on the other hand, in renal transplants, the arterial flow is affected to a much larger degree, and you get that to and fro pattern. So here's an example where you can see renal vein thrombosis in the left renal vein of the native left kidney, both on grayscale and Doppler. And this image on the right is an example of a renal transplant with renal vein thrombosis where you can see that to and fro waveform pattern within the supplying renal artery. We use Doppler to diagnose pseudoaneurysms. Those occur secondary to trauma from biopsies, trauma from penetrating trauma from gunshot wounds or knife wounds, and occasionally from infection. They occur most commonly in renal transplants because renal transplants get biopsied more frequently than native kidneys. They can be a source of hematuria. As we mentioned earlier, they can appear as simple cysts, as we see here, but they'll have internal blood flow, as you see on the Doppler image. The to and fro pattern in the neck of a pseudoaneurysm that you commonly see in pseudoaneurysm in the groin is much more difficult to diagnose in renal pseudoaneurysms, but occasionally you can see it, as we see here. And remember that they can coexist with arteriovenous fistulas. Which brings us to arteriovenous fistulas. The etiology is similar to pseudoaneurysm. They typically are self-limiting, but they can cause persistent hematuria. Now, generally, there's no grayscale findings for AV fistulas, but on Doppler analysis, you'll see a prominent artery with high velocity and a low resistive index. So on this image obtained in diastole, you see one vessel heading into the lower pole and no vessels anyplace else. That's because there was some underlying renal parenchymal disease in this transplant kidney. In systole, you continue to see that one prominent artery heading to the lower pole. Now you see another artery heading to the mid-pole here, but look at the difference in color saturation. You can tell that that artery that's heading to the lower pole has a lot more blood flow in it, and that's confirmed when you do Doppler analysis to the artery that's supplying the fistula, gangbusters arterial flow and a lot of diastolic flow compared to the artery going to the rest of the renal cortex, which has much less flow. Now, in addition to differences in the arterial flow, you can see arterialization and disordered flow in the draining vein, and typically you'll see fairly extensive and dramatic tissue vibration around the area of the fistula. Well, that does it for the kidneys. I want to just briefly review the adrenal gland. We often ignore the adrenal gland when we're doing sonography of the abdomen, and that's probably appropriate because ultrasound is certainly not a mainline test for looking at the adrenal glands. The normal adrenal glands are difficult to evaluate, easier on the right side than the left side, but even on the right side it can be tough. These are some examples of normal adrenals on the right side. Typically you'll see them as just little linear hypoechoic bands of tissue between the liver and the crus of the diaphragm near the vena cava. And occasionally, if you're lucky, you'll see the Y-shaped appearance of the adrenal gland. Now, adrenal masses are also more difficult to detect than on CT, but in the right adrenal, masses, if you pay attention, can be seen with fair sensitivity. Much more difficult on the left side. Unfortunately, the sonographic appearance of masses is usually very nonspecific, and you have to rely on a combination of detection of mass on sonography and clinical history. Clinical history can be very helpful. But many times you need to get follow-up laboratory values, and often we'll need to further evaluate these patients with CT or MRI. So just a few adrenal lesions that you can see with sonography. One is the adrenal cyst. Simple adrenal cysts are very uncommon, but they do get encountered occasionally. And you see this one here in the liver, which is a low attenuation lesion. Looks a lot like a cyst, could potentially be a low attenuation adrenal adenoma, but on sonography it clearly has appearance of a cyst. So those are usually pretty easy to diagnose. Adrenal adenomas, on the other hand, are very common tumors. They're usually non-functional. They're usually small. 3 centimeters is a reasonable number to remember. And they typically are solid and homogeneous. And these are 3 different examples of adrenal adenomas that have been seen on sonography. And they all have a fairly typical, although nonspecific appearance. Adrenal metastases are also relatively common. It's the 4th most common organ that develops metastatic disease. And on ultrasound, again, the appearance is nonspecific, but they're usually larger than adenomas, and they're often heterogeneous in appearance, as we see in this transverse and longitudinal view of a patient with metastasis from lung cancer. Adrenal pheochromocytomas are the 10% tumor. That's because 10% are malignant, 10% are extraadrenal, 10% are bilateral, and 10% occur in patients with multiple endocrine neoplasia syndromes. They typically present with hypertension, headaches, tachycardia, anxiety, palpitations. They can be seen with sonography, but again, they have a nonspecific appearance. They're usually solid, usually large, heterogeneous, and hypervascular, as we see in this example of a left adrenal adenoma in the left para-aortic region. Myelolipomas are a benign tumor that's usually asymptomatic. They contain hematopoietic elements and fatty elements. They're variable in size, but they usually contain some hyperechoic component because of the fatty elements within the lesion. And that's what we're seeing on these 2 examples of a patient with a relatively typical myelolipoma. So when you encounter a lesion like this, a CT scan or an MRI should be obtained to confirm the presence of fat. And then the final adrenal lesion is the adrenal cortical carcinoma. These are rare. They usually occur in the elderly. They're usually large, and they usually present with symptoms of some sort. 10% will be hyperfunctioning, and usually that produces Cushing syndrome. On imaging, they often will have necrotic areas, will have hemorrhagic areas, and calcification is not uncommon. And like renal cell cancers, they can invade the adrenal vein and then go on into the inferior vena cava. Here's an example of a large mass that has invaded the inferior vena cava, consistent with an adrenal cortical carcinoma. So that concludes this whirlwind tour of the kidneys and the adrenal glands. Please recognize that this is a very basic introductory review of the topic. If you really want to start doing renal and adrenal sonography and do it well, I'd advise you to go and review some chapters that are specifically focused on these 2 areas. Thank you very much.
Welcome to Introduction to Genitourinary Radiology, Part 1. I'm Dr. Dan Koval from radiologisthq.com. So in part 1, I'm going to talk about normal imaging anatomy from the adrenal glands to the scrotum. Part 2, I'll discuss renal and bladder calculi and then give you a basic overview of renal mass evaluation. And for part 3, I'll review some highlights from CT urography, talk about bladder and urethral diverticula, and give a basic overview of scrotal pathology. You'll notice that gynecologic and prostate imaging is not included on this overview. I'm planning on covering that in a separate lecture series. Alright, so let's start with some normal anatomy. Starting from the top, the right adrenal gland is located immediately posterior to the inferior vena cava. That's a great landmark to find it. It's superior to the upper pole of the right kidney and typically has a triangular inverted Y or V-shaped lambdoid configuration. The left adrenal gland, on the other hand, you'll find posterior to the pancreas. And that will be anterior medial to the upper pole of the left kidney. And it has a similar shape as the right adrenal gland. Now what about this case? What do you notice? Well, the right adrenal gland has a normal adreniform configuration and is normally positioned immediately posterior to the inferior vena cava, just anterior to the kidney. But the left adrenal gland has a linear configuration, and we don't even see the left kidney. Well, if we move inferior into the lower abdomen, you can see the kidney is malpositioned and ectopic in location, and was never in the left renal fossa during normal development. So it turns out the kidney has to be present within the left renal fossa, or right for that matter, for the adrenal glands to have a normal adreniform configuration. Otherwise, if the kidney is congenitally absent or ectopic, you'll have a linearly shaped adrenal gland. And that can help you differentiate if a patient's had a nephrectomy or if they have congenital absence of the kidney. Now in this case, you can see there's a ovoid hypoechoic mass in the right upper quadrant, posterior to the liver and where the adrenal glands should be. However, we don't normally see the adrenal glands on ultrasound, so this is abnormal. The patient went on to have a CT scan, and you can see there's an ovoid, well-circumscribed but somewhat heterogeneous mass just posterior to the inferior vena cava. And on a follow-up MRI, a few months later, this mass had resolved and there's a normal adrenal gland. So this is typical for adrenal hemorrhage. That often will just spontaneously resolve and leave a normal adrenal gland. Alternatively, you might have an adrenal gland with a few calcifications left behind or a pseudocyst. Alright, so speaking of ultrasound, let's go over a few definitions. So when you hear the term anechoic, that implies that you're dealing with simple fluid, and that will typically look black on ultrasound, as in this case, this is a simple ovarian cyst. And when sound waves hit simple fluid, they tend to speed up, and you'll get this phenomenon known as increased through transmission, or also known as posterior acoustic enhancement. And that just means you're getting a brightening of the tissues immediately posterior to or behind the lesion. Now what about this case? This is a dark mass in the testis. It's not quite dark enough to call anechoic, and for this we would use the term hypoechoic. Hypoechoic abnormalities on ultrasound typically refer to solid lesions. In this case, you can see that there's a mass which was an adenomatoid tumor of the epididymis, which has the same echogenicity of the adjacent testicle. And that terminology we would use isoechoic. Finally, in this case, you have a mass that's brighter than the adjacent structures. We would use the term either hyperechoic or echogenic, and this was an angiomyolipoma of the kidney. So the kidneys on ultrasound have a fairly characteristic appearance. The contour is typically smooth. You might see some slight lobulations in the setting of persistent fetal lobulation, which is an anatomic variant, but the contour is usually fairly regular. The cortical echogenicity should be equal to or only slightly less than the adjacent liver, and significantly less than the spleen. And usually you don't see the collecting systems. You might see some slight fullness, but they should not be dilated. Here's an example of that persistent fetal lobulation. You can see the renal contour is undulating as opposed to smooth, but the renal parenchymal thickness is normal. That's how you know you're not dealing with scarring. And this is a coronal reformatted CT image. So what do you think about this case? Does the renal parenchyma look like it's similar in echogenicity to the liver? No, it's quite a bit more echogenic than the liver. And those hypoechoic areas you see within the renal parenchyma correspond to the renal medullary pyramids, which you normally don't see so conspicuously in adults. So when we see this appearance, it's typical for medical renal disease, and this patient had chronic renal failure. Medical renal disease is a nonspecific term that could refer to multiple renal abnormalities, such as like chronic glomerulonephritis, diabetes mellitus. Here's another patient where the renal parenchymal echogenicity is markedly brighter than the adjacent liver. And this was a patient who also had medical renal disease due to lupus nephritis. Another cause for very echogenic kidneys might be HIV nephropathy. All right, now what do you notice in this case? Well, you're seeing the collecting system, which you normally don't see. So this is a patient with hydronephrosis. And notice how all the calyces connect, and that's how you can determine that this is truly hydronephrosis and not just parapelvic cysts. Here's a normal for comparison. Notice how the collecting system isn't really even visible. So the bladder on ultrasound will typically have smooth, thin walls, an anechoic lumen, which again you know is due to simple fluid. And because it's simple fluid, you're seeing some posterior acoustic enhancement there behind it. And then you won't see an intraluminal mass normally. That's something you would look for because that could indicate transitional cell carcinoma or other tumor. Could be a stone or a blood clot. In this case, you can see the walls are very irregular and thick, and that's due to chronic partial outlet obstruction causing trabeculation of the wall related to benign prostatic hypertrophy. This patient had a prostate volume of nearly 70 cc's. So why don't we review some CT definitions? So when something's darker than the surrounding structures, instead of saying hypoechoic on CT, we would state that it was hypodense. As in this case, this is a simple renal cyst. If something has the same density as an adjacent structure, we would describe it as isodense. And if something is brighter than adjacent structures, we would describe it as hyperdense. As in this case, this is a hemorrhagic cyst in the setting of autosomal dominant polycystic kidney disease. And the term enhancement implies that something becomes hyperdense after administration of intravenous contrast. So in that case, it's usually an organ or a solid tumor. So speaking of contrast, why don't we discuss the different phases of renal contrast enhancement that we see on CT, and this also applies to MRI. So on this initial image, this is a non-contrast image, and a clue to help you determine what kind of phase you're looking at is to initially look at the aorta, and you can see here the aorta is dark, so you know that there's no intravascular contrast. On this phase, this is the cortical medullary phase that typically occurs 35 to 40 seconds after injection of intravenous contrast. And around that time, you also get a late hepatic arterial phase, pancreatic parenchymal phase, enteric phase, and then the arciform enhancement phase of the spleen is typically seen during that time period. The next phase would be the nephrographic phase, which is usually 90 to 100 seconds. And then finally, the excretory phase, once contrast has started being excreted into the collecting systems, typically begins around 3 minutes and then starts to taper off around 15 minutes. So how does that look on coronal reformatted images? Well, this shows the anatomy quite nicely. So again, there's our cortical medullary phase, and you can see the difference between the cortex and the medullary pyramids. The nephrographic phase, when the kidney more uniformly enhances, and you can also see there's a little hypodense mass there in the left kidney that becomes more conspicuous. And then finally, the excretory phase, once contrast has started to be excreted. And based on this, you can tell that the nephrographic phase is the most ideal phase to evaluate for a renal mass. And you can see that that lesion is somewhat inconspicuous on the cortical medullary phase. So let's talk a bit about the anatomy here. So the subdivisions of the kidney, you have the cortex, which is superficial, and the medulla, which is deep. So the nephrons, which are the urine-producing functional structures of the kidneys, span both the cortex and the medulla. And the initial filtering portions of the nephron are the renal corpuscles. Those are located in the cortex. So where is the cortex? That's out here. And then in between these dark areas, which are the renal pyramids, you have the renal columns. So the renal cortex and columns all enhance quite briskly in the cortical medullary phase. All right, so the renal medulla is made up of these conical subdivisions known as renal pyramids. So those are the dark areas that you see on the cortical medullary phase. And they are actually pyramidal in shape. They have a broad base that faces the cortex and an apex which points internally, and that apex is known as the papilla. So these pyramids appear striped because they're formed by straight parallel segments of nephrons, and you'll see that kind of physiologic papillary blush on the excretory phase as contrast is concentrated in the cortex and extends into these parallel segments of nephrons. From there, the papilla of each pyramid will empty the urine into a minor calyx, which then joins a major calyx and then flows into the renal pelvis and ureter. And then just one other important piece of anatomy to note on these images, this little area of cupping of the minor calyx around the papilla is known as the renal fornix. And that's the area that may rupture. You may have fornicell rupture in the setting of renal obstruction. That's the way the kidney can decompress itself through a back valve. Now the bladder on CT will have a thin uniform wall, just like on ultrasound, and you won't see any intraluminal filling defects normally, so no blood clots, stones, or masses. Now you can see on the non-contrast CT the uniform hypodense appearance of urine, and then on the excretory phase CT you can see contrast excreted, travels into the ureters, and then empties into the bladder and should appear fairly homogeneous. Now ultrasound is the modality of choice for evaluating the scrotum. The scrotal structures are very superficial, which allows us to use a linear probe. Linear probes have higher frequency, which, although gives you decreased depth of penetration, has much higher resolution. So it's also good for thyroid ultrasound. So the adult testis is typically ovoid, measures up to about 5 centimeters, will be slightly echogenic and homogeneous. And when we add color Doppler flow, which will give you a direction of blood flow, the flow should be fairly symmetric. And you can see in this image, the red and blue flow indicates direction of flow towards or away from the transducer, respectively. This structure is adjacent to the testis, and this is the epididymis. So it will typically be posterolateral to the testis, up to about 7 centimeters in length, and will usually be iso to slightly hyperechoic to the normal testis. But it won't have the same vascularity. Usually it will be equal or slightly diminished. And the epididymal head is the largest part of the epididymis. The body and the tail wrap around the testis and are not usually as clearly delineated. Now, here's another normal structure to be aware of. You can see this wedge-shaped echogenic focus within the periphery of the testis, and this is the testicular mediastinum. So this is the site where all the seminiferous tubules will converge to form the reedy testes, and it tends to be peripherally located and hyperechoic. And it will connect to the epididymal head via the efferent ductules. And don't worry if you can't see them because they're not visible. Now here's another example of a normal mediastinum there on the left-hand image. On the right-hand image we have a different patient with what looks like a cystic mass replacing the testicle. What's going on there? When we add color Doppler flow, you can see there's no convincing evidence of flow within this cystic lesion. And this is typical for tubular ectasia of the reedy testes. So what happens in this phenomenon is you get a cluster of numerous small cystic structures replacing the mediastinum. It's usually bilateral and asymptomatic. It's a benign condition, often associated with spermatoceles and intratesticular cysts, and it's thought to be related from partial or complete obliteration of the efferent ducts. You may see it in patients who've had prior vasectomy. The main thing is to not confuse this with testicular neoplasm. All right, so that's it for part 1. I hope you come back for part 2, where I'll talk about renal and bladder calculi and give you a basic instruction on renal mass evaluation. Thank you. This is Introduction to Genitourinary Radiology, Part 2. I'm Dr. Dan Koval. So for this segment, I'll be talking about renal and bladder calculi and also give you a basic overview for renal mass evaluation. So let's start with calculi. Here are axial and coronal non-contrast CT images of the kidneys showing bilateral renal calculi. So the vast majority of renal calculi on CT will be visible. And when we describe calculi as dense, we're typically referring to a density of greater than 500 Hounsfield units. Those are typically calcium oxalate and calcium phosphate stones. But also struvite stones will be quite dense. Struvite is composed of magnesium ammonium phosphate and occur in the setting of urease splitting bacterial infections. Less dense calculi are typically less than 500 Hounsfield units, and those are most commonly urate stones, especially if the pH is low of the urine. These may be invisible on X-ray. This was a study that showed that stones that measured greater than 4 millimeters were typically visible if the density was 500 or more. Density of less than 500, they were often not visible on X-ray, and therefore X-ray probably isn't a suitable follow-up modality in those patients. There are other less common, less dense calculi like cysteine, xanthine, and indinavir stones. Also, another number to remember is a density of 1,000. That's been shown to be predictive of successful extracorporeal shockwave lithotripsy. Stones that have a density of much greater than 1,000 may not successfully fragment. Let's talk about some definitions on CT. So I mentioned Hounsfield unit. That's the scale we use to measure density on CT. And with that scale, water is defined as 0 and air is defined as -1,000. And the term region of interest, or ROI, is when we place a circular ellipse over an area we wanted to measure the density on. So bone is about 1,000. Blood and soft tissue ranges from 30 to 60 Hounsfield units. Water is 0, but there is a range. Fat is typically at least -50, and air, again, is -1,000. Let's look at a case. So you can see in this case, CT scan of the abdomen and pelvis without contrast. The left kidney is mildly hypodense, indicating edema, and also somewhat enlarged. And you can see that the left renal collecting system is also dilated, indicating hydronephrosis. And that's due to a stone in the left mid-ureter. And so these are all findings we see in the setting of renal calculi obstruction. So hydronephrosis, nephromegaly, and then an edematous hypodense kidney. Now, this is a really nice example of perinephric stranding, which you can also see highlighted on the coronal reformatted images. And all that is due to an obstructing calculus here at the left ureterovesicular junction. Now let me just take a minute to go over some of the anatomy here, since it's nicely delineated from the inflammatory fluid. This curvilinear line anteriorly is the anterior renal fascia, also known as Gerota's fascia. This curvilinear line posteriorly is the posterior renal fascia, or Zucker-Kandel's fascia. And those fascial planes delineate the perinephric or perirenal space, which in this case has dilated linear lymphatics due to the perinephric stranding. Also, we have the lateral conal fascia extending posteriorly here, and then the transversalis fascia coats the posterior wall of the abdomen. Two other spaces to mention. Anterior to the anterior renal fascia here is the anterior pararenal space. Sorry for all the anteriors. Posteriorly, we have the posterior pararenal space. We typically perform renal stone search scans without intravenous contrast, but patients get IV contrast for other reasons, and it can actually be helpful. So here's an example in a patient who has right hydronephrosis with perinephric stranding, and there's a delayed nephrogram, and that means that the right kidney is still in the cortical medullary phase, but you can see the left kidney is normally enhancing in the nephrographic phase. When we see a delayed nephrogram, we think of things that can cause that would be delayed arterial inflow, some obstruction to venous outflow, or urinary obstruction. And in this case, it was due to a stone here at the right ureterovesicular junction. All right, now of course, ultrasound is an excellent modality to evaluate for renal stones, especially given that it lacks ionizing radiation. And on ultrasound, renal stones tend to be echogenic, again meaning bright, and show posterior acoustic shadowing. So this superiormost image shows two adjacent stones, and the inferior image shows a stone with very nice posterior acoustic shadowing. Now, how do you optimize posterior acoustic shadowing? Well, you can make sure that your focal zone is lined up with the stone. You can also narrow the sector width of the beam. And if you're enterprising, you can increase the frequency of the probe you're using. All right, now what about this case? You can see an ill-defined echogenic area within the kidney, but it's hard to make out, and we don't really see much posterior acoustic shadowing. What can we do? Well, if you add color Doppler imaging, that can sometimes help. You can see this heterogeneous multicolored artifact called speckle artifact or twinkle artifact, and that can be helpful in identifying stones with only minimal shadowing. And here's the CT for comparison, just to show you that stone. Now, here's a patient with hydronephrosis. So when we see that on ultrasound, you should always try and follow the ureter down, and you can see in this patient it's quite dilated. And then we also have dilatation at the mid-ureter. And then here's the bladder showing a stone at the ureterovesicular junction. Here again, we're seeing the echogenic calculus within the ureterovesicular junction. So even though we typically think of CT for identifying ureteral calculi, ultrasound can be a very valuable tool, and we can occasionally see stones in the ureter. Now, another tool we use with ultrasound to identify whether a stone may be obstructing is to look at the ureteral jet under color Doppler imaging. And you can see in this patient, we did not see a left ureteral jet. So when you compare with the contralateral normal side, if you have an obstructed ureter, there's usually less frequency, shorter duration, and lower peak velocity of the ureteral jet, if you see it at all. All right, now here's an X-ray showing multiple geometric and somewhat rounded calcifications in the pelvis centered over where the bladder would be. And this is a nice example of bladder calculi on X-ray, and it will look similar on CT. They may be rounded or have this geometric shape, and the pattern of calcification will be lamellated or lamellar, where it will have these concentric rings, typical for any calcification that's formed in a hollow viscus. Bladder calculi on ultrasound will look similar to renal calculi in that they'll be echogenic and show posterior acoustic shadowing, as in this case. Also, they'll tend to be mobile, so if you move the patient around, which is an advantage of ultrasound, its dynamic nature, you'll actually see the stone roll around. And just like with dense renal stones, you will typically see speckle artifact when you add color Doppler, as in this case. All right, so let's talk about renal mass evaluation now. I'll start with ultrasound and CT. So on ultrasound, renal masses such as simple cysts will be anechoic, meaning totally black. They'll show increased through transmission, and they'll have thin or imperceptible walls. One thing you always want to do with any presumed cyst on ultrasound is to add color Doppler flow, as there should be none. The pitfalls here could be a renal AVM, could rarely mimic a cyst on grayscale imaging, and also renal lymphoma can sometimes appear cystic. So renal masses on ultrasound that are neoplasms will be hypoechoic or echogenic. They may have vascular flow, and ultrasound isn't really specific for different subtypes of tumor. So this upper case is a hypoechoic solid mass that has vascular flow, and that turned out to be an oncocytoma, whereas this mass on the lower image, which is heterogeneously echogenic, turned out to be a renal cell carcinoma papillary subtype. How do we evaluate renal masses on CT? Well, the first thing to do is to place an ROI on the lesion right here, and that was a density of 9 Hounsfield units. This was a non-contrast CT. Again, look at the aorta, and you'll see that there is no intravascular contrast. This was a simple cyst. So simple cysts will have water density, which is less than 20. I know before I said 0 was water, but there is a range, and if it's less than 20, you can confidently call it a cyst. And these simple cysts will have no septations, wall thickening, or significant calcification. Now, what about this lesion? The density is 51 Hounsfield units. That's definitely more than 20, so this is not a simple cyst. But before you jump to calling it a neoplasm, remember that benign hemorrhagic or proteinaceous cysts can have a higher density, greater than 20, and appear indeterminate on a routine CT scan, so they can mimic a solid neoplasm. So what do you do? So how can you evaluate this? Well, you can do a renal mass protocol CT. So that requires a minimum of 2 phases, a non-contrast phase, which will give you a baseline renal density, and then also a contrast-enhanced nephrographic phase, where lesions will be most conspicuous in this phase, typically. And remember, that occurs about 90 to 100 seconds after the timing of contrast injection. So this patient and the nephrographic phase, the density went up to 55. So how do you interpret that? Well, generally a difference of less than 10 Hounsfield units between the non-contrast and the contrast-enhanced indicates that there is no true enhancement. A difference of greater than 20 indicates definite enhancement. And then there's a gray zone of 10 to 20 Hounsfield units where there's no agreed upon number. Some say 15 to 20 indicates true enhancement, but again, there's no agreement. So this patient, the difference is 4 Hounsfield units. That's less than 10. You can confidently call this non-enhancing, and this is a benign hemorrhagic cyst. Bosniak category 2, it needs no additional follow-up. This is that lesion I showed you earlier on the non-contrast image, consistent with a simple cyst with a density of 9 Hounsfield units. When we give contrast and we have the nephrographic phase, the density increases to 12 Hounsfield units. That's a density difference of 3 Hounsfield units. Again, that's less than 10 Hounsfield units, and you can confidently say this is non-enhancing. This is a simple cyst, Bosniak category 1, needs no additional follow-up. In this case, the density on the non-contrast image of this mass arising from the posterior right kidney measures 23 Hounsfield units. That's greater than 20 Hounsfield units, so you cannot diagnose this as a simple cyst. It's not water density. So we give contrast, and the density increases to 171, which is a difference of 148 Hounsfield units. That's definitely greater than 20, and this is definitely enhancing. This turned out to be a renal cell carcinoma clear cell subtype, which tend to be the most hypervascular of the renal cell subtypes. So numbers to remember, if it's less than 20 on a non-contrast scan, it's consistent with simple fluid. If the density difference is greater than 20 on non-contrast to enhanced scans, that's diagnostic of true enhancement and probable neoplasm. For the last segment, let's talk about renal mass evaluation on MRI. So before talking about using MRI for renal masses, let me just touch upon some basics on how to identify what image you're looking at on MRI. So mainly we have T1 and T2 weighted images, and water will be dark on T1 and bright on T2. And you can remember the number 2 is in both H2O, water, and T2 weighted image. So you can identify the sequence you're looking at by looking for any kind of fluid or water. Whether you're looking at a brain MRI or spine MRI, you could see CSF in the spinal canal or ventricles, urine in the bladder and collecting system, anywhere you might have fluid. So in this case, you can see in the uppermost image, the fluid in the spinal canal is dark. That must be a T1 weighted image. And on the lowermost image, it's bright. So that's some type of fluid sensitive or T2 weighted image. Now, certain things will be bright on T1 and T2 weighted images. So fat is typically T1 bright. You can see the subcutaneous and intra-abdominal fat here. Hemorrhage may be bright depending on its age. Complex proteinaceous fluid, like that in a hyperdense renal cyst, will often be intrinsically T1 bright. Melanin, as in certain types of melanoma, will be bright. And gadolinium, which is the contrast agent we use. Now on T2 weighted images, fat is typically bright. Hemorrhage may also be bright, again depending on its age. And then simple fluid or water like CSF, urine, water in cysts, edema, or infection with inflammatory fluid will all be bright. And you can see there's the CSF, urine in the collecting system. There's a simple renal cyst, that's T2 bright. So you can see from this, both fat and hemorrhage can be T1 and T2 bright. That's a good rule to remember. All right, let's look at a case. So here we have T1 and T2 weighted images showing the left kidney, and within the left kidney there's a mass. It's T1 dark and T2 bright. And also note that it's iso-intense to the adjacent CSF on both sequences, so you know it has to be simple fluid, and this was a simple cyst. When we give gadolinium, you can see that the cyst is dark, meaning it's not enhancing, it's not taking up any contrast, and therefore it's not a solid neoplasm. And even though this is a T1 weighted image, you can see the fat is dark, and that's because it's a fat suppressed image where we've nulled the signal from fat, canceling it out and making it dark, which we typically do whenever giving intravenous contrast because you don't want the bright background signal of the fat interfering with your assessment of enhancement. And in case you didn't believe that this was actually a simple cyst, here's the CT showing that the density was actually 9 Hounsfield units. Again, that's less than 20. That's classic for a simple cyst. Here's another case, also with T1 and T2 weighted images. These images are fat suppressed, and that's why the fat is dark, because again, remember that fat is usually T1 and T2 bright. And we can see there's a right renal mass. And on T2, it's bright, so you may think it's a simple cyst, but then looking at T1, it's also bright, which you know is not consistent with a simple cyst. So we give gadolinium, and you can see that the lesion is bright, but not as bright as the surrounding kidney. So how do you interpret that? Do you assume it's enhancing because it's bright on post-contrast images? No. First, you would want to do subtraction images, which is a powerful tool that we can do with MRI. That's when you subtract the post-contrast from the pre-contrast images, and that leaves you with a series that shows true enhancement. So everything that's bright on a subtraction image is actually enhancing, like the kidney, the inferior vena cava, but notice the mass itself is not enhancing because it was actually a benign hemorrhagic proteinaceous cyst. So any lesion that is intrinsically T1 hyperintense, you must do subtraction images after gadolinium. Otherwise, you can't accurately assess whether it's truly enhancing, and that's a standard protocol for renal MRI. All right, thank you for staying to the end. That was part 2. For part 3, next time, I'll touch upon CT urography, review bladder and urethral diverticula, and then discuss scrotal pathology. See you then. This is Introduction to Genitourinary Radiology, Part 3. I'm Dr. Dan Koval. So for this final segment, I'll give you a brief overview of CT urography. We'll discuss bladder and urethral diverticula, and then we'll review basic scrotal pathology. So let's start with CT urography. Now, the most important phase of the CT urogram is the excretory phase, and that's when contrast opacifies the collecting system, ureters, and bladder, as in this case. And with this phase, we can identify any filling defects in the collecting system, ureters, and bladder, as well as detect neoplastic masses and areas of wall thickening. Note as well that the patient is in the prone position here. That can help distend the ureters, but also gives you information about mobility of any filling defects you may discover. Also recall that the excretory phase begins at about 3 minutes after the time of injection and then starts to wane at 15 minutes. Now, there are various post-processing techniques you can do with CT urography. One of those techniques is generating maximum intensity projection, or MIP, images with thick slab reconstruction. And a MIP is a type of reformatting process that takes the voxels with the highest attenuation value on every view throughout a given volume and projects that onto a single image. So what that does is display high-density structures like bone and contrast material-filled structures preferentially, and everything that's less dense is not as well visualized. So in this case, you can see the right ureter containing excreted contrast, very conspicuous, as well as the bladder. You can also adjust the obliquity of these images, as in this case, to highlight a particular structure. Another technique is to generate 3D volume rendered images, as in this case. This is a surface rendering of the collecting system, ureters, and bladder, showing a normal patient. And this is a great way to further characterize complex geoanomalies like congenital anomalies. Looking at a case, you can see that the left ureter is dilated and contains excreted contrast, as well as a dependent filling defect. This patient was scanned in the prone position. You can see the table there. Moving inferiorly down the ureter, you can see that there are additional filling defects, and also that the ureter is focally dilated at this level. And the excretory phase is excellent at identifying tumors such as transitional cell carcinoma and other filling defects involving the renal pelvis, ureters, and bladder. This was a patient with multifocal ureteral transitional cell carcinoma. Note also how the ureter is focally dilated at the level of the masses here. That's classic for TCC and known as the goblet sign or chalice sign, where the ureter accommodates the slow growth of the tumor. This is a different case showing excreted contrast within the urinary bladder. The contrast is very homogeneous throughout the bladder because the patient either walked around or was rolled before the scan in order to mix the excreted contrast in the bladder with the unopacified urine. And you can see again the patient's in the prone position, but there's also a polypoid intraluminal mass at the right ureterovesicular junction. And then looking at the right kidney, you can see that there is associated right hydronephrosis and dilatation of the visualized proximal ureter. So the CT urography is also excellent at detecting bladder wall thickening in any polypoid intraluminal masses, not only on the excretory phase, but on additional phases I'll discuss on a separate lecture series. And this patient did have a transurethral bladder tumor resection yielding muscle-invasive papillary transitional cell carcinoma. CT urography is also excellent at detecting collecting system abnormalities, as in this case, this is a patient with bilateral coronal MIP images showing marked distortion of the calyces, and this is typical for papillary necrosis. And this was a patient who had papillary necrosis secondary to sickle cell disease. Just for comparison, here's a normal coronal MIP of a different kidney showing that normal calyceal architecture. You can see the normal cupping of the minor calyx around the medullary pyramid apex, as well as the normal fornices. Papillary necrosis is actually ischemic necrosis involving the tips of the medullary pyramids. Remember, the pyramidal apex is the papilla. And what happens is that as that becomes ischemic, part of the papilla may slough off into the collecting system and leaves a void that fills with contrast, and that distorts the calyceal architecture. And that has a variety of appearances that have been cleverly described, like lobster claw, ball on a T, signet ring. Here's an example of ball on a T. But usually you just get an extensive distortion of the normal collecting system architecture. This is a different case of a patient with papillary necrosis involving a single pyramid. And you can see it has that ball on a T appearance again. It's upside down, but it still applies. So the tip of the medullary pyramid has become ischemic and filled with contrast as it's left a void. And then on the coronal MIP image, you can see it again there. And then also on the 3D volume rendered reformat. This is a different case of a patient with multifocal papillary necrosis. See the multifocal ball on a T appearance on this coronal MIP reformatted excretory phase image. And on the lower image, which is non-contrast, you can identify extensive renal parenchymal scarring, a finding that often coexists with severe papillary necrosis. So different causes of papillary necrosis, you may use this mnemonic postcard to help you remember. P would be pyelonephritis. O is obstruction, usually if it's chronic. S would be sickle cell disease, and that usually gives the most impressive variants of papillary necrosis. T, it would be TB, tuberculosis, which will often give you additional areas of amorphous calcification in the kidney, as well as asymmetric caliectasis due to infundibular stenosis. And then much less common causes would be cirrhosis, analgesic nephropathy, renal vein thrombosis, and diabetes mellitus. So if you just remember the post from postcard, I think you're in good shape. All right, looking at a different case here. This is an excretory phase coronal MIP reformat. And you can see the right kidney has a normal collecting system with a single ureter, but the left kidney has a duplicated collecting system and 2 ureters. When we have complete ureteral duplication, there's a rule that applies, and that's the Weigert-Meyer rule. So that rule states that with complete ureteral duplication, the ureter that drains the upper pole moiety passes through the bladder to insert medial and inferior to the ureter draining the lower pole. And you can remember that with this mnemonic dummy, DUMI. And usually the upper pole moiety will end as an ectopic ureteral seal, as in this case you can see the upper pole moiety ends as this dilated region of the distal ureter. And that's been described as a cobra head or spring onion appearance. You can also remember that the upper pole moiety tends to obstruct, whereas the lower pole moiety tends to reflux. And you can also remember that vowels and consonants stay together there. So upper obstructs, lower refluxes. There is some overlap with that, but it's a general rule. And also when the upper pole does obstruct, it can exert mass effect against the lower pole moiety and displace it, and that can cause the drooping lily sign. Now that's more of a older intravenous pyelography sign, because in that case with an IVP, you would only see excreted contrast within the displaced lower pole moiety, giving the drooping lily sign. On a CT urogram, though, even though the upper pole doesn't excrete contrast, you would still identify it on other sequences. All right, so that's a really quick overview of some of the things you can identify on CT urography. Now let's talk about bladder and urethral diverticula. The uppermost image here is a coronal MIP excretory phase reformatted image of the pelvis. You can see that here's the pubic symphysis as a landmark. And then you can also identify excreted contrast within the bladder, which communicates through this narrow mouth into a large diverticulum arising from the dome. And this lowermost image is a surface volume rendered 3D reformat, again showing that narrow neck leading into a large diverticulum. So bladder diverticula are typically acquired, more common than congenital, and they're usually multiple and have a trabeculated wall. And we see them more commonly in patients who have chronic bladder outlet obstruction, typically older men with benign prostatic hypertrophy. One thing to know with bladder diverticula is if it has a narrow mouth, a narrow neck, it will tend to drain much more slowly into the bladder. And those diverticula are much more likely to have stasis and an increased risk of infection, and also stone formation and epithelial dysplasia and ultimately cancer. So here's an example of a patient on a retrograde urethrogram that had contrast filling the bladder and then also extending through this narrow neck into the diverticulum here. And then after voiding, the bladder emptied, but then you can see this is all contrast still within the diverticulum. So that would be one with a narrow neck showing stasis. Now we're looking at a sagittal T2 weighted image of the pelvis. And you know it's T2 weighted because the bladder is bright, and simple fluid, water, urine will be bright on T2. Some additional anatomy. Here's the pubic symphysis anteriorly. Then there's the urethra. There's the vagina, and then the rectum and anal canal. And then note anterior and posterior to the urethra, we have this T2 bright lobulated structure, which when you look at the axial T2 weighted images becomes more apparent. It has a yin-yang shape, and that's a urethral diverticulum. The urethra is actually right here, immediately posterior to the pubic symphysis, and you should always get into the habit of looking for the urethra on any cross-sectional imaging study through the pubic symphysis because you may incidentally detect a urethral diverticulum, especially if a patient has a history of recurrent pyelonephritis, because these patients often have recurrent UTIs, post-void dribbling, and other symptoms. And we also have an image here of a post-gadolinium T1-weighted fat-suppressed evaluation showing that there's no abnormal enhancement within the diverticulum because there is a slight increased risk of malignancy. So MRI is an excellent tool for detecting urethral diverticula and characterizing. Now, VCUG, or vesicourethropography, is also an excellent tool to detect urethral diverticula. This is the initial image showing the bladder connecting to the urethra, and then we have this dilated collection there. And after the patient voided, there's still pooling of contrast within that urethral diverticulum. And you can see that's why you would have increased stasis leading to infection. So if a diverticulum is not detected or fully characterized on VCUG, that's when MRI would be the next best modality. So the final section we'll talk about is the scrotum. Now we're looking at an ultrasound of the scrotum. Here is the normal testis, but then you also notice there is this dilated tubular structure that's been isolated for measurement, and that measures about 6 millimeters. And that's pretty classic for a varicocele. So the definition for varicocele is somewhat variable depending on the source you review, but generally a peritesticular vein that measures 3 millimeters or more is consistent with a varicocele. And they form as a result of incompetent valves in the gonadal veins, the testicular veins. And most of them are left-sided, 85%. And that's because the testicular vein drains into the left renal vein at a 90-degree angle, and then the SMA compresses that left renal vein, and that causes increased back pressure into the gonadal vein, the testicular vein. So if those are large, they can cause infertility and pain. Now, there are certain maneuvers that should be done when evaluating a varicocele. You can see in this uppermost color Doppler image, we see no significant flow about the varicocele. However, when we have the patient bear down or Valsalva, we see marked flow within the varicocele and increased diameter to 5 millimeters. So Valsalva-induced flow augmentation should be done when the patient is supine or upright, and you'll see increased flow, ideally reversal of flow. Now, if it's isolated to the right side, as in this case, which is a right varicocele, that raises suspicion for an underlying retroperitoneal mass or lymphadenopathy compressing that right gonadal vein, because the right gonadal vein enters the IVC obliquely at a less than 90-degree angle and isn't really prone to physiologic vascular compression. So those patients need to be further evaluated with either ultrasound or CT. This patient went on to have a CT scan of the abdomen showing retroperitoneal conglomerate lymphadenopathy in the expected region of where the right gonadal vein would drain obliquely into the inferior vena cava, causing that compression. And this was metastatic retroperitoneal lymphadenopathy from prostate cancer. So whenever you have an isolated right varicocele, definitely continue the workup. This is a different case, a transverse image showing both the right and the left testicle. And you notice that the right testicle is markedly heterogeneous on grayscale images. Now, when we add color Doppler, you can see that there's absolutely no intratesticular vascular flow. And given that the testis is heterogeneously hypoechoic, this is consistent with an infarcted non-viable testis. This testis will likely need to go on to orchiectomy. You do still want to compare with the contralateral testis, though, and you can see the left testis does have normal vascular flow, and again, no flow within that right testis. There is, however, peripheral curvilinear region of hyperemia within the scrotal wall, and that's an inflammatory reaction you sometimes see in the soft tissue in the setting of prolonged torsion with an infarcted testis. So this is typical for late testicular torsion. With early torsion, though, you often will have no grayscale changes and just loss of vascular flow, and those patients need to be emergently treated because the testis can be salvaged. Now here's a different example of a flow abnormality. This is a color Doppler image showing marked hyperemia within the epididymal body and also in the adjacent scrotal wall. And this is classic for acute bacterial epididymitis. So this is caused by a retrograde spread of organism from either the urethra or the prostate, and the infection usually spreads from the tail of the epididymis to the body and the head. And the typical finding is on ultrasound, the epididymis will be enlarged, hyperemic, and then become dark, hypoechoic due to edema. And usually that hyperemia will precede any grayscale changes. Now let's look at the rest of the scrotum in this case. So again, you can see that the epididymis and scrotal wall are hyperemic, and that scrotal wall is also quite thickened asymmetrically. Note also the right testis is heterogeneously hypoechoic. Here's another image showing that. And there's a hydrocele on the right, which is just fluid in the scrotum, and in this case it's simple, anechoic. So whenever you have a heterogeneously hypoechoic testis, you want to make sure that there isn't torsion going on. So we add color Doppler flow, and there's quite the opposite. You have intense hyperemia. So not only does this patient have epididymitis, but they have orchitis as well. So this is an example of epididymal orchitis, also bacterial. So the majority of epididymitis cases occur in isolation, but 20% of the time you can have associated orchitis. And on the other hand, orchitis usually occurs secondary to epididymitis. One exception to that rule is mumps. Patients with mumps, usually younger patients, can have isolated orchitis. And the findings of orchitis on ultrasound will be similar to epididymitis, where the testicle will be enlarged, hypoechoic, and hyperemic. And it's important if you have a patient with isolated orchitis that's older than 60 to ensure follow-up, because testicular lymphoma can mimic orchitis. It can cause testicular enlargement, be hypoechoic, and even somewhat hyperemic. This is a different case, a 51-year-old male patient with a hypoechoic testis. But instead of diffuse involvement, we have a well-circumscribed hypoechoic mass on sagittal images and then also transverse. So whenever you have a hypoechoic testicular mass, you want to add color Doppler imaging, and here we do have extensive intralesional vascular flow. That excludes the possibility of abscess, subacute hematoma, or infarct, and is highly suspicious for neoplasm. And indeed, this was a seminomatous germ cell neoplasm. So germ cell neoplasms are the vast majority of testicular neoplasms, about 95%. And the most common pure subtype, meaning a tumor with only one histologic subtype, is seminoma. And the ultrasound findings vary, but they are typically homogeneously hypoechoic, well-defined, and don't tend to have calcification or cystic areas. Now, compare that to this case. This is a younger patient, a 24-year-old male with a very heterogeneous, ill-defined mass in the testicle of mixed echogenicity and with some areas of central anechoic cystic change, a very heterogeneous mass. This is typical for a non-seminomatous germ cell tumor. And these tumors tend to be mixed cell types, more than one cell type. So unlike seminoma, which is usually a single cell line, these tumors might have a mix of different non-seminomatous malignancies, such as a mix of embryonal cell, teratoma, yolk sac. And the ultrasound findings are usually the opposite of seminoma, but can overlap. They tend to be heterogeneous, ill-defined, and calcification in cystic areas are more common. So those are the basic categories of testicular tumor. Non-seminomatous occur in younger patients and tend to be more heterogeneous, whereas the pure seminomatous types tend to be more homogeneous and in older patients. All right, that's the end of parts 1 through 3. Thanks for listening in to the end, and I hope you enjoyed the series. Stay tuned for more from radiologisthq.com.
Hi, this is Elliot Fishman, and this talk is going to be on CT of the kidney, some of the basic principles, techniques, and clinical applications. Again, in one talk on the kidneys, it's hard to cover everything, but you'll see in this series we're going to have several talks on the kidneys. Now, when we speak about malignancies, we talk about a number of different tumors, and the one that I'm going to focus on today is going to be on renal cell carcinoma and transitional cell carcinoma. Now, when you look at some of the magic numbers, 58,000 plus Americans will be diagnosed with renal cancer this year, and an estimated 13,000 plus patients will die. Worldwide, the deaths are over 100,000. Over 40,000 of these cases and 12,000 deaths will be due to renal cell carcinoma. When you look at some of the demographics, typically the patients are over age 55, and it occurs more commonly in men. 92% plus cases are clear cell renal cell carcinoma, and about 8% are papillary renal cell carcinomas. When you look at some of the demographics and risk factors, more common in men, Smoking, obesity, high blood pressure are considered risk factors. So is long-term dialysis. Patients with unusual syndromes like von Hippel-Lindau get renal cell carcinomas at increased rate, but also they get them much earlier. They get multiple renal cells when they're in their 20s. So that's a very unusual syndrome. And also certain exposures, phenacetine-containing analgesics are one of the things people talk about. Now, when you talk about clinical presentation, we always think and talk about carcinoma with hematuria, but you can see from a presentation perspective, only about 40% of patients present with hematuria. 40% present with flank pain, palpable mass, weight loss, fever, hypercalcemia. You can see the lower things, palpable mass, weight loss, that tends to mean the patient has metastatic disease. Now, the good news is, as we'll talk about, the majority of patients these days with renal cell carcinoma are picked up by serendipity. We pick up an incidental mass because we're scanning the patient for abdominal pain, trauma, or many other reasons, appendicitis. What's nice about this, of course, is the earlier you pick up a renal cell, the more likely it is to be resectable. And we'll speak about that in detail later. Now, I mentioned the most common cause of renal cell, the most common symptom for renal cell is hematuria, but it's important to remember that hematuria can be due to many other causes, whether it's vascular, glomerular, uroepithelial, or just a range of miscellaneous causes. And this becomes very important. We also need to talk about hematuria as microscopic versus macroscopic hematuria. Microscopic hematuria is far more common, and when you look at the numbers, microscopic hematuria is rarely associated with neoplasms. Macroscopic hematuria is commonly associated. So some magic numbers. In patients with microscopic hematuria, neoplasm is uncommon, and in the largest study, upper urinary tract TCC was found in only 0.2% of cases, renal cell in 1%, and bladder cancer in under 4%. And those are typically older population patients with bladder cancer. However, with macroscopic hematuria, the risk for malignancy is high and can be found in up to 28% of cases, and even 10% of patients younger than age 40 with macroscopic hematuria can have a renal cell cancer. Now, the whole area of renal cancer, the whole management and treatment has changed over the last decade. Remember, in the past, the only way of treating renal cell was doing a nephrectomy. And so whether you had a small mass or a big mass, you got a classic nephrectomy. Now, classic nephrectomies do occur, but partial nephrectomies or nephron-sparing surgery is indeed becoming much more common. We also see many patients with smaller lesions getting ablation, whether it's RF ablation, or it's microwave ablation. And then we talk about other things from chemotherapy, some new chemotherapy in patients with metastatic disease, and immunotherapy, as well as vaccine therapy. Now, even in terms of partial nephrectomy, we are changing who can get a partial nephrectomy. Initially, it had to be that the tumor was 4 cm or less, but now 7 cm is the usual cutoff, and partial nephrectomy can be done in T2 tumors over 7 cm in select cases when the patient has poor renal function and the need is to save the kidney. Location of tumor is critical in selecting patients for partial nephrectomy, and CT has become a very important part in really allowing us to decide whether or not a patient can get a partial nephrectomy based on location of the tumor and its relationship to vessels, renal hilum, and the like. When we read a CT scan, we're really trying to answer some key questions. What's the size of the primary tumor? Is there vascular invasion, particularly venous invasion? Is there adjacent organ invasion? Are there nodes involved? Are there distal metastases, be it lung, liver, or bone? So there are many things we look at, but let's go back a little bit of a step. Let's talk about the challenges we face. One is optimizing lesion detection. Well, one of the things we'll speak about is that we've gotten so much better in lesion detection. Almost every patient over age 50 has a small renal lesion. We haven't done as well in lesion classification, okay? We see many small lesions and people report tiny lesion in the kidney, too small to classify further. What does that mean? Are you worrying about a cancer or is it just a small cyst? So again, detection gets better and better with our new scanners. Classification hasn't quite kept up with that, and we'll speak about that. And then, of course, one of the challenges is providing information to the referring physician. Urologists want to see things beyond the axial plane, and so multiplanar and 3D become very important. Now, I mentioned the part about the fact that 2/3 or so of lesions are picked up by serendipity. And you can see this article by Dyer made the point a couple years ago, as the size of these incidentally discovered lesions decreases, the proportion of benign lesions increases. However, while great strides have been made in lesion detection, characterization has lagged. And you can see numbers. This was an article going back some years from the Cleveland Clinic, that a quarter of lesions resected that was smaller than 3 cm were indeed benign. And so it's important to recognize the smaller the lesions you look at, the more they're going to be benign. This article by Stathovsky, 30% of tumors under 2 cm in diameter and 20% of those greater than 4 cm in diameter were actually benign lesions. And a benign lesion could be a complex cyst. It could be a oncocytoma potentially, I guess. It could be a lipid-poor myelolipoma or a lipid-containing angiomyolipoma. So again, with small renal tumors, a differential diagnosis, and yes, we're always thinking about renal cell, but it's important to remember that not every lesion is going to be a renal cell carcinoma. The American College of Radiology is trying to deal with these incidental findings. This article by Berlin, published a couple years ago. In general, large, over 3 cm renal masses are likely malignant. Similarly, the smaller a mass, the more likely it is benign. In addition, a small renal cell is more likely to be low-grade and indolent behaving than a larger one. Therefore, we've suggested that solid masses under 1 cm be observed. And so this observing means just simply getting follow-up CTs. Dr. Olive at Hopkins is following a number of older patients with lesions under 2 cm to see if it's worthwhile removing them. Remember, many of these small tumors are indolent tumors. They're not growing. Perhaps the best thing is to do nothing. In patients with additional comorbidities, maybe less is indeed more. Observation, this article by Berlin says, may be considered for solid renal masses of any size in a patient with limited life expectancy or comorbidities. So again, we're trying to understand how we need to manage patients. Removing a mass is not always going to be the best strategy. Now, in CT of the kidneys, protocol, like everything we speak about, becomes critical in our accuracy. And in the kidney, there are decisions. Contrast injection protocol, volume of contrast, injection rate, what's the collimation that we use, what phases do we get? Well, if we did not have an issue with radiation dose, I would get 4 phases on everybody. But we want to minimize the dose, and so it's very important to minimize the phases. You need to do enough phases to get the right answer, but no more than that. So how do we choose that? And then the importance of post-processing, which I'll discuss. In this article by Pam Johnson, talking about some of the pitfalls, one of the biggest pitfalls really revolves around the technique we use. With the goal of refining performance, we show the specific findings that are unique and where the errors and pitfalls occur. So maybe one way of thinking about errors and pitfalls is to look at the various phases, make the point that there's no one perfect phase, and every phase has certain advantages and certain disadvantages, and it's the use of several phases together that really gives us the best answer. So let's look at each phase carefully. Non-contrast. Now, I will say for many things these days, we don't do non-contrast CT and contrast CT. Liver, people used to do non-contrast routine liver imaging. We don't do that any longer. You don't need to. But in the kidneys, non-contrast can be helpful. Several things. Non-contrast tells you the density of a lesion. If you see a homogeneous renal mass and it measures over 70 Hounsfield units on non-contrast CT, there's a 99.9% chance it's simply a high attenuation renal cyst and it's not a tumor. So if you look at this lesion in the left kidney and you say, aha, could this be a renal cell? Theoretically, yes, but you measure it at 73, it's well defined, that's a high density renal cyst, it's a leave alone lesion. Now I know most of us will give IV contrast, and you'll see when you give IV contrast, whether it's arterial phase or venous phase or delayed phase, a high density renal cyst does not change its attenuation. And an example is this case. Look at the left kidney, that anterior mass. It measures almost 70 Hounsfield units, 67 plus or minus 13 on the non-contrast CT. And when you narrow the window, it stands out even better. Well, you give IV contrast. Now you look at the lesion and it's 68. It's not enhancing. But one would have to admit, and this is the value of non-contrast, if I didn't have the non-contrast and I only had this phase, I would say there's a solid mass in the left kidney. It measures 68 Hounsfield units. It's a papillary renal cell carcinoma. Okay? With the non-contrast, I'd say, wait a second. And then sure enough, you have delayed phase imaging, and it's 69. It does not change attenuation. And so now you're looking at a lesion that if you only had delayed phase, you would say it's a renal cell carcinoma. But now with the non-contrast, arterial and delayed, I see a lesion that I could have called on the non-contrast probably benign, but it doesn't change over the enhancement phases, and that's classic for a high-density renal cyst. It's a leave-alone lesion. If you had only the other phases, you would have probably resected that lesion. Another example here. This lesion looks worrisome. It looks solid, but it measures 15 Hounsfield units in the left kidney. Now, one of the things you'll see, under 20 is most likely benign, but you have to admit it doesn't look like a simple cyst. It measures 15 and just looks wrong. Well, you give contrast, and there it is, arterial phase. When you measure it, it measures 18 or 17. And then you go a little bit later on venous phase, and it's 15. And then you go on excretory phase, and it's 18. So this lesion did not enhance. It stayed the same within 2 or 3 Hounsfield units. That's classic for a high-density renal cyst. I have to admit, if you just visually look at the lesion, you're thinking tumor. So it's very important to measure tumors. I think one of the mistakes people make at times is assuming something is benign and it's really malignant, or assuming something's malignant and it's really benign. So looking at specific numbers, a cursor about 1 cm in size works very nicely. Now, there have been several articles that have looked at this more carefully and tried to say, well, these numbers, how important are the numbers? And a good article by O'Connor. So what they looked at is they looked at the density, and what he found was, and very importantly, mass is over a centimeter. So under a centimeter, you have too much partial averaging. So it's really hard to make rules. So assume a centimeter or better. And remember, under 1 cm, the ACR says simply just follow it. So mass is 1 cm or larger, containing fat with attenuation less than 20 or more than 70. Okay, non-contrast. Under 20, over 70 are benign if they did not have thickened walls or septations, mural nodules, or calcifications. 70 to 20, anything between 20 and 70 was considered indeterminate on non-contrast. And those were the ones you worried about. So it's interesting, kind of matches that first article, 70 or greater, 99% benign. Well, this one's saying under 20, over 70, don't worry about it. Then there's another article came along with Pooler. He kind of did the reverse. He said, let me look at all my renal cells and let's see what they were on non-contrast CT. And when you look backwards, indeterminate lesions on non-contrast CT measured within the 20 to 70 Hounsfield unit danger range, where lesions that were outside these range were benign. So again, now we have additional information from the non-contrast CT. Not only can we have a baseline, but on that baseline, we can really look and predict what we're going to see. In this article by Pooler, the average attenuation was 39.7 in patients who had malignancies. Okay? That's a very good point. When you're under 20 or over 70, it's going to be benign. So again, very, very good look. And so the non-contrast can be very important to us. Now, the reason this becomes very important is sometimes patients only have non-contrast CTs, not uncommon in the ER setting. Maybe it's a stone study. Maybe it's just a rule out anything, and the ER doc was driving you crazy, and they said no contrast. But what you recognize in this scenario, if something measures 10 and it's 3 cm, or it measures 80 and it's 3 cm, you probably can leave the lesion alone and not do anything else. But if it measures 37 non-contrast, you better tell them that they need to do a contrast-enhanced scan, because it's highly suspicious that this may be a renal cell carcinoma. Now, in saying that, when you look at lesions and it looks like this, look at the mass in the left kidney, you see calcifications that look mottled. That's a stippled calcification. To me, that looks bad. You look at the lesion, it measured about 40 Hounsfield units. It's solid. That's not going to be a benign lesion. You give IV contrast. There's some vascularity present, but it's not very vascular, but you can see it is enhancing. It's a solid mass. Lack of vascularity makes you think about a papillary renal cell carcinoma rather than a clear cell. And as you look at the lesion from the coronal display in 3D, early to late phase imaging, you can see the lesion begins to enhance a little bit more in later phase imaging. I have found that with papillary renal cell carcinomas, you may see increased enhancement later on in the study. When you're dealing with clear cell, the arterial phase is typically the brightest phase. And with clear cell, as we'll discuss, we typically think about 100, 110 Hounsfield units and better. Now, when we give IV contrast, a good way of thinking about the kidney is we're doing functional imaging. And depending how soon you scan, the kidney will look differently. And so typically we like to put things into 3 phases. If I inject contrast, and I'm telling you I'm injecting 5 cc's of between 100 and 120 cc's of Omni or Visopaque, 350 or 320. If we scan in about 30 seconds, we consider that arterial or corticomedullary phase. 60 seconds to 70 seconds, some people go to 90 seconds, nephrographic phase, and expiratory phase, we like to say 4 to 5 minutes. Some people wait longer. I'll tell you that I like 4 to 5 minutes because it creates less artifact. So let's look at these phases specifically. Corticomedullary phase, 20 to 45 seconds after injection. I like 30 seconds. It's the phase when the cortex is maximally enhanced and the medulla is minimally enhanced. So the interface between cortex and medulla is about 90 to 100 Hounsfield units. It's a wonderful phase for looking at arterial structures. It's a wonderful phase for looking at preoperative planning because you have a vascular map. Tumor vascularity allows me to say clear cell, oncocytoma, renal cell, papillary. You can see changes in perfusion. Tumor detection may only be in arterial phase imaging or corticomedullary phase imaging for some select tumors. Also, sometimes I can appreciate it's an oncocytoma because of the way it enhances in the early phase. So it's a very, very important phase to me. When you do partial nephrectomies, it creates the vascular mapping we need. So in my mind, I always need early phase imaging. Some people have not been very big on early phase imaging. They say, well, it's just not that good for picking up, and it used to be that it would give you pseudo lesions, but with current state-of-the-art imaging, it's not an issue, and to me, it's super critical to get these vascular maps. You see here with volume rendering in MIP, and then when you have a tumor, I can see the AV shunting. This is a classic clear cell renal cell carcinoma because of the neovascularity, the impressive vascularity, and the shunting. So whether you're using volume rendering or MIP, it's very easy to be very specific. So again, arterial phase really helps me define the lesion. I can tell the difference between clear cell, which this is, and a different tumor. The other thing is, although we like to think about venous phase as the best phase for renal vein and IVC involvement, in tumors that are vascular, you can see the extension of the tumor into the renal vein, IVC, and into right atrium at times because of the neovascularity. And here's a wonderful example of a right renal mass. And look at the extension of tumor into the renal vein. Look at the neovascularity. You know it's a clear cell renal cell carcinoma. And you can see it's growing up. It's not thrombus in the IVC. It's tumor in the IVC, which is growing up into the right atrium. Very, very important. Now, this idea about being able to tell what tumors are becomes indeed very, very important to us. A couple articles have really made the point very nicely. This article by Rupert made the point that clear cell renal cell carcinoma, the average attenuation value was 152, while papillary was only going to be 62. That's quite a spread. And when you use those numbers, his accuracy was 95+% with a sensitivity of nearly 98%. And in fact, when you use the cutoff of 100, the specificity was over 92%, over 100 being clear cell, under 100 being papillary. Now, it's not always going to be perfect. Zhang made the point 90% of clear cells are hypervascular, but not every clear cell. And similarly, 75% of papillary are hypovascular, and 90% of all papillary demonstrate homogeneous or peripheral enhancement pattern. So occasionally, clear cells will be hypovascular, and occasionally papillaries will be hypervascular, but in better than 90% of the cases, you can be very specific. Now, this idea about looking at the vascularity is something that becomes more important. Certain articles, like this article by Sauk, make the point that we can look and predict genetic karyotypes by looking at the vascularity. Genetic makeup of clear cell renal cells affects their imaging features. Imaging features in multi-phase CT allow you to create information that affects prognosis and may predict response to molecular targeted therapies. So, for example, clear cell with loss of Y chromosome enhance more than those without the anomaly in male patients in early phase imaging, and clear cell with trisomy 7 enhance less than those with disomy 7, or renal cells with trisomy 5 enhance more than those with disomy 5 during the excretory phase. So you can see that perhaps the genetic impact and the correlation between CT and the genetics of the tumor indeed becomes very important. This article by Chanarana, ability to non-invasively discriminate clear cell from papillary with analysis of whole lesion enhancement, histograms can potentially affect patient management as those two subtypes have different prognosis and respond differently to available chemotherapy. So again, there's lots of interest in being able to create specific maps that look at these tumors. And again, this whole idea about histogram analysis, this idea about texture mapping becomes very, very important, that we can predict how patients will respond to chemotherapies. This article by Rahman, we looked at 20 clear cells, 20 papillary, 20 oncocytomas, and then calculated how the lesions look differently with a mathematical analysis. This mathematical analysis correctly characterized oncocytomas in 89% of cases, renal cell clear cells in 91%, cysts in 100%, and papillary in 100%. So you can see that simply by analyzing, which means drawing a circle within the mass, allows us to be much more specific. And I think this is really a potential important zone as new chemotherapy comes around. And also in terms of partial nephrectomies, you're more likely to be aggressive on a partial nephrectomy for a papillary, which has a low chance of recurring, than you are for an aggressive clear cell renal cell carcinomas. Now, when you look at papillaries, the reason it's so important to recognize them, they're small typically, though not always. They're usually low-grade tumors. They're usually hypovascular. They can be multifocal, and they have a better prognosis, and they're really ideal for nephron-sparing surgery. A couple of articles by Hertz way back when made this point, that these are low-grade tumors, and the enhancement pattern is critical. Now, papillaries are also one of the tumors that's very easy to miss on non-contrast CT. Look at the image on your left. They're often the same density as normal kidney. They're not large. They may cause subtle bumps. In this case, in non-contrast, you really don't see much of anything. You would miss the lesion, which is kind of obvious on the patient's arterial phase and obvious on arterial phase when you look at the inferior part of the kidney. But again, small lesion, well-defined, perfect candidate for a partial nephrectomy. I also like to make the point with papillaries, because they're so well defined and small, if you're just scanning through a data set and you're not looking for a renal cell, you look at this and you quickly say, well defined, low density, it's just a cyst. And you're going to be wrong. It's a papillary renal cell. So it's very important to be careful. And the ability to visualize these lesions, look at the non-contrast, look at the excretory phase, easy to blow by them in those two phases. The middle phase is pretty easy to recognize. Now, one other tumor that I think we've been able to recognize in select cases is chromophobe renal cell carcinomas. It makes up around 5% of renal cells. The majority of patients are males in their 60s. Often it's an incidental finding. Chromophobes are important because if you knew it was a chromophobe, you would really do a partial nephrectomy, because these are rare to metastasize. The lesions are typically hypovascular, but they're larger than your typical papillary. They sort of fall in between clear cell and papillary, though there's considerable overlap. In this article, we found the maximum diameter was a bit over 5 centimeters, 46% enhanced homogeneously, 85% of the lesions were either completely solid or mostly solid, 14% showed calcification, Maximum mean attenuation was 88, 84 on venous, and 60 on delayed. So you can see that it's kind of closer to the papillary than it is to clear cell. Chromophobes are most likely to present as a well-circumscribed, homogeneous mass, often with a central scar. So again, it's something to think about. So I'll show you a few examples, and the reason it's important. In this case, you'd say, okay, big lesion, pushing in the pelvis, perhaps I should do a nephrectomy. But if you're thinking about a chromophobe, look with enhancement. You see it's not very vascular, looks more like papillary. And papillary, you might say, okay, I'm going to do a partial. And then you look at it, it's bigger than most papillaries, but it's so well defined. And when you look at it, there's a little bit of central necrosis on the delayed phase imaging, very well defined on the 3D mapping. And I think it's worthwhile at least to suggest the possibility of chromophobe. This may impact how the surgeon manages the patient. Or in this example, another case, it looks very similar to the last case, smaller, but there it is, same density as the rest of the kidney, almost, on the axials and on the sagittals. Then you give IV contrast, it enhances, but it's not vascular like a clear cell, so it's not a clear cell. Could it be a papillary? I guess it can. It comes very central, or comes sort of central, where you might worry about doing a partial nephrectomy, but it was so well defined, so indolent looking, we suggested could this be a chromophobe? The lesion was biopsied, and the patient had a partial nephrectomy. It was an aggressive partial, but if they would have thought this was a clear cell, they would have done a total nephrectomy. Now, in terms of functional imaging, venous phase, if you ask me what phase is not necessary for picking up tumors, detecting tumors, I will tell you that if I have cortical medullary phase and excretory phase, I'll see every tumor. Sometimes the tumor shows better in the venous phase, but I'll tell you, I typically will have seen it in other phases. Now, where this phase is best is looking for venous involvement. Sometimes on arterial phase imaging, I showed you a nice example of neovascularity with venous involvement. Sometimes the venous involvement is not that impressive, and sometimes it's hard to tell what's flow-related versus what's really tumor, and that's really where venous phase is ideal. This article by Guzzo from Hopkins a couple years ago showed that CT with venous phase imaging and 3D mapping was always able to show you venous involvement. It was basically 100% accurate. The only time it missed anything was small venous involvement within the kidney, which was not going to be of clinical importance. Now, if you look at some examples, here's a nice case. This is the early phase imaging, and you can see a mass in the right kidney, and it looks like potentially venous involvement. But is this flow-related, or is it really venous involvement? Well, realistically, you know it's venous involvement because you can see a transition in the mid IVC in the liver. You can see it's expanded. There's low density, maybe some vascularity. So I would say even on the arterial phase, which shows a vascular renal cell and tumor extension into the renal vein and IVC, I would have no problem. But I would admit that if you had the venous phase, the tumor is probably shown a bit better. Some of the vascularity washes out. You can see its extension into the mid-IVC intrahepatically, but not into the right atrium, which becomes important. Or in this example, a relatively hypovascular mass, what about IVC involvement? Here it is on the coronal views, arterial phase. The IVC looks large. Is it involved? I think you know it is, but how extensive is it? One would have to admit venous phase involvement is easier to see on venous phase imaging. You see the large renal vein, you see the large IVC, and you see tumor going into the patient's right atrium. Very nicely seen at that example. And here it is on the axial report. Going back one slide to make the point, coronals is spectacular not only for detecting IVC and renal vein involvement, but for defining extent. Sometimes on the axials alone, there's too much partial averaging. Again, volume displays work very nicely for the referring physician. Now, one of the things I'm always concerned about with renal imaging is missing renal masses. Because of the various protocols and timing, I think the kidneys give you one of the greatest areas of potential error. And remember, these are important lesions because we can cure patients with renal cell carcinoma. So if I think about where the biggest mistakes are, it's the wrong phase of acquisition. And I showed you and made some points about that a few moments ago, and we'll come back to it. We also talk about poor display formatting. If you only look at axial imaging, You may miss a lot of lesions, as I showed you, and also extent of lesions with 3D imaging becomes important. And then there's post-processing. Now, let me show you some examples and some pitfalls. In terms of the wrong phase of imaging, remember I told you I really like early phase imaging, but I will be the first to admit that sometimes you can miss things in arterial phase imaging. So I will say to you, when you use early phase or arterial phase imaging at 30 seconds, you need to have excretory phase imaging with it. This alone is not enough. And here's a good example. If you have a small renal lesion that's vascular, but it's intrarenal and doesn't distort the outline, it's very easy to miss. So if you look at this case, for example, look at the patient's left kidney. It looks pretty good, the outline, and maybe you don't see anything, but let me put a circle there, and now you see something, or maybe you still don't see something. Am I imagining something there? Well, there's the coronal of the left kidney, and coronals usually help me, but I'm still not seeing anything definitive. And there's my 3D, and I'm still kind of not doing well. But look what happens when I do the delayed phase imaging. Look how obvious that 2-centimeter renal cell carcinoma is. So again, sometimes small vascular lesions are easy to miss. Or in this next case, again, look at the left kidney, and I'll give you the upper two-thirds of the kidney. Look at the lower pole. Is this a lesion? I don't know. Probably would walk by it. But look at delayed phase imaging. You can see that's a small vascular renal cell carcinoma that washes out. That's so obvious. Or this next example, look at the lower pole of the right kidney. This was not for hematuria. It was abdominal pain. And when you look at the lower pole of the right kidney, it just doesn't look impressive. But look what happens on excretory phase imaging. There's the most subtle change on the early phase in the cortical-medullary interface, which becomes super obvious on delayed phase imaging. So that becomes very important. Phase is everything. Only one phase will give you significant error. Now, if you say to me, perhaps let me only get delayed phase imaging, I will then tell you that some vascular renal cells are missed when you only have delayed phase imaging. So there's no one perfect phase, but give me early and late together, and I'm very, very happy. Now, I also mentioned about missing lesions with display format, and I think if you only look at the axials, it's easy to miss things. And here's just a simple example, which I really like. This was read as negative. Upper pole right kidney. You see, it looks like the upper pole of the right kidney. You're not very impressed. But look what happens on a coronal view. You see the upper pole is really an upper pole mass. It's a classic renal cell carcinoma. It's obvious from across the room, but if you only look at the axials, it seems to blend with the rest of the kidney. So indeed, you need to be very careful. At a minimum, you need to look at coronals and sagittals, particularly coronals. If not, you're going to miss a number of different lesions. And this is just a very nice example. Now, delayed phase imaging I spoke about as critical for picking up small vascular renal cells. It's not a optional phase, it's a mandatory phase that we need to have. When you look at things in delayed phase imaging, you're really talking about CT urography. And CT urography, there were many different ways of doing it: multi-phase, single injection, dual injection, prone, supine, Lasix, no Lasix. Many things were done. In the era of decreased radiation dose, people went from 9 phases down to 1 phase. And when we do at Hopkins, since we give patients 1,000 cc's of water prior to the study, and we have the patient not void before the study, we get good bladder distension and we get good excretion of contrast into the ureter. Well, typically injecting 100 to 120 cc's of Omni 350. Again, that 5 cc injection rate is ideal. And I typically like 4 to 5 minutes as my optimal technique. I save 8 minutes when the patient has known obstruction, or I see known obstruction, or we're looking at a UPJ. And I'll show you why in a moment. CT urography requires axials, coronals, and sagittals. And by giving this hydration, this 1,000 cc's, you can see in this article by Dr. Kawamoto that in about 94+% of cases, we had good visualization. If the patient is not hydrated and excreting contrast, then you're not going to be able to get a good look at the pelvis and ureters. 3D imaging works very nicely. You see the volume rendering here and here showing you the renal pelvis, collecting system, and proximal ureters. And you can play around with the data set and really look inside. We can see duplication of the collecting system. Now, I will say, can I 100% of the time opacify the ureters that nicely? The answer is no. You know that from IVPs. There's often peristalsis. But I would say I'm able to opacify the ureters in most cases very nicely, and then I'm able to look at the ureters not opacified and be able to analyze it the way I analyze a loop of small bowel. Now, when we speak about the renal pelvis and collecting systems in ureters, we're typically talking about transitional cell carcinoma. The most common clinical presentation is hematuria. TCC make up less than 10% of renal cell carcinomas. The age range is about the same. There's certain things that are a bit unusual. These tumors are often multifocal, much more common male to female ratio, and you will often see multiple tumors of the upper and lower tracts. This multiplicity and recurrence is indeed very common. 40% of patients with upper tract TCC eventually develop bladder cancer. So when you're thinking about TCC, you really need to be looking everywhere. You see a lesion, don't become satisfied with the search. Look for other lesions, either contralateral kidney, ureter, or bladder. Remember, with TCC, treatment is nephrectomy, removing of the ureter, and a cuff of bladder, so we're much more aggressive. TCCs, certain things seem to be related, including heavy caffeine consumption, and there's a number of different appearances that allow you to make the diagnosis. Now, sometimes the appearances are subtle and are tricky. Single or multiple sessile filling defects that compress the sinus fat, pelvic seal irregularities with strictures, focal diffuse mural thickening, calyceal amputation, and tumor-filled distended calyces are the classic types of appearances. We talk about large TCCs, they're big challenges. They look more like renal cell carcinomas or even potentially lymphoma. TCCs are hypovascular, so they're often subtle. Look at this arterial phase imaging and look at the right kidney. There's some soft tissue centrally right there, but boy, that's easy to miss because there's no perfusion change. And here it is again in the coronal. There's no changes in perfusion, but when you get delayed phase imaging, now you look at the pelvis and collecting system. You can see it's irregular. You go to the coronal, now you see the destruction of the renal pelvis on the right, destruction of calyces, and on 3D, particularly MIP, look how nicely destruction of the calyces is seen in the upper pole. Again, 3D NPR become critical. Or in this example, one would have to admit this should not have been read as negative. It was an outside study, read as negative. The left kidney, something's going on in the renal pelvis there. I think you should recognize that. Now, they read this as parapelvic cyst, but it's not really cyst. Something looks wrong. You go to the coronal, they would have made the right answer because the coronal, you see the dilated upper pole calyx with amputation more proximally. This is a classic transitional cell carcinoma. Again, coronals will often make it very easy to show the changes in the calyces, as in this case, beautifully shown, that destroyed calyx, the blown out calyx, the infiltration, all very nicely shown. Now, sometimes TCCs are more aggressive, right? In this case, there's something infiltrating the left kidney. Perhaps it's a TCC, but maybe it's a renal cell. And here you can see it's involving the renal vein. When I see renal vein, I'm always thinking about renal cell, but it's important to remember that transitional cell carcinomas can involve the renal vein. And when you look at this a little bit closely, it has that infiltrating process that really makes you think about transitional cell, that nice infiltration which maintains the renal borders, that decreased enhancement. But you can see it has renal vein involvement. And I'm just showing you this in a number of different perspectives to really get a feel of how easy it is to either overlook the lesion or misdiagnose it. Again, very important. And when you go to coronals, you can see here very nicely the tumor infiltration, mid to upper pole. And when you look at the 3Ds, the MIP imaging from the calyces, the upper pole calyces are gone. Indeed, a classic transitional cell. Again, the subtleness, here's one on the right kidney. You look at the renal pelvis, non-contrast, not impressed. You look with contrast, kind of looks funny. And see, it kind of looks thickened here. You see it there. And then you go to delayed phase. Now you see it better because there's something that's not filling in the kidney. And when you look carefully on the coronal, at first glance you say everything looks good, but then you ask, where's the lower pole calyx on the right? You see that hypodense zone right there? And then you look more carefully, and you see the destruction of the lower portion of the pelvis and the lower pole calyx. And there it is right there. So again, this very nice example of a transitional cell carcinoma and very nice use of multiplanar on 3D imaging. Now, when you look at the kidneys, we also need to look very carefully at the ureters. The ureters, if they're not obstructed, tend to be overlooked. We look at the left kidney non-contrast, the pelvis is full, the left ureter may be full. Here it is arterial phase, you see thinning of the cortices, you see perfusion changes, and now you look at the coronal, and you look at the left kidney and you say, perhaps this is a UPJ. Maybe that's why the KLSEs are dilated. But then you look a bit more carefully, and the ureter is thickened, okay? Better seen on the axial. And now you get a few more images. And you can see at the pelvis, it's not the UPJ look, but we'll look further, and there it is on the coronal. You see the thickening of the proximal left ureter? If you have a UPJ, you have a cutoff, but the ureter then has collapsed. It's not thickened, it's not irregular. This is a subtle lesion, but it's causing obstruction, and it was a transitional cell carcinoma. Now, this whole idea about looking at the ureters to me is very important. Now, I mentioned before you can't always get perfect opacification with contrast of the ureters, but so what? The way I look at it, and the reason I don't worry about waiting more than 5 minutes, when you're obstructed, you know from IVP days, you need to wait hours to get the pelvis and ureter opacified. On the other hand, an obstructed ureter, like obstructed bowel, is filled with fluid. It's not collapsed. We give lots of water. So look at the right renal pelvis and the ureter. You can see it's dilated. Now we look for where the transition point is, which is distally, and we can see very nicely the transition point. As I go to sagittals, you can see the soft tissue infiltration. That's a transitional cell carcinoma. Now, yes, you can see it in axial views if you looked very carefully. You see the ureter with water, then you see a solid component in the ureter. But one would have to admit it becomes much more obvious when you look at this image, and then you look at that transition point right there, and you look at it on the sagittal view as well. That was a so-called goblet sign. Very nice example of a goblet sign, but a very nice transition point, and that's a classic TCC of the ureter. Now, with TCC of the ureter, thickening is the most common finding. You may see abnormal enhancement, you may see dystrophic calcification, you may see stranding, and of course hydronephrosis and hydroureter. The ureteral tumors are most common in the distal ureter compared to mid and proximal ureter. Transitional cell carcinoma accounts for 90% of ureteral tumors, with squamous cell about 10% and adenocarcinoma under 1%. Again, age 60 is very much in the same age range of renal cell carcinoma. As I mentioned in the good article by Shiva Raman, it's a challenge to look at the ureters, okay? But again, the key is multiplanar on 3D imaging. It's looking at the full sequence of images, looking for some of the transitions. And again, it's subtle, and I'll just review the points I made. Accentuation of subtle strictures and site of narrowing. You need to accentuate subtle abnormal enhancement patterns on 3D imaging. Better visualize the distal ureter with coronals and with 3D imaging. And again, lesions can be subtle and polypoid, but they often cause obstruction, and so they're easy to see if you're very careful. Look at this case, dilated right renal pelvis. There has to be a reason. You follow the ureter downward on non-contrast, it looks more solid. You see the transition point. With contrast, you now see the ureter has some increased enhancement. Now, you can be fooled at times with infection. The ureter can enhance, but you don't see transitions like this. Then you go to the next slide, and there's the soft tissue mass. Okay? So again, it's subtle, easily missed. But if you're very careful, you need to be very, very careful and analyze the images. Good article by Zhu. When stratified by location, urothelial thickening was more predictive of tumor in the pelvic system than in the ureter. In contrast, filling defects were more predictive in the ureter. A couple other examples. Look at this patient, and again, this is where the 3D imaging works well. There's no hydronephrosis in the left kidney, and you look at the left renal pelvis and proximal ureter. Even when you look quickly, you're not that impressed. But look at where I targeted. Look at that a bit more carefully. You want to say it's peristalsis, but look at it more carefully. It's irregular. It's subtle infiltration. There's a transitional cell carcinoma. Now, I mentioned enhancement is often increased at the site of transitional cell, but I also mentioned that at times with infection, ureters can be thickened and you can see enhancement. But then you see lots of stranding, and usually it's much more extensive than with the transitional cell. But again, you need to be careful. There is some overlap, so it may not always be perfect. Now, in terms of subtleties, I think it's amazing the things you can miss. With transitional cell, we often think about the fact that the ureter is dilated, but it doesn't have to be. Look at the ureter here. Look at the left side. And I'll take away the bone, and you look at the left ureter, you see it's like a crescent, but boy, that's subtle. Is there something there, or is it just transition point? Well, look at that more carefully. I don't know, you could argue a bunch, but look at the coronal. There, it's an obvious tumor, okay? Very, very obvious tumor in the left ureter. No mistakes about it, right? Classic TCC. But again, there's no hydronephrosis. There it is on the 3D volume rendering. Beautiful example of a TCC. Look how easy it would be to miss that. It's a small lesion, about a centimeter or less, and there's no obstruction. And if you say, well, that case must have been the world's craziest case, look at this patient. Hematuria, history of prostate cancer. I was taking the bone away to look at the prostate better. Look at the left ureter. I've widened the window. It's critical to widen the window because things often get very dense. And you look really hard, there is like a donut in the left ureter. That's subtle. Maybe it's my imagination. But there it is on the coronal view. Look how nicely you can see that lesion. And here it is again. There's the 3D. And there it is. Look at this case. Patient had previously had the prostatectomy. There's a TCC in the ureter. Look how subtle it is. There's no obstruction. There's some peristalsis in both ureters. But look how easy it was to miss that lesion. Again, the importance of really looking at things very, very carefully. And this article, we made the point that proper diagnosis hinges not only on appropriate interpretation of the axial images, but the importance of using 3D imaging. It's not just an ancillary tool, it's a primary tumor. It's critical to really analyzing these lesions. There's so much you're going to miss. This article by Mullen does make the point. Again, how easy it is to miss transitional cell carcinomas. In patients with hematuria, repeat CT within 3 years is unlikely to show a urinary tract malignancy if the study is done correctly. So again, you need to be very careful. So concluding then, several conclusions. CT with CTA and 3D imaging is a study of choice for the detection and staging of renal tumors. Our accuracy of CT and lesion detection and characterization is highly dependent on scanning protocols. Remember, it's easy to pick up a small lesion. It becomes harder to classify, and it's something we need to spend a lot more time doing. At times, we'll simply need follow-up. At times, you can say MR or ultrasound, but again, with very small lesions, everyone has the same issue. There's lots of pitfalls, and I went through some of the pitfalls with you. And again, this lesion detection is only step one. Also, to make the point, not only with renal cells, but transitional cells, lesions can be very subtle. Anybody can pick up a 10-centimeter mass. It's the smaller lesions, picking them up early when the patient is resectable, when the patient is treatable, when the patient has wonderful outcomes, is really our job. And it's a challenge we face on a daily basis. And with that, I'll say thank you, and I hope you enjoyed the lecture, and see you soon.
Hi, this is Dr. Karen Horton from Johns Hopkins. In this lecture, we'll be discussing CT of the acute abdomen, and specifically, we're going to be discussing GU applications. In this talk, we're going to be focusing on pyelonephritis and stone disease. These are the most common causes of GU presentation of acute abdomen. Specifically, stone disease is probably the most common indication. We'll also be discussing a potpourri of various abnormalities. So let's start with pyelonephritis. The old term for pyelonephritis is lobar nephronia, renal cellulitis, or renal phlegmon. We don't use those terms anymore. And specifically, what pyelonephritis is, it's a bacterial infection of the kidneys, so the parenchyma of the kidneys. Most of the time it reaches the kidneys via the ureter, so it's a result of an ascending infection of the lower urinary tract. So people who get urinary tract infections get pyelonephritis. So they're most common in women and older men, because those are the two populations that get most urinary tract infections. Now, the diagnosis should be made clinically, but often it's the radiologist who makes the diagnosis, either in a patient where it's not suspected, or a patient that you're scanning for a source of infection, or a patient who's septic. The doctors may not realize that it's pyelonephritis. Or also, even in cases of known pyelonephritis, we may do imaging to see how severe it is, to see if there's any complications, or in patients who don't seem to be responding to treatment. The clinical presentation of pyelonephritis is usually fever because it's an infection. It's a urinary tract infection. They may have chills, dysuria, flank pain on the side of the affected kidney, microscopic hematuria, and pyuria. You're going to see that on the urinalysis. And then sometimes you'll get bacteremia. And what that is you're really having sepsis related to the urinary tract infection. So you got bacteria in the urine that can spread to the blood. If you're going to image a patient with pyelonephritis, the technique becomes very important. Now, most of the time we're making the diagnosis, it's not suspected. But if it says pyelonephritis or rule out pyelonephritis or rule out complications from pyelonephritis, it's very important that you time the scan correctly. So IV contrast is going to be essential. It's a very, very subtle finding on a non-contrast scan. So you're definitely going to be using IV contrast. So we would typically use 100 to 120 cc's Omnipeg 350, and we would time the scan to be a little later than our typical scan. So you really want nephrogenic phase. You want the kidney to be well enhanced. Many of the times when we do imaging of the kidneys, we're doing multiple phases, and we may not be suspecting pyelonephritis, so some of the changes are very subtle, for example, on the arterial phase. It's much easier to see pyelonephritis in the complications if you're a little later and the kidney is well enhanced. But clearly, using the IV contrast is the most important part of the study to be able to see how the kidney is enhancing. What you're going to see is an enlarged, swollen kidney on the side that's affected, perinephric stranding, completely nonspecific, but usually you'll see it in patients with severe pyelonephritis. You may see a delay in contrast excretion. So what happens with pyelonephritis, you get dilated tubules, and it takes longer for the contrast to get into those tubules and longer for the contrast to be excreted, and it's very characteristic striated nephrogram, and I'll show you an example of that. The first thing that you see is loss of cortical medullary differentiation, and that's going to be most apparent on your earlier scans where you're going to see loss of the cortex. And then on the later scans, you'll see that striated nephrogram related to the edematous tubules in the kidney. And just be on the lookout, sometimes pyelonephritis may affect only a section of the kidney or a very small portion of the kidney, and it could look like a mass, and it could mimic a renal cell carcinoma. So we're going to be looking for alterations in the renal contour, in the attenuation, really the enhancement of the parenchyma, especially the cortex early on, is going to be decreased excretion, and then perinephric abnormalities, especially in complicated cases. Here's a patient with acute pyelonephritis, left flank pain, and you see the left kidney is a little bit swollen and there's a little perinephric stranding. And again, these are very subtle findings and nonspecific, but in this case you can see that it's related to the pyelonephritis, because when you give the IV contrast, you see that there is not normal cortical medullary differentiation. Here you can see the cortex, and we can follow it all the way around, and here you're losing that differential between the cortex and the medulla. So it's this portion of the kidney that's affected with pyelonephritis. Then you get the perinephric stranding, which is just a reaction to the adjacent infection. A little bit more subtle on this slice, which is a little bit more inferior. Again, you can follow the white cortex and you lose it here. So that's the earliest sign of pyelonephritis that you're going to see on a CAT scan. Here we have the coronal images, and again, here's the right kidney for comparison, and you see good cortical medullary differentiation. On this side, you can follow the white cortex, and you lose it here. It's like it gets smudged, and that's the area of infection, and then the perinephric inflammation. This is a later phase, and you can see it looks a little bit different, right? So you're no longer a cortical medullary phase, you're more nephrogenic phase, and still you get these areas. Sometimes they're wedge-shaped like that, but they're not as discrete as an infarct. These wedge-shaped areas of decreased enhancement related, these are the areas that are infected, so the kidney parenchyma itself is infected. And then on excretory phase images, in this case it's a little bit more subtle here, but again, you see this area that is not enhancing normally. Okay, different patient, left kidney looks pretty good. You can follow the cortex all the way around. It's the upper pole of the right kidney. You're losing the cortical medullary differentiation. And if you look side to side, you can see that entire kidney is kind of delayed in enhancement compared to the left. It's not as enhancing to the same degree as the normal left kidney. So this is all infected kidney parenchyma. Here's a different patient, bilateral pyelonephritis. It's easier to see on the left side where you're seeing these areas where the cortex isn't quite as enhanced. But you can see it's also involving the right side, just this tiny area here where you're losing the cortex. So bilateral pyelonephritis. Also the left kidney is a little bit more swollen and maybe a very subtle delayed enhancement of the left kidney compared to the right kidney. Here's a later scan where excretory phase, just to show you, you're starting to see a little bit of the stripes, and that's the striated nephrogram related to those dilated tubules. Sometimes it can be very subtle. So here, if you're not looking for it, you may overlook it, right? Look at these tiny areas where you're losing the cortex and the lower pole, maybe a little larger area affected here along the upper pole. I mentioned the striated nephrogram from the dilated tubules, and these are the stripes. Okay, so that's urine in the dilated tubules, and so the contrast hasn't gotten in there yet, so it gives you that striped appearance. This is a patient with pretty severe pyelonephritis, a lot of inflammation. The whole kidney looks abnormal, right? It's not enhancing normally. It's really most of the kidney is involved with the infection. Here's excretory phase on a patient, just to show you that it looks different in different phases. And here you can see these segmental areas. That might be a cyst there, but these segmental areas of low attenuation that you see on the affected side compared to the right side. Here's a part on the right side that's also involved. So again, bilateral pyelonephritis is not uncommon. I would say probably 5 to 10% of cases will be bilateral. It can look very mass-like sometime. In this case, you might say, how do you know that's not a renal cell cancer or a transitional cell cancer? Well, if you had more than one phase, it would be easier to see the difference, especially on the corticomedullary phase. So here's another patient with right flank pain. You're starting to get these rounded areas of decreased attenuation, again, on the excretory phase. Some of them are a little bit wedge-shaped, so that's pyelonephritis. And another example of the striations. Okay, those are the dilated tubules. Here's a patient with pyelonephritis in a transplant kidney. So this is the left lower quadrant transplant on a non-contrast scan. Looks a little bit swollen. Here you give the contrast and you see these focal areas of loss of corticomedullary differentiation. And here on the coronal image again, it could just be tiny areas or segmental areas, or the entire kidney in some patients. This is a later phase. They start to look a little bit more mass-like and infiltrative, and that's just the infected tissue. Just to be a little careful about the words we use. So pyelonephritis means infection of the kidney parenchyma itself. A pyelitis is different. It's also an infection, but it's really of the collecting system. So it's of the ureters, for example, or the renal pelvis. And in this case, you can see it's bilateral. A lot of inflammation in the retroperitoneum here. And here you see the ureter. And see how you can see the wall of the ureters? That's very abnormal. Usually you just see the edge of the fluid in the ureter. You don't see a discrete wall. So this is all thickening along the ureters and even the bladder. So this is cystitis and a pyelitis, so infection of the collecting system. Pyelonephritis itself can be treated usually with antibiotics early on, but in some patients it will progress, or if it's untreated it will progress, and you'll get complications such as an abscess. So that's the first complication that you're on the lookout for. And also we're going to talk about a specific type of pyelonephritis called emphysematous pyelonephritis, and that's important for everybody to recognize because it's a surgical emergency. When you're looking for a renal abscess in these patients, you need to be a little careful because we often see fluid density lesions in the kidney and we just assume that they're cysts. But in these patients with pyelonephritis, when you know they have an infection, you have to make sure those small fluid densities aren't abscesses. And you know when they're pretty small, it can be tough on CT to tell the difference. So you're looking for basically a fluid density, could have irregular walls, a lot of areas of inflammation like thickening of Gerota's fascia, extension outside the kidney into the perinephric fat. Could be single or multiple, usually unilateral if there is pyelonephritis. So here's an example. I don't think we're going to confuse this with a regular renal cyst. This looks abnormal, right? You see all this thickening of the wall and you see inflammation. It's almost like it's breaking out involving the right psoas muscle. So that's a renal abscess. Could it be a cystic renal cell cancer? It's possible. Very unusual appearance, though, to break out and involve the psoas, but it's possible. In a patient who has pyelonephritis, the diagnosis is easy, but if you can't tell the difference, you could do an ultrasound, for example, and that's definitely going to be able to help you and say, is this a solid tumor or is it an abscess? Or check with old films, right? Maybe this patient had a scan a couple months ago. You don't grow a cystic renal cell in a couple months, but you can certainly develop an abscess in that time frame. Here you go. And here's the abscess again, mural thickening, very cystic. Just always be thinking, could this be an abscess? We're so used to looking at kidney lesions and calling them tumors. So you have to just remember you can get renal abscesses. Here we go again. Here's a different patient. Now, without any clinical history, and they just say patient has flank pain, you would say that there's this low-density cystic mass with internal septations and mural thickening, right? You may not realize that that's an abscess and not a cystic renal cell. So again, you may want to do an ultrasound. If it's an abscess, they may see the abscess fluid floating around. The worst-case scenario, you're going to have to stick a needle in it, but usually, clinically, it's easy to tell the difference. These people are sick. Okay, there it is on the excretory phase. Here's a patient with pyelonephritis that has the changes that I showed you, loss of the cortical medullary differentiation, a little bit of the striated nephrogram on both sides, and here's a little fluid density, and that's what I was mentioning. You can't just assume that that's a cyst. In this case, it was a small abscess. We had a scan from the patient from the week before, and that wasn't there. That's a small abscess. Here's another patient with pyelonephritis, loss of the cortical medullary differentiation, and they're starting to develop these small, sometimes they're really micro abscesses. Here in the left kidney was infected, and you can see kind of broke out of the kidney, and this is all infection in the left perinephric space involving the left psoas muscle. Here you can see it's starting to mature here into a discrete collection. Here's a patient with pyelonephritis, an abscess, perinephric abscess. It probably started here, and you can see that there's a developing collection surrounding the left kidney. Okay, I mentioned that we wanted to discuss emphysematous pyelonephritis. This is a very specific type of pyelonephritis that's life-threatening. It's basically a necrotizing infection with a gas-forming organism. Regular pyelonephritis usually can be treated with antibiotics. If it's very early on, even oral antibiotics. If it's severe infection, obviously IV. If it's an abscess, it might need to be drained. But emphysematous pyelonephritis is one of those conditions where the patient goes immediately to the OR. It's like a level 1, clear the OR and bring the patient in. If you wait a few hours, the patient becomes septic, and very quickly the patient will become septic, circulatory collapse, and die. So very, very high morbidity and mortality in this condition, and it's a pretty easy diagnosis to make because of the gas formation within the kidney. Most patients have diabetes, usually uncontrolled. These are very sick patients. This isn't an outpatient coming in and being scanned for a little bit of flank pain. These patients are in the hospital, they're septic, they're very, very sick patients. CT is going to be the modality of choice if it's suspected. Most of the diagnoses we made is unsuspected in a very sick septic patient, usually coming down from the units. What happens is that you're going to see that there's destruction of the kidney parenchyma. It's just not that loss of cortical medullary differentiation. It's actually destroyed and necrotic, and you'll see air fluid levels, and you'll see air. Okay, so that's the key. In regular pyelonephritis, you don't see air within the parenchyma. So here's an example. In this case, you might say, okay, that kidney looks swollen. You do have a little loss of the cortical medullary differentiation, so there could be pyelonephritis, a little bit of less enhancement of the left kidney compared to the right kidney, a little bit of air in the collecting system. Now, air in the collecting system isn't so bad. Sometimes you'll see that in infections of the urinary tract, but you also can see it in patients who are post-op, who've had a procedure, or patients who had a Foley catheter. Sometimes the air bubbles up there. It's not the air in the collecting system that's what's important. It's the air in the parenchyma. And you can see here this kidney is just completely destroyed. Okay? The difference between this scan and this scan is just a few hours. Okay? Almost the entire parenchyma has been replaced. This is necrotic tissue with a gas-forming organism, and it spreads very, very quickly. Here's a different patient. You can see air fluid levels. It's in completely necrotic renal parenchyma that's been destroyed by the infection and a lot of air. This is not a pretty scan, but often these patients are really sick. They're not going to be given IV contrast. They're bringing them down, putting them on the table because they're septic and they're unstable. And you can see here, again, the kidney's just destroyed with air fluid levels necrotic, and it's breaking out and will affect the perinephric tissues as well. So they need to go directly to surgery because basically they have to do a debridement of the entire area. Ultrasound can make the diagnosis, but air is sometimes a problem with ultrasound, so usually they'll end up in CT. And this was a patient where they did an ultrasound for pain and they thought they saw air, but it was hard to know what the extent was until you do the CT, and then you can see the entire kidney is necrotic. Other terms, emphysematous pyelitis, again, that would be in the collecting system itself, so in the ureters. That's usually less aggressive. The gas and the gas-forming organisms are confined to the collecting system itself. It's still an important diagnosis that needs to be treated aggressively, but not necessarily have a nephrectomy, again associated with diabetes. Pyonephrosis is a different term. Pyonephrosis means like a severe infection and pus within the collecting system. So often that's an obstructed collecting system. So if you have a kidney stone in the ureter, for example, and you get an infection and pus in the collecting system above the obstruction. Then we have a different type of pyelonephritis called xanthogranulomatous pyelonephritis. Very interesting disease. We see a couple cases a year. It's not that common, but it's definitely a diagnosis that you can make because it has a very specific CT appearance. This is basically a chronic infection. People argue what actually caused it. Is it a chronic subacute bacterial infection that hasn't been treated well, or is it an incomplete immune response to some atypical infection? But what happens is the parenchyma gets replaced by these lipid-laden macrophages, and that gives a very specific CT appearance. You can see that diabetics only represent 10%, whereas the aggressive emphysematous pyelonephritis, 90% of patients are diabetics. Again, the patient may present with pyuria, positive cultures, hematuria. They're often treated for pyelonephritis or urinary tract infections for a long time before somebody makes the diagnosis. The presenting symptoms are usually, again, pain, dysuria, nocturia, fever, a little nonspecific. They know something's going on with the kidney, probably an infection, but clinically it's very hard to make this diagnosis. You really need the CT scan to show you the imaging findings. So what are you going to see on CT? There's almost always stone disease. So the classic CT appearance would be a patient with a large staghorn calculus. Okay, but the stone doesn't have to be a staghorn. It could be in the collecting system, the calyces, or the ureter, but usually you're going to see stones. Because of the intensive inflammatory process, you're going to see decreased function. Sometimes the kidney is swollen, but the most important thing to the diagnosis is you'll see hydronephrosis. And instead of just dilated calyces, you'll see expansion of the calyces. So you see these extra cystic spaces in the kidneys that can help you differentiate it from just hydronephrosis. And it can also break out of the kidney and involve the perinephric space. So here's an example of an article where they showed that it breaks out of the kidney capsule and can involve the perirenal space in a significant number of people. If the diagnosis isn't made, that's what's going to happen. It's going to involve the psoas muscle or even the abdominal wall. So here's an example. I think it's easy to see there's something wrong with the right kidney, right? The right kidney is very large. You can see a stone sitting in here. And you might say that's hydronephrosis, but that's a very weird appearance for hydronephrosis. It's almost like there's too many calyces, right? Because this is that cystic expansion of the calyces, so you get these cystic spaces. Okay, and here you can see there's a little bit of the upper pole of the right kidney that's not involved. And this is an example, too, how it's broken out of the kidney and involved the perinephric space. So this is all those lipid-laden macrophages. Usually you're going to need a nephrectomy in these patients. Here's a different patient, also on the right side, and again, decreased function of the right kidney, huge expansion of the calyces. Looks like hydronephrosis, but not exactly, right? There's too many calyces, and the kidney is swollen. You see a dilated renal pelvis, and in this case, the stone is at the ureterovesical junction, and there's also a stone in the lower pole of the kidney. So these big, it's usually an enlarged kidney with very big cystic spaces related to those lipid-laden macrophages. Just want to mention a little bit about patients who've had chronic pyelonephritis. It's usually an infection that has been poorly treated or incompletely treated, or multiple infections over time. And the CT appearance of that is very different than like a xanthogranulomatous pyelonephritis, because in chronic pyelonephritis you might see scarring of the kidney. The kidney will look small and shrunken. The calyces will be dilated from the scarring and retraction, but it won't look at all like the case of xanthogranulomatous pyelonephritis. So here's a patient with chronic pyelo on the left side, and you can see the right kidney looks normal, good cortical medullary differentiation, maybe a little bit of delayed enhancement of the left. It's smaller. The calyces are a little dilated, and see how they come up to the very edge of the kidney because there's so much cortical atrophy. And on the CT urogram part, you can see it's just a very small collecting system compared to the other side. Be on the lookout for mimics of pyelonephritis, and we'll talk about some of these, including infarcts. So you can see renal infarcts, you lose the cortical medullary differentiation, and that's what we see in pyelonephritis, but this looks very different. It's a very discrete loss, right? You can draw with a pencil the edges of it on the cortical medullary phase. On pyelonephritis, it looks different, right? It's more of a smudge between the areas. So this is a renal infarct. Here's another patient. It's very discrete with an acute infarct. Now, subacute infarcts can sometimes look like pyelonephritis. Those are harder. And this was that patient with that infarct. And then if you think a patient has an infarct, you should be looking at the renal arteries, right, and the renal veins. And here you can see that there's a thrombus in the renal artery. So that's just a nice diagnosis that you can make. Renal vein thrombosis sometimes can look like pyelonephritis, delayed enhancement of this side. You can even get the striated nephrogram, but here you can look and see that there's a thrombus in the renal vein. Here's another example, renal vein thrombosis. So you have to be looking at the vessels as well as the kidney parenchyma. I wanted to talk a little bit about lymphoma just for a second, because the appearance of lymphoma can look a little bit like pyelo, especially bilateral pyelo. So here's a patient with lymphoma excretory phase. You see those round areas of loss of cortical medullary differentiation. In this case, there's big nodes, so the diagnosis is a little bit easier. But sometimes, like in an outpatient, you may see changes and you think it's probably pyelonephritis, but it could be lymphoma because you're remembering this case that I just showed you. So because you won't always have that adenopathy. So in some cases, you would say, I think that this is pyelonephritis. They need to correlate it with the urinalysis and maybe even get a follow-up scan after treatment just to make sure that the kidney resolves completely and that you're not dealing with a lymphoma. Okay, for the last few minutes, we're going to be talking about stone disease. So this is a big problem. If you look in the United States, 1.2 million Americans are affected every year with kidney stones. And you can see it's up to 14% of men or 6% of women will develop stone disease in their lifetime. And people who get stones get more stones. So you could see stone recurrence 50% within 5 to 10 years and 75% within 20 years. So this is a condition where people will repeatedly present with symptoms. Increasing prevalence, huge healthcare cost in the billions every year in the United States related to stone disease. The presentation depends on how big the stone is, what kind of problems it's causing, but also where it is. So it tends to be flank pain, which is in the upper ureter, mid-abdominal pain in the mid-ureter, and if it's in the lower ureter or near the UVJ, you might get groin or testicular pain in men and bladder symptoms. But typically, patients are going to present to the ED with pain and hematuria. There's been a growing utilization of imaging over the years and kind of a progression from using plain films to IVPs to ultrasound and CT over the years. So back in 1896, that was the first time, remember, the X-ray was discovered in 1895. By 1896, we were already using plain films to detect stone disease. And early on, they thought that the plain films were very, very sensitive. But they didn't realize what they weren't seeing. Remember, plain films really can only see radiopaque stones, very dense stones. That there are stones that aren't that dense, so you can't see them on plain film, but almost all stones can be seen on CT. So when you start to compare plain films to CT, CT is much more sensitive for detecting most stones. That's just an example of a stone on a plain film. And then by the 1920s, we moved to IVP, and we really used those until the 1990s. When I was a resident, we were doing IVPs all night long for stone disease. And basically, you're giving the contrast, you're filling the collecting system, you're seeing if the kidneys enhance normally and excrete normally, or if there's an obstruction and where the stone is. But since the 1990s, we've been really using CT as a gold standard to detect and evaluate stone disease. It was really started in the mid 1990s and then really took off. And also when we had multi-detector CT, because we could do thin collimation and find very tiny stones, and that's really advanced the scope of CT, and also dual energy techniques, and we'll talk about that, where you can actually try to characterize what's the composition of the stone. How good is CT? It's very, very good. Very high positive predictive value and negative predictive value. Very high sensitivity and specificity. Really, it's as good as it gets. And it's a very quick study, right? You don't need any IV contrast, no preparation. Just put the patient on the scanner. 8 seconds later, you're done. And it has a high sensitivity for almost all stones. And also, if a patient doesn't have stone disease, you get a chance of figuring out what's really causing the pain. Very common indication of CT in the emergency room. Unenhanced CT for suspected stones accounts for 22% of all examinations performed for patients presenting with abdominal pain. So what are you going to look for? Well, you're trying to find the stone, right? That's the first thing. But then you can see secondary findings in patients with obstructing stone disease, such as hydronephrosis, hydroureter, perinephric stranding, and enlarged kidney. And you can see at least one of these ancillary signs are going to be seen in 90% of patients with acute renal colic. And again, positive predictive value, negative predictive value, hydroureter, perinephric stranding, both. So you're best when the patient has hydroureter and perinephric stranding, and then of course visualizing the stone. Almost all stones are visible on non-contrast CT. Okay, you're seeing it on CT because of the Hounsfield units, how dense it is. Some stones are not dense enough, okay, but most of them are. So even stones like uric acid stones, cysteine and xanthine stones, these are stones that you really don't see on a plain film. They still look white on CT. Okay, the only stones that are hard to see even on a CT are pure matrix stones and stones associated with indinavir, which is a treatment for HIV. Those have soft tissue attenuation, so it's hard to see the stone itself on the CT. Now you can see the effects of it if it's obstructing. You still see hydronephrosis and hydroureter, but you won't see the stone. So you won't be confident that it's a stone. You might be thinking it could be a stricture or even a transitional cell. But they're very, very uncommon. Here's an example from the literature where you see the hydronephrosis, and this is the area. Now you can't say what's there except that was the site of transition. It's really from a stone, and when you give the contrast, you can see that the stone is in the collecting system but doesn't look radio-opaque. What's the proper technique if you're evaluating patients for stone disease? It varies in the literature really based on the publication date, because early on we couldn't do 1 millimeter slices, but nowadays you want to have very thin collimation, because sometimes you're looking for a stone that's a couple millimeters in size, so you don't want to have a 5 millimeter collimation. So you want to use thin collimation. So we use 3 millimeters, but we also make available the 0.75. So I always start with the 3s and may be comfortable making the diagnosis on those. If I'm not or I'm not sure, then I move to the thins. We use 100 to 120 kVp with automated tube current modulation. You don't need IV, you don't need oral contrast, and basically you have to scan from the kidneys through the base of the bladder, and multiplanar reconstructions are definitely helpful in this indication for following the ureter. Again, especially the coronals are used and can be very helpful. So here's an example of a patient with flank pain, and often the ED won't even tell you which side, but this, I think it's the right side, so the left kidney looks normal. The right kidney, you're starting to see a little bit of perinephric stranding, right? A little bit of prominence of the collecting system there. And basically you have to follow the ureters down. You're going to do this in real time and scan. There's the dilated ureter, and there's the stone at the right ureterovesical junction. So here's a little loop, cine loop, and you can see the right kidney, perinephric stranding. You can see the tiny stone within the right kidney, non-obstructing. And now we're following the ureter. It's right here, right? You're following the ureter down. Sometimes once you get to the pelvis, you can lose it a little bit along the pelvic side wall. I think we're still here. And there was a tiny stone. Let's look at that one again. Okay, swollen right kidney, hydronephrosis, hydroureter. There's the tiny non-obstructing stone in the kidney. We're following the ureter down. There it is. And there's the tiny stone there. Could be pretty small. And then there at the ureterovesical junction. Okay, so how do the stones look? They're going to be white, right? Whether it's a cysteine stone, uric acid stone, or calcium stone, they're going to look white to you. They differ in Hounsfield units, but they're going to look white. Here's a patient, right hydronephrosis, and there you see the stone. I'll just show you a couple examples because I'm sure you're all comfortable making that diagnosis. The right kidney looks a little bit swollen compared to the left, and this is just a 1 millimeter stone. That's why sometimes you have to go to those really thin slices in order to make that diagnosis, because it's going to be very hard if you have a thick collimation scan. Stones can be big or stones can be small, and they can still be obstructing. So even if you only have a 2 millimeter stone, it still can cause an obstruction, especially at the ureterovesical junction. Here's a patient with a little bit of perinephric stranding on the right, and this is a contrast enhanced scan. We're just lucky because we saw a delay in enhancement on the right compared to the left, so there was delayed excretion of contrast so that we could catch the stone there at the right ureterovesical junction. So basically you're looking for white stones. The most important factor influencing management of stone disease is really where is the stone, what is the size of the stone, what's the composition, and that's where we can add a little bit of information but not a lot based on CT, and then patient symptoms. If it's in the upper ureter, you can see most of them, if it's a small stone, will pass on its own. The larger the stone gets, the more likely it is that it's not going to pass. So these measurements are very important in your report because that's what the urologists are doing using to predict whether or not the stone will pass, or do they have to go and retrieve it. Right? So it could be proximal, mid, or distal ureter, and you're going to be giving the size of the stone. Quantification of the stone burden is in the literature now and saying, well, maybe we shouldn't just give the size of the stone. Maybe we should be giving the volume of the stone. So there are some reports that say that might be helpful. But also, could we tell by the CAT scan what's the composition of the stone? So there is some data suggesting that you may be able to do that. When you're measuring the stone, at this point we give a linear measurement. Historically we did that on soft tissue windows. It probably makes more sense to do it on the bone windows because on the soft tissue windows you get a little bit of blooming and you want to use magnification because remember you're measuring a very small stone. You want to make sure that it's accurate. So here's an example of just measuring on the soft tissue windows versus the bone windows. It's going to look a little bit smaller, so the more accurate measurement is going to be on the bone windows. I mentioned that the literature now is looking at stone volume, so maybe we should be doing 3D volume rendering of the larger stones. We don't actually do that, but there's a little bit in the literature. You can keep your eye on whether or not that's going to be useful in your practice. Something that we can offer some information in is the composition of the stone. Most stones are calcium-based, right, or struvite, but some stones are uric acid, and so it's important to be able to distinguish between them. So, for example, here's a chart just showing what the Hounsfield units of the stones are. Now, most of the calcium-based stones, they have very high Hounsfield units, right, 1,700, 2,000, okay, but you can see cysteine stones, 600, uric acid stones, only 200. So in the larger stones where you can get a Hounsfield unit measurement, it can be helpful. There's a lot of overlap between some of them, but the uric acid stones are so low, that's usually the one you can make the diagnosis on. The reason uric acid stones are important is that they're going to be treated by alkalinizing the urine, right? So they make the urine alkaline, and that will dissolve the stone. So you can prevent this patient from having a more aggressive procedure because they don't need it. The stones can be dissolved by making the urine alkalinized. So how can you tell a uric acid stone? Well, you could measure the Hounsfield units, or if you have dual energy, you can use the dual energy, and you can use the 80 and 140 kVp, and then there's software that will color code it. And what happens is that way you can distinguish a pure uric acid stone from a mixed uric acid and calcium stone with the color coding based on the dual energy, which accentuates the difference in the Hounsfield units. So for example, using the dual energy, the calcium-based stones turn blue, and the uric acid stones turn pink. And it's as simple as that. And you can tell the difference based on the CT scan. Okay, in the last couple minutes, I just promised I'd show you a couple of potpourri of some diseases that you can see, GU causes of an acute abdomen. So this is a patient with a tubo-ovarian abscess. So pelvic pain or lower abdominal pain in women tends to be a problem, right? There's a lot of things that can cause it. We'll often start with an ultrasound, but sometimes we'll start with a CT. In this case, you see these dilated tubules. So those are the fallopian tubes that are dilated and basically filled with pus. And so that's tubo-ovarian abscess. Sometimes you'll end up doing an ultrasound as well, just to get a better look at the ovaries as well. Here, a different patient, big cystic areas. They look like abscesses, both adnexas. These are involving the ovaries and the dilated tubules. And one more case of tubo-ovarian abscess. Okay, so always be thinking it could be a GYN complication. Postpartum complications, patient after cesarean section. Here we have a big abscess in the uterus and a lot of inflammation around there. Here's a patient, again, just after a C-section, you might see a little bit of air, but the air usually leaves very quickly from the parenchyma. So if you keep seeing air within the parenchyma of the uterus, you have to worry that you have a gas-forming organism or you have an infection, an endometritis, and something like that. So that's a very important diagnosis to make. One more condition I want you to be aware of, because it kind of goes along with the emphysematous pyelonephritis, is Fournier's gangrene. This was diagnosed for the first time in 1883, right, way before we had any radiologic imaging. So this is a gas-forming organism. It was originally described in men, so it was basically gangrene of the male genitalia. But it's broader today. It can happen in men and women, and basically it's a gas-forming organism that can happen anywhere, but it's often in the groin. And very high morbidity and mortality for the same reason. Because of the gas-forming organism, it spreads incredibly quickly. It has a variety of causes. Sometimes it's in the groin from something like an ingrown hair or a little cut that starts it, or from a urinary tract infection that spreads to the perineal area. Perianal abscesses or fissures and things like that can start it going. These are sick patients. They're often diabetic. Older patients with prolonged hospitalization where the infection just gets out of control. So what you're going to see is usually a subcutaneous infection that begins adjacent to the portal of entry. So in most cases it's going to be in the groin, but it doesn't have to be. You get a localized cellulitis, inflammation, and then what happens is the gas-forming organism just starts destroying everything. So you get a necrotizing fasciitis, the muscles are involved, and it keeps spreading. It's usually a group of organisms, just not one. And the key is that it spreads very quickly, and you're going to see the gas. You're going to see soft tissue edema, skin thickening, but it's the gas that's going to alert you that this isn't just a cellulitis, that it's more severe than that, there's emphysema there. So here you can see a patient in the groin. You can see this air, very abnormal. There's really no other reason that you should have air like this in the perianal region or perineal region. This is going down the thighs and up into the abdominal wall. Okay, so what happens is this patient died because what they do is they go to surgery and they have to start resecting the necrotic tissue, and you only can resect so much over a short period of time, and so very, very severe that you need to be alerted to. So in conclusion, CT is the imaging modality of choice for patients with any acute abdominal pain. And in this talk, we focused on some GU causes of acute abdominal pain. And specifically, we spent a lot of time on pyelonephritis because that's a diagnosis that you can be the first person to suggest. And also stone disease. You see stones all the time. Instead of just saying whether or not there's hydronephrosis or a stone, you need to be a little bit more specific and give the size of the stone, the location of the stone. Are there any complications? And then if you have dual energy, you can even try to determine the composition of the stone. Is it a uric acid stone, for example? Because that's good to know, because that will affect the patient treatment. Okay, thank you for your attention.
Hello, my name is Pam Johnson, and the next talk is on CT of the adrenal gland. The normal adrenal glands are seen on almost all thoracic CTs and all abdominal CTs, and it's important to have the adrenal gland in your search pattern when you're interpreting either chest or abdominal CT. The limbs of the normal adrenal glands should be less than 5 millimeters each, and they typically have a Y-shaped configuration as shown in these coronal images and axial image. One of the big areas of research and consensus work is on how to manage an incidental adrenal nodule. These will be seen in as many as 7% of CT examinations. There have been large studies that have shown that in non-cancer patients, all lesions that were identified were benign. Most commonly, an incidental adrenal nodule is an adenoma in 80% of cases. The other two common incidental adrenal lesions that you may encounter are myelolipoma and pheochromocytoma. Myelolipoma is a diagnosis that you can make with 100% certainty by identifying macroscopic fat. It's important to recognize that even though it's a small percentage of cases, pheochromocytomas will be identified incidentally. In fact, there was a study from Hopkins where they looked at all the pheochromocytomas that were surgically removed and found that nearly 2/3 of them were actually identified incidentally. So it may be something that you encounter, and it's important to be able to recognize features that help you distinguish between adenoma and pheochromocytoma, which I will discuss later in the talk. The ACR has defined some management algorithms for how to interpret a study when you find an incidental indeterminate nodule. So this would be a patient who was scanned with a single venous phase acquisition, so you can't do a pre-contrast assessment of the lesion to determine if it's a lipid-rich adenoma. And there are characteristics that help you determine the best management for each patient. Most importantly, the size and the appearance of the lesion. So small adrenal nodules, less than 4 centimeters, that are benign appearing, can be followed up in 1 year with CT or MR. If you identify any suspicious features, such as heterogeneity, necrosis, or irregular margins, then additional characterization is mandated. Moving on to protocol design. Even though the adrenal glands are small, there are actually different protocols depending on the indication, and it's really important to understand which acquisitions are most important for each clinical indication. So we're going to talk about the protocol to use when you're characterizing an incidental adrenal mass. If you have a patient with some type of hormonal syndrome and a suspected adrenal pathology, such as an adenoma or hyperplasia or pheochromocytoma, that's a different set of protocols. A patient with a known pheochromocytoma, we have a specific protocol for that, as well as a patient with adrenal cortical carcinoma who is undergoing preoperative staging. So we'll start with characterizing an incidental adrenal mass. And the features that we look at on CT that help us in characterizing an incidental indeterminate nodule are the attenuation, the size, the enhancement levels, and the washout characteristics. We begin a dedicated adrenal protocol to evaluate a nodule with a non-contrast CT because the majority of adrenal adenomas are lipid-rich, and they will have low attenuation on a non-contrast CT. We use the cutoff of 10 Hounsfield units. So for a lesion that is less than 4 centimeters in size and less than 10 Hounsfield units on a non-contrast CT, no additional imaging is required. That is a lipid-rich adrenal adenoma. It does not require follow-up. It is a benign diagnosis. The threshold, the pre-contrast attenuation threshold, was derived from a paper by Boland that was a review article that derived sensitivity and specificity for different thresholds, and 10 Hounsfield units seems to be the threshold with high sensitivity while maintaining very high specificity. So different radiologists may use different thresholds depending on whether they prefer to have higher sensitivity or specificity, but we use 10 Hounsfield units. And here's a nice example of an adrenal adenoma in the right adrenal gland. You can see that there's homogeneous low-density mass that measures 0 Hounsfield units. This is a lipid-rich adenoma. Moving on to the next criteria, this would be lesion size. And the ACR has published a number of very helpful white papers to guide management of incidental lesions, including adrenal nodules. And they recognize that in patients without malignancy, most nodules less than 3 centimeters are benign. and you can follow lesions in the range of 1 to 4 centimeter in size, but masses greater than 4 centimeters should be evaluated for surgical resection because of the higher risk of malignancy. The original work to derive this 4 centimeter size threshold was based on axial images, and one thing that we've recognized in practice where we do MPRs on all patients, coronal and sagittal MPRs, is that adrenal masses are often larger in the coronal or sagittal plane, and this is something that requires some future research to determine the difference in maximum diameter in axial and coronal planes. But here's a nice example of a mass that's less than 4 centimeters on the axial image on the left, and yet in the coronal plane it's as large as nearly 5 centimeters and 5.5 centimeters in the sagittal orientation. This was a stable mass. So these measurements do not correlate necessarily axial to the craniocaudal dimension. And it's something to be aware of if you use MPRs in your practice like we do. The contrast enhancement level was something that was evaluated many years ago on CT, and when radiologists were trying to distinguish adenomas from metastases, and it was determined that the enhancement level does not help in distinguishing metastatic lesions from benign adenomas. However, a number of papers since then have demonstrated utility in distinguishing pheochromocytoma from adenoma based on the enhancement level. So here are some of the earlier papers where they measured the enhancement levels of adenomas and pheochromocytomas, and even in this early work you can see that most adenomas on the venous phase enhanced less than 100 Hounsfield units, especially the lipid-rich lesions. The pheochromocytomas, though, in a separate paper, did enhance greater than 100 Hounsfield units in a number of patients. In fact, the mean was 79 to 94 Hounsfield units, and some enhanced as high as 131 in this early paper. So a lesion that enhances over 130 Hounsfield units should be suspicious for a pheochromocytoma, and we'll talk a little bit more about the data behind that. Here is a nice example, 2 coronal images, an adenoma on the left and a pheochromocytoma on the right, and you can see the difference in both enhancement level and heterogeneity, with the adenoma being very homogeneous in the left adrenal gland, whereas the right adrenal pheochromocytoma that enhances to 155 Hounsfield units also enhances heterogeneously. Even small pheochromocytomas can be very vascular, as shown in this case of a small right adrenal pheochromocytoma in a patient with classic symptoms for pheochromocytoma that enhanced to 217 Hounsfield units. So Dr. Fishman has always had a rule where if we find an incidental adrenal lesion on a venous phase scan and it enhances greater than 110 or 120 Hounsfield units, we should think of the possibility of a pheochromocytoma. Based on this rule, we designed a retrospective study to compare the enhancement levels of adenomas and pheochromocytomas, and we did find that this rule was somewhat very reliable, actually, based on his many years of experience. Most adenomas enhanced with an average, all adenomas with an average enhancement level of 60 Hounsfield units. The lipid-poor adenomas had a slightly higher mean enhancement level of 90 Hounsfield units on the venous phase, but the pheochromocytoma venous phase enhancement average was 111 Hounsfield units. So there is a significant difference, with many pheochromocytomas enhancing much higher than adenomas, even the lipid-poor adenomas. Using a threshold of 130 Hounsfield units in this study, we determined this to be 100% specific, although much less sensitive. And this is because pheochromocytomas have a wide range of appearances, which we will review a little bit later in the talk. So the bottom line is, if a lesion is very vascular, up above 130 Hounsfield units, the likelihood that it's an adenoma is low. There is conflicting data in the literature, which I want to present as well in this study that was published in AJR, where they also compared pheochromocytomas and adenomas, and they found that some of the adenomas in their study did enhance greater than 110 Hounsfield units. They recorded a range as high as 202 Hounsfield units, but they did not indicate the percentage of lesions that reached this enhancement level. This was the lipid-poor adenomas. None of the lipid-rich adenomas enhanced greater than 110 Hounsfield units. So I think more work needs to be done on this with really large patient series to determine why there is discrepancy between the two studies. Moving on to adrenal washout, which was originally designed to distinguish, again, adenomas from metastases using venous and delayed acquisitions. And it's important to recognize that the venous phase has to be used for the adrenal washout characteristics. You cannot perform washout using an arterial phase. You have to use a venous phase and a delayed phase. This is our protocol for adrenal washout CT. We do a non-contrast scan. If the lesion is greater than 10 Hounsfield units, then we proceed with the IV contrast enhanced part of the protocol using a 60-second venous and a 15-minute delayed acquisition. The calculations that are performed are absolute and relative percent of washout using these formulas. So if you have a non-contrast scan, you can perform an absolute percentage washout by using the venous delayed and pre-contrast acquisitions in this formula. And if it's greater than 60%, then the lesion is considered a lipid-poor adenoma. If you don't have a pre-contrast acquisition, then you perform a relative percentage washout using venous and delayed acquisitions in this formula. And if the RPW is greater than 40%, then the lesion is considered, again, a lipid-poor adenoma. The principle behind this is that regardless of the amount of fat in the lesion, and most adenomas are lipid-rich, but a small percentage of them are lipid-poor, but regardless of the lipid content, the lesions wash out the same. They take up contrast relatively quickly and they wash out on the delayed acquisition, whereas metastases tend to retain contrast and do not have the same washout characteristics. Here's a nice example of a lipid-poor adrenal adenoma in the left adrenal gland with the pre-contrast density of 22 Hounsfield units, reaches 64 Hounsfield units on the venous phase and washes out to 26 Hounsfield units, meeting both APW and RPW criteria for a lipid-poor adenoma. Investigators have tried to determine whether they could reduce the delay timing because the original studies actually looked at 10 minutes and 15-minute delays, and 15 minutes is the delay that we use. In this paper in radiology, a 10-minute delay was evaluated but was shown to have relatively low sensitivity for both the RPW and the APW, so it was not recommended to adopt the 10-minute delay, and we support that. We continue with the 15-minute delay. There are two major pitfalls that you must be aware of in performing washout evaluations of adrenal nodules. The first is that the pheochromocytoma can wash out like an adenoma. Here's a nice example of a pheochromocytoma that reaches 164 Hounsfield units on the venous phase acquisition and washed out to 78 Hounsfield units, meeting the RPW criteria. Especially the vascular pheochromocytomas tend to mimic adenoma in their washout characteristics. So, the way that you make this distinction is that if you ever see a lesion that you're performing a washout evaluation on and it enhances to 164 Hounsfield units, based on our principle that most adenomas do not go over 130 Hounsfield units, you should suspect that this could be a pheochromocytoma even though it is washed out. There is some data that confirms that pheochromocytomas do mimic adenomas. It was shown in the early papers on washout, although many of the early papers excluded pheochromocytomas because they were only comparing adenomas and metastases. A number of papers, however, have looked at the washout characteristics, including a study that we presented at RSNA where we looked at 21 pheochromocytomas with washout imaging, and all of the pheos that enhanced over 110 Hounsfield units met washout criteria using APW and RPW. In addition to one that was hypovascular, it's still washed out like an adenoma. So most of the pheochromocytomas that mimic an adenoma washout pattern were vascular in this study. Again, the study from AJR, where they compared pheochromocytomas and adenomas, they did find that a third of the pheochromocytomas met washout criteria, and 2/3 of these were hypervascular. So it's something to remember as a potential pitfall. A second pitfall is hypervascular metastases. This is an abstract from PubMed from a paper that was published in Radiology comparing evaluating adrenal mets from renal cell carcinoma and hepatocellular carcinoma and showing that some of these lesions actually washed out like adenomas. And using a threshold of 60% APW or 40% RPW, 95% and 89%, depending on the pathology, were falsely diagnosed as lipid-poor adenomas. So it's the same principle. If this is a vascular metastasis, it may mimic an adenoma in its washout characteristics. We have seen this in practice with renal cell metastases, and you can actually, there is additional data on your 4-phase renal study that can help you distinguish a renal cell metastasis from a lipid-poor adenoma without doing any additional imaging. You do not need to do a washout. If you have a 4-phase CT, as shown in this case, you can see the hypervascular renal cell mass in the right kidney on the first image. You can see the hypervascular adrenal metastasis in the right adrenal gland on the second image that enhanced to 153 Hounsfield units on the arterial phase. The venous phase enhancement was 130, and the delayed phase 68.6 Hounsfield units. So while this might meet washout criteria using venous and delayed acquisitions, the arterial enhancement level is the key piece of diagnostic information. An adenoma, in the studies that we've done, adenomas do not enhance that high on the arterial phase. So this should make you suspect that this is a renal cell metastasis as opposed to an adenoma. And keep in mind that washout study is not going to help you make the distinction. The arterial phase enhancement level is what's going to help you make the distinction in these cases. A study that we did that is similar to that, the evaluation of arterial and venous phase enhancement levels, was comparing pheochromocytomas and adenomas that were imaged with dual phase CT. So, for example, if you were imaging a patient for hepatic, pancreatic, renal, or vascular indication that happened to have an arterial and venous phase acquisition, and you identify an adrenal nodule, we hypothesized that perhaps the arterial and venous phase enhancement levels and enhancement patterns might be helpful in distinguishing pheochromocytomas from adenomas. In this study, we measured the arterial and venous phase enhancement levels of all the lesions, and we found that all of the adenomas enhanced less than 85 Hounsfield units on the arterial phase. So, in the example that I showed you of the renal cell metastasis that reached 150 Hounsfield units on the arterial phase, this is not a characteristic of an adenoma. Adenomas are hypovascular on the arterial phase. They peak in enhancement on the venous phase. This was shown in early studies. It's been confirmed in all the studies that we've done and studies that have been subsequently published. Pheochromocytomas, in this series, 58% of them enhanced greater than 115 Hounsfield units on the arterial phase. So that is the key distinguishing feature. If you encounter a lesion on a study performed for a different indication with arterial and venous phases. The venous phase enhancement level was somewhat helpful in that a small percentage of the adenomas enhanced greater than 115 Hounsfield units compared to 58% of the pheochromocytomas, but it was less specific using that threshold. When we looked at the relative enhancement, whether the lesion enhanced more on arterial or venous phase, we found that in this series, none of the adenomas enhanced more on the arterial phase. There were some that enhanced the same on arterial and venous, but the vast majority, 85%, enhanced more on the venous phase, which is characteristic of an adrenal adenoma. They peak in enhancement on the venous phase. Pheochromocytomas, however, are very variable, and there have been a number of papers written about how variable a pheochromocytoma can appear on CT imaging, and this held up in this study. You can see that 25% of them enhanced more on the arterial phase, 25% of them enhanced the same on arterial and venous, and 50% enhanced more on the venous phase. So the take-home point is that if a lesion enhances more on the arterial phase, in a patient without any known malignancy, an incidentally identified lesion, you should suspect a pheochromocytoma. One of the other features that's been looked at in a number of studies is whether the lesion is homogeneous or heterogeneous, and in our study, as has been shown in many other studies, most adenomas are homogeneous, but heterogeneity was identified in almost 60% of the pheochromocytomas. So, as the ACR says in their white paper, this is a feature that should mandate a different additional characterization in an incidental indeterminate adrenal lesion. So in the next couple slides, I'll show you some examples of the CT appearance of adenomas and pheochromocytomas on two-phase imaging. And I just want to reiterate, the study was not conducted to suggest that we should be doing two-phase imaging. This is a study that was conducted to determine what information can we use on a dual-phase study that can help us to distinguish lesions that are incidentally identified without doing any additional imaging. So, first example, lipid-rich adenoma. This is the classic enhancement pattern. 29 Hounsfield units on the arterial phase, 60 Hounsfield units on the venous phase. It's a well-defined hypovascular lesion. An example of a lipid-poor adenoma that reached 67 Hounsfield units on the arterial phase and 91 Hounsfield units on the venous phase. So they tend to have higher enhancement levels, but still less than 100 Hounsfield units on the arterial phase. We defined 3 patterns for pheochromocytoma on dual-phase imaging. This was the first pattern. It's a diagnostic enhancement pattern, but it was only seen in 25% of the pheochromocytomas. And the pattern is a high level of arterial enhancement, 132 Hounsfield units in this case, and a high level of venous enhancement, but the arterial enhancement was greater than the venous. So this was seen in 25% of pheochromocytomas, but no adenoma had this enhancement pattern in our series. The second enhancement pattern for pheochromocytoma, the arterial phase, again, very high, 147 Hounsfield units, and the venous phase even higher. So if arterial is greater than 110 and the venous was greater than arterial, this was seen in 33% of pheochromocytomas, but again, none of the adenomas enhanced to this level. They do enhance more on the venous phase, but not to this enhancement level. Now, the third pheochromocytoma pattern is the pitfall, and this is the pheochromocytoma that mimics an adrenal adenoma. So, important to recognize that we cannot identify all pheochromocytomas on two-phase imaging. In this case, there's a well-defined hypovascular lesion in the left adrenal gland that appears homogeneous, enhances 46 Hounsfield units on the arterial phase, 68 on the venous, and mimics an adrenal adenoma. This was a pheochromocytoma, and this pattern was seen in 42% of the pheochromocytomas. So we cannot identify all of them, but we do know of features that are specific and should make you consider a pheochromocytoma for an incidental nodule on a two-phase CT. These features are arterial phase enhancement higher than venous, arterial phase higher than 115, venous phase higher than 130, or the presence of heterogeneity. So keep those rules in mind for incidental lesions on two-phase imaging. Okay, so just to review all of the adrenal nodule characterization characteristics that we just discussed, the take-home points, starting with the size. If it's less than 3 centimeters, it's probably benign. Greater than 4 centimeters, we consider surgical resection. Heterogeneous lesions, only a small percentage of adenomas are heterogeneous, but the majority of pheochromocytomas are heterogeneous. If the pre-contrast density is less than 10 Hounsfield units, you can make the diagnosis of a lipid-rich adenoma. Greater than 10 Hounsfield units, washout imaging is indicated. If arterial is greater than venous, it's suspect pheochromocytoma, arterial greater than 10, venous greater than 130. And remember that washout criteria, most adenomas meet washout criteria, but so do a majority of pheochromocytomas, depending on the study, and hypervascular metastases from renal cell carcinoma and hepatocellular carcinoma. Okay, moving on to a patient with suspected adrenal pathology. So the protocol in this patient with hormonal secretion, either Cushing syndrome or Conn syndrome, which is seen in 11% of adenomas, or a patient with a pheochromocytoma, because nearly all pheos secrete metanephrines. So if you suspect adrenal mass, you do a pre-contrast scan, and if you see an adenoma, and it's a lipid-rich adenoma, then the study is complete. If you don't see an adenoma, in our experience of venous phase acquisition is helpful to be absolutely sure that you're not missing a small adenoma on the non-contrast scan. The third protocol that I wanted to discuss was pheochromocytoma. So a patient with pheochromocytoma in the early days before we had non-ionic contrast, patients had a risk of developing hypertensive crisis because the old contrast agents resulted in catecholamine release. So patients were traditionally pre-medicated with alpha blockers. However, the new non-ionic contrast agents have been shown to be safe. This was a study in the Annals of Internal Medicine where it was a prospective study comparing 22 patients and 8 controls who were given non-ionic contrast. They measured catecholamine levels, blood pressure, and heart rate at baseline, 1 hour before the scan, immediately before the scan, and then at a number of increments after the scan. And what they found was the pheochromocytoma patients had no change in their norepinephrine levels. They did have a significant increase in blood pressure, but it was only 10 systolic, and they had no change in heart rate, whereas the controls had no change in any parameter. So the conclusion from this paper was that the low osmolar contrast had no appreciable effect on the norepinephrine or epinephrine relief, and the use of these agents for pheochromocytoma can be considered safe. Of course, if the patient is on alpha or beta blockers, they should continue on the medication on the day of the study. You certainly don't want to hold those medications, but additional pre-medication is not necessary. So what is the protocol that we use for pheochromocytoma? We give water, PO, IV contrast infused at 4 mLs per second. We do not do a pre-contrast scan. We do arterial and venous phase imaging. And what's important to remember is that if a pheochromocytoma is suspected, it may not just be in the adrenal gland. These can arise anywhere from the neck down to the pelvis, in which case they're known as extraadrenal paragangliomas. These patients can have symptoms similar to an adrenal pheochromocytoma. So if the patient has suspected paraganglioma or pheochromocytoma and we're doing a body CT, we'll image lung, apex to pelvis. Here's a couple examples of a mediastinal paraganglioma. They have the same imaging characteristics in many cases, being very vascular masses. This is a lesion that was less vascular but is in the classic retroperitoneal location, a paraganglioma of the left retroperitoneum. Here's a paraganglioma in the organ of Zuckerhandel by the distal abdominal aorta right at the bifurcation. And these are 2 different cases of patients with bladder paragangliomas. The 2 images on the right show a very small vascular bladder mass, which was resected and proven to be a paraganglioma. The mass on the left, much larger, vascular, and heterogeneous, classic appearance for a paraganglioma that was arising from the wall of the bladder. In a patient who has adrenal cancer and is being imaged with CT for staging, the protocol is arterial and venous phase with water PO. MPRs are critical in these patients. We do MPRs on every scan that we perform, but they're very important in adrenal cancer staging because adrenal cancer is one of the tumors that invades the inferior vena cava. And to really define the extent of tumor involvement of the inferior vena cava, you need to look on a coronal MPR or sagittal MPR. And your report should indicate whether it's below the infrahepatic, at the level of the liver in the IVC, or above the level of the liver, or into the right atrium. Regardless of the adrenal lesion, I just want to take a minute and talk about the importance of multiplanar display, not just for characterizing the extent of an adrenal lesion, but even for determining that a lesion that looks like it's arising from the adrenal gland is in fact arising from the adrenal gland. So here's an example of a mass on the axial image on the left, looks like it's arising from the right adrenal gland, and on the coronal image, you can see that the right adrenal is actually above the mass. The mass was positioned in the renal hilum. So it is very important to look at all adrenal lesions with axial and MPRs and be absolutely certain that the lesion is arising from the adrenal gland when you see a suprarenal mass. Okay, so moving from protocols, I want to review the appearance of different adrenal masses on CT that you may encounter in practice. So we discussed adenomas quite a bit. This is just an example of bilateral adrenal adenomas to remind you that they can be bilateral. And in my experience, when you see one on one side, if you look really closely, you may see a small adenoma in the contralateral limb. This becomes very important if a patient has a hormonal syndrome and they're trying to determine whether which adrenal gland is causing the problem, whether they need to do adrenal vein sampling. It's very important to accurately characterize both adrenal glands. Something that we've seen infrequently, but it does occur, particularly in patients who are on anticoagulation, is hemorrhage into an adrenal adenoma. So if you see an adrenal mass that is heterogeneous with regions of high density in an anticoagulated patient, this is a diagnosis that you should consider. As you can see in the coronal images on the left, the lesion was heterogeneous before IV contrast was administered. The heterogeneity becomes more conspicuous on the delayed coronal acquisition on the right, and this is the appearance of an adrenal adenoma with hemorrhage. You see the variable attenuation levels throughout the lesion. I discussed a little bit myelolipoma at the beginning of the talk. This is a benign mass. It is non-functioning. It's comprised of hematopoietic tissue and mature adipose. The size ranges from very small to as large as 17 centimeters. And what's interesting about myelolipomas is that they can, in serial imaging over time, they can remain stable, they can enlarge, and they can actually even get smaller in some cases. So they do enlarge, and they do have the risk of either mass effect or hemorrhage when they become large. So a myelolipoma may require resection, not because of a risk of malignancy, but because of the risk of hemorrhage. Here's another nice example of a myelolipoma. The diagnosis is made when you see macroscopic fat in an adrenal mass, even a mass of this size. Another nice example, macroscopic fat, the diagnosis is myelolipoma. And they can be large. As you can see, this one's causing some mass effect on the left kidney. Just one other feature that I think is really helpful. You see the small enhancing foci after contrast is administered. This is a classic appearance for myelolipoma. Those are the myelogenous elements. Moving on to adrenal metastases. Now, all the original work with washout studies was to try to distinguish metastases from adenomas. Metastases wash out slower. They don't typically meet the criteria by APW or RPW unless they are hypervascular. But they are often bilateral. Here's a nice example of bilateral adrenal metastases from lung cancer. And just take a minute and talk about bilaterality and what the differential diagnosis should be when you encounter bilateral adrenal lesions, because of all the lesions that we discuss and we're going to review in this talk, some of them have a higher propensity for involving both adrenal glands. So one of these, of course, is metastatic disease, which is bilateral in half the cases. Lymphoma. Secondary lymphoma is bilateral in half the cases. And granulomatous infection and adrenal hyperplasia are often bilateral, whereas adrenal hyperplasia is often bilaterally symmetric, but it can be asymmetric as well. Now, adrenal adenomas are bilateral in only 20% of cases, and the other lesions on the list even less frequently. Pheochromocytoma, only 10%, rare for myelolipoma, very rare for adrenal cortical carcinoma. One thing that is critical to recognize, and we will discuss in a few minutes, is adrenal hemorrhage and determining whether adrenal hemorrhage is bilateral, because the patient is at risk for acute adrenal insufficiency, which is a life-threatening condition. Back to our discussion on metastases. This was a really great paper that was recently published in AJR where they looked at 211 adrenal masses. The majority were benign, and they defined features that should aid in distinguishing metastases from benign masses. These included an irregular margin and central low attenuation. So here's two nice examples of adrenal metastases in the left adrenal gland, one from metastatic renal cell carcinoma, and the image on the right, metastatic leiomyosarcoma. You see the peripheral enhancement with central low density. That is an enhancement pattern that should make you consider metastasis rather than adenoma. One thing that we've seen in practice that also mimics this appearance is adrenal hemorrhage. Here's a patient with bilateral adrenal hemorrhage, very similar appearance with peripheral high attenuation and central low density. So these are imaging features that you should investigate in adrenal nodules in patients with cancer to aid in the distinction. As we discussed previously, metastatic renal cell carcinoma, here's another example, right adrenal metastasis with arterial phase enhancement up over 100 Hounsfield units, and this should make you think of metastatic renal cell carcinoma as opposed to adrenal adenoma. One thing to keep in mind is that patients who have had a nephrectomy can develop recurrent renal cell many years later, and this is how it first appears in the adrenal gland. And so it's very important in these patients to carefully inspect really all of the organs, adrenal, pancreas, stomach, all the places that renal cell recurs, but the lesions are going to be seen best on the arterial phase. So we're talking about clear cell or conventional renal cell carcinoma, typically a hypervascular mass, the one that is most likely to metastasize and recur. And if you look at the arterial phase with the red arrows, you see this metastasis, the small metastasis, very well on the arterial phase, almost completely washes out on the venous phase. If you're not performing arterial phase imaging in patients who, for follow-up renal cell carcinoma, you are going to miss early metastases. And the adrenal gland is one of the common locations. So look very carefully and be sure that your protocols are optimized to identify these lesions. Moving on to the imaging appearance of pheochromocytoma, just quickly review the patient presentation. So classically, it is an atypical type of hypertension. So pheochromocytomas only account for a very small percentage of the patients with hypertension. But as described in this article that I referenced below, I thought this was a very nice description of the type of hypertension that makes the clinician think of a pheochromocytoma. That's new onset, refractory, paroxysmal, or recently exacerbated. These patients are at suspicion for having a pheochromocytoma. Other symptoms, palpitation, headache, diaphoresis, flushing, they may be asymptomatic, and the diagnosis is made by evaluating urine for metanephrines, catecholamines. It is important to remember, as I said earlier in the talk, that some percentage of pheochromocytomas are going to be identified incidentally. Here's a really nice example of a patient being imaged for pulmonary embolism with an unsuspected pheochromocytoma in the left adrenal gland. So the lesion is obviously large enough to identify easily, but it's heterogeneous with peripheral enhancement. And the number one diagnosis in this case should be pheochromocytoma based on the enhancement level and heterogeneity, even though the patient this is a completely unsuspected finding. The imaging appearance of pheochromocytoma on CT or MR, highly variable. Depends on whether there's been hemorrhage. They're often heterogeneous. They can be vascular, but they're not always vascular. They can be cystic, in fact, with cystic degeneration, secondary to hemorrhage, and necrosis, and a small percentage of them can have calcification. So I'll show you some examples. This is the classic pheochromocytoma that I showed you earlier in the talk with a high level of arterial enhancement in the right adrenal gland. Here's a patient with neurofibromatosis and small bilateral pheochromocytomas in both right and left adrenal glands. You can see small vascular enhancing nodules. This is also a pheochromocytoma. We see I have a pre-contrast coronal image on the left and an axial post-contrast image on the right. Note the heterogeneity, the cystic changes. At pathology, there was hemorrhage and necrosis, which accounts for this appearance in a patient with pheochromocytoma. These lesions can bleed. This is another patient with neurofibromatosis and bilateral cystic pheochromocytomas. So it's not something that you see often, but if you see a cystic mass with a thick, irregular, enhancing wall, like this in a patient without a primary malignancy, pheochromocytoma should be high on your list in your differential diagnosis. And remember that it can be bilateral. Adrenal cortical carcinoma. This is a relatively rare tumor. We do see quite a bit at Hopkins. It has a bimodal age distribution, and slightly more than half of them are functional with a number of different syndromes. Many of these patients do have hypertension. And adrenocortical carcinoma really has a very typical appearance. These lesions tend to be very large. The larger they are, the less likely they are to be functional, but they do compress adjacent organs. They are heterogeneous with areas of necrosis. A small percentage have calcification. And as I mentioned previously, this is one of the 3 tumors with a propensity for invading the inferior vena cava. So that includes adrenocortical carcinoma, renal cell carcinoma, and hepatocellular carcinoma. This is a classic appearance of adrenal cell carcinoma in the right adrenal. You see that it compresses the right kidney and pushes the right renal artery down. This is so large that it is also inseparable from the inferior liver. The heterogeneity you can see on both the arterial and the venous acquisitions. The arterial image on the right shows you neovascularity, which is also typical of adrenocortical carcinoma and very characteristic of a malignant mass. Another example of a much more vascular adrenal cortical carcinoma that is invading the inferior vena cava. And again, the importance of multiplanar reconstructions on the coronal MPR, we can see that this has invaded the cava to the level above the liver, right at the junction of the cava and the right atrium, and this is critical information for preoperative planning. An example of an adrenal cortical carcinoma in the left adrenal gland. Similar appearance, very large mass, compressing the kidney, heterogeneous with neovascularity and areas of necrosis. There are a few masses that can mimic an adrenal cortical carcinoma. When these tumors become so large in the retroperitoneum, it can be difficult to determine exactly where they've originated from, and some of the things that may have a similar appearance include a very large exophytic hepatocellular carcinoma, a retroperitoneal sarcoma, for example, arising from the inferior vena cava, a very large necrotic pheochromocytoma, and a large hematoma. So I'll show you examples of each of these. They become very difficult at this size to determine the exact organ from which they've originated. So here's a hepatocellular carcinoma that preoperatively was misdiagnosed as being of adrenal origin. You can see the neovascularity, heterogeneity. It's invading the inferior vena cava, pushing the right kidney. It looks very similar to the adrenal cortical carcinoma that I showed you, but this actually very unusual exophytic hepatocellular cancer. Here's an example of a retroperitoneal leiomyosarcoma. Again, very large, heterogeneous, compressing the right kidney, and looks very much like an adrenal cortical carcinoma. This is an extremely large pheochromocytoma. One feature that is somewhat characteristic of pheochromocytoma in this case is the thick rind of peripheral enhancement with a large area of central necrosis, although this is not 100% specific, but it is somewhat characteristic in this case. But very rarely a pheochromocytoma can get to this large size, and it would be difficult to determine whether this was a pheo or an adrenal cortical carcinoma based on imaging alone. And the last thing I'll show you is a pitfall that we've seen in a few cases, and something to keep in mind for two reasons. One, for patient preoperative counseling, and one for operative planning as to whether a mass should be resected by open surgery or laparoscopically. So this is an example of a pathologically proven large hematoma. We have, a small number of cases that we've seen over the years where you can actually see a little bit of enhancement in the periphery of the lesion after IV contrast is administered. We even have one that enlarged over time, but it enlarged a little less rapidly than you would expect for an adrenal cortical carcinoma, but it did enlarge over time and was concerning for malignancy at this size with the presence of enhancement. But one thing to keep in mind is that this low level of enhancement that you see in the periphery of this lesion, if you see a mass that is very well defined and round and heterogeneous potential hemorrhage on the pre-contrast acquisition in a patient who is on anticoagulation, important to remember that there's the small chance that it is a large hematoma, even at this size. And it's not something that you want to recommend follow-up for. Of course, this is a patient that is going to undergo surgery, but the surgeon, if there's a high suspicion for a lesion being potentially benign, the surgeon may actually do a laparoscopic procedure rather than an open procedure, depending on the patient. And it's important for counseling the patient that there is a small chance that this mass is actually benign. There's a concern, of course, that it's malignant. And so if you see this imaging appearance, just remember to put that in your differential diagnosis. Okay, moving on to lymphoma. It's not something that we see very often in the adrenal gland, but it can be identified in 4% of patients with non-Hodgkin's lymphoma. It can be bilateral in these patients. And just like lymphoma in other locations, the appearance can be in a discrete mass, infiltrative, or ill-defined soft tissue, and it typically encases vessels without obstruction. So one of the features, this is a nice example of the feature that should make you think of lymphoma as opposed to adrenal cortical carcinoma. Those cases that I showed you of all those adrenal retroperitoneal masses all compressed the kidney and displaced it inferiorly. Lymphoma, as you can see, typically encasing the vessels without displacing the organ. So a nice example of a somewhat homogeneous hypovascular mass, classic appearance for lymphoma. A couple other examples. Here's a non-contrast CT in a patient with lymphoma showing a relatively well-defined solid mass in the left adrenal gland. Another patient with lymphoma having a more infiltrative characteristic within the adrenal gland. Okay, so moving from neoplastic disease, I'd like to discuss some of the non-neoplastic entities that can involve the adrenal gland that you may see in practice, so that you'll recognize what these are when you encounter them. And these include calcification, hyperplasia, hyperenhancement in patients with shock, very important adrenal hemorrhage, and adrenal pseudocyst, which is something that you do not want to confuse with an adrenal neoplasm. So adrenal calcification, as shown in this case, can be unilateral or bilateral. It is something that is the sequela of either prior granulomatous disease, or, as in this case, when it's bilateral and symmetric, or prior hemorrhage, particularly if you see it in one adrenal gland. Calcification can be identified within renal masses, but when you just see calcification in the adrenal gland without a mass, that is generally the sequela of granulomatous disease or old resolved hemorrhage. Adrenal hyperplasia is something that can result in Cushing or Conn syndrome. As I mentioned at the beginning of the talk, there is one paper that says that the upper limits of normal for the limbs of the adrenal gland is 5 millimeters, and when you see an adrenal gland with adreniform thickening like this, you should consider hyperplasia, particularly bilateral, as shown in this patient. Hyperenhancing adrenal glands are a manifestation of severe hypotension, whether the patient is a trauma patient in the setting of sepsis, pancreatitis, hemorrhage, any of these critical pathologies that can result in severe hypotension may produce these hyperenhancing adrenal glands. This is seen more commonly in children. It's not necessarily a finding you see in adults, even the adults with severe hypotension, but it is a poor prognostic indicator. So you see very hypervascular adrenal glands bilaterally, and that is something that should make you recognize that this is a patient who is in severe shock and with a poor prognosis. Moving on to adrenal hemorrhage. Adrenal hemorrhage can be caused by a number of different entities. It can be unilateral or bilateral, and bilateral hemorrhage is usually encountered in patients who are on heparin, have antiphospholipid antibody syndrome, have some risk factor for bleeding, other anticoagulants, but it can also be in patients who are in the intensive care unit postoperatively, septic patients, burn patients, and so it's really important when you're evaluating these patients to always carefully inspect the adrenal glands, because the radiologist may be the first physician to identify that a patient has a bilateral adrenal hemorrhage. It's not something that is easily determined clinically, but it is potentially life-threatening. So I'm going to show you a range of different cases with adrenal hemorrhage so you are familiar with the appearance. This is another adrenal entity that has a wide range of appearances, but it is something that you do not want to miss. So here's the first case, unilateral adrenal hemorrhage in the right adrenal gland in a patient undergoing CT for pulmonary embolism. So as you can see, the image on the left, there's a hyperattenuating right adrenal mass. This was a delayed acquisition that was performed after the mass was first identified on the PE study. You can see it's hyperdense because of the presence of blood, and the patient had a CT 7 days earlier when the adrenal gland was normal. So patient with antiphospholipid antibody syndrome, this is adrenal hemorrhage. This is a trauma patient. Adrenal hemorrhage in a trauma patient is most commonly on the right side. Patient was having flank pain. You can see that there's a well-defined right adrenal mass with some amorphous high density. That is classic appearance for hemorrhage. This is not a simple cyst, and on follow-up, this lesion decreased in size. So this is another manifestation of an acute adrenal hemorrhage. Adrenal hemorrhage, when it's unilateral, may not necessarily cause a problem if the patient is hemodynamically stable and the hemorrhage has stopped, but bilateral adrenal hemorrhage can cause adrenal insufficiency, which we know is life-threatening. The symptoms may be nonspecific: abdominal pain, vomiting, depression. Hypotension, of course, is something that raises concern, especially for the very critical patients in the intensive care unit. So I'm going to show you a number of different patients with bilateral adrenal hemorrhage so it's that you never miss this diagnosis. Here's a postoperative patient who was anticoagulated with new acute bilateral adrenal hemorrhage. We see bilateral hyperattenuating adrenal masses, and the patient also had acute adrenal insufficiency. Another patient with postoperative hemorrhage had undergone debulking and intraperitoneal chemotherapy. There were no adrenal masses on the preoperative scan, but postoperatively, bilateral adrenal masses. This is the case that I showed earlier, where adrenal hemorrhage can be peripherally hyperdense, as seen in both of these adrenal glands, with central low density. An acute finding is definitive for postoperative bilateral adrenal hemorrhage. In this that patient also had adrenal insufficiency. This is a little bit more challenging case. In a patient with a bilateral adrenal hemorrhage, clearly there's a mass on the right that should raise your suspicion for hemorrhage because of the hyperdensity. The left adrenal gland was just enlarged with an adreniform shape, but this patient also had adrenal insufficiency. So in order to be certain that adrenal hemorrhage is unilateral, the contralateral gland has to be completely normal. And here's an example of a very rare manifestation of bilateral adrenal hemorrhage presenting with enlarged, ill-defined adrenal glands in this patient who also had acute adrenal insufficiency. Interestingly, in this case, we have serial imaging at follow-up that shows gradual resorption of the hemorrhage and reduction in size of the adrenal glands, which is the typical course for hemorrhage that resolves. Here's another example of a patient with a larger left retroperitoneal hemorrhage who was on anticoagulation. If you see high density on the non-contrast scan, you should be concerned about hemorrhage, which is shown even better with the high contrast window on the right. And this is a rare example of a adrenal hemorrhage with active bleeding due to an underlying pheochromocytoma. So this is the patient that has to be, this is an interventional emergency. You can see arterial phase images on the two top images, and the two bottom images are venous phase images showing active extravasation of contrast into this large retroperitoneal hematoma due to active bleeding from the adrenal artery. And the patient was taken emergently to interventional radiology where the adrenal artery was embolized. For the adrenal hemorrhage that does not resolve, the patient may develop an adrenal pseudocyst. These can be unilocular or multilocular. They can have calcification, but it's important to recognize that a pseudocyst with no solid components is a benign lesion. It is a leave-alone lesion. You can have pseudocysts with adrenal tumors, so I'm going to show you first some pseudocysts and then the features that help you distinguish a simple pseudocyst from a tumor with a pseudocyst. So two examples of adrenal pseudocyst on coronal imaging, one with coarse calcifications along the wall, but it is otherwise homogeneously fluid density with an imperceptible wall. That is an adrenal pseudocyst. The second lesion has a thin septation with some calcification, but again, no solid components, and this is a benign pseudocyst. Now, two different lesions. There's a pseudocyst on the left with some small calcification in the wall, but otherwise a thin uniform wall and homogeneous fluid density. In comparison, a cystic pheochromocytoma on the right, you can see that there's varying wall thickness and enhancement of the wall. That is not the leave-alone pseudocyst. That is a cystic pheochromocytoma. So you have to really carefully inspect the wall in these patients using axial and MPR images. Finally, I just want to go over a few pitfalls. And these are lesions that mimic adrenal masses. Starting with varices. So on the arterial phase, large retroperitoneal varices will not enhance, and they will look like a soft tissue mass. But on a venous phase acquisition, they become brightly enhancing, and so they are often located right next to the adrenal gland. If you see this, be sure that you have a venous phase acquisition before you call an adrenal mass. In a patient with portal hypertension, because they can mimic a soft tissue mass if you don't have the right phase of post-contrast acquisition. Varices, classically hypervascular on the venous phase. A gastric diverticulum can often look like an adrenal nodule in the left adrenal gland. As you can see, the sagittal MPR was helpful, showing that this is actually arising from the stomach. Another thing that's helpful I found in these cases, if the patient has an old scan and you look back, you'll see at some point there was a little bit of air in the diverticulum, and then you're again sure that it's just a diverticulum arising from the stomach. But this is another potential mimic. And then finally, just a few words about collision tumors. This is something to be aware of that can occur in the adrenal gland. Different tumor types can coexist in the adrenal gland. So, for example, if you see an adrenal mass with macroscopic fat in a patient with Cushing's disease, well, macroscopic fat is an indicator of a myelolipoma, and we know that that is a non-functioning lesion. However, the patient who has Cushing's syndrome actually may have a collision tumor, as in this case, at pathology there was both adenoma and myelolipoma. So this is, again, very rare, but something to keep in mind. If you have a patient who has has symptoms of an adenoma, and yet it has an adrenal lesion that is not classic for an adenoma. So in closing, I just want you to make sure that you understand that different protocols are critical depending on the indication. There is not just one protocol for adrenal imaging. You really have to tailor the acquisitions that you perform and the timing of these scans depending on whether you're characterizing an adrenal nodule, whether you're evaluating a pheochromocytoma or adrenal cortical carcinoma. Also important to recognize the features that we've reviewed that aid in distinguishing the different types of tumors that involve the adrenal gland, and keep in mind the pitfalls and lesions that mimic other pathology. Thank you very much.
Hi, my name is Shiva Raman from Johns Hopkins University. Now, over the course of this lecture, let's talk a little bit about challenges in detection of transitional cell carcinoma. Now, we're going to really spend some time going over technique, and specifically what kind of protocol options you have in terms of CT urography. Now, I'll discuss what we do at Hopkins and our rationale for our protocols, but also give you a sense for some of the other options you might have to choose from. Now, once we've talked about technique, we'll go on to discuss a little bit about a generalized approach to imaging hematuria, including which patients really need a CT scan and which don't. And then finally, we'll spend some time really looking at CT findings, including what you should be looking for when you're trying to diagnose TCC at different parts of the collecting system, including the intrarenal collecting system, the ureters, and the bladder. Now, when you're putting together a CT urography technique, your goal is actually pretty simple. Fundamentally, you're trying to maximize distension of the upper urinary tract with contrast, but do so with the least possible radiation dose. Now, if you look at the literature, there really are three primary protocol options available: single bolus technique, split bolus technique, and then theoretically a triple bolus technique. Now, the single bolus technique is by far across the country the most commonly used technique in practice. It is undoubtedly going to be the most effective in terms of maximizing urinary tract distension. And if you look at the protocol in detail, you realize why, right? You're giving 120 cc's of contrast, you're acquiring multiple different phases, but the entirety of that contrast dose is actually contributing to excretion. So this protocol is pretty simple. You give the contrast, you acquire arterial and venous phase images at about 25 to 30 and 50 to 60 seconds respectively, and then you acquire excretory phase images between 5 to 8 minutes. Now, because you're acquiring multiple discrete phases, including arterial and venous phases, you are going to have a higher sensitivity for RCC compared to some of the other protocols I'll talk about, but by the same token, you are acquiring at least 3 phases, sometimes 4 if you include non-contrast imaging, so it does have a higher radiation dose as a result of that compared to the other protocols. Now, the other major option you have out there, and it's used in some institutions, is the split bolus technique. Now, the split bolus technique entails dividing your contrast dose into 2 and acquiring a combined excretory and nephrographic phase. So if you look at the graphic, you see that you would initially administer 50 cc's of Omnipaque, you wait about 5 minutes, then you administer another 80 cc's of contrast, and then at 7 minutes you acquire combined nephrographic and excretory phase images. So because you are combining 2 of the phases, you are going to reduce radiation dose, of course, because you're acquiring fewer phases of contrast. Now, the problem is, if you look at the protocol, only that initially administered 50 cc's of contrast is actually going to contribute towards the excretion in that delayed phase. So as a result, undoubtedly, you're going to end up with less robust collecting system distension, and that's particularly a problem in the distal ureters, where this technique is known to have problems in terms of distending the distal ureters, and that is an issue given that that's the most common location for ureteral TCCs. Now, in theory, another option is something called the triple bolus technique. Now, this is a rare protocol, and to be honest, I've never actually met anyone who uses it in practice, and I think it really is more of a literature or academic thing than a true protocol used out in the community. But just talking about it for completeness sake, the triple bolus technique involves splitting your contrast dose into three separate administrations, and so you acquire a single combined corticomedullary, nephrographic, and excretory phase. So you give 30 cc's initially, you wait a few minutes, you give another 50 cc's, you wait a few minutes more, you give another 65 cc's, and then at the end you acquire a single combined phase that gives you corticomedullary, nephrographic, and excretory phase enhancement. Now, because you're acquiring a single phase, of course, you're going to dramatically reduce your radiation dose. But as you can imagine, because only 30 cc's of that initially administered contrast actually contributes towards excretion, you get very poor collecting system distension and opacification. I think there's little doubt that this protocol dramatically reduces your sensitivity for TCC. And because you're not acquiring multiple discrete phases, I think you're going to have trouble catching some of those subtle renal cell carcinomas as well. Now, once you've decided which of those 2 to 3 techniques you want to use, the next step is to decide whether you want to use any one of a number of ancillary techniques that have been described in the literature. These are all techniques that some places use, some others don't, and there is some debate about all of these techniques if you look at the literature. So let's go through them one by one, and we'll talk a little bit about the pros and cons of using each technique, and that includes abdominal compression, IV saline, oral hydration, Lasix administration, prone positioning rather than supine, and finally using a lower dose of IV contrast. So let's start with abdominal compression. Now, for those of you who have never used this, this is essentially a band that goes across the abdomen. You basically use it to compress the upper urinary tract. So you acquire 2 different acquisitions. You get one set with the band compressing, and that theoretically traps the contrast in the upper urinary tract, in other words, the intrarenal collecting systems in the ureters, and theoretically improves distension and gives you a better chance to identify TCCs superiorly. And then you acquire a separate set of images after you release the compression band and the contrast flows distally into the ureters and the bladder. Now, the problem with abdominal compression is that even though all of that sounds great in theory, the problem is that if you look at the literature, it's actually not at all clear that it works. In fact, there's an article in Radiology a few years ago that showed that compression really did not do anything significant in terms of improving distension or opacification of the urinary tract. And I would say that my own experience has been pretty similar. I've worked at an institution where these bands were used on every case, and to be honest, I don't think that it made much of a difference. Now, on top of that, it does affect your workflow, so the study takes a little longer, or is at least a little more complicated, because your technologists have to acquire those 2 sets of images before and after compression. And you also have to be careful in terms of using the band or the compression in patients who have any kind of recent surgery or aortic pathology. It's quite painful or cumbersome to deploy in patients who are obese. Now, putting all that together, I would argue that abdominal compression isn't really worth it, and it's kind of it creates more problems than it actually solves. Now, what about something that actually has been proven to work, and that's IV Lasix? So typically just a small dose of about 10 milligrams has been shown in multiple studies to improve distension of the collecting systems and ureters, and including this article by Silverman et al. In Radiology about 10 years ago. They showed that you get significantly better distension when you use saline when you use Lasix compared to other methods, and that was particularly the case for the distal ureter, which has traditionally always been a problem in terms of getting good distension. Diuretics not only help you in terms of distension, they also actually help you by diluting out the contrast. So if you look at many IVP studies or urogram studies, the contrast is really dense, and even windowing it, you can have trouble actually seeing through the contrast to identify subtle nodularity or thickening. Diuretics, by diluting out that contrast, can actually make the contrast a little less dense, reduce beam hardening, and honestly make it a little bit easier to see through the contrast to identify true abnormalities. Now, the question isn't whether this works or not, because I think it's pretty clear it does work. The question is whether it gives you enough of a benefit to really compensate for the fact that this really can create some issues in terms of workflow, especially when you're doing a lot of these studies, right? Obviously, you have to have nursing on staff to administer the medication. You have to take into account Lasix allergies. You have to look at blood pressures, renal function, so on and so forth. So this can create some issues for workflow, both from a technologist and nursing standpoint. And for reasons I'll go into a little later, this is not something that we routinely do at Hopkins, and we feel that it's just not worth it in terms of the impact on workflow. Now, what about prone positioning? So, of course, we routinely do these supine. What about putting the patients prone? Does that make any difference? In theory, you put the patient prone, and you would hope that contrast would accumulate in the proximal collecting system or upper urinary tract and give you better distension. Is that actually the case? And the answer is no. There's a nice study about 5 or 6 years ago in clinical imaging showing that supine positioning was clearly superior to prone positioning in terms of opacifying the pelvocalyceal system. Now, on top of that, even if it did work, I would challenge any of you, ostensibly healthy people out there in the radiology community, to lie flat on your stomach on a hard CT scanner gantry for at least 5 to 6 minutes, right? I think that's pretty uncomfortable. Honestly, I would not want to do it. And you can imagine we have patients with comorbidities, who are obese, who have other issues where prone positioning would be even more problematic and even more uncomfortable for those patient groups. I would strongly recommend avoiding using prone positioning. Just stick to the standard supine positioning. So what about something that's pretty easy? Oral hydration. Now, this works really well. In fact, this is what we do at Hopkins, as I'll go into later. And there are multiple studies out there showing that oral hydration works as well, if not better, than any of the other options, including this study by Tsutomi Kawamoto, one of my colleagues. She wrote an article in AJR about 10 years ago showing that oral hydration did as well or better than any of the other alternatives. And so, to be honest, regardless of whether you pick any of the other alternatives or not, I would strongly recommend that you orally hydrate the patient. And we'll talk about exactly what we do a little bit later. Now, what about something a little bit atypical that not many groups do, and that's lowering the contrast concentration but giving a higher volume. So in theory, you could give 200 cc's of Omnipaque 240 as opposed to 120 cc's of Omnipaque 350. Now, that sounds a little unusual, so what's the rationale? Well, in theory, at least proponents of this protocol would argue that by giving a larger volume, you get better distension of the collecting systems and ureters, and because the contrast is less dense, you get less beam hardening, and theoretically a greater ability to see through the contrast and evaluate the lumen. So you might be able to identify subtle nodularity, subtle urothelial thickening a little better. This is something I would strongly urge you against using, okay? Now, the problem with this is that it assumes fundamentally that the only diagnosis you're trying to make on a CT urogram is transitional cell carcinoma. And as far as I'm concerned, that is not true, right? Your TCC is really one of many different possible diagnoses in a patient with hematuria. And by doing the study this way, you're essentially going to end up with washed out, very grayed out images, very poor contrast opacification, and I think you're going to have real trouble in terms of evaluating the rest of the abdomen and looking at the renal parenchyma. I think you'd put yourself at real risk of missing subtle renal cell carcinomas, vascular abnormalities, and other subtleties, subtle diagnoses that we'll talk about later that potentially could explain the patient's symptoms, and instead you're going to be able to, all you're really going to be able to say is, yes, there is a TCC, or no, there is not a TCC. So putting all of that together and putting together all the, considering all those options, what do we do at Johns Hopkins? Well, Dr. Fishman's philosophy regarding CT imaging in general has always been that the most important thing is to get the diagnosis right. Do the study right the first time, and that's really the best way to reduce radiation dose. By using protocols that lower dose but potentially lower image quality, you do run the risk that you don't get the diagnosis and the patient keeps getting imaged over and over again just because you're never able to arrive at a firm or definitive diagnosis. Our philosophy generally is do the study right, get the answer that allows the patient to be treated adequately, and make sure that they don't need to be scanned over and over again. So as a result, we've decided to go with the single bolus technique. Our argument is that it's the most likely to give you good collecting system distension, so it's great for transitional cell carcinoma. And by the same token, by acquiring multiple discrete phases, arterial, venous, and delayed, you maximize your chances of diagnosing not only renal cell carcinoma, but multiple other pathologies that might potentially explain a patient's hematuria. Now, we also include non-contrast images because we do want to look for stones, which are, of course, another very common cause of hematuria in the ER setting or in the outpatient setting. But that being said, we definitely do want to consider radiation dose. You do not want to radiate the patient any more than absolutely necessary. And accordingly, we only image those portions of the patient in each phase which are absolutely necessary. So we start with non-contrast images that cover just the abdomen. In that phase, all we're worried about is, are there or are there not intrarenal stones that might be causing hematuria? The arterial phase subsequently is going to cover both the abdomen and the pelvis, and that's typically at about 25 seconds after IV contrast. Now, the arterial phase images give you several advantages, and you're going to look at those, number one, to identify renal cell carcinoma. It is by far the best phase for clear cell RCCs. Number two, it gives you unopacified views of the ureters and bladder, so it is by far the best phase for identifying bladder cancers, as we'll talk about a little later, and it allows you to identify urothelial thickening and hyperenhancement in either ureter. And third, it allows you to identify a number of vascular abnormalities that might potentially cause hematuria, including renal artery aneurysms or renal AV fistulas, or AVMs. We then acquire a venous phase just covering the abdomen about 60 seconds after IV contrast. That gives you another look at the kidneys to identify renal cell carcinoma, and it gives you a good evaluation of all of the solid organs of the upper abdomen. Finally, we acquired delayed excretory phase images about 240 seconds after IV contrast injection, and this covers the entirety of the abdomen and pelvis. And this gives you nice excretory phase images of the intrarenal collecting systems and the ureters. Now, we talked about a lot of ancillary techniques earlier, and honestly, the only one that we use in our own practice is extensive hydration. So we tell the patient to drink about 1,000 cc's of water immediately prior to the study, and this does a few things. One, it improves urinary tract distension. It dilutes out the contrast, so it reduces beam hardening and allows you to see through the contrast to identify subtle abnormalities. It gives you great bladder distension, so particularly in the arterial phase images, you get great bladder distension, and you can see subtle urothelial nodularity or thickening, as well as urothelial hyperenhancement. And accordingly, we also tell the patient not to void for at least an hour prior to the study. And then, of course, drinking water is always great in CT patients who are getting a contrast CT because it reduces the incidence of contrast-induced nephropathy. Now, we give 120 cc's of Omnipaque 350, and we obtain our delayed images at about 5 minutes in most patients. Now, the only reason we go any longer than 5 minutes is in patients who have an EUPJ obstruction, and in those patients we wait up to about 8 minutes. Now, I would strongly urge you to avoid any longer delay than about 5 minutes, because the longer you wait, the denser the contrast in the collecting system gets, and the more likely you are to get beam hardening and streak artifact. Now, if you look at studies that have been done with a very prolonged delay, 8 minutes, 10 minutes, you can end up with really, really dense contrast, streak everywhere, and to be honest, even though you may get great distension and great opacification, the study is still going to be suboptimal in terms of identifying those subtle early TCCs. Now, I'm not going to go into this too much, but I will say that I think that this is probably the indication for which 3D imaging is the most helpful. Volume rendering, MIP projections can be incredibly helpful in terms of looking at the collecting system, particularly when you're evaluating the delayed excretory phase images. But if you're not using 3D imaging, and you should be, at the very least you've got to look at things in multiple planes. Especially use the coronal multiplanar reformats to look at the intrarenal collecting systems, to identify those subtle renal cell carcinomas that are either at the upper pole or the lower pole. I've seen people really get burned on these cases when they just rely on the axial source images alone. And here's some nice examples of MIP and volume rendered reconstructions. So now that we've talked a little bit about protocols, why don't we talk a little bit about who exactly should get a CT scan? And I think a lot of this has to do with what kind of hematuria you have. Now, there is little argument that patients who have macroscopic hematuria are at high risk of malignancy. So if you look at the literature, anywhere between about 3 to 6% of patients with macroscopic hematuria will be found to have a urinary tract malignancy, whether it's a transitional cell carcinoma or a renal cell carcinoma. So anybody with macroscopic hematuria essentially should go on to get a formal evaluation, and that entails looking at the bladder with cystoscopy and evaluating the upper urinary tracts, i.e. the ureters and the intrarenal collecting systems, using a CT urogram. Now, microscopic hematuria, on the other hand, is a lot more controversial. And if you look at the literature, different sources will have very different opinions on what exactly should be done. But that being said, it is undoubtedly true that a large percentage of the population, or a significant percentage, somewhere in the order of about 2 to 3%, who are asymptomatic and have no underlying pathology, will have microscopic hematuria incidentally. So that means about 1 in 30 or 1 in 50 patients who comes into the emergency room for completely unrelated reasons, if you check a UA, they're going to have microscopic hematuria. And so you have a large group of patients who you're never going to find a cause for an abnormality. And so in other words, patients with microscopic hematuria do not routinely need follow-up. So they do not routinely need a CT scan. Not all of these patients need to get a cystoscopy. These patients, you basically need to take into account who the patient is. So only those patients who have specific risk factors for urinary tract malignancies need a further workup in the setting of microscopic hematuria. Now, there are many, many different causes of hematuria. Transitional cell carcinoma is certainly not the only one. So if you look at these causes, there are many different potential etiologies at the level of the kidney, the bladder, the ureter, or even outside the urinary tract. So you're not just looking for TCC, you're looking for renal cell carcinoma, infection, stones, renal vein thrombosis, vascular malformations, papillary necrosis. You're looking for inflamed bladder diverticulum, obstruction, anticoagulation, prostate abnormalities. So you really have to make sure that you don't get tunnel vision. I think all too often when we interpret these studies, a lot of radiologists are just thinking all about TCC, but remember, TCC is one of about 30 different things that you need to consider on your differential diagnosis. But all that being said, this lecture is fundamentally about transitional cell carcinoma, so let's talk a little bit about the imaging findings. Transitional cell carcinoma is not the most common malignancy in the world, right? Relatively rare, certainly more rare than renal cell carcinoma, and tends to be found most often in men, especially elderly men, and the vast majority of these patients will present with hematuria. There are a number of different risk factors, the most potent of which include cigarette smoking, certain chemical carcinogens and dyes, cyclophosphamide, analgesic abuse, including phenacetin, and then, in theory, heavy caffeine use. Now, why don't we talk a little bit about the findings of TCC at every single point in the urinary tract. And let's start by looking at the intrarenal collecting system. Now, intrarenal TCCs, for the most part, tend to be small, superficial, and frond-like with a relatively good prognosis. So most patients with intrarenal collecting system TCCs tend to do pretty well. The problem is that there is a small minority of these cancers that end up being infiltrative, that are multifocal, and patients with such malignancies are much more likely to have a poor outcome. Now, regardless of whether you have a TCC with a relatively good prognosis or a bad prognosis, these lesions do have a strong tendency for bilaterality and multifocality. So you see a lesion in one kidney, you really need to look at the other kidney, both ureters, every single point in the urinary tract very carefully to make sure there's not a second lesion. Now, with regard to the intrarenal collecting system, the most common location for TCCs are actually going to be the renal pelvis, and that makes sense because they actually have the largest area of urothelium within the intrarenal collecting system. Now, what are you looking for? Now, on the arterial phase images, you're looking for urothelial hyperenhancement, usually focal, associated with urothelial thickening and nodularity. And you're going to be able to identify that thickening and nodularity on the delayed excretory phase images as well. You're looking on the excretory phase images for a focally dilated calyx as a result of obstruction by a tumor, or an amputated calyx that's been destroyed by an associated mass. Now, when you do see a discrete mass as opposed to just focal urothelial thickening or nodularity, the mass is typically going to be infiltrative and poorly marginated. So it's not going to look like a renal cell carcinoma that's a round ball. It's rather going to look very ill-defined and infiltrative in terms of its morphology. Now, I will admit I've seen a lot of these now that have been quite subtle. So you're not just looking for a large lesion. You've really got to look for some relatively subtle findings. So here's an example of a case in which there is asymmetric mild left-sided hydronephrosis, and notice that at the level of the left renal pelvis there is this focal urothelial thickening resulting in a stricture of the pelvis, probably over about 2 centimeters, and there's obstruction proximal to the site of stricturing. So this really is the kind of abnormality you're looking for. Any focal urothelial thickening must raise concern for malignancy. Here's another example that I think is even more subtle. Upper pole calyx in the left kidney, notice that there's subtle focal urothelial thickening and nodularity. Clearly, that's abnormal. This turned out to be a renal cell carcinoma. Here's another example. Again, you can see that there's focal soft tissue in the left upper pole. Notice that it's surrounding that left upper pole calyx, which is irregularly narrowed. This turned out to be a small renal cell carcinoma. Now, I will admit, I think that the delayed excretory phase images, at least with regards to the intrarenal collecting system tumors, is certainly going to be the best phase in terms of identifying these lesions. But that being said, there are going to be cases where it may be obvious or maybe most diagnosable on either the arterial or venous phase images. Here's an example where you can see the lesion on the corticomedullary phase images, but it's more obvious on the delayed images. Notice how there's destruction and irregularity of that upper pole calyx on the right, but the mass in the upper pole on the corticomedullary phase images, which is highlighted by the arrow, relatively subtle, right? Very easy to miss. It just blends in with the adjacent medullary pyramids. Now, as I mentioned, these lesions have a strong tendency for multifocality and bilaterality. So identifying a single lesion doesn't mean that your job is done. Identifying a single lesion just means you need to look doubly hard at the rest of the urinary tract to identify a second or a third lesion. So here's an example where you can see that there is extensive multifocal disease, right? So I've shown you a single axial slice where there are at least 2 nodules within the renal pelvis, but if you look at the coronal MIP reconstructions from the excretory phase, there are actually extensive lesions throughout the right collecting system and possibly in the left collecting system as well. Now, not everything that looks like your TCC necessarily is transitional cell carcinoma. There are certain mimics on imaging. I'd say the most important mimic is probably lymphoma, which can look very similar as an ill-defined infiltrative mass involving the kidney, but that being said, typically is associated with other stigmata of lymphoma. So you're going to see lymphadenopathy and maybe other sites of extranodal disease. Metastatic disease, in theory, can mimic TCC, and I've only seen this a few times, but every once in a while you'll see a colon cancer or breast cancer or prostate cancer that goes to the kidney. I've seen quite a few infiltrating variants of RCC, or renal cell carcinoma, that have looked for all the world like a transitional cell carcinoma. They involve the collecting system, they were ill-defined, poorly marginated, and then finally, in theory, xanthogranulomatous pyelonephritis. Now, the second compartment of the urinary tract that I want to talk about is the ureter. Now, identifying ureteral TCCs can be really a big problem. Now, fortunately for us, this is pretty rare, not that common, and so this isn't something that's going to come up every day, but when it does, I will admit, it can present quite a challenge for the radiologist. Now, ureteral TCCs can occur anywhere in the ureter, but the vast majority of lesions, at least 3/4 of all lesions, occur in the distal ureter. And that's part of why these are so problematic to diagnose, because the distal ureter is the most difficult portion of the ureter to consistently distend and well visualize, even when you're using the best of technique. Now, most ureteral tumors are going to be TCCs, but rarely you'll see a ureter involved by metastatic disease or lymphoma, but not that common. Now, the findings of TCC in the ureters are very akin to those that you're going to find in the intrarenal collecting system. Urothelial thickening, especially thickening that's focal or nodular. Abnormal urothelial hyperenhancement, again, especially when it's focal or in conjunction with urothelial thickening and nodularity. Calcifications of the ureters, in particular calcifications in the wall of the ureter rather than ureteral stones. Periureteral fat stranding, which is a finding that we typically associate with infection, but can be seen in the setting of extramural spread of tumor. And then, of course, if you're lucky, of discrete filling defect or mass, which makes it relatively easy to make the diagnosis. Now, one thing I do try to tell our residents and fellows is that treat the ureters a lot like you would treat the bowel. So when you're looking at a bowel obstruction, you're trying to find a site of transition, right? You look for proximally obstructed, dilated small bowel, distally decompressed small bowel, and then somewhere in the middle is going to be a site of transition, and then you interrogate the site of transition trying to find an obstructing mass or tumor. And that's very much going to be the same approach when you're looking at the ureters. Look for a site of transition between dilated and decompressed ureter, and at that site, you're going to look for any focal nodularity or thickening that might portend the presence of a tumor. And this has also been described as the so-called goblet sign that we all learned during in fluoroscopy. Now, these ureteral TCCs can be really difficult and really subtle. Here's an example that looks obvious when I point an arrow at it, and I give you the exact right slice to look at, but you can see that this is not a dramatic finding, right? There is focal irregularity and thickening along the medial wall of that left mid-ureter. Maybe there's a little bit of a stricture there, but honestly, that could just be peristalsis. You can imagine that this is the kind of finding that would be very easy to overlook, right? I can imagine many radiologists are not going to see that. So you've really got to be on the lookout in these patients with hematuria, not just for obvious findings, obvious signs of obstruction, because sometimes you're looking for subtle thickening, and many of these patients may not have evidence of proximal obstruction. Here's another example. Now, if you look at this coronal MIP reconstruction on the left, well, there's an area that's unopacified in the proximal ureter, on the right. There's an area that's unopacified. Is that real? Is that a stricture, or am I potentially just dealing with peristalsis? Well, maybe the right-sided collecting system is a little more dilated compared to the left, but not unequivocally so. But then you look at the source images and you see that there really is focal soft tissue at the site of stricturing. This turned out to be another ureteral TCC. Here's maybe the most subtle case that I've seen over the last couple of years. Now, this is a patient who actually had long-standing hematuria, had, as far as I know, been scanned at least 5 or 6 times at virtually every hospital in the surrounding area. Never had the diagnosis made. No one could figure out why this patient had hematuria. One of my colleagues looked at the study and noticed that, well, maybe there's a little bit of a ragged edge along the medial aspect of that left proximal ureter. Why don't I look at the source images a little more carefully? And then if you look really carefully, there's very subtle thickening along that medial ureter, and this turned out to be a ureteral TCC. That's how subtle these cases can be. That's how hard it can be to make this diagnosis. So you've really got to be on the lookout for those subtle findings. Now, here's a case that nicely illustrates what I was talking about earlier in terms of periureteral fat stranding. Now, classically, when you think of the periureteral fat stranding, we all first start thinking about infection, and in most cases, that's what you're dealing with. But when you see a focal stricture, focal urothelial thickening with focal periureteral fat stranding, that can be seen in the setting of tumor. And usually when you have a tumor and you see surrounding fat stranding, it means that you're dealing with the extramural spread of tumor into the surrounding fat. Now, another finding that can be helpful is neovascularity. Now, as you all know, transitional cell carcinoma is a tumor that can be relatively vascular on the arterial phase. And so if you're looking at arterial phase imaging, not uncommonly you'll see focal urothelial hyperenhancement. And for some tumors, you can actually see tumor vessels or neovascularity feeding the ureter at that site, as in this case. And so in cases like this, when you see true neovascularity associated with the ureter, you have to really worry about the possibility that you're dealing with a neoplasm. Finally, this is the kind of tumor we'd all want to see, right? This is easiest to identify, not difficult to make a diagnosis, focal filling defect. Unfortunately, in my experience, this is the least common appearance for ureteral transitional cell carcinomas. Most cases are not going to be this easy. Now, as I mentioned earlier, treat the ureter like you do the small bowel, look for site of transitions. Here's the classic goblet sign, right? Proximal ureter dilated, filled with urine. The distal ureter is decompressed and narrowed. There is a goblet shape right at the site of transition. This is a classic finding for transitional cell carcinoma. We're all used to identifying this finding on classic fluoroscopic studies, but it's a finding that you are going to be able to make on CT as well. So why don't we end by talking about the bladder, which to me is actually one of the most important parts of our evaluation on CT, but honestly is something that we tend to ignore all the time. Now, bladder cancer is actually quite common. Unlike the other tumors I talked about in the intrarenal collecting system and the ureters, this is something that we see all the time. It is the 4th most common malignancy in men, 10th most common malignancy in women, and you're talking about somewhere in the order of 60,000 new cases every year. Now, the vast majority of bladder cancers are TCCs, but there are other histologies possible, including squamous cell carcinoma and adenocarcinoma. Now, as with other portions of the urinary tract, most of these lesions are superficial with a good prognosis, but there are aggressive forms, and when they metastasize, the prognosis is actually very poor, somewhere in the order of 5% at 2 years. Now, all too often, I'll hear residents and fellows say, well, I didn't really look at the bladder that well because, after all, it's not our job to look at the bladder on a CT scan. They're going to get a cystoscopy anyway. That is the farthest from the truth that I think you could be. Yes, these patients with macroscopic hematuria should get cystoscopy, and yes, I will admit it is the gold standard in terms of identifying bladder cancers, but that does not obviate our responsibility for looking at the bladder. You got to remember, patients who come into the ER with hematuria and get a CT scan, well, a lot of those patients, how many of them are actually going to end up with a cystoscopy? How many of them are lost to follow-up? So if you're able to make the diagnosis of a potential bladder cancer on a CT scan, you really can speed up that patient's diagnosis. And in some patients who might have not gotten a cystoscopy because they were lost to follow-up, you might be able to make sure that those patients are better dealt with. Now, even if you assume that cystoscopy is a better modality, I think you shouldn't sell CT short in terms of identifying bladder cancers. There's a nice study in radiology from 2008 that showed that the sensitivity and specificity of CT for bladder cancer, better than you think, not bad, right? Somewhere in the order of a sensitivity of 79% and a specificity of 94%. So this is definitely a diagnosis that we can make on a CT scan. And, you know, interestingly, Dr. Fishman has always been interested by this particular diagnosis. And we've gone back and looked, and it's amazing how many bladder cancers there are that radiologists just don't see, right? And I think if you go back in retrospect and you look at a lot of CT scans, you can see that those bladder cancers are there to identify. It's just that we assume they're going to be found on cystoscopy, so we don't look hard enough. So always make this a part of your search pattern. Look carefully at the bladder and make sure that you're not missing a subtle tumor in a patient with hematuria. Now, what do bladder cancers look like? Now, there is some variability in terms of how much they enhance, but generally, most bladder TCCs will enhance avidly early and are going to be best identified on the early phase images. Now, this is one of the reasons why our protocol at Hopkins entails getting arterial phase images through the entirety of the abdomen and pelvis, because we want to look at the bladder in the arterial phase. Subtle nodularity, subtle bladder wall thickening, arterial hyperenhancement, much easier to see on the arterial phase images where there's unopacified urine within the bladder, as opposed to the delayed images. Now, on the delayed images, yes, you may be able to see a discrete filling defect, but in general, I've found that the delayed images are quite poor in terms of identifying most bladder tumors. Now, one of the reasons because we put so much stress on identifying bladder tumors in our practice, we actually have designed our protocol in such a way as to maximize bladder distension. So obviously, as I mentioned before, we hydrate the patients prior to the study, which does obviously increase distension, but we also instruct the patients not to void prior to the study for at least 1 hour, again, to make sure that the bladder is as distended as possible, allowing us to identify subtle tumors. Now, what are you looking for? You're looking for pretty much the same things you were more superiorly in the urinary tract. You're looking for focal asymmetric wall thickening, a focal mass, a small filling defect, or any calcification. Remember, calcification is a finding often associated with TCC, so any calcification within the bladder wall itself should always raise concern for a malignancy. Now, I will say that you don't want to be overcalling it, though. I mean, yes, you want to be sensitive and you want to look for bladder cancers, but you have to realize that not everyone with a thick bladder necessarily has a malignancy. In particular, what you're looking for is asymmetric focal wall thickening. Diffuse wall thickening is really common, and in most cases it's just because the bladder is inadequately distended, but if it is real, it's usually on the basis of something inflammatory. So it could be cystitis, or it could be chronic thickening as a result of bladder outlet obstruction, or it could be someone with a neurogenic bladder. So if I see diffuse thickening, I'm not going to recommend a cystoscopy. I'm only going to recommend that cystoscopy when I see thickening that's focal. So cases like this where you see a focal nodular mass or polyploid mass tend to be relatively easy, right? I will say, though, that I still think that these kind of lesions are easier to identify on the arterial phase compared to the delayed phase. In the delayed phase, if you get contrast pooling in the wrong way, small filling defects can be hard to see. Larger lesions like this are going to be obvious, but I think most bladder cancers are easiest to identify on the arterial phase. Large lesions like the last one, everyone's going to make the diagnosis. These are the kind of lesions that I've seen missed. Small nodules in that 5 millimeter, 1 centimeter range. Very difficult to identify if you don't take the time to actually look at the bladder specifically. And in this case, you can see that it's an obvious tumor, right? There's really no doubt that that's going to end up being a neoplasm, but you just have to take the time to actually look at the bladder. My one recommendation would be also, don't just rely on the axials. The axial plane can make it quite difficult in certain positions to see tumors, especially tumors that are right underneath the superior wall of the bladder or at the very base of the bladder. So look at the coronal or sagittal reformats as well. Now here's a nice example illustrating why I think the arterial phase images in general are better for identifying bladder tumors than the excretory phase. If you look at the image on the right, you can see that there's a nodule or nodular mass along the posterior wall of the bladder, fairly obvious on the arterial phase. I think it's more subtle on the delayed phase. You got contrast there, there's some streak artifact. It's just a little more difficult to identify. So I tend to concentrate, when I'm looking at the bladder at least, mostly on the arterial phase. Here's another pretty subtle case. Notice that on the excretory phase images, hard to say anything for certain. Portions of the bladder wall are obscured by that dense contrast, especially along the lateral bladder walls. But notice on the arterial phase that there's focal wall thickening at a couple of sites. Left lateral wall, probably right anterior bladder, and each of those two sites is associated with subtle urothelial hyperenhancement. This is how subtle some of these tumors can be. You see something like this, you've got to recommend that the patient go on to get cystoscopy. Now here's a nice example illustrating the avid vascularity of bladder tumors. Now this is not a difficult mass to diagnose, but notice that there's lots of vascularity, there's enhancement, there's some tumor vessels feeding the lesion. These are fundamentally hypervascular lesions, and as a result they tend to enhance most avidly and be most conspicuous on the arterial phase. Now, as I mentioned earlier, I'm a real proponent of looking at the bladder in multiple planes. Here's an example where if you look at the axial image, it looks pretty normal to me. And you can scroll up and down, and I think the axial images were not completely convincing. But if you look at the coronal images, either in the arterial phase or in the delayed excretory phase, you see that there's wall thickening and it's relatively focal. It's just involving the right lateral bladder wall. The rest of the bladder looks normal. And of course, as a helpful contributory feature, there's right-sided hydronephrosis and hydroureter. So this is a bladder cancer that is much easier to diagnose when you're looking at a coronal reformat. Now, calcification anywhere in the urothelium is problematic and should at least raise the possibility of a TCC. Now, of course, you do not want to confuse an actual intramural or wall calcification with a stone. Stones are going to layer within the bladder. They're going to be within the lumen, as opposed to these calcifications that are actually within the wall of the bladder or within a mass. Any calcification that you can't explain probably needs to be worked up. Now here's an example where there's a discrete polyploid mass, and notice that there are some punctate calcifications associated with the lesion. Now, before we end, let me just stress that I think all too often we tend to get tunnel vision. We think a lot about transitional cell carcinoma when we're dealing with hematuria, but don't forget that there are many, many other diagnoses that you need to be considering. The risk factors for all urologic malignancies share a lot in common. So just remember that TCCs are not the most common urologic malignancy. Renal cell carcinoma is, and both of those cancers share a lot of risk factors, including smoking, older age, hematuria, and so on and so forth. So as far as I'm concerned, these CT urograms are just as important for identifying RCCs as they are TCCs. And that's one of the reasons why our protocol is designed the way it is. We acquire multiple discrete phases, and we have all of the phases that you need to identify those subtle, small renal cells, especially the clear cell RCCs that tend to be most evident on either the arterial or the delayed phase images. We also acquire non-contrast images. Just remember, renal stones are way more common than transitional cell carcinoma. So you've got to be on the lookout for stones not only in the collecting systems, but also with the intrarenal collecting systems, but also the ureters and the bladder. And so remember, you're looking for stones in the kidneys on the non-contrast images, and you're going to use the arterial phase images through the entirety of the abdomen and pelvis for unopacified views of the ureters and the bladder to identify stones in those locations. Infection is really common. Again, way more common than transitional cell carcinoma. So you're looking for diffuse bladder wall thickening, often with perivesicular fat stranding and urothelial hyperenhancement. And you may see evidence of ascending urinary tract infections as well. Notice in this case, both ureters are diffusely thickened, they're hyperemic, avidly enhancing. But notice how this process is diffuse and bilateral. Very unlikely to represent a tumor because of its diffuse nature. This is almost certainly going to be infectious. Pyelonephritis, infection of the renal parenchyma, can also give you hematuria. Notice in this case that you have wedge-shaped hypoenhancement, striated nephrograms suggesting that you have renal infection. Now, one diagnosis that I think people miss all the time that actually not uncommonly can cause hematuria is renal AVMs. And I remember I first saw this a few years ago, and I made the diagnosis, and I thought, well, that's strange. I've never seen that before. And honestly, over the last 2 or 3 years, I think I've made this diagnosis 4 or 5 times. It must be much more common than we think, and honestly, it's not a diagnosis that's going to be very easy to make unless you have arterial phase imaging. But notice in this example, this patient had chronic unexplained hematuria, and you can see that there's a strange tangle of vessels. This is a renal AVM, very easy to deal with for the interventional radiologist once you make the diagnosis. But some of the protocol options I talked about earlier, if you don't have arterial phase imaging as part of your protocol, this is a diagnosis that you're going to miss. Here's another diagnosis that can cause hematuria that you might miss without arterial phase imaging. Here's a right renal artery aneurysm. Patient was presenting with hematuria. Again, not that difficult to deal with, provided that you're able to make the diagnosis. So in summary, to me the key to this whole lecture and this whole topic is really technique. If you don't have the right technique, it is going to be virtually impossible for you to make subtle diagnoses. So figure out what kind of protocol options you want to use, how you're going to ensure that you maximally distend the collecting system, maximally evaluate the renal parenchyma for renal cell carcinomas, but do all of that with the least possible radiation dose. Secondly, I think people tend to focus too much on the delayed images. Yes, the delayed images are important, particularly, I think, for intrarenal collecting system tumors. But as far as I'm concerned, we tend to pay too little attention to the arterial phase, which I think is probably the most important phase. For identifying tumors of the bladder, identifying tumors of the ureters, the arterial phase is absolutely critical, and it's also going to be the best phase to identify clear cell renal cell carcinomas. Finally, as I mentioned many times during this lecture, TCC is not the only cause of hematuria. And if you treat your CT urograms as purely an exercise in identifying TCCs, you are going to miss many other potentially treatable etiologies of hematuria, and some of which can have a significant impact on patient morbidity and mortality. And for that reason, I would strongly advise you to follow a protocol similar to ours. A full 4-phase protocol in patients who have gross hematuria, because that's going to allow you the best chance of identifying the full gamut of different diagnoses that might be causing the patient's symptoms. So that's all I have. Thanks again, and I'll see you guys later. Bye.
Try to spend a good amount of time on the recent update of the Bosnia classification. But a lot of this is going to be to really explain what the problems are in renal mass imaging. So this is a SAM, of course. You'll see little SAM alerts. Pay attention to those slides in particular. So what is the problem with the diagnosis and treatment of patients with small renal masses? Well, it turns out it's a radiology problem, and I'm going to try to suggest to you how we are trying to fix it. So, of course, our goal is to diagnose and make appropriate recommendations, and I urge you to include recommendations in your reports. I know that may be somewhat controversial, but I strongly believe that this is our purview, and I think it's important that we include recommendations. So I hope by the end of this talk you'll understand how and why kidney cancer is being overdiagnosed and overtreated today. I'm going to urge you to apply conservative approaches and to really focus on diagnosing benign disease. And finally, to apply the Bosnia classification version 2019 and understand its potential to contribute to this conservative approach. What we mean by conservative is doing less. We're conserving healthcare resources, if you will, through either active surveillance rather than surgery, or simply ignoring the lesions altogether. So if we go back 10 years ago now, in this particular paper where we were espousing that you needed to fully evaluate renal masses and do a full, what's called renal mass protocol CT. And all this is in your handout. So some of these slides I'm going to go through very quickly to try to save more time for some of the more complex slides. I think you all know how to do a renal mass protocol CT or a renal mass protocol MRI, where these are the basic requisite portions of a renal mass protocol MRI. And again, I hope you all already know this. And again, this is all in your handout and also on the Society of Abdominal Radiology Disease Focus Panel on Renal Cell Carcinoma website. So the problem begins with this so-called incident adenoma conundrum, where we see these all the time and they're almost always benign, but unfortunately, renal cell carcinoma is diagnosed incidentally now, most commonly, and it's curable only when organ confined. So this drive to find cancer at an early stage is driving the evaluation of these renal lesions that are often unnecessary, costly, and cause a lot of anxiety. So first and foremost, when we encounter a lesion that's highly likely benign, we have to reduce imaging utilization. But we have this case, this small little renal lesion there. I mean, that's well less than a centimeter. What would you do with that case? Well, this is what it looks like just 6 months later. Okay, this is a aggressive papillary carcinoma type 2 that's already spread to the nodes. Now, this is a very uncommon subtype of papillary cell carcinoma, and fortunately it's uncommon to have this kind of aggressive approach. And if you correlate the percentage of metastatic disease at presentation with the renal mass size, fortunately in T1A, i.e. 4 centimeters or less masses, the prevalence of metastatic disease presentation is on the order of 4 or 5%. And in my experience, it's probably even a little less, but nevertheless, these are the data. The size correlates with percentage of metastatic disease. I think that's been well known for many years. But because of this, we've been focusing on finding cancers at an early curable stage and treating them, but we're now wondering whether that's the right approach. Well, let's look at some overall cancer statistics in the United States. Kidney cancer and cancers of the renal pelvis are the 6th most common cancer in men and 8th most common cancer in women. So this is a relatively common cancer, okay? But if you look at mortality, it's nowhere on the map among the top 10. So there's this disconnect. We're finding cancers, but patients aren't dying of this disease. So that tells us something about whether, what really the meaning of having a kidney cancer is. But we've been aggressively treating them. This is just a study of patients with less than 10-year life expectancy, well over 66. This is patients of age 85 and older, and you can see that most patients are treated with a radical or partial nephrectomy. Okay, it's only until you start getting into patients over the age of 80 do you get active surveillance shown here in these black bars being used of any considerable amount. So back in 2015, we said, well, this idea that we got to do a renal mass protocol CT and MRI in everybody, it's probably not the right way to go. And in fact, the most common way renal masses present today is for a mass that's performed on an exam and which is really not completely characterized, okay? So we went through the rationale for saying, let's take these cases and maybe leave them alone and have this conservative approach. So there are 5 basic reasons why we argued for that. The first is that, as you all know, most of these lesions are benign, including 20% of small solid ones, but despite that statistic, many are being resected. So we have to step back and say, well, what is a renal mass? Now, the urologists look at a renal mass and they're thinking kidney cancer, okay? And that's their business. They want to make sure they treat kidney cancer at an organ-confined stage. But as radiologists, we need to be focused on any renal mass, any space-occupying lesion. So they could be pseudo-lesions, they could be non-neoplastic etiologies or neoplasms. And we need to make sure that we diagnose the non-neoplastic etiologies first. So you have this case, fairly straightforward, fever of pyuria, wedge-shaped abnormality with a lot of perinephric stranding. The more perinephric stranding you see, the more likely you're dealing with an inflammatory non-neoplastic etiology. This is a case of focal bacterial pyelonephritis, and here the history could be helpful. But the history may not be helpful. Okay? It's not uncommon for patient presented for hematuria, for other reasons, and there's a mass, and you got to look very carefully at the perinephric space to look for those subtle perinephric stranding so you can raise the possibility of focal bacterial pyelonephritis. So step back and think of the broad differential diagnosis of pseudo-lesions such as a column of Burton, hematomas, contusions, infections, vascular etiologies, an infarct, an aneurysm, a venous malformation, cysts, before you get to neoplasm. So any space-occupying abnormality is a renal mass, and I really want to emphasize that infections often will masquerade as tumors. So once you've into the neoplastic gamut, then the question is it a cancer, okay? And so we have to do a good job of making sure that we're not sending benign neoplasms to surgery. We have to exclude benign neoplasms. And unfortunately, we're doing a terrible job at that. Here's this 2019 study of almost 84,000 patients who underwent surgery. for a mass thought to be malignant, and almost 10% of them are benign, and an estimated cost of $153 million. These are urologist-authored papers who claim that this is a significant economic burden, and to quote them, efforts to prospectively evaluate modalities for pretreatment identification, so that means is better radiology, should be further pursued. So we really have a problem as radiologists. We're not distinguishing benign from malignant disease properly. As a result, many benign lesions are being resected. And I believe that it's because we're underutilizing imaging and biopsy when a mass suspected of being cancer is detected. Now, which benign masses are we talking about? And we can go back many years ago to an original Mayo Clinic study which showed that of the benign lesions, they're typically oncocytomas and angiomyolipomas. And you say, why are these being resected unnecessarily? Well, let's take the case of angiomyolipomas first. Now, this is a classic angiomyolipoma. You diagnose it by measuring -10 or less. Make sure you're measuring lesion region of interest, and make sure it's not calcified, because there are rare cases of renal cell carcinoma that have both fat and calcium. So if it's a non-calcified mass in an adult, you can make the diagnosis of a classic angiomyolipoma. But here's a case of this heterogeneous mass. The urologist is standing over you and saying, can I take this out? It looks like a renal cell, right? Can I take it out? No, you need to look for fat in every renal mass that you're about to treat. This has a tiny amount of fat. This is an angiomyolipoma with a very small amount of fat in it. It's a classic AML. It does have imageable fat, but you can't stop with an enhanced CT. No patient should go to surgery or ablation without some examination for fat. So why are classic AMLs being resected? Because they're not having that done, or using the wrong technique. You're not using thin sections. It should be no thicker than 3 millimeters. And you may miss it. We all miss stuff, but you can look very carefully, look for fat. And then there's this animal, okay, this hyperdense mass. And on MRI, it's T2 hypointense and enhancing. So hyperdense, T2 hypointense, enhancing. We said it's a renal cell carcinoma. This is an old case. Out it came, and it was a fat-poor angiomyolipoma. Oops. Patient should not have had an nephrectomy for this. What is this animal? This is a lesion that is hyperdense, enhancing. A light bulb should go off. Think fat poor AML. Or T2 hypointense and enhancing. Think fat poor AML. Could it be a papillary renal cell carcinoma? Yes. So how do you distinguish it? You biopsy it. Now, I don't have time to go into some really exciting advanced stuff using MRI. But here you're talking about a cancer versus a benign lesion. I want to be 100% certain. I want to biopsy those lesions. What about oncocytomas? Now, oncocytomas historically, there was years ago, it was thought, well, they could be malignant lesions. We now know they're not. They're benign. But we're having trouble distinguishing oncocytoma from an oncocytic renal cell carcinoma. And again, I don't have time to go through the details on this, but at the Brigham, we're just going to biopsy these things, because you can make a diagnosis of an oncocytoma with reasonable certainty with an 18-gauge needle biopsy. Now, unfortunately, biopsy is very helpful but underutilized. Okay, here's a survey of over 1,000 AUA urologists, mostly private practice. A third would never perform a biopsy of a T1A renal mass. It's hard to believe in this day and age. This is 2018 survey data. The academic urologists were more likely, but the authors of the paper really said that to their urologist colleagues here, I mean, what are we doing here? In light of 6,000 unnecessary surgeries annually, we're underutilizing this test. It's a good test. This is a large meta-analysis showing good diagnostic rate, good test characteristics. Not perfect for histologic subtype or for grade. We have room for improvement there, but it's a safe test. So you have a smattering of cases like this. These are all solid enhancing lesions. We've ruled out fat. So, we're not dealing with a classic AML. How would you manage these? I hope what you would say is we would biopsy them. Why? Because that's an oncocytoma. That's a fat poor AML. That's a metanephroadenoma, a rare benign tumor, and that's a capsular leiomyoma. So these are all diagnosed with biopsy, saving this patient an operation and nephron loss, and I'll talk to you why that's important in a minute. So diagnosed benign entities. The second reason is that many small renal cell carcinomas are not aggressive. Only about 20 to 25% of them are aggressive. So it's not just the goal of diagnosing a cancer, it's determining which of the cancers that are actually going to limit one's lifespan, okay? And that's a really important point, particularly when you're dealing with an older patient. So this is a large study looking at the grade and aggressiveness, and you can see it's all related to size. I'll just summarize this, that a sixth of 2 centimeter tumors, a quarter of 3 centimeter tumors, and a third of 5 centimeters are aggressive. So many tumors are not considered aggressive lesions. With a 10-year cancer-specific survival of 96% for indolent and 81% for aggressive lesions. So we have another diagnosis problem. We need to distinguish indolent from aggressive disease with imaging, if possible, and if not with imaging, with biopsy. And so that's another reason why biopsy is really being underutilized. But this is a larger problem. It's not necessarily an imaging-only problem. There's studies on urine biomarkers, looking at the biopsy specimens, at molecular genetics. So there's a lot of work being done in this space. So with respect to biopsy, we reviewed sort of the indications for a biopsy in our paper this year at AJR. It is now accepted and recommended when a malignant etiology is possible and where biopsy results may influence management decisions. This is fully embraced. I remember giving this talk years ago, and people come up to me and say, but Dr. Silverman, my urologists just don't want to do a biopsy. They want to take them out. No longer the case, okay? The urology community, the AUA, ASCO, ACR, everybody's endorsed biopsy. And what are the goals? The goals are, as I said, to keep the benign masses from being unnecessarily resected, and also to help select which treatment is best, surgery, ablation, or active surveillance. It's another reason to do a biopsy. So if you have a malignant result, you can put patients into different categories, if you will, an indolent category or an aggressive category, and that might dictate management. Surgery for aggressive disease, maybe watch indolent disease, and then you can put them into an intermediate category. This is just my schema, but what I've done is I've taken a mission group study from 2013 in which they actually stratified patients into indolent, which was chromophobe renal cells and grade 1 papillaries, intermediate, which was the low-grade clear cells, the grade 2 type 1s, and aggressive, type 2 papillary, like that case I showed you up top, or a high-grade renal cell, or urothelial, or sarcomatoid. And then maybe something like this might really wave the future of determining which patient should undergo which treatment strategy. So again, our goal is to try to diagnose indolent disease for which nothing is needed in selected patients. So the third reason to be conservative is that the treatments are costly, morbid, both procedure-related and long-term. And I just want to focus on the long-term morbidity. You're all familiar with, obviously, the risk of having an unnecessary nephrectomy. But the long-term results are, just to summarize, is that chronic kidney disease is an independent risk factor for death, cardiovascular events, and hospitalization. So you don't want to lose nephrons. It's a very important point. The fourth reason is that the treatments do not appear to be affecting our disease-specific survival, and that's really the ultimate goal. Most patients die of other diseases. So here's a graph where we put in the rate per 100,000 of renal cell carcinoma and the mortality between 1975, and this slide is 2015. And to summarize it, since the advent of CT, the incidence of RCC has doubled, but mortality has not changed. So despite us treating all these small cancers, we're not really affecting mortality. What are we doing? This is really the goal. The goal is to actually reduce mortality. What it means is that these small cancers never would cause any death. Here's a little more data to show that maybe the cancer incidence is plateauing, but again, there's little, if any, drop in mortality. And this is just an old slide just to point out that, most patients die of non-cancer disease, cardiovascular disease. Of the cancer mortality, most is non-renal cell. Here's where RCC mortality is, way up here in the corner. Most patients die of things other than RCC. The fifth reason is that we now have a fair amount of data to say that we can watch them safely. This is a study of median follow-up of 67 months. And the data are quite good. The risk of watching these patients appears to be about 1 or 2%. So it's not a zero risk, but it's a low risk. Now let's talk about cystic masses and get to the Bosniak classification, because most masses are cystic. And if you look at the classification, these are the data accumulated over many years, you can see here that among the 2Fs, 3s, and 4s, a good many of them are going to be benign. So the problem is we're taking a lot of these patients to surgery when they shouldn't be taken to surgery for the reasons I just mentioned. So while it's widely used, there's specific problems that we really want to address. One is that this issue of that many benign renal masses are being unnecessarily treated. Cystic RCC, like solid RCC, is overdiagnosed and overtreated. There's a tremendous amount of interreader variability. You think it's a 3, you think it's a 2F, and you think it's a 2. We're all over the place in this. There's also the data on malignancy rates per category all over the place, very variable. And we're not formally incorporating MRI and ultrasound. And it doesn't include all cystic masses. So these are problems that we want to address with this update classification. There was an effort from the SAR's RCC DFP and was published just a few months ago. So what we wanted to do is to modify the definitions to improve specificity, all right? We want to make sure that we say it's a cancer, it really is a cancer. So we had to try to put a larger proportion of masses into the lower classes, define the features, the terms fully, so that people are using the same language, adding MRI and to some extent ultrasound, and then adding every cystic mass, including those incompletely characterized. So let's briefly overview of this. I hope you're familiar with the basics of this, and so I can focus on the proposal changes. So a benign simple cyst, the difference here is that it was defined as a hairline smooth wall and no enhancement. But look at that lesion there. There's a little enhancing wall there. So the proposal defines hairline as 2 millimeters or less, and we allow enhancement in the wall of a simple cyst, so long as it's thin and smooth. Thin defined as 2 millimeters. And we can use ultrasound and MRI to diagnose a Bosniak 1 cyst. The Bosniak 2 lesion, the old criteria had thin and few, smooth septa, no enhancement, also allowed thin border forming calcification. The proposals defines, again, thin as 2 millimeters or less, few as 3 or less, and we allow enhancement in a Bosniak 2 and any calcification. The calcifications are really not predictive. The only caveat being that if you have a lot of calcification, we want to do an MRI to make sure we're not missing any enhancing components. And that's a Bosniak 2 cyst, okay? The other type of Bosniak 2 is the hyperdense cyst, okay? Here, we said it had to be 3 centimeters or smaller. The proposal now is there's an expanded list of Bosniak 2, okay? Now, I know this is complicated, but I'll try to go through them quickly. The first is the multiseptated cyst, as I just defined. The second is the hyperdense, homogeneously hyperdense, 70 or greater mass on a non-con CT. The third is a homogeneous, non-enhancing mass that measures over 20 at a renal mass protocol CT. It may have calcification of any type. A homogeneous mass on a non-con CT that measures 20 or less. That's the simple cystic perirenal mass. And then on a portal venous phase CT, a mass that measures up to 30 Hounsfield units, okay, can be considered a Bosniak 2 cyst, and a homogeneous low attenuation mass too small to characterize, okay? So that's all the masses you might see on a CT. We now can call those Bosniak 2 lesions. Bosniak 2 at MRI, again, is the septated cyst, as I mentioned. A homogeneous, markedly hyperintense on T2-weighted imaging, similar to CSF, like you might see in a lumbar spine MRI. Homogeneous mass markedly hyperintense on T1, so long as it's 2.5 times the normal parenchyma on a non-contest MRI, okay? What about 2F? 2F, the old definition, many, maybe minimally thick, perceived only enhancement, had to have a hyperdense cyst greater than 3 centimeters and thick calcium. So what do we do with that? And then we use these weird terms like indeterminate complex. Those words are out, okay? The proposal is the smooth minimally thick is 3 millimeters. It must enhance, or many, defined as 4 or more, smooth, thin, enhancing septa. And we're going to MRI hyperdense cysts or parent hyperdense cysts that are greater than 3 centimeters, and any mass with a thick calcification. We're going to call those Bosniak 2F cysts. So let's talk a little bit about these septa. Here's a case with 2 septa. It's a 2 because there are 3 or less, and they're thin. And here's one with 5 septa, so that's a 2F because there are 4 or more in thin septa, okay? So remember, enhancing septa of a 2 must be thin and smooth, okay? Now, enhancement's been redefined here, okay? We have a single definition. There's no distinction between perceived and measurable, okay? If it's unequivocally perceived, comparing non-con and contrast-enhanced images or on a subtraction MRI, or measurable. Enhancement's now allowed in a Bosniak 1 and 2, but any feature must enhance to be in a 2F, 3, or 4. So both the definition and significance have been redefined. Now, what if you're talking about a small thing here? If it's not unequivocally visibly enhancing, measure it using the standard criteria for enhancement, 20 or Hounsfield units or greater, delta on a contrast-enhanced CT, or 15%. Increase on MRI. If it's not large enough and not clearly visible enhancing, the feature is non-enhancing, okay? So what about Bosniak 3s? Here, the definition is thick septa, 1 or more, and measurable enhancement. So the proposal says 1 or more enhancing thick, now defined as 4 millimeters or more, or enhancing irregular, defined as displaying 3 millimeters or less obtusely margined convex protrusions in walls or septa. That's a Bosniak 3 lesion. This one's a septated cyst. This one's a renal cell carcinoma. 50-50 chance right now based on the current data. So let's talk about the thin versus thick issue. 2 millimeters or less is a 1 or 2. 3 is a 2F. 4 is a 3, but they must enhance, right? Same with the septa. 2, 3, and 4. So just remember those 3 numbers. 2 is thin, 3 is minimally thick, and 4 is thick. Okay, what about a 4? Those have nodules, okay? And the proposal says 1 or more enhancing nodules, and we define a nodule as 4 millimeter or more convex protrusion or any size convex protrusion with acute margin. So let's understand a little bit better with a diagram here. So here we have nodules along the wall. It's a 3 if they're obtuse margins, and you measure it and they're less than 4 millimeters perpendicular to the wall. That's irregular thickening. Nodules can be any size if they're acute margin, like that little guy, or they have to be at least 4 millimeters in that perpendicular distance to be considered a nodule if the margins are obtuse. Okay, the same with along a septum, okay? So less than 4, okay, it's focal thickening or irregular thickening. And a nodule, it has to be 4 or more if it's obtuse margin, or any margin, any size if it's an acute margin. So again, you measure the perpendicular distance. So what we're trying to do here is to put this talk together from the standpoint of what are we doing with this classification. We're trying to improve specificity, okay? And we're doing that by allowing enhancement at 1s and 2s, as long as they're smooth and thin, septa or wall. It's required in 2F, 3s, or 4s. No feature that is not enhanced can render the mass higher than a 2. And then there are caveats. So the heterogeneous non-enhancing mass at CT could be a 3 or 4. So if it's heterogeneous, non-enhancing on CT, you've got to go and do more and do an MRI. Also, heterogeneously hyperintense on an unenhanced T1 fat saturated MRI is a 2F. Those are very difficult lesions. They could be papillary cell carcinomas, so we're going to follow those. So we're applying this only to cystic masses, okay? Don't misdiagnose an aggressive necrotic RCC as an indolent cystic renal cell carcinoma. We spent a lot of time distinguishing necrosis from cyst. There's really no good definition, but try your best. Cysts are generally thin-walled, well-defined areas where necrosis is more ill-defined and more central. And before this, there'd never been a definition of a cystic mass. I mean, what do you apply the Bosniak to? What are you doing? So we defined it as a cystic mass containing approximately less than 25% enhancing tissue. And then what you can put at the end of your reports, and again, this is all in your handout, we can put this right in your structure report of what a 1 is, benign cyst requiring no follow-up, a 2, and there are 2 flavors, if you will, ones that we know are confident are cysts, and the others that we're not sure whether they're cysts or not, but we say they're likely benign. And the two F's, we're talking about the fact that nearly all are indolent if they are malignant, but most of them are going to be benign. And we're going to follow them at 6 months, at 12 months, and then annually for a total of 5 years, and then stop. Threes, intermediate probability, we're going to recommend urology consultation. Fours, the large majority of fours are malignant, and we're going to recommend urology consultation for those. So now let's look a little about biopsy of cystic masses. The sensitivity for diagnosing malignancy is lower in the biopsy of cystic masses. Network value of no malignant cells is uncertain. And what's really gotten us away from biopsy is that we've been concerned over the years about subsequent changes in the mass's appearance from the biopsy itself rather than neoplastic change. But the biggest change that's really happened is that it seems to be safe to actively surveil Bosniak 3s. So if you're unsure if a patient has medical or surgical comorbidities, we're going to choose an active surveillance protocol rather than biopsy in those patients. Now, what about active surveillance? Who should we consider? Elderly, comorbidities, limited life expectancy. Which masses? Small ones, generally under 3 centimeters, 2 Fs, and then some 3s and 4s, of course, in patients with limited life expectancy. And then we don't really have a good way to follow these patients. An aggressive approach, we did look at every 3 months, maybe alternating CT MRI with ultrasound, and then every 6 months for 3 years, then every year. We don't really know what the right way is. And of course, biopsy in these patients are only going to be used for treatment candidates. When to intervene, the size threshold could be used, growth could be used, 3 to 5 millimeters have been talked about. We're going to maybe use biopsy, nomograms. There's nothing single that allows us to choose, but all can be used in combination. And then, of course, the patient may say, "Doc, I don't really feel comfortable following my cancer." So that's prompted many to suggest that we have to stop calling these cancers, but rather call them indolent lesions of epithelial origin, or IDLs for short. So in summary, what do the data show? They show that small renal cell carcinoma is overdiagnosed and overtreated without a survival benefit. Benign masses are treated unnecessarily and because they're being underdiagnosed, and the treatments may be harmful due to nephron loss. So what can we do? Diagnose benign disease, try to distinguish aggressive from indolent cancers, and contribute to conservative approaches. So I come back to this idea of utilizing imaging. We want to decrease the use of imaging of renal masses which are highly likely benign, which we're trying to do with the Bosniak classification, but actually increase the use of imaging and biopsy of renal masses suspected of being cancers prior to treatment. These are both conservative approaches. In the first hand, we're lowering imaging costs, and the second hand, we're lowering surgery costs, which are much greater than imaging costs. So that's why we're espousing this. So what specifically? Utilize renal mass protocol CT MRI to diagnose benign disease. Institute Bosniak version 2019. Biopsy small solid masses and treatment candidates to both diagnose benign disease and assess the need, whether to treat them. And institute active surveillance in patients with comorbidities and limited life expectancy. And maybe someday we'll formally change our terminology to IDLs. And with that, I thank you for your attention.
This is imaging of adrenal adenomas and incidentalomas, and I'm Dr. Dan Koval from Radiologist Headquarters. So just a brief overview, I'll be talking mainly about adrenal adenoma, the lipid-rich and the lipid-poor types. We'll go over a washout calculation when evaluating an adrenal nodule, and I'll also talk about CT or MRI, which is the best modality for a particular nodule. We'll finish with management of adrenal incidentaloma discussion, comparing the endocrinology guidelines versus the radiology recommendations, which is a bit of a controversial topic. Ooh. So starting with a case, we have a right adrenal nodule here, posterior to the inferior vena cava. If we place a region of interest on that nodule, we get a Hounsfield unit density of -23. Hounsfield units is the unit we use on CT scan to determine density of a particular structure. So the incidental adrenal nodule usually represents a benign adrenal adenoma. It's the most common adrenal lesion. It's usually non-functioning, meaning non-hormone secreting. And an autopsy series is a prevalence of about 9% in the general population. CT scan is not quite as good at detecting adrenal nodules, but close. We incidentally detect adrenal masses in up to 7% of patients undergoing routine CTs. So the non-contrast density or attenuation is usually diagnostic for an adrenal adenoma. And that's because 70% of adenomas will be lipid-rich, meaning they have a low density with an attenuation of 10 Hounsfield units or less. And again, in this case, the density was negative 23 Hounsfield units, consistent with a lipid-rich adrenal adenoma. And then moreover, 98% of homogeneous adrenal masses with an attenuation value of 10 or less Hounsfield units will be benign. Most of those will be lipid-rich adrenal adenomas, like in this case, but also adrenal cysts and myelolipomas fall into that category. So here's another case. We have a non-contrast CT scan. You can tell it's non-contrast because there is no enhancement within the inferior vena cava or aorta, and there's a homogeneous, well-circumscribed left adrenal nodule. So let's measure the density. You can see the Hounsfield units is 15. What do we do with that? That's more than 10, so this is not consistent with a lipid-rich adrenal adenoma, but could it be a lipid-poor adenoma? So we could then do a 3-phase adrenal CT scan. So with that study, we'd start with a non-contrast CT. We'd inject intravenous contrast and then image the adrenal glands 60 to 90 seconds after the time of injection, and that would be the portal venous phase. You can see the portal veins and the inferior vena cava and aorta are all enhancing. And then we'd image again 15 minutes after the time of contrast injection, giving us a delayed phase of enhancement. And because we're doing a 3-phase scan, we would only image the adrenal glands because we really want to minimize the radiation. There's no reason to image the lower chest. Once you have that information, you could then calculate the percent enhancement washout. There are plenty of online calculators that will make that a lot easier to do for you, but if you want to be old school and do the calculation by hand, here's the formula. So it's the enhanced density minus the delayed density divided by the enhanced density minus the unenhanced density. And in this case, if we plug in the numbers we obtained, we get a percent enhancement washout of 73%. And if it's more than 60%, that's diagnostic of an adenoma. That's based on the study initially by Dr. Caioli in 2002, which showed a sensitivity of 98% and a specificity of 92% for this equation. If you don't have the non-contrast series, you can also do a percent relative washout, taking the enhanced minus the delayed density over the enhanced density. In this case, we get a percent relative washout of 57%. And if it's more than 40% relative washout, that's also consistent with an adenoma. The percent enhancement washout, though, is a more powerful predictor of adenoma and should be used over the percent relative washout when available. So to summarize the adrenal adenoma CT workup, and this is based on the 2017 ACR Incidental Findings Committee recommendations, if you have an adrenal mass with a non-contrast density of 10 Hounsfield units or less, that's consistent with a lipid-rich adrenal adenoma, and you can stop imaging. If the adrenal mass has a non-contrast density of more than 10 Hounsfield units, then you could do a enhanced CT with 15-minute delays, the 3-phase CT. And if the enhancement washout is more than 60%, that's consistent with a lipid-poor adrenal adenoma, and you can stop imaging. So if the enhancement washout is less than 60%, it's an indeterminate adrenal lesion. And then based on the clinical scenario, imaging follow-up, biopsy, PET-CT, or resection may be indicated. So what about MRI in the workup of adrenal adenoma or an adrenal nodule? How does that factor in? So MRI actually has similar accuracy to a non-contrast CT, particularly for lipid-rich adrenal adenomas. And due to the presence of intracellular or microscopic lipid that's present in the adrenal adenoma, most adenomas will demonstrate a loss of signal, meaning they'll become darker on the opposed phase images. And a signal drop of more than 20% is diagnostic of a lipid-rich adrenal adenoma. So you can see in this case, this is a T1 in-phase MRI of the adrenal glands, and there are bilateral adrenal nodules. On the opposed phase T1 weighted image, you can see that these nodules become dark, and that's diagnostic of adrenal adenomas. So here's another example of a right adrenal nodule on an in-phase T1 weighted image. You can see it looks fairly bright, but on the opposed phase T1 weighted image, it becomes dark, also consistent with an adrenal adenoma. So not to get too much into MRI physics here, but water protons precess, meaning they spin at a slightly higher frequency than lipid protons. And for chemical shift imaging, which is what we have here, in and out of phase imaging, a T1 weighted gradient echo sequence is used, and that does not have a 180-degree refocusing pulse, which allows lipid and water protons to precess or spin in and out of phase at different echo times. So spin echo and fast spin echo sequences are in-phase techniques because they do have a 180-degree refocusing pulse. But in this case, we don't have that. This is a gradient echo sequence. So what happens is on the in-phase image, signal from water and lipid within the same voxel are additive, meaning you get this brighter signal. And that's why sometimes this microscopic intracellular fat is referred to as intravoxel fat. On the opposed phase images, though, you get this destructive interference of water and lipid protons that are in the same voxel, and the signal cancels out, and you get this signal dropout or darkening. And you can also tell that this is an out-of-phase image because you get this edge artifact along the fat-water interface, and that's known as India ink or etching artifact. It almost looks like a cartoon drawing where you've gone around all the organs with a magic marker. And the other name for that, because everything in radiology has multiple names, is chemical shift artifact of the second kind. So you see that in all pixels along the fat-water interface. Here's another example. The image above shows a T1 in-phase image showing a right adrenal nodule posterior to the inferior vena cava. On the opposed phase image, you can see that it becomes very dark, diagnostic of a lipid-rich adenoma. And you can compare that signal drop to the spleen or skeletal muscle, showing that it's actually getting darker. It is a good idea to use the skeletal muscle or spleen as a reference marker since those structures don't normally have microscopic fat and should not drop out on the opposed phase T1 weighted image. You do have to be a little careful with the spleen though, since on the in-phase image, if there's iron deposition within the spleen, you might get T2 star artifact causing blooming and darkening of the spleen. So that's why I tend to prefer comparing to skeletal muscle. And in case you didn't believe me, this was from the earlier image that I showed you for the non-contrast CT, which was also diagnostic for a lipid-rich adrenal adenoma with a density of negative 23 Hounsfield units. So what about lipid-poor adrenal adenomas? How do we evaluate those? Here's an example of a left adrenal nodule with a non-contrast density of 23.5 Hounsfield units. So that's much greater than 10. That's not consistent with a lipid-rich adrenal adenoma. So 30% of adrenal adenomas will be lipid poor, meaning they'll measure more than 10 Hounsfield units on a non-contrast CT. And those can mimic malignant adrenal masses because the density is so high. And MRI, unfortunately, has decreased ability to detect these lipid poor adenomas because the whole mechanism of chemical shift relies on the intravoxel fat, right? Interestingly, though, compared to non-contrast CT, MRI can actually be useful in evaluating these hyperattenuating adrenal masses, meaning nodules that measure more than 10 Hounsfield units. There's a study by Dr. Israel that showed 62% of adenomas greater than 10 Hounsfield units on non-enhanced CT were actually definitively characterized with chemical shift MRI. A different study showed the chemical shift MRI sensitivity for adenoma was 67% for adenomas that were more than 10 Hounsfield units, and that sensitivity was increased to 89% when only adenomas that had a density of more than 10 and less than 30 were evaluated. So how do we use this clinically? The bottom line is MRI might be helpful even if an adrenal mass is indeterminate on a non-contrast CT, particularly if this mass demonstrates a non-contrast density of less than 20 to 30 Hounsfield units. So if the non-contrast density is 20 or 30 Hounsfield units, it's best to go right to washout CT as opposed to MRI to further characterize the adrenal nodule. So here's an example to bring that point home. You can see that there's a right adrenal nodule, well circumscribed and homogeneous on this non-contrast CT scan. Placing a region of interest on this nodule, you can see that the density is 40 Hounsfield units. So that's clearly higher than 10 Hounsfield units. This is not consistent with a lipid-rich adrenal adenoma, but it could still be a lipid-poor adenoma. So based on this density, what do you think we should do, an MRI or a three-phase CT? So an MRI was done, and you could see on the above in-phase image, the nodule is posterior to the inferior vena cava, and on the opposed phase T1 weighted image below, there's not really any signal dropout. In fact, the nodule actually looks darker on the in-phase image, not the opposed phase image. So this does not help. It doesn't characterize the nodule. However, if we do a three-phase CT scan, again, the non-contrast portal venous phase and 15-minute delayed phase, we acquire these density measurements on each of the three phases. We calculate the percent enhancement washout. In this case, you can see that it's 68%, which is more than 60%, and this is therefore diagnostic of a lipid-poor adrenal adenoma. So this is a nice example showing how MRI will often not be able to further characterize a nodule that's indeterminate on CT with a density of more than 20 to 30 Hounsfield units. There's just not enough intravoxel fat to detect on chemical shift imaging, and in that case, you should go right to a three-phase CT and save the patient anxiety and additional cost. All right, so when to use an MRI or a CT? This is a summary chart that compares the two modalities. So MRI is typically preferred in patients who have a contraindication to the iodinated contrast we use with CT. And that's typically if they have a contrast allergy or renal insufficiency and they're not on dialysis. It's also great for younger patients because there's no ionizing radiation. So even though we narrow the three-phase CT to just image the adrenal glands, there is still radiation, which we don't have on MRI. MRI is also excellent if there's a high suspicion for adrenal hemorrhage, as this modality has the greatest specificity in making this diagnosis. And again, if the non-contrast CT density of a nodule is more than 10 but less than 20 or 30, that's the ideal place to get an MRI. MRI is also potentially better for small lesions because it can be difficult to put a region of interest on a very small adrenal nodule on CT scan. But there is no data for CT or MRI accuracy in characterizing adrenal masses less than 1 centimeter. All the studies I've been referring to evaluate nodules that are a centimeter or more in size. And the ACR Incidental Findings Committee recommendations suggest that nodules less than 1 centimeter in size may not need further evaluation. Washout CT is great for patients who have contraindications to MRI, particularly patients with pacemakers, severe claustrophobia. Also, if a lesion is not characterized on MRI or a non-contrast CT, you might be able to further characterize that based on the washout density, as I've been demonstrating. And again, if the non-contrast CT density is more than 20 or 30 Hounsfield units, and there's no real suspicion of adrenal hemorrhage, washout CT is your next best study. So how do you manage an incidental adrenal nodule? So let's go back to 2007. Endocrinologist Dr. Young at that time recommended repeat imaging studies at 6, 12, and 24 months for lesions characterized as adrenal adenomas on CT. He acknowledged that there are no data from large long-term studies to support these recommendations. Also, he stated if an adrenal mass is 4 centimeters or more in size, or if it enlarges by 1 centimeter or more during a period of observation, adrenalectomy should be considered. Interestingly, in the same year from the radiology literature, Dr. Song did a study evaluating 290 patients with 321 lesions over a 3-year period. These patients all had incidentally detected but indeterminate adrenal nodules, so these were not characterized as adrenal adenomas. However, they looked fairly benign and the patients had no known history of malignancy. The average size of these lesions was 2.1 centimeters, but some were quite large, reaching up to 6 centimeters. And at the end of the 3-year period, all of these 321 lesions were benign. Even though they weren't fully characterized, they were determined to be benign. Of note, though, 3 were clinically unsuspected functioning adrenal masses, although still benign. Dr. Song did a study the following year evaluating over 1,000 incidental adrenal masses, also in patients with no known history of malignancy, and also these patients had no malignant lesions identified. Most of the nodules identified were adenomas and myelolipomas, benign. So these studies and multiple subsequent studies have brought about the development of 2 major follow-up algorithms for the management of incidental adrenal nodules. We have the American Association of Clinical Endocrinologists and Endocrine Surgeons 2009 medical guidelines compared to the American College of Radiology Incidental Findings Committee 2017 recommendations. And I'll just highlight some of the major features of these 2 algorithms. The endocrinology guidelines state that the goal of imaging is to distinguish among adrenal adenoma, adrenal carcinoma, pheochromocytoma, and metastatic lesions. The radiology recommendations seek to differentiate a benign leave-alone mass, like a non-hyperfunctioning mass, myelolipoma, hemorrhage, or cyst, from one that warrants treatment, like a metastasis, adrenal carcinoma, and a hyperfunctioning adrenal tumor. The endocrinology guidelines state that patients with adrenal incidentalomas smaller than 4 centimeters and characteristics consistent with a benign adenoma need to have radiographic reevaluation at 3 to 6 months and then annually for 1 to 2 years. So similar to Dr. Young's recommendations. However, the radiology recommendations state that if an adrenal mass has diagnostic features of a benign mass, such as a myelolipoma, cyst, hemorrhage, or lipid-rich adenoma, no further imaging is needed. So you see a major difference there between the 2 algorithms, whereas radiology states that if it's a non-functioning adenoma, we don't need to follow it up anymore. Radiology recommendations go on to state that if you have a mass that does not have diagnostic features, meaning It's not characterized as an adenoma or other benign mass. If it measures 1 to 2 centimeters, you could consider a follow-up adrenal CT or MRI in 12 months to document stability. But they don't mandate that follow-up is required since it's statistically still likely a benign nodule. However, if the nodule measures more than 2 centimeters and less than 4 centimeters, you should consider a more prompt follow-up imaging study to characterize that. All right, now, the endocrinology guidelines state that if the tumor grows more than 1 centimeter or more, or if it becomes hormonally active during follow-up, surgical excision should be considered, whereas the radiology recommendations note that there is not a known growth rate threshold to differentiate benign from malignant adrenal masses, so they don't describe a specific threshold. However, they do state if there are no diagnostic benign imaging features, but the adrenal mass has been stable for 1 year or more, it's very likely benign and no additional imaging is required. Meaning, if you cannot characterize it as an adenoma, but it has benign features and it's been stable for a year, you can stop following it up. Here we do have a point of agreement. The endocrinology guidelines state that if the mass is 4 centimeters or more, you should resect it. And radiology agrees if there are no benign diagnostic features or history of cancer, surgical resection is recommended to treat possible primary adrenal carcinoma. However, they do imply that if there are imaging features diagnostic of lipid-rich adrenal adenoma, regardless of size, no further imaging is needed. So I apologize for all the word slides there, but I just wanted to highlight these two algorithms and show you the differences between the two. It would be nice if at some point these organizations would come together to create a combined algorithm, but in the meantime, it's good to know that there are differences and both algorithms make valid points for follow-up. All right, now here's another case showing a homogeneous enhancing right adrenal mass, well circumscribed, posterior to the inferior vena cava. It's very nonspecific but looks benign, and this turned out to be an aldosteronoma. So let me talk a little bit about functional adrenal neoplasms. This is a patient with an aldosteronoma which causes Conn syndrome, which is also known as primary hyperaldosteronism. And in these patients, you have a high aldosterone level, which leads to low renin levels, and these patients often have hypertension and hypokalemia. 2/3 are due to benign hyperfunctioning adenomas, and 1/3 are due to bilateral adrenal hyperplasia. Compare that to Cushing syndrome, which is due to an excess secretion of glucocorticoids. Most of those are caused by adrenal hyperplasia, with a smaller percentage due to adenoma. Of note, though, both of these functioning syndromes could be due to adrenal carcinoma, although less common. This is a patient who had an aldosteronoma in the setting of Gardner syndrome. You could see these irregular soft tissue masses in the mesentery from resected desmoid tumors that had partially recurred, and the patient had also had a colectomy due to the high risk of colon cancer in these patients. All right, now imaging cannot distinguish hyperfunctioning from non-hyperfunctioning adenomas, unfortunately. There's nothing in this case that would tell you, oh yes, that's a functioning adrenal nodule. It could very well be a non-functioning adrenal adenoma. And of course, endocrine workup of the incidental adrenal mass is somewhat controversial. So those 2009 endocrinology guidelines state that the detection of an adrenal lesion should prompt biochemical evaluation unless it is an obvious myelolipoma. They also state hormonal evaluation should be performed at the time of diagnosis and then annually for up to 5 years. Now, the initial 2010 ACR Incidental Findings Committee recommendations used to state that biochemical evaluation should be considered only if there were clinical signs or symptoms of adrenal hyperfunction. However, they've updated that in 2017 to state that on the basis of clinical recommendations from our endocrine and surgical colleagues, we now advise consideration for routine biochemical evaluation for most incidentally discovered adrenal masses. And that's because some benign adenomas might actually develop cortisol hypersecretion and cause subclinical Cushing syndrome. And one study showed that 70% of pheochromocytomas were actually discovered incidentally. That doesn't mean they were malignant pheochromocytomas, but still potentially functioning and therefore life-threatening pheochromocytomas. However, it's unclear which masses should undergo endocrine evaluation. There's not agreement as far as what biochemical assays do you perform, and also if initially normal, do you repeat these assays and when? All right, that's it for imaging of adrenal adenomas and incidentalomas. Thank you for your attention. If you enjoyed this video lecture, I'd greatly appreciate it if you left a review and subscribe to Radiologist Headquarters on Apple Podcasts, or please like and subscribe on YouTube so that others may find it. You can also visit radiologisthq.com for additional reference material. Thanks. This is imaging of pheochromocytoma. I'm Dr. Dan Koval, and welcome to Radiologist Headquarters. So an overview of what I'll be talking about today. I'll give you a general background about pheochromocytoma, including typical clinical presentation and epidemiology, and then we'll talk about the imaging appearance for ultrasound, CT, MRI, and functional nuclear medicine studies. We'll talk about extraadrenal pheochromocytoma or paragangliomas, and then we'll go over some mimics. So starting with a case, this was a contrast-enhanced CT scan of the abdomen through the level of the kidneys and lower adrenal glands. And there's a complex mixed cystic and solid mass in the region of the right adrenal gland. You can see that it's impressing upon and displacing the right kidney, but it does not seem to be arising from it. There is at least a partial fat plane separating the two structures. And then this coronal reformatted image also shows the mixed cystic and solid mass, which turned out to be a pheochromocytoma. So these are rare tumors that arise from chromaffin cells, and they have variable catecholamine secretion. And the diagnosis is made through biochemical evaluation, and there are different ways to do that that are not really agreed upon. A 24-hour fractionated urine metanephrine evaluation could be obtained. You could evaluate for urinary catecholamines. Total plasma metanephrines can be measured, and plasma concentration of free metanephrines can also be evaluated. So any combination of these biochemical assays can be performed. And because the catecholamine secretion is variable, the symptoms are also variable. The typical symptoms for pheochromocytoma will be headache, palpitations, sweating, and hypertension. But they can be asymptomatic. In this case here was actually an asymptomatic presentation that was detected incidentally. In this example, though, this patient was very symptomatic. These are FLAIR images of the brain. FLAIR stands for Fluid Attenuation Inversion Recovery, which is a T2-like sequence that has suppressed CSF signals, so the CSF will look dark and it brings out white matter abnormalities. And indeed, there are bilateral frontal and left parietal occipital areas of white matter signal abnormality indicating encephalopathy, and that was due to this right heterogeneously enhancing solid adrenal mass, which was resected and determined to be pheochromocytoma. And this is an example of hypertensive encephalopathy secondary to pheochromocytoma. So most cases of pheochromocytoma are sporadic, with the mean age of presentation in the 40s. And younger presentation will be seen in patients that have a genetic predisposition. And those patients that will have a hereditary form of pheochromocytoma may have one of these syndromes: von Hippel-Lindau disease, multiple endocrine neoplasia type 2, neurofibromatosis type 1, and this one's a bit of a mouthful, pheochromocytoma paraganglioma syndromes associated with succinate dehydrogenase gene mutations. And that's something that will typically be tested for in patients that have paraganglioma. You can think of pheochromocytoma as the 10% tumor, because 10% of the time it will be bilateral, although in patients that have an inherited form of pheochromocytoma that's usually higher. 10% will be extraadrenal, also known as paragangliomas. 10% typically have calcification. 10% will occur in children, and 10% will be malignant. And the only reliable imaging feature for malignancy for pheochromocytoma will be the presence of direct invasion into an adjacent vessel or organ, or if there's metastatic spread of disease. Just the appearance of the tumor by itself, even if it appears complex, is not a reliable indicator of malignancy. However, since they have a malignant effect on the patient's physiology, they tend to be removed, usually laparoscopically. Also, when pheochromocytoma occurs in children, it tends to have a higher incidence of malignancy, unfortunately. And then also, they tend to enhance to greater than 110 Hounsfield units on an arterial phase CT scan, which I'll discuss more in a few minutes. Now, it used to be thought that approximately 10% of pheochromocytomas were inherited, but that number has actually been found to be higher. About 25% of patients carry some kind of gene mutation. Let's look at an ultrasound case. This is an image of the left upper quadrant. You can see the spleen anteriorly there, and then there's this solid heterogeneously hypoechoic mass in the region of the left flank, posterior to the spleen. And this was a pheochromocytoma on ultrasound. So most pheochromocytomas will appear solid on ultrasound, but there are varying degrees of complex cystic and solid pheochromocytomas. And if there's hemorrhage, that may appear echogenic within the mass. And they may also be hypervascular. This case showed moderate hypervascularity when we apply color Doppler. Now, this patient also had a CT scan. This was actually an aortic dissection protocol, so we're looking at an early arterial phase. You can see the aorta enhancing brightly, and the kidneys are in an early corticomedullary phase of enhancement. And there's this large mass in the region of the left adrenal gland. If we look at the axial images, and these are maximum intensity projection series, which give you a thicker slab and bring out the areas of hyperdensity in the individual voxels, these areas of hypervascularity within the mass stand out a bit more, as the serpentine vessels coursing within and surrounding the mass. And this is typical for pheochromocytoma. And there was actually a study that evaluated whether dual-phase enhancement patterns could be used to differentiate adenoma and pheochromocytoma. What the investigators found that on studies where there was an arterial phase enhancement levels greater than 110 Hounsfield units and lesion heterogeneity should prompt consideration of pheochromocytoma. They also found that there was no adenoma that enhanced more than 85 Hounsfield units in the arterial phase, whereas most of the pheochromocytomas, 58%, were more than 110 Hounsfield units enhancing. They also found that adenomas tend to enhance more in the venous phase, which occurs after this arterial phase. So the bottom line is if you have an arterial phase, like you may have on a CT angiogram or other multi-phase study, look closely for incidental pheochromocytomas, as you might identify them by a small area of hyperenhancement, especially if it's greater than 110 Hounsfield units. Now let's go further into the CT appearance for pheochromocytoma. This was a non-contrast CT scan. This is actually the same case I showed you earlier with the patient that had the hypertensive encephalopathy. And the density of this mass is 30 Hounsfield units. So if you remember from the adrenal adenoma lecture, this would not be consistent with a lipid-rich adrenal adenoma, right? Because that should be 10 Hounsfield units or less. So if we continue with the three-phase adrenal CT protocol, the portal venous phase density was 95 Hounsfield units, and then the delayed, which is typically 15 minutes delayed, density is 66 Hounsfield units. And if we put those numbers into the adrenal washout calculator, we get an absolute washout of 45% and a relative washout of 31%. Now, are those washout percentages consistent with a lipid-poor adrenal adenoma? No, they're not. If you have an absolute washout less than 60% and relative washout less than 40%, that's not consistent with adenoma. So just like on ultrasound, the majority of pheochromocytomas on CT scan will appear solid, the remaining complex or cystic. Here's an example of a solid pheochromocytoma, and this one is a mixed cystic and solid pheochromocytoma, the cystic or necrotic components non-enhancing. And it's extremely uncommon for pheochromocytoma to be purely cystic. Usually there'll be some degree of complexity. And the solid components will tend to show robust enhancement, as you can see there. And most pheochromocytomas will have a non-contrast density of greater than 10 Hounsfield units. Here's a different example of a pheochromocytoma with non-contrast density of 35 Hounsfield units, so well above 10 Hounsfield units. And the absolute washout will tend to be less than 60% with relative washout less than 40%. Again, that's similar to adrenal cortical carcinoma and metastases. And on CT, 10% will have calcifications. Now, a comment on pheochromocytoma and CT contrast. So there's a historical theoretical risk of catecholamine secretion causing life-threatening hypertension, or a catecholamine surge, after the administration of iodinated CT contrast. And because of this, for years pheochromocytoma was considered a contraindication to iodinated contrast injection. However, studies have actually shown that this surge is extremely unlikely with current non-ionic CT contrast agents, even without alpha-blocking medications given beforehand. Therefore, pheochromocytoma is not considered a contraindication to modern iodinated IV contrast media, and you can read more about that in a study by Drs. Bessel, Brown, and O'Malley in AJR. Now, looking at pheochromocytoma on MRI, again, it can be solid or mixed solid and cystic. It's rarely primarily cystic, but it usually has some thick enhancing wall and possible septations. And the light bulb sign is classically described as a markedly T2 bright appearance of the pheochromocytoma, as in this case. Remember that fluid will be bright on T2 weighted images. You can see the CSF in the spinal canal is very bright on that lowermost T2 fat saturated image. But this is an unreliable sign. Studies show that it's seen in 11 to as many as 65% of pheochromocytomas. And it's also not specific for pheochromocytoma. They can also be T2 hypointense as well. And the appearance is variable. They can be homogeneous or heterogeneous with hemorrhage and areas of necrosis and calcification. Here on this T1 weighted image, which is actually an in-phase image, these areas of dark susceptibility artifact correspond to old hemosiderin deposition from prior hemorrhage. There's also a faintly visible T1 hyperintense hemorrhage level within that cystic component, which likely represents a more acute area of hemorrhage. And the solid components will usually be hypervascular, as denoted by that orange arrow. Again, the cystic and necrotic areas will not enhance. Also, pheochromocytoma usually does not show dropout on opposed phase T1-weighted gradient echo images, and that's how you can differentiate them from lipid-rich adrenal adenomas. Now let's look at an example of that. So here's an in-phase and opposed phase T1-weighted series, and there's a right adrenal mass. On the opposed phase image, do you see any signal dropout? No, there isn't. You guys are getting good. So you're not thinking that this is a lipid-rich adrenal adenoma. And if we look at a true FISP image, FISP is a balanced steady-state free precession sequence. Its signal is actually based on a T2 to T1 ratio, but you can think of it as a T2-like fluid-sensitive sequence. It's a really useful sequence. The right adrenal mass here shows solid components and also T2 bright cystic components. And if we look at the post-contrast image, those solid components enhance, whereas the cystic areas do not. So let's take a further look at the post-contrast appearance of this particular mass. So this is a T1 fat-suppressed coronal post-contrast arterial phase sequence, and you can see it's an earlier phase. We have the aorta enhancing, and then the kidneys are in the corticomedullary phase of enhancement. And this right adrenal mass is very hypervascular, but the cystic necrotic component is not enhancing. It's remaining T1 hypointense. If we look at a later portal venous post-contrast series, that mass is still enhancing, and the cystic necrotic areas are not. So this is typical for pheochromocytoma, showing that early arterial enhancement with non-enhancement of the cystic necrotic areas. And this is just a 3D rendering showing the hypervascularity of the mass and its relationship with the adjacent right kidney. Now what about the functional imaging appearance of pheochromocytoma? Well, here's that earlier case that I showed you with the right pheochromocytoma, and then here's a planar whole body scintigraphic image also showing avidity in that region. And this is an MIBG scan. Specifically, this was an I-123 MIBG scan. MIBG stands for meta-iodobenzyl-guanidine, and that's why we just call it MIBG. And it can be radiolabeled to either I-131 or I-123, but I-123 has pretty much replaced I-131 for MIBG scanning just because it has a lower radiation dose and the image quality is superior. So the normal activity that you'll see with an MIBG scan includes liver uptake greater than spleen, and compare that to a white blood cell or pentatreatide scan where the spleen will be more avid than the liver. Also, salivary gland uptake will normally be seen, as in this case, you can see that the parotid and submandibular glands show activity. And then you'll see normal soft tissue and blood pool uptake. You will not see bone marrow uptake, and that's one way you could differentiate this scan from a white blood cell scan. MIBG is useful because it has nearly 100% specificity for pheochromocytoma. Studies show a range of 95 to 100% specificity, and sensitivity is as high as 90%. So it can be used to confirm clinically suspected pheochromocytoma and also to evaluate for metastatic disease. In this case, there was no metastatic disease. The avidity was isolated to that right pheochromocytoma. So there are certain tumors that will show increased uptake on an MIBG scan, typically pheochromocytoma and paraganglioma, as in this case, but also neuroblastoma, which is a pediatric adrenal tumor. Other tumors can also show uptake, but they have a lower sensitivity for detection on MIBG scan. That includes carcinoid tumor and medullary carcinoma of the thyroid. And then other nuclear medicine studies that we could do to evaluate pheochromocytoma include indium-111 pentatreatide scans and FDG PET scans. However, these tend to have lower sensitivity and specificity for pheochromocytoma, and that's why MIBG is typically considered a first-line scintigraphic examination for pheochromocytoma. However, though, these two studies can be useful for pheochromocytomas that are dedifferentiated and therefore MIBG negative. All right, let's move on to a different case. Here's a large retroperitoneal mass that has solid and central necrotic or cystic components, and it's in the mid to lower abdomen extending into the upper pelvis. It's very nonspecific at first glance. You may think of a sarcoma or neurogenic tumor. However, if we look a little more closely, you can see that it's actually occurring anterior to the aortic bifurcation. There are the common iliac arteries demarcated by the arrows. And when you see a mass in this location, you should be thinking about paraganglioma, which is an extraadrenal pheochromocytoma. So remember, 10% of pheochromocytomas will be located outside of the adrenal glands. Most occur in the abdomen, and many occur in this region, which is the site of the organ of Zuckerkandl. which is a small mass of chromaffin cells derived from neural crest, located at the aortic bifurcation or inferior mesenteric artery origin. You can also have pheochromocytomas in the retroperitoneum, and often they're periadrenal and difficult to differentiate from adrenal masses. They can occur in the bladder wall, mediastinum. They can also occur in the heart as well. So let's take a look at an example of a paraganglioma. This is a 3-phase CT scan. If you've seen Introduction to Genitourinary Radiology Part 1, you'll recognize the non-contrast corticomedullary and nephrographic phase images from a CT urogram. If you haven't seen that lecture yet, well, it's waiting for you. And there's a mass here medial to the right renal hilum. It's fairly solid, it has a punctate calcification, and it's demonstrating heterogeneous enhancement. If we look at the coronal images from the same series, again, you can see that it's medial to the kidney. It's definitely not where you would expect the adrenal gland to be. So there was a clinical suspicion for pheochromocytoma, and an MIBG SPECT CT was done. And this fuses SPECT images on top of a CT scan, and in that same region of the mass, you see marked avidity. And this was the coronal planar image showing that same finding. There's, again, the normal liver uptake for an MIBG scan, physiologic. And this turned out to be a retroperitoneal paraganglioma, well encapsulated at the time of surgery. And after this was removed, the patient's hypertension and symptoms of catecholamine excess resolved. Now, unfortunately, a pheochromocytoma can sometimes mimic other tumors. And that's because rarely they may have a non-contrast density of less than 10 Hounsfield units on CT scan, and sometimes also show greater than 60% washout on a multi-phase adrenal CT. And in that way, they act as an imaging chameleon and mimic adrenal adenomas. And there's a great radiographics article by Dr. Michael Blake that highlights more the chameleon-like nature of the pheochromocytoma. Also, they can appear T2 dark. They often don't have that characteristic T2 light bulb bright appearance. Conversely, though, other adrenal lesions can sometimes mimic pheochromocytomas. Let's take a look. So this was a large right cystic mass arising from the adrenal gland. You can see the claw of adrenal tissue there on that lowermost image showing adrenal origin. But then there's also this lobular soft tissue there in the anterior superior aspect of the mass as it abuts the liver. If we look at that coronally, we again see that claw denoted by the green arrow showing that that's adrenal origin. But then there's this other soft tissue superiorly. So an MRI was done, and on this T2 coronal image, we again see that area of possible nodularity within the superior aspect of the lesion. The cyst itself is extremely bright on T2, and you can see it's iso-intense to the fluid in the adjacent common bile duct, which is expected for simple fluid. On the post-contrast images, we again see the normally enhancing right adrenal gland from which this cystic lesion arises from, and this unusual area of soft tissue nodularity. So it was unclear as to whether this was related to the adrenal gland and just a bit of displaced adrenal tissue since it was enhancing iso-intensely to the gland, or if it was actually a true intracystic nodule, so the possibility of cystic pheochromocytoma was raised. However, again remember that pheochromocytoma is a biochemical diagnosis, and a biochemical assay was performed, plasma metanephrines and 24-hour urine catecholamines and metanephrines, which were negative. Despite that, this mass was still removed because it was large in size and symptomatic, and turned out to be a benign unilocular epithelial-lined simple adrenal cyst. Let's look at another case. This is a non-contrast CT scan showing a right adrenal mass. Measuring the density of that mass, we get a non-contrast density of 15 Hounsfield units. So that's not consistent with a lipid-rich adrenal adenoma, right? So a 3-phase adrenal washout CT was performed, and that demonstrated a less than 60% absolute washout. So that's also not consistent with a lipid-poor adrenal adenoma. This patient also had an MRI, and on these in-phase and opposed-phase T1-weighted images, you can see that there's no signal dropout on the opposed-phase image. So this is not a lipid-rich adrenal adenoma, which we already knew. Incidentally, you could see some susceptibility artifact on the in-phase image in the region of the gallbladder fossa corresponding to cholecystectomy surgical clips. If we look at the T2 fat-suppressed images, this mass looks cystic and solid. These T2 bright areas indicate a cystic or even necrotic component, with the hypointense areas representing solid tissue. And these coronal T2-weighted images without fat suppression show the same thing, a mixed cystic and solid mass. Looking at the post-contrast images on this early post-gadolinium phase series, the mass demonstrates heterogeneous enhancement. It's not extremely robust, but it's definitely enhancing on this early phase. Looking at a later portal venous equilibrium type post-contrast series, the mass is demonstrating continued enhancement, and then the cystic necrotic areas are not enhancing. They remain T1 hypointense. So pheochromocytoma was suspected on imaging, but it was excluded due to normal plasma metanephrines. Again, pheochromocytoma is a biochemical diagnosis. And it turned out to be an adenoma with cystic degeneration on surgery. This was removed laparoscopically because even though pheochromocytoma was excluded biochemically, there was suspicion that it may be a functioning adrenal adenoma causing subclinical Cushing syndrome. And just to further bring home the point that imaging cannot really distinguish pheochromocytoma from other tumors, these are two of the cases I've already showed you. One of them is a pheochromocytoma and the other one is a cystic adenoma with degeneration. And you can see that they're extremely similar in appearance on both T2 and post-contrast imaging. And this was the pheochromocytoma, this was the adenoma with cystic degeneration. Again, one had abnormal biochemical profile indicating pheochromocytoma, whereas the other did not. And that concludes imaging of pheochromocytoma. Thank you for staying till the end. If you enjoyed this video lecture, it would be fabulous if you left a review and subscribe to Radiologist Headquarters on Apple Podcasts. We're also on Facebook, and you can like and follow us there. You can also subscribe on YouTube and click the bell icon to receive a notification whenever a new episode comes out. Thank you. This is imaging of adrenal hemorrhage. I'm Dr. Dan Koval, and welcome to Radiologist Headquarters. So this will be a part 1 lecture of leave alone adrenal masses. I'll be focusing on adrenal hemorrhage, mainly the CT, MRI, and ultrasound appearance. And then I'll also talk about causes of adrenal hemorrhage. Next time we'll talk about other leave alone masses, adrenal cyst, and myelolipoma. And by leave alone I mean masses that are benign and need no additional intervention. All right, let's start with the case. This was a 33-year-old male who came to the emergency department with left flank pain. So because of that left flank pain, there was concern for an obstructing renal stone, so a non-contrast stone search was performed. There was no renal stone, but there was another cause for the patient's pain, this heterogeneously hyperdense mass superior to the left kidney. Looking at the axial images, you can see the mass there with some periadrenal fat stranding denoted by the green arrow. That's due to fluid and hazy infiltration of the surrounding fat. If we measure the density of this mass by placing our region of interest down, we get a density of 50 Hounsfield units. Remember, the Hounsfield unit is the unit of density we use to calculate density on CT. And if you've seen the adrenal adenoma lecture, you know that this is not consistent with a lipid-rich adenoma. Adenomas have a density of 10 Hounsfield units or less when they're lipid-rich. So this is characteristic of adrenal hemorrhage. So on CT, hemorrhage will typically be a round or oval hyperdense adrenal mass with a density of 50 to 90 Hounsfield units. That's the density of blood. And there'll be surrounding stranding due to inflammation in the fat and fluid. An adrenal hemorrhage should not enhance, which is defined as a change in pre- and post-contrast imaging of less than 10 Hounsfield units. And that means that the density of this mass, which is 50 Hounsfield units on this non-contrast CT, would not increase to more than 59 Hounsfield units if we gave intravenous contrast, because it's just a hemorrhagic mass. This is not an underlying tumor. And in that case, no additional workup or follow-up imaging is needed. And that's based on the current American College of Radiology Incidental Findings Committee recommendations for management of incidental adrenal masses. Now let's take a look at the MRI for this patient. This is an axial T2 weighted image. You can tell it's T2 weighted because the fluid is bright, the CSF in the spinal canal, and you can remember that H2O has a 2 in it, just like T2, so that will be bright. And then there's this left adrenal mass here. You can see it has a peripheral hypointense rim, and it's centrally bright. And you may say, well, the central brightness is similar to the surrounding fat. Could this just be a fatty lesion? Well, if we do a fat-suppressed T2 weighted image, you can see that the subcutaneous fat signal is canceled out, but this mass remains very bright. It actually looks brighter than on the non-fat suppressed image, and that is because whenever you add fat suppression, you narrow the dynamic signal range, and anything that's intrinsically bright will become brighter. So this is clearly not fat. We can also look at the in and out of phase T1 weighted imaging. Remember, this is chemical shift imaging. And there's that left adrenal mass again. It's not dropping out on the opposed phase series, meaning it's not becoming dark. And again, you can tell it's the opposed phase image because it has India ink artifact, etching artifact around all the structures. So you know that this is, again, not a lipid-rich adrenal adenoma. And if we add fat suppression to that T1 weighted image, this little bright rim surrounding the mass becomes even brighter, again because we're narrowing the dynamic signal range. And this is a very classic appearance for adrenal hemorrhage on MRI. So MRI is actually the most sensitive and specific modality for diagnosing adrenal hemorrhage. And this specific MRI imaging finding is this high signal intensity rim sign, which is due to the presence of methemoglobin, which is a form of hemoglobin we tend to see in the setting of a subacute hematoma. And if we gave contrast, just like on CT scan, there would be no enhancement. Let me just talk a minute about adrenal hemorrhage on MRI. So it will have a variable appearance depending on the age of the hemorrhage. With acute hemorrhage, which is defined as less than 7 days, you have predominantly deoxyhemoglobin. And the mass will be T1 isointense to slightly hypointense, and T2 markedly hypointense. So it'll be fairly dark on both sequences. When you have subacute hemorrhage, which is defined as 7 days to 7 weeks, you have predominantly methemoglobin, and the hemorrhagic mass will be markedly hyperintense on both T1 and T2 weighted images. And that's what we have in this case. With chronic hemorrhage, which is defined as more than 7 weeks, you have mostly hemosiderin, which is dark on T1 and T2 weighted images. Now in real life, you often don't have this perfect signal characteristics of an adrenal hemorrhage. There's usually varying phases of hemorrhage, especially if there's ongoing bleeding or rebleeding, so you might get a mix of different signal intensities. So let's look at another case. This was a patient who came with acute right upper quadrant pain, and you can see that this CT scan shows a well-circumscribed, ovoid, heterogeneously hyperdense right adrenal mass. If we look at the MRI for this patient, you can see that there is a heterogeneously T2 hyperintense and hypointense right adrenal mass. Again, the upper image is without fat suppression, and the lower image has fat suppression. You can see that there are also some trace pleural effusions. Looking at the T1 in-phase opposed phase chemical shift imaging series, this mass demonstrates no signal dropout, again not consistent with a lipid-rich adrenal adenoma. If we look at the T1 fat-suppressed image, you can see that there is a faintly hyperintense rim on T1 images, and given the T2 signal, this is consistent with acute to subacute adrenal hemorrhage, which goes along with the patient's symptoms of fairly acute presentation. So the T1 heterogeneously isointense appearance with a faint hyperintense rim, and then the heterogeneous mixed signal. The darker the T2, the more acute the hemorrhage is. Now, what's usually the course for adrenal hemorrhage? Well, this is that same patient back to the CT scan showing the right adrenal mass. This patient had a follow-up MRI 6 months later, and you can see that the right adrenal gland posterior to the inferior vena cava there looks totally normal now. So, in most cases, adrenal hemorrhage will resolve completely. It may leave behind adrenal calcifications or a pseudocyst, which I'll talk about in a later lecture. Now, what about ultrasound for adrenal hemorrhage? Well, this patient actually did have a right upper quadrant ultrasound prior to getting the CT scan, and you can see that there's a 6 centimeter ovoid, well-circumscribed, solid-appearing mass there in the region of the right adrenal gland. And on the lower image, which shows color Doppler, there's no flow within the lesion, so that means it's avascular. So adrenal hemorrhage on ultrasound, usually we don't see the adrenal glands very well in ultrasound if they're normal. But with hemorrhage, the appearance is variable. It depends on the age of the hemorrhage. So it could be hypoechoic or hyperechoic, meaning dark or bright. It could be solid or cystic, and hemorrhage will become anechoic and cystic as the hematoma liquefies. Anechoic means completely black, like fluid. So here's a different case. This was a 2-week-old patient, and the bilateral adrenal glands were imaged on ultrasound. In the right adrenal gland, you can see that there's a mass that's both solid and has anechoic cystic components, whereas the left adrenal mass is homogeneously echogenic and solid. If we add power Doppler imaging to that right adrenal mass, power Doppler also detects flow like color Doppler, but it's more sensitive. You can see that there's no flow within the right adrenal mass. We do see some normal flow within the adjacent right liver. This patient had follow-up ultrasounds and the hemorrhage resolved 2 months later, which is the expected course. Now here's a cine clip from that same patient, nicely showing in real time the mixed cystic and solid components of that right adrenal hemorrhage. You can see that the anechoic black areas correspond to the hemorrhage components that are liquefying. Now here's another case. This is a patient who had an isolated right adrenal hemorrhage. You can see that there is a mixed solid and anechoic cystic mass in the right adrenal gland region. And there is significant mass effect against the adjacent right kidney on the upper image. The lowermost image shows a color Doppler image, and again, there's no vascularity within this hemorrhage. It's completely avascular. This is a 3-day-old with isolated right adrenal hemorrhage, with liquefaction causing that cystic appearance. So neonatal adrenal hemorrhage. Adrenal hemorrhage is actually more common in neonates than in children and adults. So it's actually the most common adrenal mass in infancy, so important to remember. Causes include various neonatal stresses and also difficulty with birth or hypoxia. So let's talk about different causes of adrenal hemorrhage. This is an adult patient who presented to the emergency department, and there is this right ovoid mass within the adrenal gland. The left adrenal gland looks normal, denoted by the green arrow. And it's unclear on this image alone what the cause for this adrenal hemorrhage is. However, you can see that there's prevertebral hematoma, and also the vertebral bodies look fragmented here on these images. Switching to bone windows and coning down a bit to the vertebral bodies, you can see that there are comminuted burst fractures of the T10 and T11 vertebral bodies. So this was a patient who sustained severe trauma. There was also a large pneumothorax and bilateral rib fractures together with pulmonary contusion. So the most common cause of adrenal hemorrhage in an adult patient is trauma. And it's usually unilateral. And can you guess which side is more common? Yes, right. Right is more common than left. And that's in part due to the fact that the right adrenal gland is sandwiched between the liver and the vertebral body. So when there's blunt trauma, it takes more of the brunt of that. This patient actually had spinal fixation and then a follow-up CT showing that that right adrenal hematoma had resolved. There are also, of course, non-traumatic causes, and when you have non-traumatic adrenal hemorrhage, it tends to be bilateral, whereas in the setting of trauma, only about 20% are bilateral. And causes for non-traumatic adrenal hemorrhage include sepsis, surgery, burns, hypotension, and then also pregnancy. Various coagulation disorders also predispose to adrenal hemorrhage, and thromboembolic disease, which can cause adrenal vein thrombosis. Adrenal tumors, particularly adrenal cortical carcinoma, can also cause hemorrhage. And of course, like everything else in medicine, there's idiopathic as a cause. And actually, the first case I showed you was idiopathic. It was never discovered what caused that patient's hematoma. All right, let's look at another case here. You can see that there are bilateral adrenal masses. And so right away you're thinking, if this is adrenal hemorrhage, it's likely non-traumatic since it's bilateral. Coronal image also showing bilateral, mildly heterogeneously hyperdense adrenal masses just superior to the kidneys. And this was a patient that had Waterhouse-Friderichsen syndrome. They had bilateral adrenal hemorrhage secondary to this meningococcal septicemia. So this is an infectious process that can lead to shock and massive hemorrhage into usually both the adrenal glands. It's also characterized by hypotension and can evolve into disseminated intravascular coagulation, DIC. So important not to miss this. All right, that's it for Leave Alone Adrenal Masses, focusing on adrenal hemorrhage. Thank you for your attention. Next time I'll talk about adrenal cyst and myelolipoma. If you enjoyed this video lecture, I'd really appreciate it if you left a review and subscribed to Radiologist Headquarters on Apple Podcasts. Or please like and subscribe on YouTube so that others may find it. Please share this video lecture with a friend and visit radiologisthq.com for additional reference material. Thanks. This is imaging of non-mass-like adrenal abnormalities. I'm Dr. Dan Koval, and welcome to Radiologist Headquarters. So just an overview of what I'll be talking about today for non-mass-like adrenal abnormalities. I'll review normal adrenal anatomy, a congenital variant of the adrenal glands, adrenal hyperenhancement and what that means, adrenal calcifications, adrenal atrophy and adrenal hyperplasia, and then we'll talk about the rare adrenal infarct. So starting with anatomy of the right adrenal gland, the gland is immediately posterior to the inferior vena cava, superior to the upper pole of the right kidney. It tends to have an inverted V configuration or even a comma shape. The left adrenal gland is posterior to the pancreas, and it's anteromedial to the upper pole of the left kidney, and that's more likely to have a triangular or inverted Y configuration. But you can see here, especially on the coronal reformatted image, that both of the adrenal glands tend to have a lambdoid configuration. So what about this case? You can see that the left adrenal gland has not really an inverted V or Y configuration, but more of a linear configuration. And if we scroll inferiorly into the pelvis, you can see that there is an ectopic kidney. So the linear adrenal gland indicates congenital malposition or absence of the kidney. In other words, renal ectopia or renal agenesis. And that will lead to a vertical, linear, almost disc-like configuration of the ipsilateral adrenal gland. That's sometimes described as a pancake adrenal gland or a lying down adrenal sign. And after nephrectomy, the adrenal gland will actually maintain its normal adreniform shape. So that's how you can differentiate whether a patient has had a nephrectomy or has congenital absence of a kidney. Because you need that normal positioning of the kidney in the renal fossa to get that normal adreniform configuration. Looking at another case, this is a T2 coronal MRI image showing a normal right adrenal gland with that lambdoid configuration, but the left adrenal gland has a very vertical, linear, disc-like configuration. And on this image, you can see that there's a normally positioned right kidney, but where's that left kidney? This patient also had a CT scan of the abdomen, and these multiple axial images show that the left kidney is actually fused to the lower pole of the right kidney, and this is known as cross-fused renal ectopia. And because we did not have normal positioning of the left kidney in the renal fossa, that's why you have that developmental variant linear adrenal gland on the left. Okay, looking at another case, this was an elderly patient with abdominal pain. And what do you notice here? Well, the adrenal glands have normal configuration, but they seem to be very bright. They're hyper-enhancing, especially when you compare that to the inferior vena cava there, denoted by the orange arrow. They're much brighter than the inferior vena cava. So adrenal hyperenhancement is denoted when there is enhancement greater than the inferior vena cava. Normally, the adrenal glands can enhance to 50 to 60 Hounsfield units, but this will be much greater than that. And that raises suspicion for hypotension, and it may be part of the CT hypoperfusion complex, where you can get thickened hyperenhancing bowel loops, the so-called shock bowel, collapsed inferior vena cava, and these findings are often more commonly seen in pediatric patients in the setting of shock, sepsis, and trauma. And here, denoted by the blue arrow, there's actually extensive free air that was due to an anastomotic breakdown. The patient also suffered cardiovascular collapse, and that's what prompted these hyperenhancing adrenal glands. So there have actually been a few studies on this topic. One study showed that this is a finding that may be an early sign of impending shock, warranting early critical care management. And it may also be an indicator of poor prognosis in ill patients. So the bottom line is when you see this finding, you want to pick up the phone and notify the referring physician rapidly, because this may be a sign of impending shock and that the patient may go downhill. Another study showed that if this finding is identified, it may actually indicate a therapeutic window before irreversible shock has set in. So also underscoring the importance of notifying the caring physician as soon as possible to intervene on this. Now, what about this case? It looks like the adrenal glands are brighter than the inferior vena cava bilaterally, right? But if we use bone windows, you can see that this is actually not enhancement, but it's calcification. And this patient also had an X-ray showing that finding as well. You could see that there are bilateral left greater than right adrenal calcifications. They have that typical amorphous calcification you see that occurs in the setting of a solid parenchymal structure. So what can cause adrenal calcifications? Let's go over the differential diagnosis. Well, one of the most common would be prior adrenal hemorrhage. So infection is also a common cause due to tuberculosis or histoplasmosis, sepsis, typically Waterhouse-Friderichsen syndrome. And then there are certain neoplasms that you always want to consider in the setting of calcification, such as pheochromocytoma, adrenal cortical carcinoma, metastatic disease can occasionally calcify, and neuroblastoma, a pediatric tumor, can also calcify. And then there are unusual metabolic diseases that can cause that, such as Wallman's disease, which is an autosomal recessive xanthomatosis, where the adrenal glands can calcify. And this patient was an older male that had Addison's disease, adrenal insufficiency, which can occur after bilateral adrenal hemorrhage. So how will adrenal calcifications look on MRI? Well, here's a case. If you look at these two sets of images, the images above are in-phase T1 weighted images, and the lower images are opposed phase T1 weighted images. You can tell that those are opposed phase images because it looks like you've drawn a magic marker around all the parenchymal structures. So in-phase images are T2 star-like, meaning they're susceptible to the inhomogeneities of the magnetic field. And what that does is cause things like gas, calcium, and metal to bloom, to appear as a black cloud. So if you look at the normal physiologic gas within the transverse colon there, on the in-phase T1 weighted image, it's blooming. It looks like a black cloud compared to the opposed phase image. So what else do you notice that seems to be blooming on the in-phase images there? Well, you can notice that the bilateral adrenal glands have these amorphous areas of hypointensity, which you don't see on the opposed phase image. So that could be due to calcification. It could also be due to hemosiderin from an old hemorrhage. But if you look at the CT scan that the patient also had, you can see that there are bilateral adrenal calcifications, indicating that this susceptibility artifact, the blooming we were seeing on the in-phase T1 weighted series, was due to calcification. So one of the things I'll look at when reviewing a T1 in-phase abdominal MRI image is susceptibility artifact to indicate calcification in the adrenal glands or kidneys, but it's also great to find areas of abnormal gas and metal artifacts. So free air, pneumobilia, portal venous gas, you could pick up nicely on the in-phase T1 weighted series. And if we look at the coronal CT maximum intensity projection reformatted images from this same CT scan, it nicely shows the bilateral amorphous parenchymal calcification involving those adrenal glands. Do you see any other findings, incidentally? Right, there's an inferior vena cava filter and a non-obstructing left intrarenal calculus. The patient also had an abdominal x-ray, again showing that amorphous calcification of the adrenal glands. Let's look at another case. Here, the bilateral adrenal glands are rather small in size. They seem to have normal configuration with that inverted V or Y configuration, but they're small in size. Just to compare, here's a normal study, and you can see that the normal adrenal glands are larger. So this is a patient with adrenal atrophy. So atrophic adrenal glands may indicate adrenal insufficiency. And adrenal insufficiency is insufficient secretion of corticosteroids. So there are two types. The primary type is due to destruction of the adrenal cortex, and that's something we might see after adrenal hemorrhage or adrenal infection. The secondary type is caused by a lack of adrenal corticotropic hormone, ACTH, which will lead to adrenal hypofunction. ACTH stimulates the adrenal gland, and that can occur in the setting of panhypopituitarism, such as patients with Sheehan syndrome, and also patients taking corticosteroids. So this patient actually had a history of chronic prednisone treatment for Meniere syndrome. So this was a type of secondary adrenal atrophy. So another example here, do you see the adrenal glands? They're very hard to see because they're almost completely atrophied on the axial image. The coronal image also shows barely detectable adrenal glands bilaterally. And this was a 76-year-old male with Addison's disease and had very severe adrenal insufficiency. Now, on the opposite end of the spectrum, you have this type of adrenal abnormality. What do you notice on this case? Well, the bilateral adrenal glands appear hypertrophied, left greater than right, and on this coronal image, the left adrenal gland is clearly hypertrophied. So this patient also had an MRI. The upper T2 fat saturated image shows that the bilateral adrenal glands are hypertrophied, left greater than right, almost with a macronodular configuration. And the post-contrast T1 image below shows the same thing. We don't see any hyper-enhancing adrenal nodule, just this non-mass-like adrenal hypertrophy. And this is a patient with adrenal hyperplasia. So this is a benign finding, and the definition is an enlarged adrenal limb greater than 10 millimeters thick. And you can see that's the case here bilaterally. And the adrenal gland should maintain an adreniform shape. They might be macronodular, but they should still have a relative normal adrenal configuration without a discrete mass. And these can be functioning and cause Cushing or Conn syndrome, but they might be non-functioning. And they may also be lipid-rich, showing signal dropout on T1 opposed phase images, just like the lipid-rich adrenal adenomas, but they don't always have to. This patient did not have significant dropout. All right, let's look at a final case. This was a pregnant female that presented to the emergency department with right flank pain. An MRI of the abdomen was done, and on this T2 coronal image, you can see that the right adrenal gland is enlarged, edematous, and has periadrenal edema, which is T2 hyperintense. Also, the renal collecting systems are somewhat dilated, more pronounced on the right, but in this case, this was due to physiologic compression of the gravid uterus against the distal ureters. There's also no perinephric edema to indicate high-grade renal obstruction. So if we then look at the T2 fat-suppressed axial images, the fat is suppressed, which makes the fluid signal more conspicuous. This right periadrenal edema and adrenal enlargement is more apparent. The T2 hyperintense edema is isointense to the CSF and the spinal canal. So at this point, you'd want to consider adrenal infarct as your main differential diagnosis, and that can also be hemorrhagic. So we would look at the T1 fat suppressed series, and blood is usually bright on T1 weighted images. What do you think about this case? Right, the adrenal gland is not hyperintense, so we don't have any evidence that this is a hemorrhagic adrenal infarct. So this was a case of non-hemorrhagic adrenal infarction. An adrenal infarction has a variety of causes. Anything that leads to a hypercoagulable state can cause adrenal vein thrombosis and adrenal infarction. An entity particularly noted to be associated with adrenal infarction and adrenal insufficiency is antiphospholipid antibody syndrome. This syndrome causes arterial and venous thrombosis as well as miscarriages and thrombocytopenia, and it's most common in females aged 30 to 40. It can also be associated with other syndromes, mainly lupus. And pregnancy is another cause for adrenal infarction. And a recent study by Dr. Glomsky showed that unilateral non-hemorrhagic adrenal infarct was seen in 1.3% of pregnant women undergoing abdominal MRI for acute abdominal or flank pain, similar to our case here. So what's the imaging appearance for non-hemorrhagic adrenal infarction? Well, the infarcted adrenal gland will be non-enhancing on CT and MRI, and there'll be surrounding stranding. We did not give intravenous gadolinium in this case because it's a pregnant patient and gadolinium is contraindicated in the setting of pregnancy because it can cross the placenta. Also, on MRI, there'll be T2 hyperintensity of the adrenal gland due to edema, and restricted diffusion will be seen on DWI and ADC sequences. And adrenal infarctions can evolve into or be preceded by hemorrhage, so it's important to identify whether or not hemorrhage is present because that can influence anticoagulation. If there's significant hemorrhage, that may be a contraindication to anticoagulation, depending on the clinical scenario. And just to show you how the infarcted adrenal gland will appear on CT scan, here's a delayed post-contrast CT image showing the right infarcted adrenal gland, which is enlarged, edematous, and has periadrenal stranding, and it's non-enhancing relative to the normal left adrenal gland, denoted by the green arrows. This axial image is showing you the same information, the non-enhancing enlarged edematous right adrenal gland, non-enhancing relative to the normal left adrenal gland. This is a different case showing a dramatic example of adrenal non-enhancement. Thank you to Dr. Bogna Targonska for sharing this case with me. This is a contrast-enhanced CT of the abdomen, and the left adrenal gland is non-enhancing, enlarged, and edematous, consistent with adrenal infarction. Compare that to the normal right adrenal gland, denoted by the orange arrow there. If we look at the coronal reformatted image, you can see that the majority of the left adrenal gland is non-enhancing and edematous. A small portion of the super aspect of the gland does demonstrate residual enhancement, but the majority of the gland is infarcted. And again, compare that to the normal right adrenal gland with the orange arrow. And this was actually a pediatric patient with lupus. So as I mentioned previously, lupus can be associated with antiphospholipid antibody syndrome, causing thrombotic vascular occlusion leading to adrenal infarction. In addition, though, lupus is often associated with an immune complex-mediated inflammatory vasculitis, and that could also potentially serve as a mechanism for adrenal injury in these patients as well. All right, that's it for non-mass-like adrenal abnormalities. Thank you for your attention. Hey, if you enjoyed this video lecture, I'd really appreciate it if you left a review and subscribe to Radiologist Headquarters on Apple Podcasts. We're now on Facebook, and you can like and follow us there. You can also subscribe on YouTube and click the bell icon to receive a notification whenever a new episode comes out. Thanks. This is imaging of adrenal cysts and myelolipomas. I'm Dr. Dan Koval, and welcome to Radiologist Headquarters. So we're going to continue our discussion on leave-alone adrenal masses. Last time we discussed adrenal hemorrhage. Now we're going to talk about adrenal cyst, as well as a differential diagnostic consideration, gastric diverticulum, and myelolipoma, and its malignant differential diagnosis of retroperitoneal liposarcoma. By leave-alone adrenal masses, I mean that these are benign masses that are not functioning. They do not secrete hormones. So starting with a case, this is a patient who had a non-contrast CT scan. You can tell it's non-contrast because the aorta is not enhancing, and there's a well-circumscribed homogeneous left adrenal mass. So the next step is to place a region of interest on that mass, and we get a Hounsfield unit density of 8. And you might think, okay, that's consistent with an adrenal adenoma because it's 10 or less, right? There's also a punctate calcification within the wall of this mass, as you can see here, denoted by the green arrow, which is a clue as to what this is. So if we look at the in-phase and opposed-phase T1-weighted images from the patient's MRI, you can see this left adrenal mass does not lose signal on the opposed-phase image. It does not drop out. So therefore, it's not consistent with a lipid-rich adrenal adenoma. On the T2 coronal series, the mass is extremely bright, similar to water or fat density. You can see it's isointense to adjacent fat. There's also a small amount of layering T2 hypointense debris within this structure. And then on the T1 fat-suppressed post-contrast series with gadolinium, the mass is completely non-enhancing, It also is dark on T1, which is consistent with fluid. And this is typical for an adrenal cyst. The patient also had an ultrasound of the left upper quadrant here, showing that the mass is anechoic with increased through transmission, and there's an imperceptible wall consistent with a cyst. Just on these images alone, it's difficult to tell is this an adrenal cyst or a renal cyst, but we know from the cross-sectional imaging that it's arising from the adrenal gland. Here's another example of an adrenal cyst. You can see that this time it's on the right side, and it's T1 dark. It's following the same signal as the CSF in the spinal canal since it's fluid, and then it's also T2 bright, iso-intense to the adjacent CSF. Remember, water is T2 bright, and both H2O and T2 have a 2 in it. And then on post-contrast T1 images, you can see that it's not enhancing. It just has a thin peripheral wall of enhancement which corresponds to the surrounding adrenal gland. So adrenal cysts are not very common. There are two major types. There's the simple type, which is endothelial line, that tends to be dark on T1, bright on T2, following simple fluid, like in this case. And then there's also the pseudocyst, which has no epithelial lining. Those usually arise following adrenal hemorrhage, and those are more likely than simple cysts to be symptomatic. And they may have a complicated appearance and have a T1 bright appearance if there's hemorrhage within them, which can also be T2 dark. And there may be peripheral calcification. So that initial case I showed you with the CT ultrasound and MRI was likely a pseudocyst. And these will not enhance because it's just a cyst, it's just water. And if these become symptomatic, they can be removed laparoscopically. So if we go back to that initial CT scan of the left adrenal cyst, again, the density is 8 Hounsfield units. This patient actually had a CT scan 4 years earlier, and the adrenal cyst had a density of 21 Hounsfield units. And you can also see it was a little smaller before, and it has since developed calcification on the wall. So this is typical evolution for a hemorrhagic pseudocyst that was a little dense previously and has become more simplified over time. Now, water tends to have a density of 0 Hounsfield units, but actually ranges from 20 to -10. So 8 Hounsfield units is consistent with simple fluid, and 21 is a bit hemorrhagic or proteinaceous. Now, if you recall from the adrenal adenoma lecture, there's some overlap here, right? Because adrenal adenomas have a density of 10 Hounsfield units or less. So these are sometimes misdiagnosed as adrenal adenomas, but that's okay in the respect that these are completely benign. It's not okay in the fact that these are completely non-functioning. There's never a functioning simple adrenal cyst, whereas adenomas can be functional. So you want to try to differentiate them if you can. All right, so here's another case. This is a right upper quadrant ultrasound showing the liver, kidney, and then this anechoic cystic structure with increased through transmission and imperceptible walls. So statistically, this would almost always be a renal cyst, but not in this case because we're talking about adrenal cyst, right? So if we look at the CT scan for this patient, there's the right adrenal cyst sitting on top of the kidney. But what don't you see that you would expect to see for a renal cyst? Right, there's no claw sign, meaning there's no claw of renal tissue surrounding this structure, which would indicate that it's renal in origin. It's just sitting on top of the kidney, and that's because it's arising from the right adrenal gland. And you can see that there is a claw sign from the adrenal gland there. There's that claw of adrenal tissue arising posterior to the inferior vena cava, where you'd expect the right adrenal gland to be. And this is a typical adrenal cyst. The density there is 11 Hounsfield units, which is consistent with water. It's in that range of 20 to -10. And what else do you see on this patient? Just an incidental finding. Right, there's a fatty liver. The density of the liver is quite low. And that's why it was also a bit echogenic on ultrasound, if you happen to pick that up. Let's look at another case. Here's a non-contrast CT scan showing an ovoid cystic lesion in the region of the left adrenal gland. If we measure the density of that lesion by placing a region of interest, we get Hounsfield unit density of 4, which is consistent with fluid. So this is probably a left adrenal cyst, right? Now, if we look at this image, it's actually communicating with the stomach. The patient had a prior study where oral contrast had been administered, and you can see that there's oral contrast extending from the stomach into this structure posteriorly. And this is typical for a gastric diverticulum. Deception. So these most commonly arise from the posterior aspect of the gastric fundus. When they're fluid-filled, they can mimic a left adrenal cyst or even an adenoma. And when they're collapsed because of the soft tissue density of the stomach, they can mimic an indeterminate adrenal mass. So it's key to look for communication with the stomach. And even if your current study does not have oral contrast, the patient may have a prior study where oral contrast was administered, which is extremely helpful in confirming the diagnosis. Here's a different patient showing a left adrenal region nodular density. And if you look closely, there's actually gas within it. And you can see that a bit more evidently on the lung windows. So the diverticulum might contain physiologic gas from the stomach, and that's also diagnostic of a gastric diverticulum. And it may be helpful to apply lung windows to detect that. Now, when you're trying to determine if you're dealing with an adrenal lesion or a gastric diverticulum, it's often helpful to look at multiple imaging planes. This is a different case showing a cystic appearing lesion in the region of the left adrenal gland on coronal reformatted images. But when you look at the axial images, you can see clearly that it's arising from the posterior aspect of the stomach, and this is just another gastric diverticulum. Here you can see some gas in it as well, which is physiologic and diagnostic of a diverticulum. Here's another case. This is a T2 axial image, and you see the cystic structure posterior to the stomach. So what do you think that is, a gastric diverticulum or an adrenal cyst? It's really hard to tell on this image alone. If I show you a CT scan, though, what do you notice? Right, there's no oral contrast extending into this structure, so you're thinking it's probably an adrenal cyst. So the next thing you'd look for is the claw sign, and on this image, it's nicely shown a claw of adrenal tissue surrounding this adrenal cyst. So that shows you that this cystic structure is arising from the adrenal gland. That's also evident on this CT scan image, a claw of adrenal tissue around the cystic lesion, and again, it does not have oral contrast within it. And the coronal reformatted CT image also shows both of these findings nicely. Okay, now that you're all professors of the gastric diverticulum, let's look at a different adrenal mass. This is a case showing a CT scan of the upper abdomen with intravenous contrast, and there's a soft tissue and fat density mass in the left upper quadrant, posterior to the stomach and medial to the spleen. On these images alone, it's difficult to tell exactly what organ is this mass arising from. Looking at the coronal images, you can see that it's sitting on top of the left kidney, and you don't see a claw sign, meaning it's not arising from the renal parenchyma. That green arrow shows a lack of a claw sign. And this is at the same level of the adrenal gland. So this is a mass arising from the left adrenal gland, and this is a myelolipoma. So myelolipomas are rare benign neoplasms that contain macroscopic fat and hematopoietic bone marrow elements. That accounts for the soft tissue. So they're well-defined masses, and they contain varying degrees of fat and soft tissue. And fat density you can measure with a region of interest at -30 to -90 Hounsfield units. But often on CT scan, you don't even need to do that. You can just visually see that it's the same density as the surrounding macroscopic fat within the abdomen and the subcutaneous fat. So here's an example where the myelolipoma is completely fat density, and it's actually difficult to see, but you do see a claw of adrenal tissue surrounding this fat density mass. It's isodense to the surrounding periadrenal perinephric fat, and it can blend in. Here's a different but similar example of another purely fat density left adrenal myelolipoma. And myelolipomas can also have very little fat density. So here's an example of just a small amount of fat density within an otherwise soft tissue predominant myelolipoma. And that blue arrow is pointing to the small area of macroscopic fat within the lesion. It's also not unusual to have small calcifications within myelolipomas. Up to 30% can have calcifications, here denoted by the green arrow. Just to keep in mind, other adrenal masses that can have calcifications include pheochromocytomas and adrenal cortical carcinomas. And hemorrhage is a potential complication of myelolipoma, but it's very uncommon and typically only seen when these tumors become large, more than 4 centimeters in size. The nice thing about myelolipomas is they're completely benign. There's no risk of malignant transformation. Here's an example as to how calcifications within a myelolipoma might look on plain film. On this frontal view of the abdomen, there are these amorphous calcifications within the right upper quadrant. Here's the correlative coronal CT image showing those calcifications as well. Now, here's the main differential diagnosis you do not want to confuse myelolipoma with. In the left upper quadrant of this contrast-enhanced CT image, there's an amorphous soft tissue and fat density mass in the same location as that initial myelolipoma that I showed you. But what's different about this lesion? Well, it has ill-defined margins, and if you look closely, you can see that it's actually displacing as opposed to arising from the left adrenal gland, denoted by those green arrows. So is this arising from the left kidney? Well, if we look at additional axial images of the CT scan here, you can see that it's amorphous and ill-defined, it's fat and soft tissue density, but it's displacing as opposed to arising from the left kidney. It's not, you don't see a claw sign there. It's also displacing the adjacent abdominal bowel. And it has, again, mixed soft tissue and fat density. And this is typical for a retroperitoneal liposarcoma in the differential diagnosis for myelolipoma. The difference is it arises from the retroperitoneum as opposed to the adrenal gland. And it actually displaces or invades the adrenal gland and the adjacent structures. A key differentiating feature is that it's not usually well defined. It tends to be very ill-defined and aggressive looking, as in this case. This one was biopsied and it yielded well-differentiated liposarcoma. And just a tip when you're biopsying a lipomatous mass is always target the soft tissue density regions. Otherwise, the pathology might come back as a nonspecific lipomatous lesion, which may not be helpful. Now, how do myelolipomas appear on MRI? Well, here's an in-phase and an opposed phase chemical shift series showing that there's a right adrenal mass. It has mixed high and low signal. And do you see the areas of high signal dropping out on the opposed phase image? No, not really. They remain fairly bright. But if we look at this T1 fat saturated image above, this mass suppresses, the fat signal suppresses within it, which is typical for macroscopic fat. And that's the same type of fat that we have in the subcutaneous fat and the abdomen. Notice how that's also becoming dark on this T1 fat saturated image. And if we look at this T1 fat saturated image with gadolinium, the mass is only slightly enhancing. The fat signal areas are not, which is typical for myelolipoma. They can have varying degrees of enhancement, but it's only the soft tissue components that will enhance. Note also how it's well circumscribed, unlike a liposarcoma, and it's separate from the right kidney. It's not an angiomyolipoma. So again, unlike adenoma, myelolipomas have primarily macroscopic fat, meaning they'll lose signal on the fat-saturated sequence, which is diagnostic of myelolipoma. And you can think of macroscopic fat as fat you can see. All the fat you can see just by looking on CT is macroscopic fat. You can put an ROI on that and get a density of -30 to -90. But it's also apparent visually. And contrast that with the adenoma, which has the microscopic or intracytoplasmic or intracellular fat, which will lose signal on the T1 opposed phase image. Now, interestingly, even though MRI is very specific for myelolipoma, it can be a little more laborious to make the diagnosis just because you have to look at multiple sequences as opposed to CT with macroscopic fat. You can just see it evident on a single image. This is the same patient's T2 coronal and T2 axial images showing that right adrenal myelolipoma, but it's very difficult to say this is a myelolipoma just on these images alone because it's a T2 bright mass. You might even wonder, is this a complex adrenal cyst? Is it a pheochromocytoma? But if you look at the T2 fat saturated image, the fat density areas partially suppressed. Those other areas that remain bright are not fat density. That's probably soft tissue there. So just keep that in mind, that on T2 images, not only is fluid bright, but also fat. And here on this T2 fat saturated image, the CSF remains bright, but the subcutaneous fat, the macroscopic fat, loses signal. All right, that's it for adrenal cysts and myelolipomas. Thank you for your attention. Hey, if you enjoyed this video lecture, I'd really appreciate it if you left a review and subscribe to Radiologist Headquarters on Apple Podcasts. You can also subscribe, like, and even comment on YouTube so that others can find it. Please share with a friend and visit radiologisthq.com for additional material. Thanks. This is imaging of malignant adrenal masses. I'm Dr. Dan Koval and welcome to Radiologist Headquarters. So to give you an overview of the lecture, pheochromocytoma is a potentially malignant mass of the adrenal gland. Remember, 10% are malignant, but we discussed that in a separate lecture, which you can check out. So in this lecture, I'll talk about adrenal metastases, including the fabled collision tumor, and then also adrenal cortical carcinoma and adrenal lymphoma. So starting with a case. This was a CT scan of the abdomen with intravenous contrast through the level of the adrenal glands. And you can see these two large mixed cystic and solid masses in the region of the adrenal glands bilaterally. If we look at the coronal reformatted image, you get a sense of their large size and the mass effect they exert against the underlying kidneys. Also, there are multiple ill-defined hepatic metastases. So these findings are typical for adrenal metastases. And adrenal metastases are the most common malignant lesion involving the adrenal gland. The most common sites of primary malignancy that spread to the adrenal gland include lung, that's the most common, kidney, particularly renal cell carcinoma, breast cancer, melanoma, and then also colorectal carcinoma. Anytime you see masses that are bilateral and greater than 3 centimeters, you should be concerned about adrenal metastases. Remember, though, that pheochromocytoma can be bilateral 10% of the time, especially if there's a genetic predisposition, then the incidence may be even higher. This patient, though, had small cell lung carcinoma with hepatic and adrenal metastases. Now here's a different case showing an example of renal cell carcinoma metastatic to the adrenal gland. You can see that there's a heterogeneously hyperdense mass there in the right adrenal gland, and this was a patient who had had a nephrectomy from renal cell carcinoma. You can see surgical clips in the left renal fossa there. Also, this image represents a hepatic arterial or pancreatic phase image where the portal vein and hepatic artery enhance maximally, and this is the best phase to detect hypervascular masses throughout the liver. It's also a great phase to detect hypervascular pancreatic masses, and you can see this peripherally hyperenhancing centrally necrotic mass in the pancreatic tail. Remember that the most common metastasis to the pancreas is from renal cell carcinoma from the kidney. Now this patient has a later portal venous phase image where the hepatic veins are starting to enhance and the rest of the hepatic parenchyma is also enhancing. And notice that it's very difficult to see any hepatic metastases on this phase. And that's why it's important to get a hepatic arterial phase image whenever there's a concern for possible hypervascular metastases. You can again see that right adrenal metastasis, which is enhancing a bit more now, and the pancreatic tail metastasis is also still apparent. Now, up to 50% of adrenal masses in patients with known malignancy might actually be benign, and that's because adrenal adenomas are so common we often just see them incidentally, and that's where PET-CT becomes invaluable. And this was an example of lung adenocarcinoma with a metastatic focus to the right adrenal gland. Generally on PET, malignancy is metabolically active and will take up the radiotracer and appear avid, hot. And a general rule is if an adrenal gland is more avid than the adjacent liver, then that increases suspicion for malignancy. But we can get a bit more specific than that. There was a study by Dr. Metzer that evaluated malignant adrenal lesions compared to adenomas, and it was found that an SUV cutoff of 3.1 was the most accurate predictor of whether an adrenal nodule was malignant or not. An SUV is the standardized uptake value, quantitative measurement of the metabolic activity on PET. Another study by Dr. Watanabe also looked at adrenal cortical adenomas and metastases, but instead compared the ratio of the adrenal to liver SUV, and actually found that a cutoff value of 1.37 was actually 100% specific to differentiate these two adrenal abnormalities. Also, they found that that ratio was more accurate than just the SUV max alone, or even doing an adrenal to spleen SUV ratio. I'm glad they included the spleen in this study because I feel like the spleen often gets left out. It's very lonely there in the left upper quadrant. So the bottom line, with this ratio, it can be helpful in cases where you have equivocal avidity when you're inspecting it visually, or if the maximum SUV is just around 3.1. A ratio will help you determine if there's a metastatic focus with greater specificity. Here's an example of a patient with a known history of lung cancer, and on this non-contrast CT scan, there's a left adrenal nodule. If we look at the PET data fused on that CT scan, you can see that this nodule is avid, and visually it does look like it's more avid than the liver. If we actually measure the SUV value, we're getting a maximum SUV of 4.2, and the adrenal to liver ratio was greater than 1.4. So these findings are extremely suspicious for a metastatic focus. Indeed, on a follow-up PET-CT only 2 months later, this mass had increased significantly in size and avidity, now with a maximum SUV of 14.2. And if we look at the lung bases, you can see that the avid right lower lobe lung cancer is present there, and there are also ipsilateral metastases to the right hilum and mediastinum, all metabolically active. So this is an example of metastatic lung cancer to mediastinal and hilar lymph nodes as well as the left adrenal gland. So let's look at another case. This patient also had a history of lung cancer, and we're looking at T1 in-phase MRI images through the adrenal glands. There's a left adrenal nodule superiorly there, and then another one more inferolaterally, also on the left there. If we look at the T1 opposed phase MRI images, and you can tell that these are post phase or out of phase because there's India ink or etching artifacts surrounding all the organs at the fat interface. You can see that the larger of the two nodules demonstrates signal dropout. It becomes dark, as does the smaller one arising from that lateral limb of the adrenal gland. So these are both diagnostic of lipid-rich adrenal adenomas. The patient also had a PET-CT at that time for staging purposes. And again, you can see that there's the larger left adrenal nodule and the smaller one there. Both have avidity similar to the liver. They're not more avid than the liver, and I'll tell you that the max SUV was less than 3.1. However, if we look at a follow-up PET-CT done 3 years later, what do you see now? Now there's increased avidity demonstrated by that larger left adrenal nodule, whereas the smaller one is unchanged. Now if we measure the SUV for this nodule, we get 5.7, which is consistent with metastasis, and this was a collision tumor. So these are rare. A collision tumor is when two histologically distinct tumors abut or are near each other in the adrenal gland. The most common collision tumor has actually been reported to be myelolipoma and adenoma, but we're more worried about the metastatic type, as in this case, a metastasis and an adenoma. And PET-CT is actually the best way to characterize these masses without doing a biopsy. But there are other modalities that you can still make this diagnosis on. Like in this case, so this was a patient with a history of renal cell carcinoma, and we have in-phase and opposed-phase T1-weighted MRI images. And do you see anything? Yeah, there's a left adrenal nodule there on the in-phase image, and on the out-of-phase image it completely drops out. It becomes very dark, diagnostic of a lipid-rich adrenal adenoma and benign. Now if we jump ahead 9 years later, we have these 3 separate MRIs all showing opposed-phase T1-weighted images. And these MRIs are arranged oldest on the right-hand side and newest on the left-hand side. And what do you see there? Well, you see the adrenal adenoma has the signal dropout again, but you also have this new area of defect in the area of dropout, and it's enlarging over time. Here's that T1 opposed phase image again showing the defect within the area of signal dropout. And if we look at the post-contrast image from the same MRI, you can see that there's a rim-enhancing lesion within this adrenal gland. Also on the T1 fat-suppressed coronal post-contrast images, there are multiple solid enhancing renal masses indicating recurrent metastatic renal cell carcinoma. And this was another example of a collision tumor, this time a renal cell metastasis to a gland containing an adrenal adenoma. And 2 teaching points from this case: renal cell carcinoma metastases can be extremely slow growing and can occur many years after the initial tumor presentation, as in this case, which was 9 years after that initial MRI that I showed you. I've seen cases present as far as 20 years after the initial presentation of renal cell carcinoma, coming back with metastatic disease. Also, the T1 opposed phase images can be really helpful in identifying collision tumors by seeing this defect in an area of signal dropout. This is particularly useful if you're reading an examination done without intravenous contrast. And this same principle also works for identifying lesions within a fatty liver or osseous lesions within the spine, because both the fatty liver and the bone marrow will demonstrate signal dropout on opposed phase images, and if you suddenly see a defect in that dropout that wasn't there before, that indicates that there's probably a new lesion. All right, let's move on to a different malignant adrenal mass. So this was a 73-year-old female who presented with abdominal pain. And you can see that there's a very large left adrenal mass, heterogeneous, and with a few areas of calcifications as denoted by those green arrows. The patient also had an MRI, and on these T1 and T2 weighted images, again you see this large left adrenal mass, very heterogeneous. It has areas of internal T1 hypointensity and T2 hyperintensity, fairly isointense to the adjacent CSF, and that's consistent with fluid indicating central necrosis. These wedge-shaped peripheral areas indicate hemorrhage, and both the areas of hemorrhage and central necrosis do not enhance on the post-contrast images here, but the surrounding bulk of the solid tumor does. And this is a T2 coronal image showing again the large size of the mass super adjacent to the left kidney, and the central T2 hyperintensity isointense to that CSF in the spinal canal indicating necrosis, and this was an adrenal cortical carcinoma. So these are rare primary malignant neoplasms of the adrenal gland, and they have a bimodal age distribution. So they can present in the first decade of life in children and the 4th to 5th decades of life in adults, although there is some variation. And one important fact to remember about these tumors is they might be functioning, particularly in female patients, meaning they can secrete hormones. And when they do, Cushing's syndrome as opposed to Conn syndrome is the most common. And unfortunately, they have an extremely poor prognosis. So what are the features of these tumors? Well, they tend to be very large, meaning they often present greater than 6 centimeters in size. and they often have areas of non-enhancing internal hemorrhage and necrosis, like in this case. So you can see these peripheral T1 hyperintense wedge-shaped areas within the tumor that are also T2 dark on this lowermost T2 fat suppressed image, and that indicates hemorrhage. However, though, just on these images alone, you can't really differentiate this from fat, right? Because fat will also be T2 bright, and it will be dark on a T2 fat suppressed image. So what sequence would you like to see next to confirm that this is actually hemorrhage, not fat? Right, a T1 fat suppressed image. And on this image, you can see that these wedge-shaped areas are T1 hyperintense, whereas the subcutaneous fat has been suppressed. So this is consistent with hemorrhage. And another feature of these tumors is that they can calcify in about a third. So venous invasion is common with adrenocortical carcinoma, and when there's metastatic disease, it tends to spread to lymph nodes, lung, bones, and liver. So let's look at another case. This is a large adrenocortical carcinoma on the left, very heterogeneous. You can see some areas of calcification there within the anterior aspect of the tumor. And this coronal image shows the underlying kidney being displaced by the extremely large tumor. This is much larger than 6 centimeters. And then what do you notice on this coronal image? It's very subtle, but there's an area of left renal vein invasion, and that was confirmed at surgery. So anytime you see an adrenal mass that's larger than 6 centimeters and invading into the adjacent renal vein or even inferior vena cava, that's extremely suspicious for adrenocortical carcinoma. Here's another case, different patient with a left adrenal cortical carcinoma, large and heterogeneous. And you also notice that there's this irregular pleural thickening at the right lung base. And the features of malignant pleural thickening are nodularity, thickness greater than 1 centimeter, circumferential thickening, and pleural thickening abutting the mediastinal surface. And this has all those features, so this was consistent with pleural metastatic disease. And this coronal image just again shows the large size of that left adrenocortical carcinoma, the right malignant pleural thickening with a pleural effusion. Here's yet another left-sided adrenocortical carcinoma, and what do you notice on the opposed phase image? There's a small area of signal dropout, indicating the presence of microscopic or intracytoplasmic fat. And you also see signal dropout throughout the vertebral body there in the adjacent spine, which is totally normal and physiologic. So just be aware that ACC can rarely have foci of microscopic fat with signal dropout on the out-of-phase, post-phase images. But you don't want to confuse that with adrenal adenoma. This is just a small area of signal dropout. And if we look at the remaining images for this particular adrenal cortical carcinoma, it's heterogeneous and solid on the T2 fat suppressed image, and it's very heterogeneously enhancing and vascular on the post-contrast image. So these findings are not consistent with adrenal adenoma, and also the large size of the mass would raise suspicion. However, even though adrenocortical carcinoma tends to present at a large size, it has to start small at some point, and it could conceivably be confused with adrenal adenoma if caught in the early stage. So that's just something to keep in mind. All right, let's talk about the final malignant adrenal mass that we'll be discussing in this presentation. Here's a contrast-enhanced CT scan through the level of the adrenal glands, and what do you notice? There's this adreniform mass-like homogeneous thickening of the left adrenal gland. It looks like it's a bit hypoenhancing. The patient also had an MRI, and if you look at these in-phase and opposed-phase T1 weighted images, you can again see that adreniform mass, homogeneous, and it's not showing any signal dropout on the opposed-phase series. So this is not consistent with a lipid-rich adrenal adenoma. It could still be adrenal hyperplasia since that doesn't always show signal dropout, but it does look a bit too mass-like for that. Looking a little more closely at this mass-like thickening, you can see that it's relatively iso-intense on T1 weighted images relative to skeletal muscle, and on T2 it's heterogeneous and mildly hyperintense relative to skeletal muscle. Looking at the post-contrast series, it's homogeneously hypoenhancing, and this was biopsied and demonstrated to represent adrenal lymphoma. So adrenal lymphoma is rare in the primary form. It's more common to see it in the setting of diffuse disease. It often presents as round or adreniform in shape. And on CT, it's usually hypoenhancing. On MRI, it's T1 iso-intense, T2 hyperintense relative to skeletal muscle, like in this case, and it usually shows minimal progressive enhancement. A key feature, though, is it tends to show restricted diffusion, and that can help you differentiate this from adrenal hyperplasia. And on PET imaging, it's often hypermetabolic, which is also helpful. Now, this is a different case, more dramatic, showing bilateral large adrenal masses that are adreniform in shape, hypodense and ill-defined. And you can also see that there's lymphadenopathy in the portahepatis peripancreatic region and some infiltration of hypodensity into that left kidney. On this image, you can again see that portahepatis lymphadenopathy, also portal caval, and the infiltrative hypodensity within that left kidney is more apparent. And this was a patient that had bilateral large B-cell adrenal lymphoma, also with metastatic lymphadenopathy and left renal involvement. Also notice that all of these masses are relatively isodense to skeletal muscle on CT, which is a typical feature for lymphoma, homogeneous and isodense to skeletal muscle on CT. So adrenal lymphoma is non-Hodgkin's lymphoma, and it's usually diffuse large B-cell lymphoma. Symptoms are often B-cell symptoms like fever, night sweats, weight loss, and also adrenal insufficiency is a common presentation. They tend to be bilateral as opposed to unilateral, as in this case, and they may invade into the adjacent kidney. Hey, we made it to the end of malignant adrenal masses. Thanks for your attention. And if you enjoyed this lecture, it would be phenomenal if you left a review and subscribed to Radiologist Headquarters on Apple Podcasts. We're on Facebook, and you can like and follow us there. You can also subscribe on YouTube and click the bell icon to receive a notification whenever a new episode comes out. Thank you and have a great day.
My name is Wei Chong. I'm at MD Anderson Cancer Center, Houston, Texas, and I'm going to talk about renal transplants. Okay, renal transplants. So the one-year survival rate for renal transplants is now 80%. 80% of transplants are from cadavers and 20% are from living donors. Transplants are placed extraperitoneally in the contralateral iliac fossa. And this is a graphic showing how a left kidney is placed. It's usually in the right iliac fossa. And in this particular case, the anastomosis is an end-to-side renal artery to the external iliac. Here is an alternative way of anastomosing the renal artery. Here it is going into the internal iliac artery, and the anastomosis here is going into the external iliac vein. So, sonographic assessment of renal transplants. First point I want to make is that Doppler ultrasound is the first-line imaging modality for evaluation of renal transplants. We use grayscale, first of all, to look at renal parenchymal echogenicity. We look at the collecting systems and ureters for hydronephrosis to diagnose obstruction. We look for perirenal fluid collections. We use Doppler to look for flow in the renal artery and the renal vein to look for obstruction. Then we look for peripheral resistance in the renal artery bed as a marker of graft dysfunction. And the metric we most commonly use is the resistive index, or RI, which I will refer to in the rest of my presentation. And we use color and power Doppler to assess renal perfusion. So, Doppler assessment of renal transplants. The resistive index, or RI, is the main parameter for peripheral resistance. We use the acceleration index and the acceleration at time obtained from the main, segmental, and arcuate renal arteries. We obtain angle-corrected velocities from the main renal artery and iliac artery, and if main renal vein stenosis is suspected, we obtain angle-corrected velocities from the main renal vein. And most but not all of the problems related to vascular obstruction occur at the anastomotic site. So that's where you want to focus your attention. So a couple of words about the resistive index. The resistive index is a measurement of peripheral resistance within the renal artery bed. It is independent of angle correction. And high resistance indicates renal dysfunction. A normal resistive index is less than 0.7. Between 0.7 and 0.8, it's indeterminate. And above 0.8, it's abnormal. These are not hard and fast numbers. This is a kind of soft categorization. And it's particularly important to observe the trend in the resistive index on serial scans rather than rely on a single measurement. You should see if the RIs are rising on serial measurements or falling. And the most severe form of elevated peripheral resistance is when the diastolic flow is reversed, as on this image here, where you have forward flow in systole but reversal of flow in diastole. This indicates very high resistance and is a sign of severe abnormality. The color Doppler analog of this is what I call a red-blue flashing. Basically, you see the renal artery in red during systole and blue in diastole, and it flashes red, blue, red, blue. Power Doppler allows visualization of smaller arterial branches and parenchyma, and you can, to a certain extent, assess cortical perfusion. Here you see a normal renal transplant colored with beautiful colorization with the Power Doppler, and you can see flow all the way to the edge of the cortex. This is a brief review of the complications of renal transplantation. Vascular complications can be in the artery or the vein, and you can have false aneurysms and arteriovenous fistulae. You can get ureteric obstruction, fluid collections, extrinsic compression. So these categories overlap to a certain extent. So extrinsic compression can lead to arterial and venous obstruction. There's an entity known as compartment syndrome, which I'm going to talk about a little bit. And then there's renal parenchymal disease, which is a catch-all phrase for rejection and acute tubular necrosis and immunosuppressive drug toxicity. And then finally, we'll talk briefly about transplant-related malignancy. So the vascular complications, starting in the renal artery, you can get a stenosis in the renal artery. That usually occurs at the anastomosis, and that presents on Doppler as elevated velocities at the site of narrowing and tardus parvus waveforms distal to the point of stenosis. A renal artery kink is a folding or twisting of the vascular pedicle due to malposition or lack of space. So if the renal artery is a little bit tortuous and the surgeon packs it into a kind of small space, it might kink. And this is a form of compartment syndrome. It usually presents immediately post-surgery and has the same sonographic signs in terms of Doppler as RAS. It's easily correctable, so it's important for us to pick it up. The renal artery can thrombose. The renal vein can be thrombosed and also stenose, and you can get AV fistulae and false aneurysms. So renal artery stenosis in the transplants. It is less common with cadaveric allografts because a cuff of aorta is harvested during a cadaveric transplant, allowing larger caliber anastomosis. Doppler ultrasound is essentially a kind of screening tool because it's highly sensitive for renal artery stenosis, but it tends to be less specific. So if you get a positive Doppler ultrasound finding, then the patient will proceed to CTA or MRA. So the Doppler criteria that are out there are peak systolic velocity of greater than 3 meters per second, renal artery to iliac artery peak systolic velocity ratio of 1.8 to 1, greater than 1.8 to 1, and tardus parvus waveform with an acceleration time of greater than 0.1 seconds. There is some early data out there to indicate that contrast ultrasound may be as sensitive as Doppler, but with higher specificity, and we're probably going to see a lot more of that in the years to come. So here is an example of renal artery stenosis. Here we have the Doppler cursor at the anastomotic site, and we see a very high peak velocity of 7.7 meters per second and a very turbulent waveform. This is the same patient, and now we have our Doppler spectrum from the intrarenal arteries, and this is the classic tardus parvus waveform with a slow rising early systolic spectrum. And this is another patient showing how the tardus parvus waveform can change or improve after treatment. So here's a patient with renal artery stenosis on the left. This is the intrarenal artery waveform showing tardus parvus. The same patient after successful angioplasty, and the tardus parvus has gone away. You got a nice sharp upstroke in early systole. Renal vein thrombosis presents with the following signs. The kidney may be enlarged. You may get reversal of diastolic flow in the renal artery, and you may get absent or monophasic flow in the renal vein. In the example I have here, you see the cursor and Doppler cursor is on the renal artery, and you have reversal of flow in diastole, very high peripheral resistance. And the arrow here is pointing at the thrombosed renal vein, which is this hypoechoic structure over here with clot inside it. Renal vein stenosis presents with elevated velocities, and in this case we see a stenosis at the renal vein IVC anastomosis, and we have a peak velocity here of 2.1 meters per second. You may also see elevated RIs within the renal artery caused by the outflow obstruction here. There aren't any precise figures for renal vein stenosis as there are for a diagnosis of renal artery stenosis, because it's a relatively rare entity, but it's something you want to look at if you have someone who has a very high RI with no visible cause, and you see on color Doppler an apparent focus of elevated velocity in the main renal vein at the point of anastomosis. Infarcts in the transplant kidney may show up as filling defects on power Doppler. This is a case here of an infarction which shows up as a wedge-shaped filling defect on this power Doppler image. Power Doppler is more sensitive than color Doppler for low flow states, but generally speaking, we are not that good at picking up infarcts with our standard ultrasound techniques, although contrast may change that in the future. False aneurysms and AV fistulae. Now, I've put them together because they have some features in common, although they are quite separate entities in terms of their flow dynamics. First, they're most commonly secondary to transplant biopsy, although they can be a surgical complication. You can get this multicolored or mosaic appearance where you have red, blue, green, yellow, a kind of red, blue, green, yellow blob in the area of the aneurysm or AV fistula. This is caused by turbulence. This is the color analog of spectral broadening. And it may be difficult to differentiate a false aneurysm from an AV fistula. They may be difficult to distinguish from each other if they are small. So this is an example of a false aneurysm, and this is a particularly dangerous one because it is outside the kidney. So here is the transplant kidney, and we see a cystic area on the grayscale outside the kidney, and when we turn on the color Doppler, this is the renal artery heading into the hilum, and we see the classic yin-yang waveform filling the cystic area here, and this is a saccular aneurysm of the renal artery. This one was a surgical complication, not post-biopsy, and this kind of aneurysm is more like, this kind of post-surgical false aneurysm is more likely to rupture because it's unlike the false aneurysms that occur inside the kidney as a result of biopsy, there's no renal parenchyma to buffer it. This is a post-renal biopsy arteriovenous fistula. These are very common in that they occur in 10% of biopsies. The Doppler findings are focal high velocity, low resistance, and turbulent flow. And on color Doppler, you may get the tissue reverberation artifact. That's something that Dr. Kluwer mentioned during his talk. Basically, you get a false Doppler signal due to tissue motion from the adjacent turbulent flow. So here you have the mosaic pattern. That multicolored area represents the AVF, and you get all this false color, which is the tissue reverberation artifact around the AVF. And you may see arterial waveforms in the renal vein. And in this case, we see a turbulent Doppler spectrum. No treatment is required if the patient is asymptomatic, but embolization may be necessary if there is hematuria or renal failure. Here is another example of an arteriovenous fistula, and this patient, here we have the Doppler spectrum on the renal artery. You can see very high velocities in that renal artery branch, 6 meters per second, spectral broadening, and very high flow during diastole. Ureteric obstruction in a transplant has multiple causes, but it most commonly occurs in the distal ureter at the anastomotic site due to ischemia or fibrosis. It can be caused by external compression from fluid collections or hematomas, from kinking, fungus balls, papillae, or calculi, and there's an increased incidence of calculi in transplants. Hydronephrosis is not always synonymous with obstruction because hydronephrosis due to reflux from a full bladder is commoner in transplants than in native kidneys because the UVJ valve doesn't exist to the extent that it does in a native kidney and ureter. So hydronephrosis does not always imply obstruction. One of the complications of ureteric obstruction at the anastomosis is that it can lead to leak at the anastomosis and a urinoma. So here we have a transplant kidney with hydronephrosis and a dilated ureter down to the level of the anastomosis where there is a stricture, and here is the bladder here. So I'm just going to briefly cover the causes of elevated resistive indices or elevated peripheral resistance inside the transplant kidney. You can put them in two broad categories. There's parenchymal disease, which is rejection, ATN, immunosuppressive drug toxicity, and pyelonephritis. And the take-home point here is that ultrasound cannot distinguish between these, generally speaking, between these entities. Then there are the morphological causes: renal vein thrombosis, ureteric obstruction, extrinsic compression due to hematoma or compartment syndrome. And what ultrasound can do is it can distinguish a morphological cause from the parenchymal causes. Renal transplant compartment syndrome is something that's not well recognized in many places, but it is now not well seen in many places, but it is a recognized entity, and it is defined as graft failure from extrinsic compression due to confined space at the transplant site. Basically, the kidney is too big for the space that the transplant surgeon is trying to fit it into, so he packs it in, and the kidney is under pressure, and it usually presents immediately post-op. And it is defined as pressure of greater than 20 millimeters of mercury on the transplant kidney. The Doppler findings are variable. It depends on which part of the kidney and the vessels is being pressured the most. So if the entire kidney is being globally pressed, you might get elevated resistive indices because of increased resistance to flow. If the renal artery is being squeezed and kinked, you might get focal narrowing in the renal artery and elevated velocities, as I described earlier. You generally get reduced renal vein velocities. So this is now becoming more and more well recognized, and in fact, there's actually a society dedicated to this entity of abdominal compartment syndrome. It's called the World Society of Abdominal Compartment Syndrome, and they actually have ambassadors to go around the world and spread the gospel about ACS. So I thought if I wasn't a radiologist, I might like to be an ambassador and go to a party and introduce myself as the ambassador for the World Abdominal Compartment Society. So it is a very well recognized entity, and they have a convention. Next one is in Ghent in Belgium. Okay, so how does it look? Well, if the kidney is being compressed, you're going to get elevated RIs. But when you turn on the power Doppler, you should look for something like this. So here's a patient with an RI of 1.0 because the kidney is being squeezed. And on power Doppler, you can see that the orange color does not extend all the way to the capsule, unlike in this patient here, where the RI is normal. And this is a sign usually that you are dealing with a situation of elevated peripheral resistance, and that prevents the color from the power Doppler from going all the way to the edge. And this, of course, an extreme case when the artery is completely occluded and you have no power Doppler signal at all. Here's another type of, another variation of compression, if you like. This is a subcapsular hematoma compressing the kidney. Here is the transplant kidney here is kind of bowed in a kind of arch-like manner. Here's the collecting system all collapsed, and it is caused by this lenticular fluid collection, which has a fluid level. It's actually a hematoma that has partly liquefied, and when we put the Doppler on the renal artery, we see reversal of diastolic flow in the renal artery due to renal compression. And this is called a page kidney because this is a subcapsular hematoma. It's pressing on the kidney, and it is causing high resistance to flow within the renal artery. Okay, so I'm going to just briefly cover renal parenchymal disease. Acute rejection. This manifests as a rapid rise in creatinine, greater than 25% over 24 or 48 hours, decreased urine output, and definitive diagnosis requires biopsy. So there are some features on grayscale ultrasound. You might see features of renal edema. The kidney may be big. You can get thickening of the collecting system, the thickening of the urothelium, and you get thinning of the renal sinus fat. The pyramids may become more prominent, and you may see increased or decreased cortical echogenicity. The resistive index can go up, but remember that rejection can be present with normal RIs. So this is a patient during his rejection phase and after he had his treatment. So note the kidney when it was being rejected was much bigger. There's loss of the corticomedullary differentiation. It's much more echogenic. The urothelium is thickened, and this is how he looked after he had been given anti-rejection medication. So this is a sign of renal edema. This is the thickening of the wall of the renal pelvis. Normally it's pencil thin. Here you can see it's at least several millimeters, and this is just a feature of the global edema that you're seeing in the kidney that extending into the collecting system. Chronic rejection is defined as slow deterioration occurring over months or years. And this is something we cannot diagnose generally on ultrasound. There are usually no morphological changes, and resistive indices may be normal. Acute tubular necrosis is characterized by an acute decrease in glomerular filtration rate, an increase in creatinine and anuria that is maintained for several days, followed by spontaneous recovery. It occurs in the immediate post-transplant period. It almost always occurs in cadaver transplants and is directly related to the length of graft ischemia period prior to the transplant. It does not affect ultimate graft survival. On ultrasound, the kidney may appear normal or may demonstrate hyperechoic renal cortex with elevated RIs. So this is an example of acute tubular necrosis, and the only thing that we could see that was the abnormally elevated RI with reversal of flow in late diastole. So the renal transplant patients get drugs to prevent rejection, but these immunosuppressive drugs themselves are nephrotoxic, and these drugs are now the calcineurin inhibitors, of which the most commonly used are cyclosporine and tacrolimus. So although they have markedly improved allograft survival by reducing rejection, they have a nephrotoxic effect that appears as an arteriopathy and a microangiopathy. The nephrotoxic effect occurs even when the serum concentration is within the therapeutic range, and the nephrotoxicity may be acute, subacute, or chronic. Acute and subacute are dose-related, while chronic nephrotoxicity occurs 60 days after the transplant and is not dose-related. On ultrasound, we see echogenically normal kidneys with elevated RIs, and the definitive diagnosis requires renal biopsy. Peritransplant fluid collections can be classified as lymphoceles, which is a leak of lymph, urinoma, hematoma, or abscess. So this is an example of a perinephric fluid collection anterior to the transplant. Hematomas usually occur immediately after surgery or biopsy, and they look like hematomas everywhere, heterogeneous, partly solid, partly cystic masses. Here we see a large perinephric hematoma anterior to the transplant. Lymphoceles are the commonest fluid collection. They occur at a different on a different time scale. They classically happen 4 to 6 weeks after transplantation. They may be asymptomatic or compress or obstruct the kidney and may contain debris or septations on ultrasound. They frequently recur after percutaneous aspiration, and they may require surgery because of this recurrence. Urinomas tend to occur in the early post-transplant period. They are caused, as I mentioned earlier, by a leak at the ureteric anastomosis, and they are associated with ureteric obstruction. They are usually transonic, but may contain debris, and they tend to grow because as the urine continues to leak out. Abscesses are infections of pre-existing hematomas, lymphoceles, or urinomas. They usually contain internal echoes, and the appearance of debris or gas in a pre-existing echo-free collection is suspicious for abscess. So remember, all these patients are immune suppressed, so they may not show classical signs of fever or pain, so you have to be on the watch out. This is an example of a renal abscess. We see a hypoechoic area inside the lower pole of this transplant kidney, and it's got internal echoes, and that this has no internal flow on Doppler, so it's not a mass. And this is the MRI showing a lot of enhancement and internal septations, and this is turned out to be an abscess in the inferior pole of the transplant kidney. I'm just going to briefly mention transplant-related malignancy. It's all in your handout here, but patients who have transplants have a much higher incidence of RCC, 6 times higher. It's mainly in the native kidney. They can also get transitional cell carcinomas and non-Hodgkin's and post-transplant lymphoproliferative disease, which is a B-cell lymphoma associated with the Epstein-Barr virus. This usually occurs outside the transplant. They may get massive adenopathy, and you may see hypoechoic masses. They also get increased incidence of sarcoma, Kaposi sarcoma, and skin cancer. This is an RCC appearing inside a native kidney. The kidney itself is markedly echogenic and shrunken, but so the RCC stands out quite well. I'm going to spend just a minute talking about ultrasound guidance for renal transplant biopsy, which is something that most transplant centers offer to their nephrologists. We try and biopsy the upper or the lower pole, and we find a tract where there's no bowel or major vessels in the needle path. So this is the biopsy guide here, these two dotted lines, and the needle will traverse between them. We use spring-loaded automated biopsy needles, and the trajectory should pass through the cortex like this and avoid the hilum. So we tell them, avoid the white stuff in the middle of the kidney. You have to explain that to the nephrologist. The complication rate is low with reported graft loss rate of 0.4 to 1%. This is how not to do a renal biopsy. You can see that the nephrologist needle has gone right into the white area, which is what we tell them not to do. And this is what you don't want to see. And this, you try not to hit the panic button when you see this kind of thing, but you can see an active extravasation from the lower pole. And here are some of the other things that will happen when your biopsies bleed. You can get a perinephric hematoma here. You can get rapid appearance of hydronephrosis. That's always a bad sign due to clot inside the collecting system, and you look in the bladder and there's huge clot inside the bladder. So in conclusion, Doppler ultrasound is the first-line imaging modality for evaluating renal transplants. Doppler can diagnose renal artery and vein obstruction. Elevated resistive indices are nonspecific and can be caused by parenchymal disease and morphological causes. Definitive diagnosis of renal transplant disease requires biopsy. Rejection can be present with normal resistive indices. Thank you.
So the following is just a brief overview that will go through renal transplants, focusing on their sonographic evaluation, and will hopefully give you a framework from which you can then apply these concepts to real-life cases that you'll be seeing during your service. So let's start off by talking about the indications for renal transplants. And as it turns out, renal transplants are really the gold standard for anybody with end-stage renal disease for any reason. Right? You want to try to get to the point where they can get a renal transplant. And you can end up getting these renal transplants really of one of two ways. They can either be from a donor who is living, or a donor who is deceased. And in terms of the living donors, they can be related to, they can be non-related to, and the increase in life expectancy from living donors is about 20 years, and from deceased donors about 10 years. So ideally you'd get a living donor, but even a deceased donor really gives you a significant amount of increased life expectancy for patients with end-stage renal disease. We typically like to place these renal transplants in the right lower quadrant whenever possible. Turns out in the left lower quadrant, you have the sigmoid colon that gets in the way, so it's maybe a little bit easier to place them in the right lower quadrant. And this is what it kind of looks like, at least a schematic of it. You can see the kidney placed over here, and we make 3 anastomoses. We make an anastomosis between the donor's renal artery over here and the recipient's external iliac artery. We make another anastomosis between the donor's renal vein and the recipient's external iliac vein. We'll make a third anastomosis between the donor's ureter and the recipient's bladder over here. And some of the parameters to at least think about when it comes to measuring some of these velocities is that the peak systolic velocity within the right renal artery of a transplanted kidney will be a little bit higher than in a native kidney, and it's in the range of 200 centimeters per second in general. Also, when we do the waveforms within this vessel, we end up seeing a low resistance waveform, so this continuous flow, as you can see here, throughout systole and throughout diastole. And if you were to measure the resistive index, which is defined as the end systolic velocity subtracted by the end diastolic velocity over the end systolic velocity, we end up getting a resistive index of about 0.6 to 0.7, which is what we like for these renal transplants. Now, in terms of complications that we may anticipate post-renal transplants, ultrasound is a great modality, and in fact almost always the first line imaging modality to evaluate these complications. When we think about these complications, I really split them up into 2 broad categories. And the first broad category are non-vascular complications, while the second one, as you can imagine, are vascular complications. So we'll go through these briefly and talk about a little bit what you'd expect to see. First thing I look for non-vascular complications is hydronephrosis. Okay, now, as it turns out, these transplanted kidneys, for a variety of reasons, may have collecting systems that are a little bit more distended than you'd expect in a normal kidney. But when you really start to see the calyces look a whole lot bigger, for example, tracing over this, really start to get big like this, then you can anticipate that there's some degree of hydronephrosis. And understand that that is somewhat of a subjective call. So if you're ever really worried about the presence of hydronephrosis, one quick trick is to measure the resistive index. So get a spectral tracing of a waveform out in the renal parenchyma over here. And if that resistive index is high, it suggests that there's some degree of pressure in this kidney, and that is likely or could be attributed to the hydronephrosis. If we get an RI in that instance of greater than 0.8, that may suggest that the hydronephrosis that we're seeing is quite significant. The second complication that I look for is things like renal infarcts. And one of the images that the sonographer should show you when they present their cases is one image where there is color flow throughout the kidney, so the upper pole, the interpolar region, and the lower pole. And with renal infarcts, as you'd expect, you'll see a pretty nice, well-defined region, such as something like this, where there's absolutely no flow. So if you see that, you want to suspect that there's a renal infarct. There's a whole bunch of causes for it, including segmental thrombi of a vessel, dissection of a vessel, but you certainly want to be able to look for an image where you don't see any focal flow, and that would suggest that there's an infarct over there. The next thing I look for are the presence of masses in the kidney. And these renal transplant patients are at actually an increased risk for things like RCC and a whole bunch of other tumors, including something called post-transplant lymphoproliferative disorder. And for the most part, as you can imagine, what I'd be looking for on my ultrasound are masses. So I want to see if there's any mass within the kidney, a solid mass or a complex cystic mass. With PTLD, it can look a little bit more infiltrative kind of appearance throughout the kidney. So again, it takes only about a few seconds to scan the kidney on grayscale imaging and realize that it's free of masses. But certainly if you see one, it's something that should be commented on and something that should be biopsied. The third thing I look for is around the kidney. So I look for collections. And for the most part, we can't really tell apart any collection around the kidney. Okay, you can see a collection surrounding the kidney over here and over here. And ultrasound's very good for either detecting the collection and following it over a period of time to see if it's getting bigger or smaller. It's also very good to guide imaging-guided biopsy if you want to aspirate it. And some of the collections that we anticipate in these patients include things like hematomas, which typically have fluid hematocrit levels. You can also see urinomas at times, which are typically seen near the bladder and ureteral anastomosis. You can get things like lymphoceles, which are collections seen about 4 to 8 weeks after surgery. And you can also see, of course, abscesses. So if you see any focus of air within these collections, it's either an abscess or superimposed collection, hematoma, urinoma, or lymphocele. One of the other non-vascular complications that is relatively common is this idea of acute tubular necrosis. Where this happens is when the recipient gets a kidney that is already damaged to begin with. So we end up seeing a little bit more with deceased donors whose kidneys have been damaged for whatever reason. Perhaps they were in a code situation and the kidney did not get appropriate perfusion for a period of time and then was then donated to somebody else. And so it takes a little bit of time for them to perk up. And the imaging finding of acute tubular necrosis is essentially decreased diastolic flow with elevated resistive indices. And we're talking about the realm of 0.8 and above that, and it's typically seen in the first 3 days of transplant. So if you see that finding in the first 3 days, it's likely going to be acute tubular necrosis. And in terms of the spectral waveform, if this is what the normal one looks like over here, the spectral tracing for something like acute tubular necrosis will have good systolic flow and no diastolic flow. So if you see the resistive index, which is defined as the end systolic velocity minus the end diastolic velocity divided by the end systolic velocity, this value will be close to 0. So you essentially get the end systolic velocity divided by itself and a number that'll be anywhere from 0.8 to 1.0 itself. And finally, in terms of a non-vascular complication is rejection. And rejection happens in a couple of stages. And from an imaging perspective, the two stages that we can detect are acute rejection and chronic rejection. And acute rejection typically occurs within the first 3 weeks that the patient has the transplant, while chronic rejection is something that occurs in the first 3 months. And so one way I like to remember it is that ATN is in the first 3 days, rejection acutely is in the first 3 weeks, while chronic is in the first 3 months. And the imaging findings of a rejection will be somewhat identical to ATN, where you get elevated resistive indices as well as low diastolic flow. So now let's shift gears a little bit and talk about the vascular complications of renal transplants. And one way to think about it is just to think about the anatomy, right? So we have a renal artery, we have a renal vein, and either of those can get completely obliterated or thrombose, or can narrow or get stenosis. So if we first start talking about the renal artery, the first complication we can think about is renal artery thrombosis. And as you can imagine, in renal artery thrombosis, when you evaluate the renal artery, you see absolutely no flow. So when you look at it over here, it'll be completely obliterated. Patients may present with anuria and pain over the kidney, and that really needs to be urgently treated in order to salvage that transplanted kidney. The next complication is renal artery stenosis. Now, renal artery stenosis has a bunch of imaging findings that we need to be aware of. And the idea is that for whatever reason, the renal artery gets narrowed. So for example, we see over here, it's not completely obliterated, but it certainly gets narrowed. And what ends up happening is that right in that location, the peak systolic velocities get really, really elevated. So they get really high over here, suggesting that this is the area of narrowing. When we evaluate the vessels more distal to it, so in this location, and especially within the renal parenchyma more distally, what we end up seeing is something called a tardus parvis waveform. So again, if we go back to what our normal waveform looks over here, the tardus parvis waveform will be a little bit different. In that, we'll get peak systolic velocities that are lower than what we'd expect, and the time to reach those peak systolic velocities is also quite delayed. So instead of getting a nice sharp systolic upstroke with good flow throughout diastole, you get more of a delayed upstroke with decreased peak systolic velocities. So you can compare that, which is a tardus parvis waveform, with a normal waveform, which should be much like this. All right, so these findings suggest that there's a renal artery stenosis, and this tardus parvis waveform is always seen distal to the region of stenosis. Let's move on to the renal vein. So again, the renal vein can thrombose or stenose. Well, let's talk about renal vein thrombosis. And as you can imagine, with renal vein thrombosis, you'll see no flow in that renal vein. And what's also interesting is what you end up seeing if you evaluate the renal artery in this instance is reverse diastolic flow. So again, if we go back to what our end systolic and end diastolic velocities look like, in renal vein thrombosis, if it's quite severe and complete, you'll end up seeing forward flow in systole, and in diastole, you'll end up seeing reverse flow, much like this. So when you see waveforms like that with an obliterated renal vein, it suggests that there is renal vein thrombosis. And again, as with the renal artery, you can get renal vein thrombosis, renal vein stenosis, and it turns out there's not much good criteria for this, and you end up seeing a narrowing of the renal vein, and if you use a ratio of about 3 to 1 in terms of the elevation in velocities across this narrowing, it is predictive of potential renal vein stenosis. But again, this is an extremely uncommon thing to see. So finally, let's end with two other complications that I lump into the vascular complication, but strictly speaking, they are really seen in the context of post-biopsy, and those complications are pseudoaneurysm and arteriovenous fistulas. And the idea of pseudoaneurysm is that the people biopsy and it's done quite close to the renal hilum, where you have a bunch of vessels over there, and you end up getting a collection like this that is communicating with the vessels, and a portion of it has arterial flow flowing into it, and a portion of it has flow going out of it. So what it ends up looking like is something called a yin-yang. So it's the yin-yang sign of a renal artery pseudoaneurysm, and there's a variety of treatments that can be associated with it depending on the sign. So finally, let's end with arteriovenous fistulas, and these are little tiny communications you can see between the renal arteries and veins, again seen typically post-biopsy, and these can be difficult to detect sometimes because of their small size, but you end up really seeing a triad of findings that make you suspicious for it. Within the renal artery feeding this fistula, you'll see increased diastolic flow. That's because the renal artery is communicating with the veins, which is a low resistive bed. Within the actual fistula itself, you'll see a lot of aleasing or turbulent flow with very high velocities. And within the renal vein that is draining this fistula, you're going to see pulsatile flow. So if you see these triad of findings in the context of a recent biopsy, it's highly suspicious for a arteriovenous fistula. So there you go. That's a little bit of a summary for renal transplants and their evaluation. At least it gives you a framework for which to approach any potential case that you may end up seeing.
So, we mentioned Doppler before, and just, a few words about Christian Doppler. He's from Salzburg, Germany. He died in 1853. Interestingly, he was supposed to be a stonemason, but didn't quite have the strength for that. And so he studied mathematics and astronomy, became professor of physics at the University of Vienna, where he formulated the Doppler effect, which, as you know, has lots of different applications these days, including GPS, weather forecasting, and radar guns. He read his paper in 1842 concerning the colored light of double stars. And every time I see that, it just sort of reminds me of a Pink Floyd song or an album. It just, it's so psychedelic. And he described fluctuations in the frequency of sound or light when there is motion between the source and the eye or ear of the receiver, which is the basis of flow and measurement. And I can't imagine he has any idea how we use that these days. It would definitely blow his mind. So let's go ahead and talk about the renal and mesenteric evaluation. I will speak first in general terms about how to optimize the exam, and then I will go into the specifics for each exam, and then we'll do the same questions at the end of the presentation. So what I'm going to do is talk about optimization. We'll talk about criteria and protocols, and hopefully that will improve the quality in the interpretation of the studies that you do. So, of course, these are challenging studies, really more challenging, I guess, for the sonographer, because they're the ones who have to present that data to you and make sure that it's in a format that you can interpret. And so, obviously, using the best equipment with harmonic imaging, I find very, very important to improve the quality of the study. Of course, the other key element here is getting the right views, and I call these money views, and I show these to my sonographers right away when they do these studies. Once they're able to get these views, obtaining the data is relatively straightforward. They know to change the position of the patient from one decubitus position to the other, sometimes even going coronal for the renal arteries to get those views. And you can see here's a look at the right renal artery. And the way we get the right renal artery in its entirety is by scanning through the liver, turning the patient up. And you can see the renal artery in this patient in its entirety. And so it's just a matter of dragging the sample volume from the origin, from the aorta, into the hilum of the kidney to get all the information on that side. Of course, if you optimize the color Doppler and you see a nice homogeneous pattern like that, you know that there's no stenosis. But that requires adjusting your color gain or your PRF so that you would see a stenosis. And here again, renal vein, renal artery, very well seen. For the left kidney, again, it's essentially just turning the patient left side up and using the kidney as your window, and as I'll show you in a second, able to see it extremely well. For the mesenteric arteries, a little more challenging because of the fact that you tend to go midline. You can adjust the perspective and where you try to find the abdominal aorta and the branches coming off, but we tend to use a longitudinal approach for those. And that requires having less bowel gas, which is why we fast the patient prior to the study. So again, as I mentioned to you, adjusting the color gain, the PRF, and the wall filter are really key. Adjusting it for that patient, very important. Here's another look at the right renal artery. Again, very well seen. No aliasing, no flow disturbance, so we have a really good idea that there's no underlying stenosis even before we get our Doppler velocity measurements. Here we also notice in this particular case there's early branching of the renal artery. Nice to see the anomalies right away. By adjusting your PRF and looking for flow disturbances, you're able to easily see aliasing when it occurs. And here's an example here of focal aliasing at the origin of the left renal artery, which tells you there is likely a stenosis there, particularly when it's paired with a color-Bruy artifact. Other things to optimize, making sure the sample volume is relatively small. Okay, and here we're looking at the sample volume in the mesenteric artery, again, small, so it's just in the lumen. You're not getting conflicting signals, overlapping waveforms. Angle correction, always have to make sure it's 60 degrees or less. And make sure when you record those waveforms that you record the whole waveform and you're not aliasing everything. You want to increase your PRF so you can include the waveform on your tracing. Normal waveforms. Okay, obviously, whenever we talk about a different application, most important is recognizing normal. We talked about carotids before. Have to recognize normal velocities, need to know normal waveform shapes. That's how you determine pathology. Even if they miss the lesion, you can sometimes infer the pathology because the waveforms have changed. They're no longer normal. When we talk about the celiac, the renal arteries, they provide blood flow to those high metabolic organs. The liver, the spleen, like the brain, demand continuous forward flow throughout the cardiac cycle, so you expect to see lots of forward diastolic flow. No flow reversal. When we talked about the carotid before, lots of forward diastolic flow. There should always be forward diastolic flow. Same with the celiac, same with the renal and the proximal aorta that provides blood flow to those vessels. And we contrast that with the mesenteric arteries, the SMA and the IMA, which are high resistance in the fasting state. So we see little diastolic flow and sometimes a little bit of flow reversal on those waveforms. And that's exactly what we see in the distal aorta, because distal aorta is providing blood flow to the extremities. And as we'll see in some of our other cases today, high resistance flow, triphasic waveforms are the normal flow pattern in the peripheral arteries. So it doesn't matter what type of Doppler study that we're doing, the approach remains the same. When we talked about the carotids earlier, we talked about looking for plaque, looking at the color pattern, looking at velocities and waveforms. It's really the same thing. Optimizing the image so you can see the plaque allows you to tell right up front whether you expect that there's going to be a stenosis or not. A lot of plaque in the aorta, particularly near the ostia of the vessels, really clues you in that there's probably some disease there. And then it's just a matter of getting the rest of the information, putting your clues you in that there's probably some disease there. And then it's just a matter of getting the rest of the information, putting it on your color, looking for the flow disturbances, and sampling where you see abnormal flow. Some quick examples here, looking at the renal artery, seeing plaque. Even here, it's relatively hypoechoic plaque, good resolution. Seeing the plaque, seeing the narrowing, even before you put the color on, allows you to make a determination there's going to be something there. And also looking for other things, looking for evidence of dissection, looking for a flap, looking for fluid around the aorta, looking for other things that are abnormal, like an aneurysm. All important parts of the exam. Turn the color on. And here in this case here, we can see that there's stenosis in the celiac artery, there's narrowing, there's aliasing. Like I said, with a high-grade stenosis, you'll see color-Bruy artifact, and it allows you to be fairly certain you have an abnormality, usually flow-reducing lesion. If it's occluded, you optimize it, look for the absence of flow, and you can also look for collateral vessels, which confirms to you, again, that there's a problem there. When you see the collaterals and no flow in the main vessel, clearly then that means that it's occluded. The criteria, just like with the carotid, we say the main velocity criterion, the peak systolic velocity, is where we start. But we augment that by looking at the ratio and by looking at the waveforms. And I find that by combining those, you really have a high accuracy. It's the same principle. Don't rely just on the numbers. Put the whole picture together. You've looked at the grayscale, you've looked at the color. Now you have these other features that will confirm for you that it's a significant stenosis. By combining that information, you're going to have a very high accuracy. In general, for the celiac, for the IMA, for the renal, we use a velocity cutoff of 200 centimeters per second. The only exception is the SMA, where 275 works better. Bear in mind, as we said before, velocity cutoffs don't work for all patients, particularly very old patients or very young patients. As we said before, younger patients typically have normally high velocities that may be surpassing the threshold. Very old patients with cardiac disease may have relatively low velocities, which may not make the cutoff for you to decide it's a significant lesion. Which is why we like to incorporate velocity ratios. When you have very high flow or very low flow, the ratios can help you in those situations. And when that ratio is greater than 3 to 1 or 4 to 1, then you can now start to be very suspicious it's flow reducing. And the icing on the cake are these post-stenotic waveforms. This shaggy waveform, that sort of picket fence appearance that you get in the post-stenotic area, is the confirmation that it's flow reducing. We see these distal to just about every significant stenosis. We say it's bidirectional because, as I mentioned before, when those red blood cells come spilling out of the stenosis, they're moving at different velocities in different directions, giving you that chaotic appearance. So, some people call it shaggy picket fence. My friends at Cleveland Clinic call it Bart Simpson hair. It all looks the same. And in general, they tend to have very low velocities because as they shoot out, not only are they losing energy, they're losing pressure and they're losing velocity. So you can go from a very high velocity waveform in a stenosis to this turbulent low velocity waveform in the post-stenotic space. Now, we also mentioned tardus parvus waveforms, and that's that slow rise to systole that we see in the post-stenotic area. Now, this is typically a little bit further down from that post-stenotic signal. The post-stenotic signal is that shaggy one, and if you go further downstream, then you start to see that the red blood cells start to reform that flow pattern, but it has that slow rise to systole. And you learn to recognize that. You can do that by calculating acceleration time or acceleration index. But in general, I just have my sonographers and my docs look at the waveforms. I want them to look for that TP shape, and when they see that, then they know that it's a tardus parvus waveform. They can calculate it, but I don't find that that's necessarily reproducible, and I want to train their eyes to look for those waveforms. Here I borrowed from an article from Ultrasound Clinics, and you can see that with increasing severity of disease, you can see that there's prolongation of that delay. So the first waveform is the normal one, the rapid systolic upstroke, perpendicular to the baseline, and as you get with increasing stenosis, you start to see delay until it's finally completely rounded with a very tight stenosis. Okay, and here's just another example. Here's a patient with a celiac stenosis. The velocity is very high in the stenosis, and as I move it just a couple of millimeters downstream, you can see now it's a disorganized flow pattern. The velocities have come right down. I've got a bidirectional signal with a shaggy pattern. Always look for that. Always make sure your sonographers continue to move the sample volume, because if you get a borderline velocity, say you're looking at a celiac and they give you 210, it's right at the borderline. So you're not going to be sure. So you say, well, what's the velocity in the aorta? So you can compare it. Well, if that's 180, that's probably not a stenosis. But if they give you this really abnormal post-stenotic waveform, then you say, oh, that probably is significant. Because look at the change in the flow pattern across that stenosis. That's the key. So let's start out by talking about the mesenterics. Now, patients who present to the ED with severe pain, where you're concerned about acute occlusion, they're going to go for CT angiography, typically in the ED. But it's the patients that we see that have chronic pain, that's gone through multiple tests. They've had endoscopy, they've had CT scan, there's no diagnosis. They may even give you a history of not enjoying food or weight loss. Then those are the patients that have come to you for the mesenteric exam. And, some will give you the classic history, some will just give you this history of chronic pain. Now, intestinal ischemia, can have different etiologies. It could be related to arterial disease, it could be related to venous thrombosis, or just a low flow state. Now, obviously, if the patient's in the unit and, they're not doing well and they have abdominal pain, obviously you worry about shock, you worry about sepsis. But typically what we're looking for is evidence of arterial stenosis, occlusion, or venous thrombosis, and we can do this on our sonographic exams. And in fact, the ACR appropriate criteria puts ultrasound right below CT angiography for these diagnoses, on par with arteriography and MRA. Now, grayscale ultrasound is going to be nonspecific. You may see signs of bowel abnormalities. I think it's always important to look at the bowel. Is the bowel dilated? Is the bowel thick-walled? There's a lot of information that you can get just by looking at the bowel, even before you hit the color button. Looking for ascites. But you can improve and fine-tune your differential diagnosis by adding the Doppler, because if it's inflammatory bowel disease, if it's Crohn's disease, you'll see not only bowel thickening, but increased blood flow in the wall. If it's related to ischemia, you typically have decreased flow in a thick wall of the bowel. So there's a lot of ways to utilize it in these cases. For the mesenteric artery evaluation, we're typically going to look for abnormalities in blood flow in all three vessels, the celiac, the SMA, the IMA, typically dragging the sample volume from the aorta into the proximal portions of the vessels that we see. For the diagnosis of chronic mesenteric ischemia, we need to see abnormalities in at least two of the three vessels. One vessel usually is enough because there's so much collateral circulation that the patient compensates by having disease in only one vessel. So you need to see involvement in at least two of the three vessels to call it chronic mesenteric ischemia. Our protocol, again, we start out with the abdominal aorta, look for evidence of aneurysm, look for evidence of plaque, and then we start to take samples from the celiac, SMA, and IMA. Again, here are the normal waveforms. We mentioned before the aorta is going to be relatively low resistance at the origin of the celiac because it's supplying blood flow to the liver and the spleen. The celiac will also have low resistance flow pattern, like the internal carotid, but the SMA is going to be very high resistance in the fasting state. If you have a low resistance SMA, that means there's either a significant abnormality at the origin of the vessel, or the patient has really cheated and had breakfast or lunch before coming to see you, which is usually the case. If you see a very low resistance pattern, you have to really push them. Did you really fast? And many times they'll say, well, I only had coffee and toast today. I didn't have my cereal and my waffles for breakfast. So to them, that's fasting, but that's not the case. Normal velocity measurements, okay? So we said for the ICA, it's 60 to 100 centimeters per second, and we tend to be in the same range, maybe a little bit higher for the mesenteric artery. So the celiac is about 100 centimeters per second, a little bit higher for the SMA and the IMA, which is why we have that higher cutoff of 275 for the SMA. So for a flow-reducing lesion, we say the velocity cutoffs are 200 for the celiac and the IMA, 275 from the SMA. That comes from the work that was done long ago by Greg Mineta, from the University of Oregon, and that work has held up. Now, I did some work looking at the IMA because I felt the IMA was neglected, and yet you can see the IMA. The IMA is not hard to find if you look for it. The way you find the IMA is by going in a transverse plane down from the celiac, and the SMA, and then you see the renals coming off, and if you continue down inferiorly, you'll see the IMA coming off to the left. It's right there. And if there's significant mesenteric disease, the IMA is hypertrophied and even easier to see. And we came up with the velocity cutoff of 200 centimeters per second. So some years ago, we did a Doppler review of 205 patients, trying to see which of the Doppler criteria worked the best in this examination. So we looked at the peak systolic velocity, we looked at the mesenteric aortic ratio, and we looked at the end diastolic velocity, because these are the criteria that are out in the literature. And we found that the best measurement, as we would suspect, just like from our other Doppler studies, is the peak systolic velocity. It performs the best. And that the ratio has a higher specificity, but then it has a sensitivity. So we start out with the velocity, and then we look at some of the other parameters that we talked about. And in terms of diagnosing chronic mesenteric ischemia, the peak systolic velocity performs the best, and we had a 93% accuracy for that diagnosis. So these are the recommended criteria that we use, which we've already mentioned. Look at the velocity, do the ratio in your head, and then look at the waveforms to see if there is a flow-reducing lesion there. And by combining these features, you should have a pretty high accuracy with this diagnosis. Color Doppler will show you the aliasing, the Bruy artifacts. The pulse Doppler will give you the high velocities, abnormal ratio, and the poststenotic turbulence with the tardus parvus waveforms. Here's a 68-year-old presenting with abdominal pain. The celiac has a velocity of 131, so that's in the normal range. The SMA is elevated at 400. And here you can see the Bruy artifact right at the origin of the SMA. And then we go to the IMA. That velocity is also elevated, and you can see here the abnormal flow in the IMA compared to the aorta, which is in the normal range. So you have two-vessel disease. It's classic chronic mesenteric ischemia. Now, there are a number of pitfalls, just like with any study, and I already mentioned the postprandial state. You get higher velocities after patients eat because there's vasodilatation of the vessels to improve digestion. There's increased blood flow to the gut, just as you would expect. So that will increase the velocity, but that's why we have the patients fasting, and it also gives us a better acoustic window. Other things to think about: vessel tortuosity, aneurysmal dilatation, aortic stenosis. These will all be confounding elements. And there's ways to sort through all of these things. The one I want to focus on here is the median arcuate ligament syndrome. I'm sure most of you heard of this before. It's very common, particularly in our younger patients, younger women. This is something that is frequently seen if you look for it. This is caused by a leaflet of the diaphragm that compresses the celiac at expiration. You can see here on the MRA, the indentation that occurs across the top of the celiac near its origin, which obviously will elevate the velocity. But that's only seen in expiration. If you have the patient breathe normally or take in a breath, you see that that velocity is usually relieved and the velocities come back into the normal range. Patients get pain probably not from the decreased flow, but from the nerve compression that occurs from the leaflet. And over time, you can get scarring in that area, and I've actually seen fixed defects in patients with median arcuate ligament, particularly in those older patients. And so going to surgery may not necessarily correct the abnormality. So we see elevated velocities in expiration or at rest, relieved with inspiration. Here's my fish hook appearance of the celiac. You can see it's tugged down, and you can appreciate that in real time. You could see the celiac being tugged down as the patient breathes out. And here's the examples. With expiration, the velocity is 450, which you'd call a stenosis, but have the patient taking a breath, and the velocities come all the way down to 176 centimeters per second. Other things to keep in mind: sometimes you'll just pick up another abnormality. Here's a case of a dissection. I've got a number of dissections in my collection. Most of them incidentally picked up. Now, some of them have had a dissection that was known on a prior CT scan, usually an extension of a thoracic dissection that's moved into the abdomen. And sometimes they're picked up incidentally, as this case was. And here you can clearly see a dissection. Even if, the best way to see the dissection is to turn the color off, and you can see the flap. But if you have the color on already, you can see that there's a double lumen there, and you could see the delayed fill-in of the false lumen in diastole. And here you can see pretty well on the CT scan. You can also evaluate patients post-stent. I find Doppler is the best way to look at renal and mesenteric stents. They're very small. It's very hard to tell on MR, which sometimes has so much artifact, or on CT, the luminal reduction of a stent, whereas we actually can calculate the velocities pre and post-stent. And I'll show you again with renal stents. It's really easy to do if you find the stent. And again, turning the color off, you can see the stent pretty well. And here again, comparing it to the other modalities can be very tough. And we're certainly not sending patients to angiography just to confirm patency of the stent. In my last few minutes, I'll talk a little bit about renal arterial disease. You know, most commonly these patients are atherosclerotic. Every once in a while you get a patient that has another etiology, such as FMD. They can both produce hypertension and ischemic nephropathy. Our protocol, again, we look at the kidneys first, and then we look at the aorta. We get peak systolic velocity measurements from the renal arteries, and then we take waveforms from inside each kidney at the level of the segmental arteries to look at the waveforms. Looking at the kidney first, we look for evidence of atrophy, right? Scarring, look for hydronephrosis, look for stones, and we look for masses. Here's a patient who has a large mass incidentally picked up from the upper pole of the right kidney. And what I do for those is to make sure that it's solid. I put the color on. I could see tumor vascularity within it. If it has high velocity flow, then I get concerned it's renal cell carcinoma, as was the case here, incidentally picked up. We do the direct examination of the renal arteries, getting samples origin, proximal, mid, and distal, making sure angle corrected, easy to review from each side. And then we're going to take waveforms from the segmental branches inside the kidney to look for changes in the waveform that may suggest that there was an occult stenosis that we missed. And sometimes there are duplicated arteries, which you may not have picked up, may have a stenosis. You'll pick it up with the indirect exam. Or even less commonly, you can have a segmental artery stenosis you'll pick up with this test. So again, we talked about this earlier. Turning the patient allows you to get the views that you can see the artery in the vein. Here's the left renal artery scanning through the kidney. That's our window. We see it in its entirety. The criteria for the renal exam, again, peak systolic velocity greater than 200, coupled with an elevated ratio. The renal aortic ratio has been around a long time, pretty well established, greater than 3.5, and looking at the Hyla waveforms. Here's a stenosis in the proximal right renal artery. You can see the aliasing there. The velocity is almost 400. And you can see here the TARDIS waveforms inside the kidney. So this is an easy one because everything's there. Same thing, here's the left renal artery. We see turbulence, aliasing at the origin of the left. The velocity is over 700 centimeters per second, more than 3 times the velocity in the aorta. Classic TARDIS parvis in the left kidney. And if you're not sure, you say, is that really TARDIS parvis? Bring up the right side. And the right side has a perfect upstroke with an early systolic compliance peak. See that little peak there? That you see in normal waveforms. So big difference between the waveforms when you're not sure if there's TARDIS. Here's a patient with FMD, and we see it on this MRA involving the iliacs. You can see the beaded appearance. And we also had FMD in the renal artery. Again, FMD occurs in younger patients. It occurs in the mid and distal portions of the artery, unlike atherosclerosis, which likes the origin. So when you have a younger patient, hypertension, when you want to evaluate for renal vascular disease, you need to make sure you see the whole artery really well. And here we have another example of FMD, mid-portion of the vessel, elevated velocities there. Looking at our series, we again found that, like the carotids, complementary findings, the peak systolic velocity, very sensitive. The ratio, very specific. TARDIS waveforms, not very sensitive. We do not rely on the indirect exam. But when you see them, very specific. So by incorporating this information, you can have pretty high accuracy. People mention the resistive index. I usually don't, because it's like flipping a coin. The resistive index plays no part in trying to determine if the patient has an underlying stenosis. I mentioned about the value in renal stents. Obviously, we can see through the stent, see the high velocities before and after successful stent placement. Also, you can also assess the Hyler waveforms. Here they're abnormal pre-stent, and they go back to a normal appearance after successful stenting. In our study, we came up with a peak systolic velocity of 240 and a ratio of 3.2 to evaluate for in-stent restenosis in our renal arteries. Finally, in my last minute or so, there's lots of other things we see incidentally in the kidneys. We can see aneurysms. We can see occlusion. We can see pseudoaneurysms. And like I mentioned before, we can see tumors. So that's why we include an evaluation of the kidney when we look at the vessels. Here's a patient that has a renal artery occlusion. The kidney is small. It's atrophic. You can see there's barely any parenchyma surrounding the echogenic hilum. We just see a nubbin at the origin of the right renal artery. You don't see the artery at all, correlating very well with the MRA. And you may see flow inside the kidney. But if you do see flow inside a kidney with an occluded artery, it's typically very abnormal, very low velocity, in a very rounded appearance, because this flow is coming in via collaterals. Here's an example of a renal artery aneurysm with the angiographic correlation. Not very common, but you will see them once in a while. They occur more often in women than men, typically middle age. 90% of them are extrarenal. They can be, usually the true aneurysms are related to some connective tissue disease like Ehlers-Danlos, and you typically wait for 2 to 3 centimeters before considering intervention. And one thing we tend to pick up once in a while, patients who present with back pain or hematuria, we may pick up infarcts. Here was a patient that had a history of atrial fibrillation, developed hematuria and pain, and you can see very nicely the wedge-shaped defect in the upper pole on the power Doppler study. Again, a bunch of cases like this. Patient went on to have a CT scan just to confirm the wedge-shaped abnormality on the right side. So I'm going to conclude the presentation by saying we do have a number of different techniques that we can use to evaluate the vessels: ultrasound, CT angio, MR. We've had a very high success rate with ultrasound. The advantage of Doppler is that it determines the hemodynamic significance of a lesion that we see. It's not just a morphologic test. By assessing the poststenotic signals, we can tell that it is indeed flow reducing. We've had the best results by combining both the direct and the indirect examination. And of course, making sure that you train your techs to look for all these things will improve their experience and your diagnostic accuracy.
All right, well, thank you all for coming and staying on this beautiful Hawaiian day when I know you could be outside. I'm going to be talking to you about some of the opportunities and limitations in renal mass imaging. Just to orient you, this is where I come from, NYU. We're all in Hawaii here, but we're in the lower kind of east side here. If you zoom in, you can see we span First Avenue near the East River. Our campus has been broadening recently. We go from about 38th Street down to Bellevue Hospital Center on 25th. And now we're also spreading our tentacles into Brooklyn, Staten Island, and New Jersey. So we've got a large case mix. This is NYU, which was founded in 1837. This is our main site. Our MRIs used to be here until Hurricane Sandy demolished them. Then we put them into trailers and moved them uptown. Bellevue Hospital is the oldest pelvic hospital in the U.S. This is the IMPay glass addition onto Bellevue, which is a beautiful addition that was put on in about 2001. Here is the Center for Biomedical Imaging, which is at 38th Street. You can see there are the trailers here. This is where our 1.5 Teslas were moved after Hurricane Sandy. And this is our home base. Many of you may know Dan Sodikson and Dr. Boda. This is our site. Again, we have the trailers with the 1.5, and then we have 3 Teslas on site. We have a 7 Tesla, and we have a PET MR, as well as a cyclotron, which is going to start producing in a year and a half. So we have extensive MR facilities. Here is Eric Sigmund. He's giving a lot of the sequences and talks this week. He's at the 7 Tesla. This is our current number. I think my chairman keeps telling me I'm underestimating the number of magnets that we have. This is mostly our on-site and Manhattan numbers, but we have many more than this in our off-sites. And so with that introduction, this is our 3 Tesla renal MR protocol. We essentially do have a very long sequence. Many chairmen will not allow you to have such a time-intensive magnet hogging sequence if they're focused on clinical revenue, but we've been pushing the limitations that we can. We do a coronal and an axial haste. We do an axial in and out. Diffusion is mandatory for the kidney. We do it at 0, 400, and 800, which is pretty much the standard based on the inverted ADC. And then we have pre and post contrast vibe. We cover the liver on one of our vibes just in case there's some lesion that we didn't pick up that we want to make sure we characterize later. And finally, we do a coronal delayed vibe. We also do it in sagittal now because our renal surgeons have said that they find the sagittal gives them a more accurate depiction of where the renal mass is relative to the rest of the kidney. All right, so with that kind of background, I'm going to go into a little bit of the clinical context with how we're using MR imaging. So we know renal cancer is about 3.7% of all cancers, and it's only 2.4% of all cancer deaths. That puts it behind the big players that get more funding for research from the NIH, like breast, lung, prostate, lymphoma, colon, and bladder. And the other, kind of interesting point is that most of these renal cancers are incidental, so like less than 10% produce with any symptoms. And we know that those are going to have a better prognosis than those that do present with symptoms. What is interesting in this as well is that our mortality rate is not improving. So we know that we've been picking up more cases due to incidental cross-sectional imaging, but the death rate is unchanged over time. And that's because we haven't changed in picking up the advanced cancers that present late with regional disease or metastatic disease. And so from this, we know that although we were not picking up as many because of less imaging in the 70s, we really haven't changed this death rate of about 14,000 per year. And because of this, most of the current literature will tell you that we realize that we've just had a stage migration by picking up tumors with a longer lead time, but we haven't affected the length time bias. And so what a lot of people are saying is we're not really doing any benefit by picking up these smaller tumors. How does that parlay into us? Well, I'm going to try and show you some data on what we can do to be useful. Maybe we can characterize better those aggressive tumors, and how can we subtype lesions to kind of say which ones are safe to watch. So our prior role of MR really in renal mass lesions is finding the mass and seeing if we can depict internal enhancement. And these skills can be tricky. This seems like a no-brainer, and we're expected to do this, but I'm going to show you how we can have pitfalls in this. And what is the future role is we really need to be subtyping these lesions. And I'll tell you, even as we've been mastering distinguishing clear cell from papillary, the pathologists keep changing their WHO classification. And I just had a talk from Ebley at our institution about this change, where you're adding more subtypes and deleting others. And I'll tell you, papillary type 2, they were debating for the 2016 of eliminating this classification, and they decided to keep it there to let it die off naturally because translocation tumors, collecting duct tumors, with all of the immunohistochemical stains they're doing, they're actually finding that type 2 papillary was a mixed bag. It wasn't a pure group. And instead of deleting it from the WHO criteria, they're going to let it slowly die off as they get better at putting it into the real categories. So why do I have this slide here? Well, when we're predicting these subtypes, we're chasing pathologists because they keep changing the rules on us. So it's a little bit of a game here. I think radiology is better. I'll show you where I think we beat pathology here. All right, so our roles of MRI, we're going to do cyst versus tumor, and then I'm going to show you how to do some subtyping of renal cell carcinoma. So how do we determine MRI enhancement? They're subjective. You look at the pre and you look at the post and you say, I think it's enhancing. Then there is this article from Ho, and I always get scared when presenting this at an MRI meeting like this because the physicists, I hope there's none in the audience, they cringe when they hear us putting ROIs on renal, on any MRI image because there's no noise map and because the transmit gain and receive gain differ from the pre to post, so it makes it completely inaccurate. And I know for a while physicists had been working on making a noise map to make these ROIs accurate, but for the time being, it's not accurate. As long as you accept that people will cringe with this, this is at least reasonable to do. So what this paper was, and I still use it, is you look at the pre, you minus the post, you use the 2 to 4 minute delay post-contrast, and you stick ROIs on it. And if a physicist walks by, you just say, leave me alone, I'm reading a clinical case. And so you can operate like that. And the other way to do it is subtraction. You do the post minus the pre, and if it's bright, then it usually means it's enhancing. All right, so here's a good case. This is a calcified dense mass, and you look at the pre and the post, and you say, is this enhancing? Impossible to tell. So this is a clear-cut case for MRI, and here on MR you can clearly show on the inside there's this peripheral nodularity, and this was a cystic RCC. Some people may say when it calcifies it may be burning itself out, kind of like seminoma tumors, but that's in the air because people have shown METs even with those type of tumors, but that's neither here nor there. All right, so here we are back to the pitfalls. ROI measurements. Be careful if the enhancing region is too small for your ROI if you're going to put it on it. And the other is subtraction misregistration, and subtraction noise is additive. All right, so here is one, and I'll tell you, I love this case because part of the Radiology 2.0, our institution decided to put us more into the clinic with our urologists. So I get to sit in this clinic room with the urologists as they're going through their cases. And over time, that room has evolved to have me sitting next to 3 med students and a nurse practitioner with boxes falling on my head. But it is still radiology of the future. And at least I get to see clinical cases as they're happening in real time. So here is this man. He came in, and this was read as an RCC. It's bright on pre, arguably enhancing. I don't think it is. So you put your ROI on it, it goes from 44 to 53. That's only 9 Hounsfield units. Most of us would say that's not enhancing, but this was read by someone in the community as an enhancing mass. But they said it maybe you want to get an MR. So then they got an MR. So this was their MR. They did a pre here and they did a post here. And if you visually look at it, it looks like it's de-enhancing as you go from pre to post. You can put your ROI on it, and you see the number is also going down from pre to post. Any lesion that's de-enhancing is benign, okay? But this was, the problem was they relied on their subs. And what you can see here is they misinterpreted this as enhancing. But those of you with an eagle eye will see there is this thickened white rind around the liver. And what happens is because this was at a higher level, and they breathed at a lower level post, your subtraction is going to be misregistered. And so in reality, here is the ghosting of the non-enhancement of this renal cyst. So this is one of those FAFA syndromes. In radiology, our surgical chairman loves to say fumble after fumble after fumble after fumble. And so this was almost resected as a cancer, when in reality it's a benign renal cyst. And so just be aware of these pitfalls. That's misregistration. Another one, and this goes into a nice sidebar, which is kind of one of the American College of Radiology's current priorities is these incidental lesions. How do you know when you don't need to work up anything? And these are some nice papers that have been out. You can ignore on non-con simple cysts less than 20 or greater than 70 Hounsfield units. And this just came out recently. Gary Israel did some nice work on this, showing that very bright bloody cysts that have a signal intensity of 2.5 when you take the lesion to the parenchymal ROI had a 99.9% accuracy of being benign. And finally, Silverman did a nice article on if a lesion looks like a cyst and it's tiny and it's smaller than a centimeter, you can just ignore it. All All right, and so in this case, if you had just looked at this cyst and you said, you know what, this is brighter by more than 2.5 relative to the parenchyma, you can ignore it, and this is benign. So that was another takeaway. And finally, my last example of pitfalls with subtraction are this corollary case. Here we have a mass in the lower pole of the left kidney. Here on T2, it looks really irregular and ugly inside. So you can visually look at it, and from pre to post, hard to say. You can look at the wall, because often the wall is the hint as to whether these are enhancing. But it was equivocal, so then they looked at the subtraction. This was interpreted as internal enhancement. But beware, if you're looking at the subtraction, look at the noise around it. This looks just as noisy as what's going on in this cyst. And that's the problem with subtraction. Noise is additive. So if you're relying on this to look for subtle enhancement, you're going to get fooled with low level. And in this case, actually, they also looked at diffusion, and here's the B400 for diffusion, and you'll see it's really not that bright, and it's not restricting. And ultimately, they got a CT, and it got smaller, and it didn't show any enhancement. This was interpreted as benign. It's anyone's guess if this thing actually was a burned out tumor or not, but regardless, it behaved as an indolent lesion. So I'm going to go into a little bit of some advanced MR techniques looking at renal tumors and see how they can help us. How good is diffusion? And I think the prior speakers were going through the limitations of diffusion in terms of endometrial cancer as well as adnexal lesions. It's kind of the same thing for renal as well. It's not there yet for solid bloody cancer versus cysts. Cystic, and it's all because of cellularity. It's not there for cystic RCC. It's starting to be promising for solid RCC. And really, why is it so limited? It's a signal issue. It's because signal is low and the cellularity is low. And this is a constant problem in a lot of these tumors. So for example, here's a nice article. My colleague, Sue Kim, who's in the audience, looked at how good we are at ADC values, and you see this overlap, although RCC does tend to be lower than benign lesions. If you look at the whisker plot of this, there's overlap, so you can't rely on it alone. Here we have a cyst, which is bright on ADC, and here's a papillary, which is uniformly dark. Those are the two best tumors that behave according to the rules. The rest are a grab bag in between. And again, here's a nice article from Zhang showing that the ADC overlaps. So if you draw a line here, you're going to get overlap between almost all of these. But again, there is a trend towards ADC being lower for solid lesions. This is a nice article by my section chief, Hirsch, where he showed how papillary RCC here has a lower ADC, but you'll notice the other tumor subtypes, including chromophobe, clear cell, and cystic, all essentially overlap on ADC, so it doesn't help us there. What he did show that was interesting is if you look at the intervoxel incoherent motion, which is the beginning part of that curve on ADC, looking at the perfusion characteristics from the diffusion curve, you'll see that the papillary had a much lower perfusion fraction, and you can get good separation of the tumor subtypes. Here we've got chromophobe, clear cell, and then you've got your cystic RCC, and this does show better differentiation. So this is an evolving area that we're showing some promise. All right, and now for the second half of the talk, I'm going to discuss some of the subtypes of RCC. And I'm going to focus on some of the more tricky cases. And just again, as a quick review, AMLs, clear cells, and chromophobe RCCs are all going to be hypervascular. So you're going to need to rely on other sequences to distinguish them. Papillary is probably the easiest because it's hypovascular and it doesn't show arterial enhancement. When I say papillary, I'm talking about papillary type 1. Again, as I mentioned before, papillary type 2 is probably going away. It was almost kicked out of this current WHO 2016 classification. Here's a nice flow chart if you're interested in it from Kang AJR in 2014, kind of going through, again, the low-level enhancement you see in papillary RCC and the avid enhancement you're going to see in the other tumor subtypes. Again, there's some overlap in all of this. All right, quick review of chemical shift artifact. It's interesting, in my training, I trained in Boston at Beth Israel Deaconess, and Herb Kressel was the chairman at the time, and he used to come in and tell me, just use the T1 in and out. Those are the most important sequence. And I was like, this guy's out of his mind. These are 8 mm thick slices. This is so ugly. It looks like a 1980s MRI sequence. I think he's crazy. But I've learned with my life that he was right. And I actually find more information from this sequence than from a lot of the others. And when I've missed tumors, I usually go back and I see it was actually there. So I am going to try and proselytize you to be converted to the T1 in and out of phase sequences, and I'll go through why. So intravoxel is going from in to out. You're going to see loss of signal. When people talk about loss of signal in clear cell RCC because of the glycogen-rich clear cells in it, they're not talking about something going from bright to super dark. They're talking about this type of loss of signal, and it's subtle. So it goes from this degree of brightness to this degree of signal loss, and that's subtle. But it is going from bright to dark. That's what people are talking about. It's not something obvious. You have to really look at it, and you can put on that dreaded ROI and look at the loss in signal from one to the other. And it is seen in both clear cell and in AMLs. All right, and what about bulk fat? And I'll tell you, bulk fat on MR is the hardest thing in the world, and it is really difficult. People will talk about using this line, and I actually wrote this up with Gary Israel when I was a resident, and it was looking at this black line at the interface of water and fat, and if it's between bulk fat and the water, that tells you that it's going to be an AML. And if it's between the lesion and the bulk fat, then it's something else. In this case, it was a hemorrhagic cyst. But I'll tell you, this sign in and of itself is subject to a lot of artifacts. You can have edge artifact, you can have some other hemosiderin mimicking it, so it's not perfect. What I would advise you to do is look at the signal in the lesion and look at the bulk fat in the subcutaneous space. And if it's following what the bulk fat is doing on every sequence, you've got to think that it may be an AML. And it's not easy. All right, and so we're going to go down this flow chart and see if we can subtype a few lesions. All right, here we can go. We've got a pre-contrast T1, and we're looking at this lesion. It looks similar to the fat in the subcutaneous, so we're thinking it's probably bulk fat. I will say the problem with VIBE is that it is both an opposed phase, so it has both intravoxel fat as well as a frequency-selective fat-sat sequence. So it's not ideal to use for this because if a lesion's going to lose a lot of signal on the opposed phase, you may get fooled. But anyways, this is what we have. So we're going to say, it looks like bulk fat. We go to the next one, and here we have, this is her demographic. As soon as you see she's a 40-year-old female, you're thinking an AML. Okay, middle-aged, female, AML. But still, we're going to go through the exercise. In to out of phase. Is there bulk fat? Does it look like bulk fat on this sequence? Yes. Okay, then we go to the next one, and it has that dark line at the interface. But those of you that are savvy are going to say, Nicole, I see that dark line at the interface with it. Fine, I'll say, I told you this was not a perfect sign. Okay, intravoxel fat, does it go from bright to dark? Yes, it does. All right, and is it enhancing? Yes, it is. So in this case, you're going to think of an AML, and here again, is it uniformly low on T2? No. Is it following the bulk fat signal? Yes. So you know that this is going to be an AML. But if you're in doubt, you can get a CT. This is how hard bulk fat is. It's not easy. It's not like a CT. Here's a corollary case, 72-year-old man. Wrong demographic for a benign lesion. These are the people who have bad cancers. So we see it's enhancing. Is it going from bright to dark? Is there bulk fat? Do we see a black line with the adjacent kidney? No, we don't. So we say it doesn't have bulk fat. Does it have intravoxel fat? Well, yes, it does, and it has a lot of it. And is it low on T2? No, it's heterogeneous. So this is going to be a clear cell renal cell carcinoma. And finally, going to this one, here's a 45-year-old female. What are we thinking? Age group, this is going to be likely an AML. That being said, women in this age group do get cancer, but you're favoring in your mind an AML. It's enhancing. We go from bright to dark. Is there any loss of signal? No, there's not. So there's no fat. There's no bulk fat. We don't see that dark line with the adjacent kidney, and it's not following bulk fat in all sequences. And however, it is uniformly low on T2. And I'll tell you, This was actually a lipid-poor AML, but there's no way you can do this. There's no MRI technique that's perfect for this yet, and so that's why a lot of the guidelines, and including the current ACR guideline, I think it's coming out in JACR this year, on the guideline for this workup, is probably recommending biopsy for these dark T2 lesions. All right, and here is the next one. Another 40-year-old female right renal mass. Is there internal fat? Does it look like the subcutaneous fat? It does. And there's also quite a bit of loss of signal. We can see, again, it's following bulk fat on this sequence and on this one. But I'll tell you, this was read as avidly enhancing. It was read as a clear cell. But this was an AML. So what I'm just warning you is bulk fat is hard on MR, and CT is just much easier. You can see the internal fat in the lesion here, as well as the classic aneurysms. So this is not something that's easy, and I've noticed my colleagues who are specialists in this have missed about 5 of these AMLs because it can be hard. They should have a greater loss of signal in a post phase when they're fatty. India ink is not always obvious, and if you're in doubt, just go back to CT. I know this is an MR course, but sometimes it's just easier. All right, now I'm going to go through some low T2 lesions which don't have fat. And so here is one of the other challenges. These are T2 dark lesions. Are they benign or malignant? Well, this one is homogeneously low on T2. It has no blood on T1 pre, and you can see it is enhancing post-contrast. This is one, it's low on T2, it's not so homogeneous, it has hemorrhage, which AMLs never have, at least not the lipid-poor ones that are dark on T2. And on subtraction, it's got heterogeneous enhancement. So looking at the pre, I already know this is going to be a papillary because papillaries bleed. And so this one's a papillary. This is a lipid-poor. Again, there's no data that can confirm this. That's why these are going to go to biopsy every time. So we're just not there yet with subtyping for that. All right, how good are we at predicting tumor aggressiveness, which is going to be the next stage? We know cystic appearing RCC are less aggressive. You really need to only call it cystic if less than 25% of it is solid. We know high stage are going to be more heterogeneous than low stage RCC. And also, as was shown with the discussions on response of tumor, the high grade are lesions that are going to have more necrosis tend to have a lower ADC compared to low grade. It's kind of counterintuitive, but you have to think it's probably because it's so aggressive and it's necrosing. What is the role of diffusion? Again, high grade tends to have a lower ADC. And one of the problems is not all tumor subtypes show diffusion restriction. I showed earlier the slide from Hirsch from our institution showing that papillary is pretty good at doing this, but the other subtypes really don't help. And I'm going to show some examples on why you cannot rely on diffusion alone for screening. I'm going to show you some cases where I've been burned. All right, so here's ADC for prediction of tumor grade. We can see which of these looks like it's more uniformly dark. That's going to be the lower grade. This one is more uniformly dark than this one, and this was a lower grade clear cell than this one. All right, so it's a bit of a judgment call. How about diffusion as a standalone? Okay, this is a man who had already lost his right kidney. Here you have this heterogeneous mass on haste. In and out of phase, we see that loss of signal, so we know that this is going to be a clear cell renal cell carcinoma because it's going from bright to dark, from in to out of phase. And on the ADC, it looked like there was some good restriction there. So we figured, it showed diffusion restriction, so this guy got his partial nephrectomy, and afterwards had already lost one kidney. I know we're a little aggressive. We do partial nephrectomies, even for these aggressive tumors. Probably was not the right call in this guy, as I'm going to show you next, but he really wanted it. He didn't want to go on dialysis from this. So we screened him for 2 years after his partial nephrectomy, and he refused to get IV contrast. And can anyone in the audience find the recurrent tumor? Well, it took us a while to find this, and he came back, I said, for 2 years. And finally, you can sort of suggest maybe that's going from bright to dark. Very difficult call. Really, like I said, Dr. Kressel's hint of using the in and out of phase was a better call here because I looked at this and I said, that renal vein actually looks expanded. And it all goes back to our favorite sequence, T1 in and out, because diffusion just let me down here in a big way. And so as you go, we called him back for dynamic contrast. That tumor had recurred. It was infiltrating and going along the renal vein and now involving the retroperitoneum. And diffusion just ignored it. You don't see any of it. So I'm not the biggest fan of diffusion alone for these sequences yet. However, it can be helpful. Here was another case where it did help. Here was a renal cell, aggressive. Again, the guy got a partial nephrectomy because he was trying to preserve his kidney. And as you go to the post-contrast, here's the partial nephrectomy site. Here, and actually, Sue, I believe you picked this up when you were here with us. You can see that there is this implant in the rectus abdominis muscle, but it looks like bowel. Here, diffusion was bright and did show diffusion restriction, so it was helpful in this case for picking up this recurrence. This recurred there because that's the way they resect. They do an anterior resection, and they pull out the kidney specimen through that port side of that anterior abdominal wall. So this is a place where you can get recurrent disease after a partial nephrectomy. A good pickup. So kind of what's our future directions? Can we replace pathology in subtyping renal lesions? That's really where we're trying to go. And we're hoping that we'll be able to do that based on enhancement and perfusion, and maybe we'll obviate the need for a biopsy, kind of like the direction MRE elastography is going, and where HCC characterization went. So we're hoping that that's where we go. Can we predict which tumors, when they're advanced stage, are going to respond to VEGF, and which ones won't, and which ones we need to use neoadjuvant, and which ones maybe will be better served by doing an immediate resection? And finally, can we use non-Gatto techniques? There's a real demand in these patients who've lost part of their kidney. They don't want IV contrast. They'd love it if our diffusion was more accurate. I don't think we're there yet, but it would be great for the day that we could get there and use it to monitor for recurrence. So in conclusion, MR has a proven role in determining enhancement in renal lesions, especially when CT cannot in calcified lesions. Be aware of the pitfalls of MRI enhancement. Look carefully and use your ROIs on it, even though physicists cringe. Subtyping renal lesions is a needed skill. It's going to come into play more and more as how they're monitored and surveillance imaging is used in the future. If we can predict those lesions that are going to have an indolent course versus those that are going to be aggressive, it's going to be important. And also, you don't want to operate on AMLs in women. I do feel we're going to replace pathology someday. And diffusion and IVIM are promising techniques, but they still have a way to go. However, I'm optimistic we're going to get there. And I'd like to just say Dr. Bosniak, one of the fathers of renal imaging, passed away this past September, and he's deeply missed already by all of our colleagues. And McCary, who was one of the leaders of our section, also passed away in 2012, the same time as Sandy. And this is Dr. Balthazar, one of the founders of GI radiology, and they're all deeply beloved and missed. Thank you.
So we're going to discuss the characterization of renal lesions with MR. And these are my disclosures. We have institutional research support from Philips Healthcare. So the goals on this talk are to review the indications for MR and the characterization of renal masses. I'm going to make emphasis on aspects of the protocol that allow you to characterize tissue and detect enhancement accurately. I will discuss the characterization of both cystic and solid renal masses, and then talk a little bit about the pre-surgical assessment of renal masses, what needs to be included in the report. So as always, when you have contraindications of iodinated contrast or you have concerns about radiation, MR is a great alternative to CT and ultrasound. More generically, because of the superb soft tissue contrast of MR and the sensitivity to small amounts of gadolinium, MR really is a great technique to characterize renal masses. So basically any mass that we have that is incompletely characterized by ultrasound or CT, we use MR to try to give a more straight answer. However, because of our limitation in detecting calcifications, we don't use MR as the first test to study patients with hematuria. Our protocol starts with the coronal single-shot fast spin echo images in both coronal and axial plane. We do then chemical soft imaging, axial T1 in-phase and post-phase imaging. And then we acquire a series of 3D fat-saturated T1 spoil gradient echo images in the coronal and sagittal plane for each kidney. After administration of a single dose of gadolinium, and we do this on a body weight-based approach, we acquire our coronal images again dynamically, as you can see here, with a corticomedullary phase. There's a time to the arterial phase, and an early and late nephrographic phase. We then acquire again the sagittal images for each kidney, and we finish with axial delay during the excretory phase. The sagittal images are acquired, as I can show you here in this diagram, slicing the kidney longitudinally, independently in two different acquisitions, and those are very useful to look for the anatomy. We have moved away from standard T1 SPGR sequences. We now use Dixon-based techniques for all our dynamic images. They provide more homogeneous fat suppression routinely for these exams. The coronal T2 single-shot fast spin echo images are great to characterize cysts. Simple cysts will appear as homogeneously bright with a thin wall and no internal architecture. Anything else that you see on these images really requires contrast to be characterized. They're great also to detect and characterize septations. They're very motion insensitive, so you can actually assess the thickness of the septations very well, which is very important, as I'll discuss later. And also to assess the quality of the fluid, again, another important feature when you characterize renal masses. Chemical shift imaging is based on the fact that protons of fat and water process, rotate along the magnetic field at a different velocity. So depending on the echo time that you use, you can look at this, listen to the signal from fat and water when these protons are pointing in the same direction, in phase, or when they're pointing in opposite direction or opposed phase. And when this happens, the signal in the voxel that contains both fat and water get canceled because of the opposed phase. And it's important to discuss the feature of fat characterization rather in MR in renal masses. Try to clarify what the nomenclature is here, because there's a lot of confusion in the literature. So first of all, if you consider subcutaneous fat, you can see that the signal really doesn't change that much because it's almost 100% fat. So the same thing is going to happen in angiomyolipoma. And by the way, the opposed phase image is recognized easily by this India ink effect that you see at the interface between fat and water. But an angiomyolipoma that contains fat will have the same characteristics. It will be bright both on in-phase and opposed-phase imaging because there's basically pure fat in the center, and an India ink effect at the interface between the mass and the water in the renal parenchyma on these opposed-phase images. Now, in terms of the fat that you're going to see in a renal mass, people discuss different descriptors for this. I like to talk about bulk fat and intracellular fat, which I think is a little more precise than intravoxel or microscopic fat. I don't think those are necessarily good terms. Bulk fat really refers to adipocytes, is fatty tissue. And when that happens, when you have a voxel filled with bulk fat, about 100% of the tissue inside that voxel is going to be fat. When you have intracellular fat, you have liposomes and vacuoles filled with fat in the cytoplasm. So essentially what you have is a combination of fat and water. A percentage of the voxel is going to be composed by fat, and another percentage of the voxel is going to be composed by water. How this translates into MR images. Again, if you have just pure fat, it's going to be bright both on the in-phase and opposed phase, but you're going to see an India ink effect around the fat at the interface between fat and water on the opposed phase images, and this is what you see when you have bulk fat in an angiomyolipoma. You can be certain when you see bulk fat in a mass that is an AML. If you only have water, there's no cancellation of the signal, intermediate signal, both in phase and opposed phase images. If you have coexistence of fat and water, then an opposed phase imaging, you're going to have cancellation of the signals from fat and water, and you're going to see drop in signal intensity on opposed phase images relative to in-phase imaging. And this is what happens when you have intracellular fat, like for example in a clear cell renal cell carcinoma. However, some AMLs have very small amounts of bulk fat, and the net effect is going to be the same. You're going to have both adipocytes and water in the same voxel. So you're going to have as well intermediate signal that drops on opposed phase imaging. So the conclusion here is that if you only see that on a renal mass, intermediate signal that drops on opposed phase imaging, you cannot distinguish a clear cell renal cell carcinoma from an AML. You can only make the diagnosis of AML when you see bulk fat. Here you have a couple of examples. On the in-phase imaging in this patient, you can see drop-off signal on the post phase. This other patient, also drop-off signal on the post phase. However, this was an AML, this was a clear cell carcinoma. Again, you cannot distinguish based only on the signal drop on the opposed phase images. And this chemical shift score or signal intensity index was proposed years ago, but we and other groups have shown again that based on this score comparing signal intensity on in-phase and opposed phase imaging, you cannot distinguish those two entities. It's complete overlap of the signal. Some have suggested a T2 ratio to distinguish these entities, and the T2 ratio is the T2 of the tumor divided by the T2 of the renal cortex. And in this study, they concluded that a T2 ratio of 0.9, a T2 ratio of 1 will be basically isotense signal of the renal mass and the renal cortex. So a 0.9 will separate AML from, with minimal fat from renal cell carcinoma. Well, that's not exactly true, because when we look at the subtypes, again, for clear cell carcinoma, that may be the case, but not for papillary tumors. So again, you can actually distinguish with a T2 ratio AML with minimal fat from clear cell carcinomas. But AMLs with minimal fat and papillary renal cell carcinomas have exactly the same T2 ratio. Now, in the same paper, they show this graph, which I think is a very elegant way to combine the T2 signal with the contrast enhancement characteristics. So they have this arterial delayed enhancement ratio, which is basically how much the tumor is enhancing in the arterial phase divided by how much is enhancing on the delayed phase. So if we use the T2 ratio, again, 1 will be isotense. So lesions that are on the left side will be hypointense to the renal cortex. And then the contrast enhancement ratio here, which means if the lesions are up here, they enhance more on the arterial phase than on the delayed phase. Below will be a more progressive enhancement. And again, you can see that AMLs will be hyper-enhancing and dark on T2. Papillary tumors will be hypo-enhancing and progressively enhancing, actually, and dark on T2. So using those two characteristics, we can distinguish those two pretty well. And clear cells tend to be hyper-intense on T2. So a couple of examples, mass that is very obviously dark relative to the renal cortex. You don't have to do a T2 ratio. You can actually look at it and see, is it darker or not than the renal parenchyma? Certainly it is. There is a minimal amount of drop of signal on the chemical shift imaging. This is an AML with minimal fat. You can recommend a biopsy to confirm. In this other case, however, you can see a rim of signal intensity that disappears on the post-phase imaging, so there's no question that there is fat in this lesion. However, you have central necrosis, and AMLs don't tend to have central necrosis. So whenever you see that, you have to consider this is going to be a clear cell and to prove it otherwise. Another way to explore the presence of fat in a lesion is to use frequency-selective fat saturation techniques, which destroy the signal of fat by applying an RF pulse in this frequency of fat. And if the mass goes dark after applying the pulse, you can tell that this is fat as long as you don't change any other parameters in the sequence. And this is obviously an AML. You can also use Dixon-based techniques, and again, this has been discussed in other lectures. By using 2 echoes per TR, you can separate the signal of fat and water. You can actually subtract these two and get an opposed phase imaging, or add these two and get an in-phase image. And once again, if you see the bright signal on the fat-only reconstructed image, you can tell with confidence that this is an AML, this is bulk fat. Now, how about enhancement? On MR, the signal intensity is relative. It's not like CT. We don't have Hansfield unit scale. So we have to use a different approach to determine if something is enhancing or not, because enhancement is the best predictor of neoplasm that we have on cross-sectional imaging. If a lesion is enhancing, you have to assume it's a neoplasm and to prove it otherwise. And as you can see here, this patient presented with perirenal hematoma, a spontaneous large hematoma, and you can already tell there is something in the center that is probably enhancing. And if we compare the signal intensity, it's been shown that if you have a 15% difference between the pre-contrast and post-contrast images at 2 minutes, you essentially have perfect sensitivity for the presence of enhancement. Another approach is to use subtraction imaging. You can generate this at the scanner by subtracting the post-contrast images minus the pre-contrast images. And just by looking at these images, you can tell that this lesion is enhancing, because you can compare to an internal control, tissues that you know that are not enhancing, like, for example, in this case, the gallbladder contents and the hematoma around the kidney. So these are dark, background signal. So this is gray, clearly brighter than the dark signal and the hematoma. This is an enhancing renal mass. And this subtraction techniques are pretty useful when you have hyperintense masses before you give contrast. After contrast, in this case, you see two lesions in the kidney. There's no way for us to tell which one is enhancing and which one is not. When you look at the pre-contrast images, you can tell that probably the lesion in the lower pole is not enhancing since it's bright pre-contrast. But just by looking at the subtraction and looking at the lesion, you can tell the lesion turned black, so that's not enhancing, compared to the lesion at the top, which, although is darker than the kidney, is clearly gray, it's not black, so that's hypo-enhancing, but it's still enhancing, and that's indeed a papillary renal cell carcinoma. So again, just by looking at these images, you can assess the presence of enhancement very rapidly without having to do region of interest analysis and measuring signal intensity. These hyperdense cysts or hemorrhagic cysts are very problematic as incidentalomas or incidental findings in single-phase CTs. And one of the questions is, what do we do after we see one of these lesions? Do we let it go? Do we do follow-up imaging? And if you do follow-up, what are you going to do next? You can do a multiphasic CT, but that's a lot of radiation. Or you can choose to do an MRI. With hyperdense cysts, usually with ultrasound, it's rare that you're going to be able to clear them as cysts. We prefer to do an MR because in a single study, you can basically rule out neoplasm and stop the follow-up. So like in this case, for example, you can see that the lesion is hyperintense, pre-contrast, and then when you do the subtraction, it's completely black, you're done. This is a hemorrhagic cyst. And this takes us to the Bosniak classification, which just as a reminder, is a 5-category classification, 4 plus the 2F in the middle for follow-up. And this is based on CT data, more on CT experience rather than data, because Bosniak basically created this classification based on his experience. And what it does is basically give you a sense of the likelihood of a neoplasm based on the complexity of the cyst on CT or MR. Bosniak 1 is a simple cyst. Bosniak 2, you may have some thin septations. 2F is, again, a follow-up is in between 2 and 3. 3, you're going to see minimally irregular or thickened septae or walls in the cyst. And a 4, you see frank enhancing tissue. And traditionally, we have managed these lesions with surgery for Bosniak 3s and 4s, although we're moving much more toward active surveillance in lesions that we know for sure, or not for sure, but most likely they are actually neoplasms. So how applicable is the Bosniak classification to MR? So Gary Israel and Bosniak look at this, and they found that in almost 70 cases, about 20% of them are discordant, mainly because you're going to see more septations, increased thickness of the cyst wall or septae, or the different enhancement pattern on MR compared to CT. And overall, this resulted in about 7% change in management. Now, many of these change in, they get upgraded because we see more cysts on MR than we do on CT. But one question you may ask is, what do we do with the lesion where the CT shows nothing, the MR shows septations, but then post-contrast images, you don't see absolutely any enhancement? Is this really an upgrade in the lesion? Do we have to worry about this? But it's possible that actually the MRI technique is too sensitive for the Bosniak classification. So we have to really base decisions on the presence of enhancement, not on the presence of a number of septae. On the other hand, we need to know also how sensitive MR is for neoplasm and how specific. We don't have really good data on that. We do know, though, that when we have clear nodularity on MR, even when it's small, you can be confident that this is going to be a neoplasm. And we showed this a few years ago, a small number of tumors, but these were all cases, cysts with known nodules on MR, and pretty much every one of them was a neoplasm. And these were small cysts, although the cysts were, small nodules, sorry, although the cysts were several centimeters in size. On average, about 70% of these nodules was less than a centimeter. So we're talking a millimeter nodules. And again, when you see a 5, 6, 7 millimeter nodule on a cyst, you can be confident that it's going to be a neoplasm. But that doesn't mean you need to rush to surgery. And there may be other imaging characteristics in renal mass that can help you make decisions about how to really triage those patients for the most optimal management. I want to discuss some of these features and divide this into cystic and solid masses. I won't be discussing infiltrating masses. And starting with cystic masses, typically you're going to see two flavors. One is the cyst that contains simple fluid, and by simple I mean fluid that looks like CSF, bright on T2 and homogeneous, and dark on T1. And then you're going to see a variable amount of nodules and septations, which are typically hypervascular on the post-contrast images. And almost invariably, these cysts with this phenotype are low-grade clear cells. And this is important because these are very low-grade malignancies, particularly when you have very small amounts of solid components like I showed you before. So you can follow these lesions over time and see if they clear themselves. So that's why really making the decision between a Bosniak 2F versus 3 is not necessarily that critical. You can still follow them in 6 months and see if they grow. This patient actually refused surgery for a while, and eventually we were pretty certain that this was a neoplasm, and she got resected. It was a low-grade clear cell, and she didn't have any problem afterwards. So again, the risk of metastasis in this particular phenotype is extremely low. A different category is papillary tumors. Those tend to have hyperintense fluid on T1, hemorrhagic fluid, and heterogeneous fluid on T2, very different appearance. And on post-contrast images, they're very well encapsulated. And post-contrast images, the solid components are going to be in the periphery of the cyst as these papillary projections, which can be better recognized on subtraction imaging, as you can see here. Recognizing this phenotype is important, and is particularly important on CT, because this is a mistake that I've seen a few times. When you do a region of interest analysis on a CT, pre and post contrast, and you can see that the cyst is hyperdense before contrast, you know this is not a simple cyst. You see this is going to be, at the very least, a hemorrhagic cyst. So if you actually look for enhancement in the same area on post-contrast images, you won't detect enhancement because, again, papillary tumors have the solid component in the periphery of the cyst. So you want to interrogate the periphery of the cyst very carefully to see if there's an enhancement in those areas. Otherwise, you may actually miss a papillary cancer and consider that's a hemorrhagic cyst. How about solid masses? So we like to look first at the T2 characteristics in a solid mass. If the lesion is predominantly, these are again very heterogeneous, but if predominantly is hyperintense on T2, we tend to think of clear cell and oncocytomas. These tend to enhance very avidly. They may or not have necrosis, and they may have intracellular lipids. So a couple of examples of clear cells. These are, again, very vascular, post-contrast, predominantly bright on T2, but heterogeneous. That one has necrosis. If you can see a mass that is predominantly bright on T2 and hyperintense, hypervascular, and that has fat on chemical shift imaging, you can be pretty certain that this is a clear cell carcinoma. Okay? And this is important because you don't need to do a biopsy in these cases. That this is clearly a renal neoplasm, a malignant neoplasm. There are exceptions. Without fat, you can see a lesion that looks exactly the same, and that can be an oncocytoma. Those don't tend to have fat, but they can have, the other characteristics can be exactly the same. So again, there is definitely an overlap between clear cell and oncocytomas. How about the enhancement characteristics? So this is something that we published a few years ago, just to look at 3 time points with a standard clinical contrast-enhanced protocol. And you can see that clear cell carcinomas enhance much more avidly than papillaries, and chromophobes are typically kind of in between. So when you compare to the renal cortex, clear cells tend to enhance about the same as the clear renal cortex. Papillaries about 20%, 20 to 30%. Chromophobes tend to be about 50% of the renal cortex. And we base this, as I'm going to show you in a diagram at the end, we use these thresholds to characterize these lesions. And if you have 84% change in signal intensity on the early phase, on the corticomedullary phase, you can distinguish clear cell from papillary carcinomas with about 99% diagnostic accuracy. If the lesion is dark on T2, hypointense, then we typically think of 4 main differential diagnoses: papillary renal cell carcinoma, chromophobe renal cell carcinoma, oncocytoma, and AML. Of course, there are, in the less than 1% category, there are other lesions that can look like that, lymphomas, metanophic adenomas, different tumors that are rare. But these are the main diagnoses, and what's important here is you have 50-50 benign malignant disease. So when you have hyperintense masses on T2, that's when the biopsy may actually be more effective. You may be able to avoid some surgeries in some of these patients. I showed you before that papillary tumors are cystic masses with papillary projections in the wall? Well, they evolve from a solid mass to a solid mass with internal hemorrhage to a frank cystic lesion with those papillary projections in the wall. Regardless of their status, where they are in terms of the evolution, they're always dark on T2. The viable portion of the tumor is dark on T2. Obviously, you have hemorrhage, it's not. But the viable portion is dark on T2, and they're always hypoenhancing relative to the renal parenchyma. So if you have dark signal on T2 in the viable portion and hypoenhancement, you have to think of papillary renal cell carcinoma as your favorite diagnosis. Other lesions are dark on T2 as well. I described the AML with minimal fat before, chromophobes, RCC as well, and oncocytomas can be dark on T2 or isointense to the renal parenchyma. The segmental enhancement inversion sign was described on CT years ago as very specific for oncocytoma. This sign describes areas in the mass that are hypervascular in the early phase and then wash out, and other areas that are hypoenhancing on the early phase and then catch up and become hyperdense on CT or hyperintense on MR on the delayed phase. However, Andy Rosenkranz from NYU has shown that there is overlap with findings in chromophobe RCC, and that's our experience as well. You cannot distinguish these two entities based on that finding. So to summarize the results, not the results, but actually our approach to these masses, for a solid mass, we look first at the T2. If the lesion is hyperintense on T2 relative to the kidney, again, predominantly hyperintense. If there is having enhancement, we think of clear cell, particularly when there is fat, or oncocytoma clear cell if we don't have fat. If the lesion has moderate enhancement, again, remember those thresholds, 25, 50%, 100%, we think more of oncocytoma and chromophobe RCC. Again, these are all surgical lesions. If the lesion is isointense on T2 and there is avid enhancement, we think of the same differential, not a specific findings. If there's moderate enhancement, still not very specific finding. I should mention that biopsies here are not very helpful because very few pathologists will entertain a definitive diagnosis of oncocytoma on a core biopsy. There's too much overlap. Basically every renal cell carcinoma can have oncocytic differentiation. So on a single biopsy, they don't tend to give that diagnosis. So a biopsy is not necessarily diagnostic in this scenario. If there's low enhancement, again, we think of papillary renal cell carcinoma. If the lesion is hypointense on T2 and avid enhancement, then we think of the AML with minimal fat. Rarely a clear cell can present as dark on T2. But that's when a biopsy is very useful. Pathologists can make this distinction. This will actually prevent patients from having unnecessary surgeries. And if there's low enhancement, then we favor papillary, but AMLs can sometimes present with this feature as well. So again, if it's hypointense on T2, that's where you want to really consider biopsy to avoid unnecessary surgeries. In terms of the pre-surgical evaluation, there are several things that you want to mention in your report. First of all, you want to describe the location of the mass and how exophytic it is in the kidney. It's important to describe this because the percentage of the mass that is exophytic is the best predictor of the need for intraoperative ultrasound. If the lesion is completely endophytic, the urologist won't be able to find that lesion intraoperatively, and depending on their degree of sophistication, some of them are very used to do intraoperative ultrasound, but in certain hospitals, the urologists require the help from radiologists with the intraoperative ultrasound, so you want to know if that's the case. The number of renal arteries is important. They have to clump those renal arteries to do a partial nephrectomy so they don't have bleeding during the surgery. So if you have accessory renal arteries, you want to mention those. If you have an anatomy of the renal vein that is not conventional, it's very important as well. So they don't have accidental damage of that renal vein and hematomas and bleed in the OR. You want to describe the presence of infrarenal aortic aneurysms, as sometimes they have to approach these lesions from the retroperitoneum, and they don't want to, again, damage the aorta. And of course, the presence of lymph nodes and adrenal and distal metastases have to be part of the report as well. If you have renal vein thrombus, you want to describe the level of extension of that thrombus. If it's in the renal vein, typically is considered approachable through the standard surgery, level 1. If it gets into the IVC, then you have to describe if it's below the inferior margin of the liver, or if it's intrahepatic, if it's gone inside the liver. In that case, typically we'll distinguish between below and above the hepatic veins, or if it has extent above the hepatic veins, then you want to be sure that there is not a level 4 thrombus which actually reaches the atrium. You don't have to remember these 1, 2, 3, 4. It is very important, however, that you describe where the tip of the thrombus is. If it's below the inferior margin of the liver, inside the liver, above or below the hepatic veins, if it's suprahepatic, if it has reached the right atrium or not. When it's inside the heart, those patients are typically put on bypass. Cardiothoracic surgery typically is involved in those surgical resections. Diffusion-weighted imaging, as you know, has gained a lot of interest in recent years for characterization of multiple different neoplasms, and renal cancer is not an exception. There are several papers looking at the use of diffusion in these lesions. It's been shown that as you go from Bosniak 1, benign cyst, to Bosniak 2, 2F, cystic RCCs, and solid RCCs, there is a tendency toward a lower ADC. Makes sense. You're going from a cystic lesion to a more solid lesion. However, there is substantial overlap between benign and malignant disease, as you can see here. Interestingly, AMLs have a very low ADC. AMLs with minimal fat have a very low ADC. In my experience, papillary tumors are basically at the same level. You can see very low ADCs as well in papillary tumors. So again, you can distinguish those two based on the ADC alone. So in other words, it's still the role of diffusion in characterization of renal mass is still debatable. We use diffusion primarily to look for disease outside the kidney, metastases, and other lesions. In patients that can get contrast, you get another extra tissue contrast mechanism. So it's useful to have these sequences as well. These are the b-values that we use typically for our renal mass protocol, like we do for any other abdomen: 050, 400, and 800. So in conclusion, remember the threshold for determining and enhancing mass on MR, 15%. You saw on the slide it was actually 15 to 20. 15% will increase the sensitivity without decreasing the specificity. So that's the threshold that we use, 15% between the pre and post-contrast images. If you see bulk fat in a renal mass, in other words, you see areas that are bright on the in phase, that remain bright on the out of phase with an India ink effect around it, and they get saturated by frequent selective fat saturation, or you can see them as bright signal on the fat-only image on your Dixon acquisition, then you can be confident that that's an AML, angiomyolipoma, benign lesion. If you see what you can call little fat, small amounts of fat, then two scenarios are possible. One, you can have an AML with minimal fat, so you have a mixture of small amounts of adipocytes and muscle cells. But in those cases, the mass typically is homogeneously dark on T2. That helps you distinguish AML with minimal fat from the clear cell RCC, which can also show small amounts of fat on the post-phase imaging, but those tend to be hyperintense on T2, and if you have cystic degeneration or necrosis, then you're more certain about it. And finally, there are some phenotypes on MR that are predictive of histology, like the papillary renal cell carcinoma with low signal on T2 and hypoenhancing. So with this, I would like to finish, and thank you very much for your attention.
All right, thank you. It's terrific to see everyone. I know it's the last lecture of the day, so I will try to do my best to get us all to the luau as fast as possible. So we're going to close off with talking about MR urography. So that's going to be our topic here, and I have no conflicts of interest to disclose. So, you know, MR urography is an interesting term, and when I think about it and hear it, I always like to think, what is the goal of MR urography? And there's a lot of publications about this, and they give a lot of really beautiful images where we're filling up the collecting system. But again, we have to figure out, what do we want to do? This is one of the main goals of MR urography, and that's to recapitulate the IVP, right? We fill the collecting systems with contrast, and this is a method of tumor detection by looking for filling defects, okay? This is a lot of times what people mean when they talk about MR urography. The other actually way that people, when you talk about MR urography, there's another aspect that we're able to do with MR that we really can't or shouldn't do with other imaging tests. You can do this with CT, but certainly wouldn't want to with the radiation dose. And you can do a quantitative analysis of renal function. And this is by using dynamic contrast-enhanced information to obtain information about renal function. Nicely, gadolinium is freely filtered at the glomerulus, just like inulin, so you can actually use the signal to actually quantitate GFR. You can also quantitate other parameters such as renal blood flow. So these are actually two very different goals, and it will actually oftentimes impact your MR technique and protocol. So it's important to understand what you're trying to do. Are you trying to do tumor detection, or do you actually want to do quantitative analysis of renal function, or can you do both? That hasn't been really, that was very difficult before to really do good tumor detection work and quantitative analysis of renal function, but newer methods, newer advances in software and hardware techniques have made this more possible. So again, this is just kind of repeats what we were discussing before. The goals of MR urography have an impact on the technical approach. So again, are you looking at a tumor? Are you looking at function analysis, or a combination of both? So let's just kind of take them one at a time. So first of all, MR urography for tumor evaluation. And this is that whole concept of recapitulating the IVP. And there's a few ways you can do this. There's different imaging techniques, and one of the ways is to use T2-weighted images. Again, the nice thing here is you don't have to use contrast. You're using the intrinsic signal of the urine, which is very bright on T2-weighted images, to show you dilated, fluid-filled collecting systems. There's multiple ways to acquire T2-weighted images. Most commonly, when people do this, they use a 3D heavily T2-weighted sequence that's often respiratory gated. Again, if you do this sort of sequence in the pelvis, it's not a problem, but if you do it in the abdomen, you have to gate this. The gating is difficult. It may not always work, and it takes a long time. So you're talking about a longer sequence here. This is certainly not a breath hold, several minutes acquisition. So this is one way to do it. It's just to use the intrinsic signal features of the urine itself. The other way is to use an excretory phase post-contrast T1 weighted 3D gradient echo. So again, here you give contrast, and just like the image I showed in the early slide, you fill the collecting system with contrast and then look for filling defects. So that also works well, and they often are complementary, right? Because there are certainly times when the kidney, if it's obstructed, it doesn't function very well, so it doesn't actually excrete the contrast into the collecting system. So you may need a combination of these T2 weighted images versus the excretory phase post-contrast T1 weighted 3D gradient echo. And again, you can. There's certainly people have published on doing patient preparation with this, so hydration, pharmacological in terms of administering a diuretic, furosemide is the most common. So again, it can be a little complicated to do. Here's a case of showing sort of the kind of images you would get with this sort of technique. On the far left of the screen, you'll see that there's an obstructed ureter. That is a post-contrast excretory phase. So here you're filling the collecting system with contrast. You can see the hydronephrosis beautifully. You can see the obstruction at the ureteropelvic junction. When you look at the T2 weighted images, this isn't a heavily T2 weighted 3D sequence, but you can see this quite well in just the standard single shot haze sequences. But you can see a dilated collecting system, again, not using contrast, using the intrinsic signal of the fluid itself, and you can see the obstruction again is at the uteropelvic junction. Nicely in this case, you can see that the cause of the obstruction is an accessory vessel, which is crossing right at that point. So this is not an intrinsic UPJ. This is actually an external cause due to a crossing accessory vessel. So that was the cause of the patient's right side of the abdominal pain. So you have a 23-year-old male UPJ obstruction due to a crossing vessel. Again, just to talk briefly about the heavily T2-weighted sequences, I'm showing you the biliary system here, but this is basically the same sequence that you might use if you were going to do a sort of T2-weighted urography. The 3D sequences are really can be quite beautiful. You can get these very nice thin section, isotropic voxels, rotating MIP images. Can be really quite nice. It's interesting though, if you do a 2D slab, again, the images are not quite as nice, but the question is how much more information are you getting from the 3D technique? And this is where you have to, time, especially nowadays in the medical environment that we're working in, really time is money, which really impacts the efficiency of your overall program and how valuable MR is to the system. So the 2D technique, about 6 seconds. That 3D techniques can be 5 to 6 minutes. It may not even work well if the gating didn't work well. So again, this is something that you have to look at and see how valuable is this. This is a patient. It's a 38-year-old male with an ectopic left ureter insertion. And again, you can see the T2 weighted images show the anatomy here quite beautifully, markedly hydronephrotic, markedly dilated ureter. You've got essentially what looks like a ureterocele down to the pelvis. And again, you had that beautiful 3D T2 weighted image, but then just on the regular standard images, this is a high resolution T2 image of the pelvis. You can see the dilated ureter quite beautifully. You can see the layering debris in the collecting system of that left ureter. Now, again, here, the post-contrast, we can actually see the collecting system filling with contrast. And so in this case, the kidney did have some residual function, but it's interesting, the ureter was so dilated and obstructed, we're actually not getting contrast coming into that ureter, even on the delayed phase imaging. You can see on the right side, it works beautifully. So again, that ureter is massively dilated, but we're not seeing it on that 3D excretory phase. So again, this is where the T2 and just looking at the intrinsic signal of the urine is the most important in this patient. So we talked about the 3D T2 weighted images, and the downsides of this is, again, the time it takes, the need to do gating. And again, if the gating doesn't work, which is not that uncommon, as some people have seen here using this for the biliary system, you may have just wasted 5 to 6 minutes, which is quite a lot of time for MR. But this is where technology helps, right? And there's new methods coming out, and you can do this sort of technique with the compressed sensing method, which will reconstruct a very sparse data set. And so you can markedly accelerate the images, and what you can see here is the source images that are basically sort of rotating through. That's in a breath hold acquisition now. So we can get a 3D isotropic 1 millimeter voxels in a breath hold, and the images are quite nice. You can see here in this patient, they've got a dilated collecting system, but this is sort of just a sort of a mild functional UPJ obstruction. So, okay, so again, this is where now this becomes much more feasible, becomes much more practical on an everyday basis to do this kind of imaging to get the intrinsic signal features of a dilated collecting system. So we talked about using this sort of recapitulation of the IVP. But what I would have to say, just when we're thinking about tumor evaluation, is that that's actually not the best way to think about diagnosing tumor. Because again, we're sort of holding ourselves back to this old technique where we're just trying to fill up the collecting system, but that's not the best way to actually look for tumor. What we want to do is we actually want to find the tumor itself. So what are the disadvantages of the IVP technique? It remains a luminal technique, right? This is the problem with just doing an MRCP, right? Just doing an MRCP will tell you if the ducts are obstructed, but it doesn't tell you why. Is it a stone? Is it a tumor? This is why we learned this in residency of this differential of things that cause obstruction. But we're not actually seeing what's causing obstruction. Filling defects are non-specific, right? And again, the diagnostic specificity of what is causing the obstruction, which is what's the most important when you're actually trying to give a diagnosis, that comes from an analysis of the dynamic enhancement properties and the signal features of the lesion, of a lesion. So actually, the most important sequence when you're looking at urography, especially for tumor evaluation, it's not necessarily looking at the other sequences and filling the collecting system. What you want to do is you need to look at the urothelium on post-contrast imaging, but before contrast has excreted into the collecting system, right? That's when the urine is dark, but the tumor itself will actually enhance, and you'll actually be able to make a more specific diagnosis. Here's just a few examples. So this is an 80-year-old male with a transitional cell carcinoma. Now this is really obvious, right? So this is not a problem. You can see here there's a tumor filling the entire left collecting system. It has very heterogeneous delayed enhancement. This is the pattern of enhancement of a carcinoma. The T2 is quite dark. You can see how it's growing into the, growing down the ureter. Again, filling the collecting system here does not help us with the diagnosis, right? First of all, it's infiltrating so much, it's basically obliterating the calyces. But even when you have some dilated calyces, you're seeing them obstructed, but the key feature here is to look at the dynamic post-contrast sequences to actually give the specific diagnosis of a transitional cell carcinoma. So that was a large one. This is a small one, though, right? So you can see here, you have obstruction here. The right kidney is hydronephrotic. You can see the ureter coming down. Now here, there's this tissue here. Now this tissue is gray. This is what tumor looks like. Here's the ureter just above the point of obstruction, dilated, very nice thin wall. Here's the point of obstruction here, and now you can see the tumor is enhancing, and you can see this against the background dark urothelium, which is not filled with contrast, right? If we have this filled with contrast, we actually can't see how this thing is enhancing, right? It totally throws off our ability to assess for enhancement. So this venous phase image, right, before contrast is filled in the collecting system, this is what is the key for actually giving a diagnosis of tumor or something else. This is a 74-year-old male with hematuria. They got an MR. And here, what you can see is that the right kidney is hydronephrotic, right? And here you can see that there's enhancement, but this is actually a totally different pattern, right? The urothelium has this very thin, so it has this uniform, mildly thick, but uniform enhancement. And then when we look at the T2-weighted images, the thing is very dark, right? There's no tumor that's this dark. It's almost like there's no signal in there. That's what calcium looks like, right? So we saw this, we looked at that and said, this has got to be a stone. They got a non-contrast CT afterwards, and you can see the stone sitting right there in the proximal ureter, and it looks exactly like that on the MR. We've seen quite a few of these now. We do a lot of MR imaging in patients with acute abdominal pain at our center. Obviously, CT is the best way to look for stone disease, but sometimes patients come in, they don't actually expect there to be stone disease, and they get an MR thinking about appendicitis, but they actually ended up having a ureteral stone. But we're able to make that diagnosis quite often with the MR. So here's another patient. I showed you large transitional cell carcinoma before. Here's a smaller one. So again, we can see the dilated collecting system here, right? And we can see on the T2-weighted images, the superior calyces are filled. We can see the intrinsic T2 signal of the dilated collecting system filled with urine. And here is it here, again, showing the dark urine. Again, here, we could do an MR urography in terms of filling that collecting system with contrast. On an excretory phase, we can do a heavily T2-weighted sequence to show those obstructed calyces, but that doesn't give us the diagnosis. What gives us the diagnosis are the soft tissue images, where we look at the pre-contrast, we look at the post-contrast, we can see that there's a small heterogeneously enhancing nodule, shows delayed enhancement. The T2 is subtle, but it's dark, and then you can see that there's abnormal restricted diffusion in that area. This is a small transitional cell carcinoma. Transitional cell carcinoma is nice. It's like the cousin of pancreatic duct adenocarcinoma and cholangiocarcinoma. The very first thing it does is it obstructs the duct or the collecting system. This is a good contrast case. It looks very similar, right? When you take a look at this patient, you got dilated calyces in the superior pole of the right kidney. Again, you can fill it with contrast and you can see that they're dilated, but we don't know why. This is where the soft tissue imaging is key. And I'm not showing you all the images here, but there's no hypointense tissue there. There's no poorly vascularized tissue there. If you look at the DWI, totally normal signal. This is a 24-year-old. Cancer would be very uncommon. This is a patient with congenital calyceal dilatation. Okay? Now, again, the whole concept of recapitulating the IVP, you would not be able to tell the difference between these two patients, right? One has tumor, one has a congenital issue. It's really looking at the soft tissue images that gives you the diagnostic specificity that's critically important for providing value in these patients. This is a somewhat recent article by Suda. They looked at MRU for looking at tumor detection. They compared with CT urography, which is what a lot of people are using, again, because CT, you can look for stones also. They looked at about 24 patients, and they did the MRU at 3T, and they found that the findings were very similar to CTU. MR was actually slightly better at visualization of ureteral disease. And again, this is because you can do multiple phases, and if you want to make sure that the ureters are filling, you can, for example, here you can see that mid portion of the ureter was not filling, but you do additional phases and you can see it fills quite nicely. And again, the average radiation dose of the CTU was about 9.2 millisieverts. So, so that's really important to show how accurate MR is. Just to show a few other cases, again, this is a 52-year-old male. This is not a diagnostic dilemma. This is a large bladder cancer. But again, the tumor that we're looking at is on the soft tissue images. Here's the T2-weighted images. Here's the venous post-contrast, the very dark urine here. You can see the heterogeneously enhancing tumor. If you do delayed phase, you can fill up the rest of the bladder, and you can see that there's a large filling defect, but the diagnosis comes from looking at the enhancing pattern of the tumor itself. That was a large tumor, but look at this patient. So here you can see they've got a bladder cancer, but if you're just filling up the bladder to look for filling defects, you may miss this tumor, right? Because it's infiltrating in the wall and into the perivesicular tissues. But you can see the abnormal thickening on the T2-weighted images. You can see the abnormal enhancement, abnormal restricted diffusion. It's a patient with bladder carcinoma. Another patient, much more subtle, right? But we can see here, there's tissue here on the T2-weighted images. Again, if you fill this bladder with contrast, like you might do for a CT urogram, or again, try to recapitulate IVC, you may not see a filling defect here. But here you can see the enhancement pattern, you can see the bladder, the urine is markedly dark, so it shows the visualization of the tumor quite well. This is a superficial bladder carcinoma. Contrast that with the stone. Here you would see a filling defect if you filled up the bladder, but when you look at the T2-weighted images, markedly dark, there's absolutely no enhancement. Here is the CT, which shows a large bladder stone. So again, offering diagnostic specificity, not just a general diagnosis of a defect in the bladder. Again, another patient, 58-year-old male with a bladder stone, large dark T2 signal, absolutely zero enhancement. On the post-contrast images is the most important for making this diagnosis before contrast has been excreted into the collecting system. Okay, so we're going to shift from talking about tumor analysis to talking about functional analysis. And this is something that a lot of groups have been working on, methods for an accurate, reproducible measurement of renal function, especially single kidney function, which is not so readily available, right? Estimated GFR, creatinine before, but now estimated GFR is widely used, but again, these are very crude measures of renal function. They vary from measurement to measurement. And again, they can't tell you differential renal function, right? Nuclear scintigraphy is widely used, right? But this does not provide an analysis of structure and function in one test. And certainly can provide a measure of split renal function, but some of the common agents don't directly measure GFR. So again, gadolinium is freely filtered at the glomerulus, and signal changes related to the changes in gadolinium concentration can be used to calculate GFR. We've advocated using the term MR and nephrourography, right? So not just looking at the collecting systems, but actually you're looking at the kidney itself, right, to look at kidney function. What are the advantages of this technique? Again, we're using MR. There's no radiation, no iodinated contrast. High temporal resolution is possible to obtain the arterial input function. And again, the ability to obtain both structural and functional information in one test. And again, not just GFR, right? We can obtain additional measures of renal function, such as renal blood flow. Again, several groups have published on quantitative renal functioning imaging with MR. There's varied methods, 2D versus 3D techniques. At our center, Dr. Martin has really developed a lot of this work, and there's different ways to model the data, 2 versus 3 versus other multi-compartment models, PATLAC, TOFS model, others. So again, multiple techniques, but they tend to all center around using DCE methods. And, you know, the question is this practical? Now, this is a relatively recent, or, you know, year and a half ago publication. This is often done very in pediatric imaging, and here the total study time was under 30 minutes, but only this. But again, if you look at the sequence time itself, it was about 19 minutes. So this is should not be something that's complex and takes a very long time. This should be relatively efficient. Now, the key thing is newer techniques have improved the ability of, have improved the speed and the acquisition for dynamic imaging. So before, when you're doing this dynamic imaging to actually get the quantitative renal functional analysis, you actually had difficulty looking for tumors at the same time because you have something like this, right? So to get the speed, you had to really ramp down the resolution to go very fast, so small tumors may not be seen very well. But this is not the case anymore. This is the method that we are using and testing at our center, basically using a radial stack of stars method. Basically, we're getting a very high resolution arterial input function to increase our accuracy for calculating GFR. And then using compressed sensing techniques when we're imaging the rest of the kidney. So again, this method should provide accurate GFR measurements, but also diagnostic quality kidney perfusion. And again, this should be totally free breathing, right? So the patient doesn't have to breath hold. We're using view sharing techniques with the breath hold. Here, the patient can just sit there, and you can get high quality imaging looking at quantitative function, but also anatomy. So this has been presented previously here at ISMRM and also been published in JMRI. And again, here you can look at, these are basically, this is a 4-second temporal resolution image. This is 8-second temporal resolution, so you can see how much better the images are, right? But now you use a 4-second temporal resolution, but with compressed sensing, and the images, you don't have to do the compromise anymore for time and image quality. And this is just what our group has published on this, and this is it was a small number of cases, but really showing that the MR GFR calculations actually were quite tightly correlated to the estimated GFR when you combine the values for the two kidneys. So. So it's been working quite well. We've been using it more commonly, and again, by acquiring high quality anatomic images, not only can you get, again, the quantitative function, but you're actually getting anatomy. So for pre-surgical planning, you get a beautiful view of the arterial system. So this actually now becomes a comprehensive pre-surgical evaluation. This is a patient that got MR, 83-year-old male with a clear cell renal cell carcinoma. The diagnosis is quite obvious here. There's heterogeneous arterial enhancement, heterogeneously elevated T2 signal, no diagnostic dilemma. The surgeon, though, really, the patient had very poor background renal function, and it was important to him. He wasn't quite sure what he was going to be able to do, if he was going to be able to do a partial nephrectomy, if that's going to be possible with the size of this tumor or not. So it was really important to him to know how that kidney was functioning. So here's the pre-surgical analysis, and you can see the difference between the left kidney and right kidney. They actually, the left kidney was functioning actually quite well, very similar to the other kidney. And so he was able to go in with this patient to actually preserve as much of that kidney as he can. He went for a partial nephrectomy as opposed to just taking the entire thing out. But again, here's the radial stack of stars data that we were able to do. And if you take a look at that, that image quality is fantastic for actually giving an anatomic diagnosis, right? This was not possible before without the acceleration techniques that are much more common now. This is a 57-year-old female with a ureteral reimplantation, and they wanted to know how that left kidney was functioning after the reimplantation, and it was working quite beautifully. You can see the contrast filling that left collecting system. You can see the bladder is tethered up somewhat superiorly from the post-surgical changes from the reimplantation. This is actually a obstructed transplant kidney from, they actually had a previous transplant in that left hemipelvis, and that left kidney, the new transplant is actually being obstructed by that old transplant, unfortunately, but we were able to give a quantitative renal functional analysis for that graft kidney. So this is a patient, a 67-year-old male with a solid arterial enhancing tumor in that right kidney. So the diagnosis of oncocytoma is not necessarily easy on any imaging study, but this, unfortunately, we had prior imaging dating back several years, and this has been totally stable. So we felt pretty confident that this is an oncocytoma, had this scar appearance. Again, the patient actually, they wanted it out. So the question was to do a global analysis of renal function to be able to look at that kidney and see how it's functioning relative to the other side. And so we're able to provide with split renal function, giving a quantitative GFR for each of the kidneys. So in summary, we'll just say that MR urography really is a powerful tool. And again, now, especially now, it's able to concurrently evaluate both the renal and urothelial anatomy and also function. The tumor evaluation capabilities, and this is what the literature shows, should be at least as equal to CT with an improved safety profile. And again, that post-contrast imaging before contrast is created in the collection system is the most important for providing diagnostic specificity. Newer MR techniques, including radial acquisition methods with compressed sensing reconstruction, can really accelerate the temporal resolution capabilities while concurrently improving image quality. And again, the combination really allows us to provide a truly comprehensive imaging study, looking at both function and anatomic image quality. And that is that.
All right, thank you very much for the introduction. Thank you everyone for being here. I'm impressed to see so many people still here for the last session. I see a lot of familiar faces, so most of you are my friends just trying to be nice to me, I know, but let's get through MR in bladder cancer. I have no disclosures to make. Just to start by telling you a little bit about bladder cancer and why it's important. I'm delighted to have been invited to talk about this topic. Bladder cancer is usually forgotten about a little bit. Most emphasis is made on prostate cancer these days, and bladder cancer is just not something that features very prominently when it comes to talk and when it comes to research. However, it is relatively common. It's actually the 4th most common cancer in men and the 6th most common cancer in women. The prevalence depends on where you hail from. The most widely prevalent areas in the world are in the Middle East and Europe, where the mortality is twice as much as what it is in Europe and 4 times as much as what it is in the US. The typical bladder cancer patient, when you're thinking about epidemiology, is a man. There's a 4-to-1 male to female ratio who is 60 years or older. Most of these tumors from the histologic perspective are urothelial cancers or transitional cell carcinomas, and these are the ones that are associated with risk factors such as cigarette smoking and occupational exposure as seen in the painting, textile, and rubber tire industries. So you start to get a picture of how your typical bladder cancer patient is not exactly the fittest patient. They tend to be older men who are smokers and have occupational risks. A small but important proportion of bladder cancer, especially those seen in the Middle East and Egypt, have nothing to do with urothelial carcinoma. They're actually related to infection by a parasite, Schistosoma hematobium, and those are the ones that are related to squamous cell histologies and account for about 5% of bladder cancers in general. So having talked a little bit about the epidemiology and why it's important to study bladder cancer, in this talk I want to focus on 3 specific points to discuss and where I feel imaging has a great potential to make an impact in bladder cancer patients. The first one is regarding staging or local staging of bladder cancer, and there's a critical step or a critical change where we go from defining bladder cancers as superficial versus muscle invasive, and I'll dwell into that a little bit later on, but it will define basically how patients are going to be treated primarily. The second topic I'll touch upon briefly is going to be upper tract involvement and how we do that. We're in ISMRM, so we'll talk about MR urography, and I'll give you a few of the alternatives of how to deal with that. And the last part of the talk, I'll focus a little bit on the potential role of MRI for treatment response assessment. And in the context of bladder cancer, the key question is, can we use MR, can we use imaging to predict complete pathologic response to neoadjuvant chemotherapy in patients before they go on to have surgery? So I'll explain a little bit more about what I mean there. But let's start about talking about how you do the T staging. I said the local staging. T staging is one of the most important clinical and imaging factors that are going to help determine what happens to the patient. So in bladder cancer, it's all about how far into the bladder wall has the tumor invaded. So just to show you histologically here, the bladder wall has 4 layers from the inside out: the uroepithelium, the lamina propria, the muscularis propria, and the serosa. Basically, bladder tumors are going to start in the uroepithelium, and they're going to grow from the inside out. And each of the T stages are going to represent involvement of each one of these different walls, so that a carcinoma in situ or a TA cancer is going to involve the uroepithelium only. Once you have extension into the lamina propria, you have a T1 tumor. Once you have extension into the muscularis propria, and notice the muscularis propria is actually the thickest layer in the bladder wall, then you're in the presence of a T2 tumor, and you'll see why T2 tumors are specifically important in a moment. And once you have extension to the serosa and beyond, you're in the presence of a T3 tumor. The reason why I say T2 tumors are extremely important, and again, T2 involves the thickest layer of the bladder wall, the muscularis propria, is because once that's involved, we're in the presence of a muscle invasive bladder cancer. These account for about 1/3 of all bladder tumors, and they are usually treated with definitive therapy, most often in the form of radical surgery, can also be done with radiation therapy. If you have a T1 cancer or below, these are the ones that we're going to categorize as superficial bladder cancers. They're the vast majority of bladder tumors, 70 to 80% of them to be precise, and they're the ones that are usually treated with local therapies, most often transurethral resections, alone or in combination with instillation intravesically of BCG or other similar substances. So if we're saying that we're going to base the management on what the pathologic staging is going to be, then it would be a fair question to ask, why would we need imaging? Can't we just do a biopsy, determine what the T stage is, and decide how we're going to treat this patient? The answer is, in some cases, imaging is not needed, but cystoscopy and biopsy do have their limitations, and these are well known. The first one is that, as you can imagine, the bladder wall is a very thin structure. So when you're trying to biopsy a mass that comes right up against the bladder wall, a lot of times you want to be careful that you don't perforate right through it and perforate the bladder wall. What that means is that relatively often when a bladder mass biopsy is performed, when the pathology report comes back, it says the muscularis propria layer was not included in the biopsy specimen. In other words, you biopsied the bladder mass, you got the histology, you got the diagnosis of cancer, but in terms of staging, the needle didn't go deep enough to reach the muscularis propria, and therefore you can't make that key differentiation that we talked about between superficial and deep tumors. And this is just to show a real life sample. This is just a typical transurethral biopsy report from my institution. They tell us about what the tumor type is, what the histologic grade is, what the pattern of growth is. But when it comes to local invasion, see, this tumor is said to involve the lamina propria, so it's definitely at least a T1 tumor. But when we're trying to decide, is this a muscle invasive tumor, we see this section here saying muscularis propria not identified. So then how is this patient going to be treated? You're still having the same conundrum. You don't know if it's a superficial tumor or it's a muscle invasive tumor, and that's where imaging can have a big role. There's other limitations of the cystoscopy and biopsy approach. Neither of them, for obvious reasons, can tell us anything about extravesical spread, nodal spread, or metastatic disease. The cystoscopy is not perfect, so some tumors may be overlooked when it's performed. And a well-known fact is that perhaps for the same reason that usually urologists are careful not to perforate the bladder wall when performing a biopsy, pathologic upstaging from biopsy to cystectomy is common and occurs in up to 40% of cases. So how does this all look on imaging, on MRI? So the morphologic assessment is performed with T1 and T2 weighted images. This is a T1 weighted image here on your left. It's not very useful for assessment neither of the wall or bladder masses. Basically, the urine is dark and the bladder wall is dark, so you can't really differentiate between them. You have no contrast. When we have T2 weighted images, now the bright urine helps us see much more clearly what the bladder wall looks like. It's seen as a thin, dark T2 signal structure surrounding the entire urine. And basically, most of the signal that we're seeing in the bladder wall is going to come from the thickest layer that we talked about, the muscularis propria. Once we have a tumor, a bladder tumor, it's usually going to be of intermediate T2 signal intensity, and we enter into this concept of trying to decide, is this a superficial tumor or is this a muscle invasive tumor? The way to do it on morphologic T2 weighted images is to identify the low signal intensity of the muscularis propria in the bladder wall and try and see if you can actually follow it all the way around the area where the tumor is located. If you can convince yourself that you can see that uninterrupted low T2 signal intensity from the muscularis propria all the way around the tumor, then that means you're in the context of a superficial bladder tumor. The opposite is also true. If you have an intermediate T2 signal intensity from a tumor that seems to be encroaching or digitating into the muscularis propria and breaking that low T2 signal intensity ring, then you are in the presence of a muscle invasive tumor. Extravesical invasion is usually a little more straightforward to do. This is an anterior tumor, usually typical location for a urachal adenocarcinoma with obvious digitation of soft tissue into the anterior perivesical fat. So this is a T3 tumor. And once you have invasion of the adjacent organs, like in this case a man, so the prostate here is invaded, you're in the presence of a T4 tumor. Now, there are pitfalls for T-staging on MRI. It's not always straightforward. By far, the most common problem that we have when we're trying to stage bladder cancers is overstaging. And the overstaging comes from the fact that most of these patients, by the time they reach us, have already had some sort of manipulation done to their bladder, usually in the form of a transurethral resection, and that generates inflammation that is sometimes very difficult to differentiate from tumor on our images. This is just an example here. For all intensive purposes, you see the low signal intensity on T2 weighted images of the muscularis propria. You have intermediate T2 signal intensity here, which looks like tumor. It's even enhancing like tumor, but this patient had neoadjuvant chemotherapy and subsequently went for surgery, and the pathology showed complete response, so there was no residual tumor. This was all just related to post-resection inflammatory changes. So by now there's clear data and a lot of data in the literature showing that diffusion weighted imaging improves our accuracy for T-staging on MR. This is just an example from one of the early papers. The principle is that, number one, the muscle invasive tumors are going to have a higher extent of diffusion restriction, but perhaps more importantly, when evaluating these images qualitatively, is the fact that the non-muscle invasive or the superficial tumors tend to have a smooth outline, as we see on the image from the patient on the top here, whereas on this other patient at the bottom, the outline is more spiculated or irregular, and that's a very strong sign, an indicator that this is a muscle-invasive disease. As I said, one of the early papers, 2009, showing improvement in accuracy from 79 to 96% with implementing diffusion, and a modest further increase when using qualitative evaluation of contrast enhanced sequences in addition. Since then, there's been a number of publications. This table here is from a paper published in 2014. All the papers show more or less the same. Diffusion definitely helps and demonstrates incremental value compared to T2-weighted images alone. We are already seeing how these papers introduce the concept that quantification of the extent of diffusion restriction may also be relevant, and I'll talk to you a little bit more about that in just a moment. This other meta-analysis that I've cited here at the bottom looked at, I think, 28 papers or something like that, and overall a pooled sensitivity of 0.85, specificity of 0.90, and AUC of 0.92 was found for differentiating muscle versus non-muscle invasive bladder cancer. So as I mentioned earlier, quantitative diffusion has also been explored. Significant differences have been shown in ADCs between tumors of different stages and tumors of low grade versus high grade. Note that one of the main problems when it comes to trying to apply these concepts into practice is that even though there's statistically significant difference in the means of the ADCs between the different stages and grades, there's still a lot of overlap, so that it's at this stage impossible to establish a threshold above which or below which you can call it one stage or another. So significant trends, significant associations, but still quite some way to go before this can be used routinely for clinical purposes. Some hope that applying a diffusion kurtosis model for the diffusion data could help reduce a little bit of that overlap. This is a paper published last year, and basically it showed, as had been found before, that low ADC is seen in bladder cancer compared to the normal bladder. In addition, the two kurtosis parameters that were evaluated, the revisionary diffusion coefficient and the deviation from the Gaussian distribution, were significantly different as well between bladder cancer and normal bladder. However, the hope, and all of these parameters were also able to differentiate low versus high-grade tumors. However, the hope that the DKI was going to be better than the simple ADC metric didn't materialize. Unfortunately, as reported in this paper, they weren't significantly different, neither for differentiating cancer from normal bladder wall or for differentiating cancer from high-grade tumors. So we know diffusion helps, especially qualitative assessment. Is there a role for contrast? This is from the same review paper, 2014, summarizing most of the literature that has been out there about the use of contrast in bladder cancer. Some of the very early literature, 1996, was already talking about important issues such as the timing of the contrast enhancement of the bladder tumors compared to the bladder wall. And this paper, for example, showed that the bladder cancer enhances approximately, on average, 4 seconds earlier than post-biopsy tissue. So maybe some opportunity to exploit the concepts under dynamic contrast-enhanced MRI to our advantage. For the most part, if there is no inflammation, if there's been no transurethral resection, contrast is actually very good. It does improve the accuracy compared to T2. The jury is still out there with regards to, does it actually improve the accuracy when you take into consideration the information from T2 and diffusion combined? There's very few papers that have actually tried to address or evaluate this issue. This paper by Gupta et al. Published last year did a stage-by-stage analysis and basically reported very similar accuracies and correlations between the imaging findings and the pathology for diffusion and DCE MRI. And in fact, 83% of patients had absolute agreement between the two sequences. So no hint here that one or the other is going to be best. This other paper by Zhu, published in 2014, looked at the ADC from the diffusion and the washout rate from the DCE MRI, found them both to be associated with bladder cancer aggressiveness. But again, if you focus on this and remember what I showed 2 slides ago, you have a similar problem. So there's a significant differences in the mean, but the box and whisker plots show that there is a lot of overlap between the parameters. So still at this stage, neither with diffusion or with DCE, you can actually establish a threshold for any of these parameters to try and decide about a stage or decide about a grade. I wanted to mention some other novel approaches that have been reported. For example, this paper published in PLOS ONE in 2014 found that ADC, and this is just the standard mono-exponential mean ADC value, was not only associated with T stage and with grade of aggressiveness, but also with markers of proliferation or proliferative activity such as P53, P21, and Ki67. And actually on multivariate analysis, only the ADC and the P53 were independent predictors of muscle invasive disease. This other paper from the NYU group published last year took an approach of doing a whole lesion analysis. Up until now, every paper I've discussed here has focused on a single slice ROI measurement on a representative area of the tumor. This paper tried to analyze the entire lesion, so put a volume of interest and ROI over every slice where the tumor was seen. As in all the other papers, it found that ADC was lower in muscle invasive tumors. The kurtosis, and this is not the kurtosis from DKI, it's the kurtosis derived from the histogram analysis, was lower in patients who had nodal metastasis, but was not in itself associated with the T stage. So the conclusion of that paper was that maybe you can use both. You can use the ADC value for its association with the T stage and use some of these more fancy histogram volume-derived parameters to establish extent of disease. So the second and third points I'm going to talk about will be quicker. The second one is regarding upper tract involvement in bladder cancer, very important concept. It happens in about 4 to 5% of patients with bladder cancer. The problem is it can happen at any time. It can happen at the time of diagnosis, at the time of presentation. It can happen during initial treatment, after initial treatment, any time during follow-up. So it's a big deal, first of all, to continuously have to evaluate this, and second of all, to deal with it if something is identified. So traditionally, the thought is that CTU and MR urography are equivalent somehow from the diagnostic perspective. Most times CTU is performed in clinical practice, but more and more MR urography is growing in popularity and is obviously also an alternative when there's allergies to iodine contrast from the CT. However, some recent papers, including this one published last year, found that actually MRU has better sensitivity than that CT urography, but still imaging cannot replace the approach of cystoscopy and biopsies, given that there were a number of tumors that were seen on cystoscopy that weren't seen neither with MR or CTU. So it still remains sort of staging mechanism rather than a primary diagnostic. With MRU, we take advantage of the different methods for evaluating the renal collecting systems and ureters that MR affords, such as evaluating through static fluid techniques that can be various forms of T2-weighted images, including this 3D respiratory triggered heavily T2-weighted FSC sequence that David showed quite elegantly in the talk this morning. It's akin to the MRCP-like sequences and very good for delineating the ureters without having to use intravenous contrast. The other obvious option is the use of contrast and excretory urography, deemed excretory urography because of the underlying principle of filling the pelvic calyceal systems in ureters and evaluating for the presence of filling defects indicative of tumor. But actually, once you give the contrast, you can take the opportunity to evaluate the kidneys in the parenchymal phase as well, about 80 seconds after administration, and that gives you a chance to see flat tumors that present themselves as urothelial wall enhancement or tiny nodules that have enhancement. And obviously the excretory phase, the literature reports variable timings for the excretory phase ranging from 5 to 12 minutes, but usually what we're looking for there are filling defects. And these are just two examples of essentially what we're looking at in the lower pole calyx in this patient and in the left upper pole calyx in this other patient. So MR urography has its limitations. Most of them are related to the difficulties with the technique and the experience that the group needs to have in order to get good quality images. There are well-known artifacts associated with MRU, most of which are associated with MR in the abdomen and pelvis in general, motion, the presence of calcification not dealt very well with, artifacts from surgical clips and flow-related artifacts, especially in those heavily T2-weighted 3D images that we see. Now, one of the things that has traditionally hampered a little bit the use of MRU has been that if you need to stage the bladder cancer and you need to image the upper tracts, it's been a little difficult to negotiate how you're going to do to evaluate the contrast enhancement of the bladder, and at the same time, how are you going to evaluate the upper tract? So the timing of the contrast and the type of the sequence doesn't quite work out most of the time, and usually that led to two separate examinations, and usually that was a bit of a problem. This paper was very interesting here, published very recently by, again, our group at NYU here. We have Hirsch in the audience, prior speaker. Simultaneous high temporal resolution quantitative perfusion imaging of the bladder together with conventional multi-phase urography. So this essentially solves that issue we just talked about. Essentially, they did a golden angle radial sparse parallel sequence, a GRASP sequence, where the raw K-space data is acquired continuously. So there's no need to have a predetermined temporal resolution, and then basically the data can be reconstructed retrospectively at variable temporal resolutions of interest to simultaneously evaluate the primary bladder tumor and the upper tracts. So this is an example taken from the paper. Very nice. I believe the temporal resolution was about 2 seconds or so, but you can get the picture of the time to signal intensity change curves between the bladder tumors and the blood pool. And you can make quantitative DCE measurements and get differences here, for example, the K-trans differences between the normal bladder and the bladder tumors. And you can get different post-contrast phases of the kidneys and the upper tract. Have an excretory phase here on the right-hand side and some earlier phases of enhancement before that. So final point, diffusion to predict pathologic response to chemoradiation. Why do I even think that that's important? Why did I include it as one of the 3 points that I had to choose about bladder cancer? Number one, in bladder cancer, it's a fact that neoadjuvant chemoradiation has been shown to have a survival advantage. So theoretically, you want as many patients to undergo neoadjuvant chemoradiation prior to surgery as possible. However, the chemotherapy is very intensive. It's debilitating. Remember, our typical bladder cancer, old, smoking man is not very fit to tolerate the chemo and the surgery. And the problem is, right now, every patient who has neoadjuvant chemo-RT will go on to have surgery, regardless of whether there's pathologic response in the bladder or not. And that's because we don't have accurate enough non-invasive techniques to define the response to chemotherapy. So if we were to develop something that's sufficiently accurate to be used, it is possible that in the near future, some of the patients who have neoadjuvant chemotherapy may not need subsequent surgery, as in the case in other tumors already, such as rectal cancer. So encouraging results published to date. This is a 2012 paper here showing significant differences in mean ADC values between chemoradiation sensitive patients and chemoradiation resistant patients. Not a lot of overlap in the box and whisker plots, so maybe something that could be used moving forward. This one is also very interesting, published JMRI last year. Instead of DWI, this paper used DCE. And basically, it used a clustering algorithm, a k-means clustering algorithm, to separate out within the tumors areas that had variable combinations of these two DCE parameters, the KEP and the signal intensity amplitude. So a cluster 1 with low both parameters, cluster 2, 1 parameter low, 1 parameter high, and cluster 3 vice versa. And essentially what this helps do is tap into the concept of tumor heterogeneity. It doesn't have to be that the whole tumor behaves in the same way, and there may be that there is a cluster that behaves in a particular way that's going to define how the tumor is going to change and evolve. In this particular case, all the 3 clusters that were determined were associated with chemo response. However, one of the clusters, cluster number 2, had the highest area of the curve, 0.96 for defining and predicting the presence of response. This is an example of how they did that. You can see the tumor with the variable colors representing different clusters. You can see the cluster representation on the graph here, and you can see the association between the clusters and the chemotherapy response here. So interesting concept. Maybe the answer lies here. Maybe when we try and make these metrics that are basically averaging the findings of DCE or diffusion throughout the whole tumor, we're losing out on this heterogeneity concept, which is a known feature both from the pathologic perspective, genomic perspective, from many other tumor biology related perspectives. So maybe that is the way that we should try and think about our imaging moving forward. So I finished with this slide, PET-MR. Simultaneous with this session, there's been another session all day that's been talking about this. Obviously, we're in ISMRM, and this is an MR bladder talk, so I've focused on the use of MR in bladder cancer. However, there is plenty of literature that talks about the usefulness of PET-CT in bladder cancer for exactly the same purposes that I focus my MR bladder talk here. Most of the literature is about the standard fluorodeoxyglucose or FDG PET, but there's also some literature on more novel tracers, choline and acetate. It may be that in the future, PET-MR can play a bigger role in bladder cancer as well. So far, the only paper I could find in the literature is a focus on the technical component of the PET-MR acquisition, something that is indeed very relevant, especially for bladder cancer, and is not only relevant to PET-MR, it's probably relevant to MR per se. This paper was trying to think about sequential versus simultaneous acquisition of the PET and the MR data. And if you think about bladder cancer, and if you think about the bladder lumen constantly filling as we're doing the exam, even if we're doing just MR, it means that what we're seeing when we're doing the beginning of the exam may vary slightly compared to what we do later in the exam. And especially for acquisitions that last a few minutes, it means that the tumors and the bladder wall and all the structures in the pelvis are going to be moving along the time. And that has to be dealt with because it causes specific difficulties when it comes time to try and quantify and make any specific measurements. This is an obvious example. You see the difference in the registration of the PET data on the background in the orange and the MR data when the images were acquired sequentially, first the PET and then the MR, and you see how they fit much nicer when the images are acquired simultaneously. So it makes sense, but something important to keep in mind. So with that, I thank you and open the floor for questions or comments. Thank you very much.